Good evening, friends. We start with the subject psychiatry. First question. Yes, this is a very important topic, catatonia. So we will discuss little bit about all the question previously asked on catatonia. First, we read question. 35-year-old male, patient of schizophrenia, okay, brought to psychiatry OPD by his family. They describe a peculiar change in his behavior over past few weeks during examination. इसको मैं highlight कर रहा हूँ. I highlight during examination when you put patient's arm straight over his head means uncomfortable position. Okay. Patient keep his arm there for 15 to 20 minutes means normally you will not be able to maintain that abnormal posture, but this patient is maintaining abnormal posture for 15 to 20 minutes for long time. Yes, means if a patient is maintaining abnormal posture for a long time spontaneously, means you go to ward and a patient is lying in this uncomfortable position spontaneously, then this phenomena is posturing spontaneously. Spontaneous. But in this question they have given that you are doing examination, means you are doing passive movement. Yes, if I am moving my hand, active movement. If you hold my hand and do this, that is passive movement. Means during passive movement, if you leave the patient in abnormal posture and patient maintain abnormal posture for long time, then it may be catalepsy or waxy flexibility. Now I will write like this. If during passive movement no resistance felt and patient maintain abnormal posture. They may give image like this or this. Then it is called catalepsy. This is called catalepsy. But during passive movement, if examiner feel resistance, if resistance is present, and final abnormal posture is maintained, then it is called waxy flexibility. So in this question, yes, during examination means passive movement is being done and there is no resistance, then the answer would be, yes, please do reply, catalepsy. Okay, catalepsy, not cataplexy. Cataplexy is sudden loss of muscle tone seen in narcolepsy. Mnemonic for this is lepsy में lepsy नहीं होता, lepsy में plexy होता है. Yes, lepsy is not in lepsy. Yes, in lepsy there is plexy. Okay. Waxy flexibility, in the same question if I change that patient shows resistance, yes, you will give me answer. Patient shows resistance like you are bending wax candle. So sometimes they will give resistance is there, or they will give complete just like you are bending wax candle, then the answer would become waxy flexibility. Okay. So in this question, the answer is catalepsy. Waxy flexibility, I told you in another scenario, in the same question, if you change little bit, answer may be there. Automatic obedience. What is automatic obedience? Means patient follow the command despite painful consequences. If I ask a catatonic patient to protrude his tongue and I prick needle to the tongue, patient will take the tongue back. You will also do the same. But if I ask you to protrude your tongue again, you will not protrude. But this patient of catatonia will protrude. So this is automatic obedience. इतना obedient है. Yes, follow the command despite painful consequence. All these are seen in catatonia. Catatonia. Okay. One question recently asked question in FMG. Catatonia. There is one phenomena. Echolalia. Echolalia means mimicking examiner's speech. Mimicking examiner's speech. Yes, if I ask patient what is your name, patient would say what is your name. Just like copycat, you play with your girlfriend, boyfriend. Echolalia. Echopraxia. Echopraxia. Mimicking examiner's action. Motor movement. Motor movement. Suppose I enter the ward and do like this and this. Patient does the same this and this. I became angry. मैंने कहा इसको ECT लगा दो. Current लगाओ इसको. Actually, yes, the treatment of choice of catatonia is, question is asked, treatment of choice, modified ECT. Initial treatment or medical treatment, injection, lorazepam. Both are question. Initial treatment of catatonia, yes, injection, lorazepam, or medical management. If question is asked, treatment of choice, modified ECT. Good evening, Subhash. Okay, so answer is B. These questions can be asked. This is very important. They may change little bit language and answer would change. If patient maintain abnormal posture spontaneously, image-based potential question, then yes, posturing. If you do examination and patient maintain abnormal posture after the examination, during examination no resistance, then it is catalepsy. If resistance, Vexy, flexibility. Second question. In this question, they have given the explanation of all these options I discussed. During psychiatric evaluation, 30-year-old patient present with prominent symptoms suggestive of schizophrenia. Okay. The patient described feeling emotionally detached, decreased social interaction, preoccupied in own thoughts which are not reality based, unable to take decision. Okay. Till now. Means patient is lost in his own world. That is called autistic thinking and behavior. Means patient is lost in his own world. Okay. No social interaction, emotionally detached. That is autistic thinking and behavior. Unable to take decision and action due to conflicting thoughts. Ambivalence, unable to decide. Suppose a schizophrenic patient is standing outside the room and is unable to decide, should I go inside or not go inside for half an hour. This is ambivalence, unable to decide. Additionally, there is evidence of a disturbance in coherence and logical progression of thought and speech, means formal thought disorder. One is loosening of association. Yes. Anhedonia is not Bleuler's 4A. This is frequently asked question in FMG exam. Yes, Bleuler's 4A. Yes, include autistic thinking and behavior, ambivalence. Very good. Correct answer. Answer is C. Association loosening, and if I write E, then is affect disturbance. Affect disturbance. These are 4. Anhedonia is negative symptom. Anhedonia is negative symptom of schizophrenia. Not getting pleasure in previously pleasurable activity. Definition में question है. Anhedonia means not getting pleasure in previously pleasurable activity. Previously I used to play cricket and I used to enjoy. Now I don't enjoy playing cricket. Anhedonia. Also seen in depression. तो एनिडोनिया डिप्रेशन में मिलता है. ऑल्सो सीन इन नेगेटिव सिम्टम ऑफ सिजोफ्रेनिया. प्रीवियसली आई यूज्ड टू एंजॉय टॉकिंग टू माय गर्लफ्रेंड बट नाउ आई डोंट एंजॉय. दिस इज एनिडोनिया. यस और नो? प्लीज डू कमेंट. मतलब यू एंजॉय टॉकिंग टू योर गर्लफ्रेंड, पहले एंजॉय करते थे अब नहीं करते. एनिडोनिया है. हो सकता है, नहीं भी हो सकता है. हो सकता है गर्लफ्रेंड पुरानी हो गई हो. तो साइकेट्री में वी टेक यस लिटिल बिट डिटेल्ड हिस्ट्री. ओके, just for fun. Okay, now, so in this answer is C, Bleuler's 4A to diagnose schizophrenia. Anhedonia is not a part of Bleuler's 4A. Now, Next question. A 35-year-old female present to psychiatry OPD with history of recurrent episode of recurrent again and again low mood. First symptom, low mood. She struggles to get out of bed, means energy may be less. Yes. Neglect her personal hygiene, withdrawal from social activity. She used to enjoy, feel loss of interest in them. Means loss of interest is there. Decrease energy, maybe it is suggesting. Okay. Low mood, worthlessness, guilt, concentration is less, means more than 5 symptoms for 2 weeks. Diagnosis is depression. And if depression is occurring again and again, just like in past 5 years, yes, there is several times these episodes occurred. That is recurrent depressive disorder. Depression is occurring again and again. Depression is occurring again and again. Yes, sometimes you may find image-based question. Yes, depression. This is means more than one episode of depression. Then it is recurrent depressive disorder. One more question. If they ask that depression is occurring again and again and occur every time in a particular season, just like winters, then it would become seasonal affective disorder. Seasonal. So same question, if they say this depression occur every time in a particular season, then seasonal affective disorder. And Fmge question was there in seasonal affective disorder. What is the treatment? Bright light therapy. Bright light therapy. Okay. Very good, Naveen. Seasonal affective. Let's discuss other options also, because recently question has been asked. Bipolar disorder, BPAD, bipolar affective disorder type 1 and BPAD type 2. Both are question. One is also called classical BPAD. You will make a mnemonic mania. If you find mania in any question, you will say the diagnosis is BPAD 1. Okay. If you find 2 looks like H. Hypomania. Yes, hypomania. Then it is BPAD 2. Means if a patient is there, yes, depression is there and hypomanic episode is there, then the diagnosis is, please do comment. Yes, the diagnosis is BPAD 2. In the same question, if I say this patient develop mania, now the diagnosis would change to BPAD 1. Okay. So if hypomania and mania both are given, then answer would be BPAD 1. Now Fmge question, if 4 or more than 4 episode within a year, 4 or more than 4 episode in a year, yes, means CHAR, rapid cycler, or CHAR. Rapid cycler means 4 or more than 4 episode in a year. So these are question. So bipolar in this mania or hypomania is not there. So this is not bipolar. Persistent depressive disorder, also called dysthymia. Dysthymia, depressive symptoms are there. Yes, dysthymia, depressive symptoms are there. Yes, I write here. In dysthymia, depressive symptoms are there, but don't fulfill the criteria of depression, and these symptoms 2 years. Okay. One question has been asked in Fmge that depression in dysthymic patient. Dysthymic patient is called double depression. So depression in dysthymic patient, double depression. Now adjustment disorder means after breakup. Yes, after financial loss, after divorce, means subjective stressor, depressive symptom may come, but they don't fulfill the criteria of depression. That is called adjustment disorder. So adjustment disorder is diagnosis of exclusion. Listen carefully. If I say, yes, I take on this page, sorry for that. Yes, this is different question, but yes, I take here. Yes, if I say that there is after divorce, you will give me answer. After divorce, a lady, husband gave divorce to a lady, lady is very sad, decrease sleep, decrease appetite. These symptoms are there, don't fulfill the criteria of depression. Yes, you know, depression, to make the diagnosis of depression, 5 symptoms should be there. 5 symptoms should be there, but in this only 3 symptoms are there. After divorce, diagnosis would be adjustment disorder. Adjustment disorder with depressed mood. Depressed mood. In the same question, if they say sadness is there, decreased sleep is there, decreased appetite is there, decreased interest is there, decreased concentration is there, means 5 symptoms are there, depression criteria is fulfilled. After divorce, after breakup, after, yes, any subjective stressor, yes, depressive criteria is fulfilled, diagnosis is depression. Okay? Got the point? So, if criteria is not fulfilled, then it is adjustment disorder with depressed mood. If criteria is fulfilled, then depression. So, in this, adjustment disorder is not the answer, as there is no stressor in this question they have given. Okay. Now, yes, you can give me answer. By only one word you can give me answer. Seems confused. After road traffic accident, after burn, after electrolyte imbalance, after severe trauma, after major surgery, if patient is confused, acute confusional state, acute confusional state, acute disorientation. So, in this question, I pointed out only this acute confusion and marked the answer delirium. Acute confusional state, acute disorientation or clouding of consciousness. Without second thought, answer is delirium. Okay? Very good. Another name of delirium is ICU psychosis. ICU psychosis. Treatment of delirium is, yes, what is the treatment? Treat the cause. But if symptomatic management, then low dose antipsychotics. And in the same question, if I say the patient is having tremors, means same question is there. Patient is having tremors plus history of substance, means alcohol particularly, not substance, alcohol, better to say. History of alcohol. Okay. Then the diagnosis would become delirium tremens. Delirium tremens. And the treatment would be, yes, injection lorazepam plus IV thiamine plus IV dextrose. Yes, one question you can expect from delirium and treatment. Okay. So, same question, if they have given history of alcohol, tremors are there, autonomic disturbance are there, delirium tremens. If they have not given the alcohol and tremors and autonomic disturbance, then it is delirium. Okay, treatment of delirium tremens, lorazepam, thiamine, dextrose. Remember, we give dextrose after thiamine, not before thiamine. Question has been asked. Now, in this, these symptoms worsen in the evening significantly compared to daytime. This is called sundowning phenomena. क्या कहा मैंने? Sundowning. Very good. Naveen, sundowning phenomena. मीन्स जैसे जैसे सन डाउन होता जाएगा वैसे वैसे सिम्टम वर्सन होते जाएंगे. फिनोमेन. ओके, गॉट द पॉइंट. नाउ yes, this is insight. Yes, before going to question, insight, direct question in FMG. What is insight? Awareness about illness. Awareness about illness. Definition, multiple time question has been asked. One question on the level of insight, 5 level of insight. Suppose I am having schizophrenia, I am hearing voices, I am having hallucination, and you are a doctor, you ask me, do you have any problem? I say, no, I have no problem. Complete denial. Complete denial. You will say the level of insight is 1/5. So level is 1. Okay. If you ask me, do you have any abnormal sound or any problem? I say, Dr. Saab, I hear voices, but this is not illness. Everybody hear voices. Means kabhi ha, kabhi na. Means some awareness is there, that patient says that some voices are there, but denying at the same time. Then you will say 2/5 or level 2. Third is awareness of being sick but attribute to external physical factors. Suppose I am hearing hallucination and you ask me, do you hear voices? I say, yes, Dr. Saab, I am having some abnormal voices, but Dr. Saab, this is not my illness. Yes, my neighbors are releasing radioactive waves. That's why I am hearing voices. Means he is aware about being sick but attribute to external factor. My neighbors are emitting radio waves, that's why I am hearing voices. Means I attribute it to the external factor. Or I say, Dr. Saab, yes, I hear some voices, but whenever my sugar level fluctuates, then I hear voices. Means I attributed these symptoms to physical factor. So in this question, patient presented psychiatry OPD with self-muttering. When the patient was asked about hallucination, the patient replied, it is not a mental illness, it's due to fluctuation in blood sugar. Means attributed to physical things. Okay, physical factors. That is level 3. Level 3. Now level 4. Intellectual insight. In this patient would say, Dr. Saab, I know I am having mental illness, I am having hallucination. Means level is 4/5. But he will not follow your command. You will say, okay, you are having schizophrenia, you are having hallucination, take these treatment, do like this, take your medication on time, go to sleep on time. Means he will not follow your command, then it is intellectual. But if he is aware about his illness, or patient is aware about his illness or her illness and follow the command, change behavior, then it is emotional insight. This question has been asked. The highest level of insight is emotional insight. Okay. So these are 5 level of insight. In this, level of insight is 3. So these are question of psychiatry. In the last period of preparation, I would like to say that you should be confident enough, whatever you have studied till now, that is sufficient to clear your exam. The only thing you require is positive thinking. And the last phase for these 20 days around, okay, you must invest your time wisely and honestly. Means you will not waste your time. Means you will study honestly. Wisely means whatever required, means the important topics, previously asked topics, those should be read. So wisely and honestly. Best wishes. Thank you.
Hello, dear students. How was your CBoT today? I am Dr. Anupama Chaudhary Devgan, your physiology faculty, and I will be discussing the physiology questions. Hopefully, physiology was not too difficult, but let's discuss all these questions. Now, let's see the first question. This is from a very important topic which is asked again and again, and that is the baroreceptor control of blood pressure. The baroreceptors, as you know, are involved in minute-to-minute control of blood pressure. So let's see this question, it says, when blood pressure rises above normal levels, which of the following physiological responses occur as a part of a negative feedback mechanism to restore normal blood pressure? So if the blood pressure increases, increase in blood pressure will cause an increased stretch of the vessel wall. And if there is an increased stretch of the vessel wall, this will increase the firing rate of baroreceptors. Baro meaning pressure. So these are receptors for pressure. These are stretch receptors. More the stretch of the vessel wall, more will be the firing rate of the baroreceptors. Now, the baroreceptor reflex. If there's an increased firing rate of baroreceptors, the baroreceptor reflex now decreases the sympathetic and increases the parasympathetic discharge. And if there is a decrease in the sympathetic and increase in parasympathetic, what is going to happen to the heart rate? Decreases. And what will happen to the blood pressure? There will be a vasodilation, and a vasodilation will result in a decrease in the total peripheral resistance, and a decrease in the total peripheral resistance will cause a decrease in the blood pressure. So please remember, whenever there is a increase in the mean arterial pressure, more stretch of the vessel wall, more firing rate of the baroreceptors, what will happen to the sympathetic discharge? Reduces. And if the sympathetic discharge reduces, what will happen to the blood vessels? They will dilate. So let's see which of these options. Increased heart rate? No, there will be a decrease in heart rate because there is a decrease in sympathetic. Increased diameter of blood vessels? Yes, there will be a vasodilation which will increase the diameter of the blood vessels. Increased production of RBCs, increased production of WBCs, these are both unrelated to blood pressure control. So these cannot be the answer. So the answer to this question is B. Let's see the next question. Which of the following molecules commonly utilizes facilitated diffusion for its transport across the cell membrane? Now, please remember, gases, oxygen, carbon dioxide, they move across the cell membrane by simple diffusion. These are lipid soluble, so they move across the cell membrane by simple diffusion. Sodium ions, they move from outside to inside, from higher to lower concentration through channels. Now, movement of ion through channels is an example of simple diffusion, not facilitated diffusion. Yes, channels are proteins, but the sodium ion does not combine with the channel protein, right? So it passes through this channel protein. So it is more of a simple diffusion rather than facilitated diffusion. On the other hand, glucose is transported into the cell by GLUT, different types of GLUT. Glucose transporters. What are glucose transporters? These are carrier proteins which are specifically meant for the transport of glucose. And what happens is, glucose will first bind with the carrier protein. And then there is a conformational change of the carrier protein and glucose will enter into the cell. So remember, in facilitated diffusion, it is a carrier-mediated transport. It is mediated by that carrier protein. Whereas in the case of movement of ions through ion channels is more of simple diffusion rather than facilitated diffusion. So answer to this question, C. Let's look at the next question. Which of the following compartments holds the largest percentage of total body water in a healthy individual? Remember, 2/3 of the total body water is present in the ICF and 1/3 is in the ECF. In terms of percentages, 40% of the body weight is ICF and ECF is 20% of the body weight. Plasma is 5% and interstitial fluid is another 15% of the body weight. So my answer to this question is ICF. 2/3 of the total body water will be present in the ICF. Let's look at the next question. At high altitudes, which of the following changes commonly occurs due to decreased partial pressure of oxygen? Now, we are quite clear about this, that when you go to high altitude, because of decrease in barometric pressure, in high altitudes, because of a decrease in the atmospheric pressure, there is a decrease in the partial pressure of oxygen. If there is a decrease in the partial pressure of oxygen, this will stimulate the chemoreceptors. This will stimulate the peripheral chemoreceptors. Which are the peripheral chemoreceptors? These are the aortic carotid and the aortic bodies. And whenever the peripheral chemoreceptors are stimulated, they will stimulate the respiratory center, and there is an increase in the rate and there is an increase in the depth of ventilation, and this will increase the total as well as the alveolar ventilation. At the same time, peripheral chemoreceptors will also stimulate the vasomotor center. Vasomotor center is also present in the medulla, and this controls the sympathetic response. And if it stimulates the vasomotor center, there is going to be an increase in the sympathetic discharge. Increase in sympathetic discharge will cause an increase in blood pressure, increase in heart rate. So options A and B are not your answer. Is there going to be an increase in respiratory rate? Yes. Peripheral chemoreceptor stimulation will stimulate the respiratory center. There is increase in both the rate as well as the depth of ventilation. Will there be a decreased red blood cell production? No, there will be an increased RBC production. Why? Because remember, hypoxia is a very potent stimulus for increasing the secretion of erythropoietin. Erythropoietin is secreted from the kidney, and erythropoietin will increase the RBC mass. It increases the total number of red blood cells. So the answer to this question is C. Let's see the next one. A 24-year-old patient presents with shortness of breath and unable to exhale fully. Which lung volume is responsible for maintaining air in the lungs to prevent collapse during forceful expiration? Now, please remember, at the end of forceful expiration, the lung volume is not zero. There is air trapped in the alveoli, and that air which is trapped in the alveoli is known as the residual volume. What is residual volume? Residual volume is the volume of air which remains in the lungs at the end of a forceful expiration. So because this residual volume is present in the alveoli remain patent. They do not collapse. So answer to this question is B. What is tidal volume? This is the volume of air which is inspired or expired during a normal tidal or a normal quiet respiration. What is inspiratory reserve volume? This is the volume of air inspired forcefully over and above a tidal inspiration with maximum effort. What is ERV? This is the volume of air expired forcefully over and above a tidal expiration with maximum effort. So my answer to this question will be residual volume. Let's see the next one. A 43-year-old patient presents with symptoms of epigastric pain. There is heartburn. There is frequent belching after meals. Upper GI endoscopy reveals erosions in the gastric mucosa. Laboratory investigations show increased serum gastric acid levels. Which of the following hormones is most likely responsible for the increased gastric acid secretion observed in this patient? Now, out of these, the only one which can increase the gastric acid secretion is gastrin. Gastrin will act on the oxyntic cells or the parietal cells and increases the production of HCl. Secretin cholecystokinin will decrease the gastric acid secretion. Ghrelin is an orexigenic hormone, that means it increases appetite. It is also a growth hormone secretagogue. It increases growth hormone secretion. It does not affect the gastric acid secretion. Let's see the next one. C fibers are involved in the transmission of, and that is slow pain. Vibration is carried by A beta fibers. Fast sharp pain is by A delta fibers. For proprioception, A alpha as well as A beta, but if I have to choose between the two, then better answer is A alpha. A alpha neurons can be motor and they can be sensory. Which sensation is carried by the A alpha neurons which are sensory? That is proprioception. Proprioception is the fastest conducted sensation. So answer is C. Let's see the next one. The Nernst potential for sodium is which of the following? The Nernst potential for sodium is plus 61. Minus 90 is the equilibrium potential or the Nernst potential for potassium. Plus 125 is the equilibrium potential for calcium. Minus 70 is the equilibrium potential for chloride. For sodium, it is plus 61. The next question. Which of the following is not responsible for causing a right shift of the oxygen dissociation curve? Increased temperature causes a right shift. Elevated PCO2 will cause a right shift. Increased 2,3-DPG will cause a right shift. Increased pH or a decreased H plus or increased pH will cause a left shift. So answer to this question is option B. Let's see the next one. Which of the following hormones primarily acts by increasing intracellular cyclic AMP? Let's go over the options. Insulin does not need a second messenger. It does not use a second messenger, and this is because the insulin receptor itself has tyrosine kinase activity. Estrogen and thyroid hormones are lipid-soluble hormones, and lipid-soluble hormones can easily cross the cell membrane, so they do not use second messengers. Only water-soluble hormones use second messengers. So the answer here is glucagon. Glucagon uses cyclic AMP as the second messenger. Let's look at the next question. Sodium potassium chloride co-transporter Na plus K plus 2Cl minus co-transport for ultrafiltrate in tubules is located in which of the following? This is in the thick ascending limb of loop of Henle. In the DCT, Na plus Cl minus co-transporter. In the descending limb of loop of Henle, there is no sodium reabsorption. Sodium is reabsorbed in all segments of the nephron except the descending thin segment. What is absorbed in the descending thin segment? Water. PCT, for sodium absorption in the PCT, you have a sodium glucose co-transport. You have a sodium amino acid co-transport, a sodium inorganic phosphorus co-transport, and a sodium H plus counter transport. But in the thick ascending limb, the co-transporter which is present is the Na plus K plus 2Cl minus co-transport. Let's see the next one. Transcytosis occurs in which type of cell? Now, what is transcytosis? Let's try and understand that. This is the intestinal epithelial cell of a newborn. Now, what happens is, a newborn baby is given colostrum. The colostrum is very rich in immunoglobulins. The colostrum is the initial secretion from the mother's breast, and this is very rich in immunoglobulins. So what happens is, the epithelial cell, the intestinal epithelial cell of the newborn, it absorbs the intact immunoglobulin molecule by endocytosis. The intestine of the newborn is not mature enough to break down the immunoglobulin. So the complete immunoglobulin molecule will be absorbed by endocytosis. It enters into the cell, and then this immunoglobulin molecule is exocytosed on the basal side so that the intact immunoglobulin enters the baby's plasma. And this is a very important route of passive immunity in the newborn. And this process is known as transcytosis. Endocytosis on the luminal side and exocytosis on the basal side. So this is seen in the epithelial cells of the intestine. You do not see transcytosis in any of the other cells. So answer to this question, option C. What initiates late repolarization phase of the action potential in the cardiac muscle cells? Now, in the cardiac muscle cells, you have the plateau potential. 5 phases. Phase 0 or depolarization due to opening of voltage-gated sodium channels and due to a sodium influx. Phase 1, which is the early repolarization phase, and this early repolarization phase is due to closure of the sodium channels, so decrease in sodium influx. Then you have phase 2, which is the plateau phase, and plateau phase is due to calcium influx through slow calcium channels, plus there is also a potassium efflux through opening of voltage-gated potassium channels. In this phase, there is gain of positive charge and loss of positive charge happening at the same time. So there is no change in potential and you get a horizontal line in phase 2. The calcium channels will close at this arrow, and then you have phase 3, which is the late repolarization phase. And this late repolarization phase is only due to potassium efflux through voltage-gated potassium channels. Phase 4 is the hyperpolarization phase, which is due to slow closure of the voltage-gated potassium channels. So answer to this question is B. Next question. A 28-year-old patient with suspected histotoxic hypoxia. What is histotoxic hypoxia? Here, the cells are unable to utilize oxygen. Like, for instance, what you see in cyanide poisoning, right? There is inability of the cells to utilize oxygen. Which symptoms would be atypical and inconsistent with this condition? Altered mental status will be seen. Respiratory distress will be present. Decreased tissue oxygenation will be seen. But what will happen to the arteriovenous oxygen difference? It in fact reduces. Normally, when blood passes through a capillary, the PO2 on the arterial side is 95 millimeters of mercury, and on the venous side, it reduces to 40. Why does it reduce to 40 on the venous side? Because the oxygen has diffused from the blood into the capillaries. The tissues utilize that oxygen, so the venous PO2 reduces. But if the tissues are unable to utilize oxygen, the venous PO2 will increase. Instead of 40, it may be 50, 60, 70. So what will happen to the arteriovenous oxygen difference? This will in fact reduce, not increase. So answer to this question is D. All other features of REM sleep except beta waves of EEG are recorded in this phase. This is true. This is also known as paradoxical sleep. Yes. Why is it known as paradoxical sleep? Because you're sleeping, but the EEG waves recorded are beta, and normally beta are recorded in the alert, awake state. This is associated with somnambulism? No. Somnambulism is sleepwalking. This occurs in NREM sleep. Sleepwalking, sleep talking, nocturnal enuresis. What is nocturnal enuresis? Bedwetting. All of this occurs in NREM. Tone of the neck muscles is markedly reduced? Yes. Isn't it? This is a very common kind of an experience when you're traveling in the bus or in the train. The fellow sitting next to you dozes off, and after a while his head topples to one side. That is because he has gone into REM sleep, and in REM sleep, the tone of the neck muscles is markedly reduced. So these were your questions in the CBoT, and my email ID is dranupamadevgan@gmail. So any queries related to today's test, please feel free to send me a mail and I will try to clarify your doubts. So hope you enjoyed this session and hope I could clarify some, if not all, of your doubts. And thank you very much and all the best.
Hello students, welcome. So today we will be discussing dermatology questions. The first question was, identify the disorder shown in the image below. Now what you can see a female having a light color or depigmented lesion over center of forehead. Now we know that what females apply over center of forehead, they apply bindi. So many a times the adhesive which is present behind bindi can have certain chemicals which can lead to contact leukoderma, that is white skin. Leuko means white, derma means skin, due to contact to some chemical. Okay, so this is contact leukoderma is the answer here. Albinism, all of you know, is a genetic condition, and since birth the whole skin is white in color and the hair follicles also become white. Vitiligo, all of you know, here also depigmented skin can be seen, and remember that it is not at a particular specific site like in contact leukoderma, it is only over here. Okay, while in vitiligo vulgaris, which is the most common type, there can be bilaterally symmetrical lesions. And similarly, pybeldism is a genetic condition. So since birth, a depigmented patch is present. Okay, so that's why here the answer is contact leukoderma. In the second question, you can see 22-year-old male presented to the OPD with annular lesions. So lesions are annular. They are scaly. Plaques in both the groin, and groins are the affected areas. He used over-the-counter topical drug which led to temporary relief, but after stopping the drug, it reappeared. What is the diagnosis? Okay. Now, if you see the image, you can see that in the groin, patient is having such type of scaly annular lesions with central, in the central lesion. So in the central part of the lesion, there is central clearing. It is appearing as if the lesion is healing in the center, but it is progressing in the periphery, and that's why such ring-like lesions are seen. So this is a case of tinea, which is a fungal infection. Now, if you apply steroid in tinea, what happens that the inflammation subsides and the lesions appear as if they are resolving, but as soon as you stop applying steroid, it flares up. Okay, and that is what they are saying, that he used over-the-counter drug, which could be steroid, which led to temporary relief, but on stopping, it reappeared. Okay, so they are talking about which type of tinea. The tinea where patient has applied steroids and then it has reappeared. This type of tinea is known as tinea incognito. So incognito means hidden tinea, and why this is hidden? Because of steroid application. A rose gardener. So from the name itself, you know, rose gardener. So there is one disease, rose gardener's disease, which is sporotrichosis. Yes, and in sporotrichosis, what happens? Generally, the lesions start developing after plant injury. So after plant injury, like thorn prick injury, he developed following skin lesions, and if you see the skin lesions, they are present in linear fashion. Okay, so what can be the causative organism? Yes, the diagnosis is sporotrichosis, which is caused by sporothrix. Yes, so sporothrix Shiansky is the causative organism which causes sporotrichosis, where linear nodules are seen generally over extremities. Why over extremities? Because generally it occurs after plant injury, which is generally over exposed areas like hand and foot. So that's why these lesions also develop over extremities. In the next question, they are saying 6-year-old boy presented with multiple papules and exudative lesions. Exudative means there is some wet lesion or there is some fluid which is coming out from the lesions on his scalp, face, web spaces of the finger, palms and sole. His elder brother also had history of itchy lesions. What is the probable diagnosis? Now remember that in adults, when scabies occurs, okay, so when scabies occurs in adults, generally face, palm and soles are spared. Okay, so if these sites are mentioned like face, palm, soles, then it is suggestive that probably this is not scabies. But remember that when this occurs in infants, so generally in infants, but yes, in young children also, like here, there is a 6-year-old boy, these sites can get involved. Okay, so this is a case of scabies, and the most important clue are web space involvement, which is very common for scabies. Itchy lesion, because scabies is a very itchy condition. Initially papules are seen, but gradually what happens due to secondary infection, sometimes they may become exudative lesions as well. So this is a case of, yes, scabies. So remember that why the answer is scabies, because here these are 3 important clues which are present. That is, the lesions are papular and they are present over web spaces and they are itchy. Now remember that atopic dermatitis can also be itchy, but it has predilection for flexural areas, okay, and not necessarily palm and sole. So that's why it is not atopic dermatitis. Seborrheic dermatitis can also be itchy. Here also exudative lesions can be seen, but this occurs generally over seborrheic areas. Seborrheic areas like face, scalp, but not palm and sole. And allergic dermatitis generally occur over the site where the allergens are coming in contact with the skin. Like if somebody is having airborne contact dermatitis, then wherever the air is coming in contact, there only the lesions will be present. So generally the hidden areas are spared, like web spaces. So that's why the answer is not these 3, but the answer is scabies. Which of the following is the most common blistering disorder in infants and children? Now, all of you know that there are so many blistering conditions like pemphigus, pemphigoid, but among all these blistering conditions, which is very common in infants and children? And remember that it is also known as CBDC. Why? Because it is very common in children and it is known as chronic bullous disease of childhood. That is childhood linear IgA disease. Linear IgA disease. Okay, so this is one of the very common blistering condition which is present in infants and children. Though epidermolysis bullosa simplex is also a genetic condition, So it can be seen in children and infants, but remember that this condition is not very common. It is a genetic condition, it is a rare condition. Then pemphigus, like pemphigus vulgaris, which is the most common type, and pemphigus vegetans, which is the rarest type. Pemphigus generally occurs in the age group of 40 to 60 years. So this is the common age group for this. So that's why these are not the answer. The answer is linear IgA disease. So thank you very much. All the best.
Hello students, so now we'll discuss the radiology questions of today's CBoT. So only 5 questions, easy enough I think. So let's go and start the radiology question. So coming to the first question, a 4-year-old boy visited the pediatrics outpatient department reporting pain in the left flank, a noticeable mass after consuming significant amount of water. The pain resolves over time, the mass becomes non-palpable and the child also experiences increased urine output. An intravenous pyelograph was performed revealing the following image. What is the diagnosis? So first of all, this mass comes and goes and is more when the child drinks water. Now what is the image that is given to us? So tell me, is it a normal X-ray KUB? It is an IVP or is it an MCU? Because these are the 3 types of images in which students have a lot of confusion. So a simple rule of thumb, if you are able to see the ureter, okay, so here you are able to see the ureter, this is the ureter, but you are not able to see any urethra. That means the contrast has been given IV, it is being excreted through the urinary tract into the bladder and not out of the bladder via the urethra. If you are seeing the urethra, that has to be a maturating cystourethrogram. Okay, I hope this is clear. So this is an IVP image. And in the question also it is given to us that it's an intravenous pyelogram which is performed. Now what are the findings here? On the right hand side, this is the right side of the IVP, this is the left side of the IVP. So on the right hand side, which is the normal side, this is the normal side. What are we seeing? This is the normal side. What are we seeing? We are seeing the normal PCS. These are the calyces, the major calyces and the minor calyces. This is the renal pelvis. And the contrast is excreting into the ureter. So the normal side is not dilated, but on the left hand side, what do we see? We see that the left ureter is not visualized, And what do we else see? We see that the PCS, pelvic calyceal system of the left kidney is grossly dilated. So there is gross hydronephrosis, HDN. So this is a case of PUJ obstruction, that is contrast is not getting excreted from the renal pelvis into the ureter. That is, there is a block at the level of the renal pelvis or the pelviureteric junction. So pelviureteric junction will have what? It will have hydronephrosis, but the ureter is not visualized. Okay? If you have hydronephrosis plus the ureter is dilated, okay, that means that there is an obstruction either at the lower end, so it is either a distal ureteric calculus in case of an IVP image, or if it's a maturating cystourethrogram, then the second possibility, the second reason for a HDN plus dilated ureter is a VUR or a vesicoureteric reflux. And in VUR, you will be given an MCU image. You will be given an MCU image, maturating cystourethrogram. So you will see the urethra. Okay. Now, why is it not a Staghorn calculus? You will say because this is an IVP image. Okay. Now, how does a Staghorn calculus, a putty kidney looks like? So I've given you plain KUB radiographs. Okay, so all these are KUB radiographs. Why am I saying these are radiographs, not IVP? Because you are not seeing any ureter, you are not seeing any bladder which is getting filled with the contrast. So this is a plain X-ray KUB. Similarly, on the second image, you do not see any nephrogram on the left hand side. You do not see any ureters. You do not see any bladder. So this is a plain KUB X-ray. Similarly, on the third image, what do we see? We do not see any ureter. We do not see any bladder. So this is again a plain KUB radiograph. Now, on the first image, we see that there is opacity, which is taking the shape of the renal pelvis, renal calyx. So this becomes a staghorn calculus, right? Calculi taking the shape of the renal calyx. Now, in the second image, we again see calcifications, but they are lobulated in the shape of the kidney. These are reniform calcifications. They are calcifications in the renal cortex. They are calcifications in the renal cortex. So this is an example of putti kidney. Correct? Now, in the third image, you see that there are these patchy calcifications. Okay? These are these patchy calcifications, and these are in fact the calcifications in the renal medulla. And so this is a case of medullary nephrocalcinosis. Medullary nephrocalcinosis. This is a case of medullary nephrocalcinosis. Two important causes of medullary nephrocalcinosis, you remember. One is hyperparathyroidism. I am writing it as hyper-PTH. And the second cause is renal tubular acidosis. Okay? Distal renal tubular acidosis per se. These are the causes of medullary nephrocalcinosis. So I hope this was clear how to differentiate a PUJ obstruction, a vesicuretic reflux, a putti kidney, a staghorn calculus, and medullary nephrocalcinosis. Correct? Now let's move on to the other images of such appearances. So tell me the first image, what kind of a modality is this? You are not seeing any ureter, you are not seeing any bladder. So this is a plain KUB X-ray. This is a KUB radiograph. And tell me the diagnosis. You are seeing again opacities outlining the renal pelvic calyceal system. So this is staghorn calculus. Correct? Now in the second image, tell me the modality. So you are seeing the ureter, you are seeing the bladder, but you are not seeing any urethra. So this is an IVP. This is an IVP. And here you see that there is some obstruction, there is some dilatation at the level of renal pelvis. There is although faint contrast opacification of the ureter, but the pelvis is dilated and so are the calyces. So there is abrupt transition at the PUJ. So this is a case of a partial PUJ obstruction. Okay? Now tell me this third image. What image is this? So you are again seeing bilateral renal calyces, you are again seeing ureters, you are again seeing bladder, but here you also see a urethra. So this is an MCU, maturating cystourethrogram. So the patient is voiding on the table, excreting contrast, and during that time the ureters and the renal calyces are also being opacified. So yes, this is a case of a vesico-ureteric reflux. Okay, now let's move on to the next question. So which of the following accurately represents the sequence of material attenuation on CT scan? Okay, so a simple straightforward question from CT basics. So an accurately represents sequence of material attenuation on CT scan. Now we know that from black to white. So if this is a graph or this is a line from blackness to whiteness of the structures on CT. So we know that the most black structure is air. We take its attenuation as -1000. Then we know another black structure, that is fat. We take its attenuation, it's negative around 60, 40 to 60. So at 0, we have water, right? Now at plus 1000, the most white structure is a metal. So metals show streak artifacts on CT scan, right? And around 400 to 600, we have bone, we have IV contrast, iohexol, etc. So let's see the options here. So what will be the sequence? So air will have the least attenuation, okay, minus 1000, followed by fat, followed by water, followed by bone, and finally followed by metal. Okay. Now in between water and bone, at this level, we have our soft tissues. So soft tissues on a non-contrast CT have an attenuation around 40 to 60 HU. Okay. So on a non-contrast CT, soft tissues will fall in between water and bone, So amongst these, tell me what will be the correct order of material density. So most will be bone, followed by liver, water, fat, and air. Okay, this is a decreasing order of attenuation. So the correct answer here is option B. Okay, so let's just revise this once again. At minus 1000 we have air. At plus 1000 we have metal, bones around 400, soft tissue around 50, water 0, and fat minus 100. So 60 minus 60 to minus 100, you can take it as fat. So all these structures below 0 will appear black, and all those structures above 0 will appear white on a non-contrast CT. So how do they look? So see that this is a non-contrast CT and you are seeing these acute hemorrhages. Okay? These appear bright on non-contrast CT. Similarly, fat, dermoid has a fat within, so it appears black. So any fat containing ovarian mass, okay, so this is the uterus, this is the typical location of an ovary on a CT scan, a fat containing ovarian lesion. Also, you see that there is this calcification within. So you have fat, you have calcifications within an ovarian lesion. So this is a case of dermoid, right? And you can see how bright bones appear on a CT scan. That's actually how we identify that this is a CT and not an MR, because on MR, bones appear black. And similarly, IV contrast. You can see contrast in the vessels. It also appears bright on CT. Okay, so remember this diagram, that this is the order of attenuation values of various structures on a CT scan. Correct? Now let's move on to the next question. So a 38-year-old man visited the gastroenterology outpatient department reporting non-specific upper abdominal pain. Sonography indicated focal areas of fat infiltration, prompting request for an MRI of the liver for a more detailed evaluation. So which sequence are most effective in confirming the diagnosis of focal fatty infiltration? Now remember just one term, that focal fatty infiltration has intracellular fat. That is, it is a microscopic fat. That means that the hepatocytes, within the hepatocyte there is microscopic fat deposition. It's not like that adipocytes are replacing the normal hepatocytes. No, the normal hepatocytes have microscopic or intracellular fat within. So whenever we want to image intracellular fat, remember one sequence, we have to do in phase, oppose phase imaging. This is also known as out of phase. So this is in phase, opposed phase imaging, also known as chemical shift imaging. Okay, also known as chemical shift imaging for microscopic or intracellular fat. Now coming on to, you would ask me, sir, okay, why don't we use a fat saturated sequence? You told us in basics of MRI that for suppressing fat, we use fat saturated sequence. So remember, fat saturated sequence are used to image macroscopic fat. For example, you have fat in your subcutaneous tissue. Okay, you have a lot of fat in the mesentery, in the omentum. So whenever you want to image that, or we want to suppress that fat, we'll use a fat saturated sequence. But for microscopic fat, we have to do chemical shift imaging or in-phase opposed phase imaging. Okay. Now, how does this in-phase opposed phase imaging look like? So, this is how typical chemical shift MR is done. Chemical shift MR, and you can see that these are out of phase images and these are in phase images. Now, both in phase and opposed phase images are T1 weighted. Okay, both of them are T1 weighted. And how do you identify that it is an opposed phase image? You don't really need to know the physics of in phase and opposed phase at this point, but just remember that opposed phase image you identify by this India ink artifact. India ink artifact. Now, what is this India ink artifact? If you see carefully this image, you can see this black line outlining the various structures. So, this is the rectus muscle which is being outlined by this black line like in India ink. Similarly, pancreas outline is being outlined. Okay? So, this is how you identify this as an opposed phase image. And a normal T1 weighted image, you won't see any India ink artifact. So, this is a normal T1 weighted because the CSF in the spine is black. So, this is a T1 weighted image and you do not see any India ink artifact here. So, this is an in-phase image. Okay. Now, on in-phase image, if you look at this area, this is similar to that of the normal liver, correct? But on the same area on opposed phase image, you see that there is a signal loss, that there is blackening of that area. The signal has lost there. So, if there is a signal drop on opposed phase images, that tells you that it is a microscopic fat or intracellular fat, or sometimes the terminology can be intravoxel fat. Okay? The same voxel has both microscopic fat within. Okay? Now, how does focal fatty infiltration looks like? On ultrasound, if you do, it will appear like a geographic lesion, an ill-defined lesion, not having a capsule. So, capsule formation tells you that this is a lesion, this is a mass. But focal fatty infiltration, that a part of the liver has fatty infiltration, will appear ill-defined. It will have geographic margins and it will appear bright on ultrasound. Bright ko, what do we call it? We call it hyperechoic. So, focal fatty infiltration is hyperechoic on ultrasound. And just now we read that fat has low attenuation than soft tissue and then water. Okay, -100 tha fat ka attenuation. So, on CT scan, they will appear hypodense, matlab black. So, focal fatty infiltration is hypodense on CT scan and again has an ill-defined outline. Now, to confirm whether this is a lesion or just a focal fatty infiltration, what we do this chemical shift imaging or in-phase opposed phase imaging. Because CT पे तो हमें लग रहा है ना कि ये lesion क्यों नहीं है? This can be a tumor, this can be a mass. But how do we confirm it? We do a chemical shift imaging, and if there is signal drop on chemical shift imaging, we know that this is a focal fatty infiltration. Okay? A little tough topic, yes, but very important for you to understand this point. Now, just a word, since we are talking about in-phase opposed phase imaging, so I'll just tell you two uses of it at your level in MRI. So, first use we have just read, it is focal fatty infiltration, and second use of this is in adrenal adenoma. Okay, adrenal adenoma also has microscopic fat within, and if you see a signal drop on in-phase opposed image in an adrenal mass, then you can say that yes, this is an adrenal adenoma. Okay, so I hope this little tough topic is clear to you now. Two important uses, focal fatty infiltration and adrenal adenoma. How do we identify it? We see the India ink artifact. If there is signal drop on opposed phased images, we know that it is a microscopic fat or intracellular fat. Now we move on to the next question. A 38-year-old man arrived at the emergency room with sudden onset of dizziness, weakness and palpitations. An emergency diagnosis is identified a hypertensive emergency, and the patient reported similar episodes in the past with no family history. So there is recurrent episodes of hypertensive emergency and the patient has palpitations. Now pheochromocytoma is one of the DDs, yes, and he was referred for radionuclide scan. So it's a direct question, which of the following radionuclide scans is used for imaging of pheochromocytoma, and we all know that yes, MIBG scan is used for pheochromocytoma and other paragangliomas, right? Now what is DMSA scan used for? It is used for imaging renal scars, so mainly vesico-ureteric reflux in children, to see how much scarring has happened in the kidneys. Again, MAG3 is again a type of renal scan, but where is it used? It is used to calculate the tubular secretion plus GFR plus glomerular filtration. So it is secreted both via glomerular filtration and tubular secretion. So it is used for renal dynamic studies. Okay, RDS, renal dynamic studies, for seeing PUJ obstruction. We use MAG3. Now HIDA scan, we know it is secreted by the Kupffer cells. HIDA is secreted by the Kupffer cells of liver. So it is excreted in bile. And which pathologies is HIDA scan then used for? It is used in acute cholecystitis. However, in acute cholecystitis, we know that the investigation of choice is, however, an ultrasound. Where else is HIDA scan used? It is used in biliary atresia. Biliary atresia, and one more thing, for bile leaks. These are the three uses of HIDA scan. Okay, now we move on to the next question. What type of MRI technique is shown in the image? So again, a straightforward question. We see that this is the gallbladder, this is the biliary tree which has been outlined. Okay, this right here is the main pancreatic duct. So what is the modality? We are imaging the biliary tree and the pancreatic duct. So it is a magnetic resonance cholangiopancreaticography, because it is an MRI. Everything is appearing black. Now if it was a ERCP, so ERCP is endoscopic retrograde cholangiopancreaticography, so it will have an X-ray image. Okay, how does an ERCP looks like? This is how an ERCP looks like. You see an endoscope and you see that there is a cannulation of the CBD which has been done, and again the whole of the biliary tree is being opacified. So for biliary tree, we know that ERCP is the gold standard for biliary tree pathologies, and for biliary tree pathologies, MRCP is the investigation of choice because it is non-invasive. Okay. Now other two options, MR enterography and urography. So as the name suggests, if we are imaging the bowel on MRI, that will be MR enterography. So you see the small bowel being distended by the hygroscopic agent mannitol. So this is an MR enterography. And if we are imaging the urinary system on MRI, we use MR urography. Okay. So this was about today's CBoT for radiology. Thank you.
Ladies and gentlemen, welcome to the CBoT of ophthalmology. And as we go into the final lap of exams for my friends, in another 20 days, let me guide you through the final few questions of ophthalmology as we move into the final phase of exams. Okay, so let's look at that. First of all, we have this question which says, during a game, a 26-year-old baseball player is hit on the head by a baseball, causing damage to his optic canal. Now that's important. Remember, optic canal. Which of the following pairs of structures is most likely to be damaged? So here we're dealing about pure anatomy questions. Remember, I have always told you that anatomy is destiny. Okay, so let's look at that. Optic nerve and ophthalmic vein. Dear me, incorrect. Ophthalmic vein, ophthalmic nerve, incorrect. Ophthalmic artery, ophthalmic optic nerve is the correct one. Please remember, that is the correct answer. This one. And ophthalmic nerve, optic nerve is again wrong combination. So we have the two most important structures passing the optic canal, and this you can see here. Look at that. This is optic canal structure in a wide cross section. This is the optic nerve here, and this is the ophthalmic artery passing through the optic canal. And from the ophthalmic artery, a small branch will come out and enter into the optic nerve as the central retinal artery, isn't it? So remember, this is very important for us because the optic canal, and remember the surface anatomical structure we have to be careful about, the optic canal lies very close to this junction where the eyebrows are. Okay, so if you remember, the best way to locate this thing is the junction of the medial 2/3 and the lateral 1/3 of the eyebrow. Okay, the junction of the lateral 1/3 and the medial 2/3 of the eyebrow. This is where directly the optic canal lies under it. So if you have an injury somewhere here, and I must tell you that this year, early January, I had an injury to my left exactly that way, and was really scared that the optic canal and the optic nerve would be compromised. So that is the intracanalicular part of the optic nerve, which you can see passing through. This is the part of the optic nerve. Another MCQ. This is the part of the optic nerve that is susceptible to maximum trauma. Remember, the optic nerve has 4 parts. Okay, there's one part intraocular, then it becomes the intraorbital, it becomes intracanalicular, and then it becomes the intracranial. Can you remember of this? The intracanalicular part, that is the part of the optic nerve that is within the optic canal, is the most susceptible to trauma. Okay, that is the answer. Very well. I hope you got that, ladies and gentlemen, if your anatomy is strong enough. 48-year-old farmer comes to the hospital with a history of an eye injury from a leaf that happened 5 days ago. The patient has congestion, photophobia, and watering. What is the diagnosis? Now, ladies and gentlemen, the most important thing here is that we have an injury from a leaf. Okay, remember, anything organic matter, which means the leaves of a tree, the flowers of a plant, okay, or the bark of a tree, anything organic. It could be a cotton, it could be rayon, it could be handkerchief, it could be coat, whatever. Anything organic, anything non-metallic causing damage to the eye leads to one inescapable conclusion that we're heading towards number C, fungal corneal ulcer. Fungal corneal ulcers are well known for the lack of symptoms. They do not cause pain. That is why there's no pain here. So photophobia and watering, but there's not much pain here. We call the fungal ulcer very quiet, very quiet. We call them signs more than symptoms because there are no symptoms as such. The patient is not aware of the ulcer, but the doctor can see the infiltrate, and that's the fungal corneal ulcer. As you can see it here, look at the hypopyon. Look at the typical shape of the fungal corneal ulcer. It's fluffy, feathery, and the classic satellite lesions, which we are so fond of asking you, are missing here. Of course, remember, in every case, you do not get the satellite lesions, but if they are present, then it tells us that this is a fungal corneal ulcer. So, look at the feathery, the fluffy margins, looks like cottony, soft like thing. It looks like you can scoop out the entire infiltrate. This kind of appearance with finger-like projections of surrounding stroma and feathery margins is very typical of fungal corneal ulcer. Is it not? So, the answer here, and most of you got this, I hope, is a fungal corneal ulcer. Question number 3 is a new one, a tricky one, an old question actually, which has been recycled from the depths of the previous papers. And the formation of a salmon patch in the cornea is classically associated with an infection by, remember the salmon patch, salmon is a fish, as you know, no? It's a fish, and it is appears sometimes reddish pinkish in color. Salmon pink we call it because of the typical appearance of the fish itself. So on the cornea, you get this typical reddish pinkish color on the cornea. And this is classically associated with tuberculosis, HIV, syphilis, or HSV. The answer, ladies and gentlemen, is syphilis. Remember this, as I said, it's an old question dredged out from the well of the previous year's questions. And look at the salmon patch. Got a very famous question. You can see this pinkish reddish on the superior limbus here. This is a combination, remember, of extension of the lymphatic vessels as well as the new blood vessels. You see, this is a stromal infiltration of new blood vessels, typically seen in interstitial keratitis. We call it interstitial keratitis caused by syphilis. And this combination of new blood vessels and lymphatic extension causes a peculiar pinkish appearance in the cornea, which we called salmon patch cornea. This used to be very common in the bad old days till penicillin came along, and nowadays thankfully we have less of. We do not have too much of syphilis, so we do not have salmon patch cornea. But you must remember this particular term. Salmon patch is due to syphilis, could be congenital or acquired syphilis, and also called interstitial keratitis of Hutchinson. Very well. Based on the provided image, the most likely diagnosis, and if you look at the image, we have an FA here, fluorescent angiography. But if you look at the dye leaks out like, what are these peculiar shapes like this? They have these shapes like this, like a flower, like this. And those of you who have been careful with your studies, you can really make out that these shapes are telling you of the new blood vessels that are formed on the retina due to choice number B, PDR, proliferative diaberetinopathy. This is not. See, in hypertensive retinopathy, you do not have these new blood vessels. This is obviously, as you can see this, the dye has filled up and leaked out of the main vessels, and these are new vascularization. These fronds that you see, these typical flower petal-like appearances are the new vascularization on the retina. Now, you do not get neovascular in the hypertensive retinopathy. So, answer is PDR. Sickle cell retinopathy, incorrect. Central retinal vein occlusion, you do not get this neovascular on the retina like this. This flooded neovascular on the retina is a typical sign of PDR. The answer, ladies and gentlemen, is proliferative retinopathy, as you can see by the new blood vessels that appear on the disc and on the retina all around. Okay, so remember, PDR usually takes about almost 15 to 20 years of diabetes before it comes. Okay, in the first 20 years, you have NPDR, and then after about 20 years, remember, it comes about PDR. So this is the PDR. On ocular examination, next question, a patient known to have an autosomal recessive disorder shows the following image. What is the diagnosis? And on this bluish iris, you can clearly see this brownish colored ring here, which is the famous Kaiser-Fleischer ring. All of you should have no difficulty in identifying this. It's the famous KF ring, the Kaiser-Fleischer ring, and therefore the answer is not diabetes, not galactosemia, not homocystinuria, but the answer is Wilson's disease. You all remember that Kaiser-Fleischer ring is a deposit of copper on the Descemet's membrane of the cornea. This is not, remember, it is not to be confused with the Fleischer ring, which is a ring on the epithelium, and it is not copper. Remember, Fleischer ring is in keratoconus, Kaiser-Fleischer in Wilson's disease. Fleischer ring is deposit of iron, KF ring is deposit of copper, and Fleischer ring is present on the epithelium, but KF ring is from the Descemet's membrane. They're completely different, and you should have no difficulty identifying this as the KF ring of Wilson's disease. And you can see another type of Wilson. Look at that. In this iris, which is a bit of a hazel colored iris, you can see the KF ring appears brownish color. Sometimes it appears also as greenish bluish also, because it's copper. And sometimes, as we saw in this, it appears a dark area on a blue iris like this. But this is all the same on the periphery of the cornea and Descemet's membrane, and this copper deposition. This is KF ring, and the diagnosis is Wilson's disease. I think all of you have got this right. We have done this many times in your practice run-ups. Increased intraocular pressure in ophthalmos causes all of the following except, okay, remember, ophthalmos is raised intraocular pressure to congenital glaucoma. So, is it ruptured descemet membrane? Yes, remember, ruptured descemet membrane does occur because the size of the cornea enlarges because of raised intraocular pressure. So, this causes ruptured descemet membrane, which appears as usually as horizontal lines parallel railway tracks. We call it as Habs-Tri, is it not? So, we do have that. Corneal edema we do have because raised intraocular pressure forces the aqueous humor into the cornea, causing haziness of the cornea due to corneal edema. Axial myopia also we do have because the stretching of the eyeball causes axial myopia. You all remember 1 mm extra stretching causes 3 diopters myopia. But what it does not cause, and that is the question which it does not cause except, is corneal neovascularization. You don't have new blood vessels on the cornea in ophthalmos, and you can see here that the eye it's a huge eye. You can see the size of the eyeball bulging out, and you see the haziness. We cannot see the iris here. So you can see all of these, but you do not see corneal vascularization. So I think, ladies and gentlemen, you should have all got this correct. Next question. A 56-year-old male presents to you with alcoholic liver disease, alas, all too common nowadays. Presents with bilateral, oval, punched out corneal ulcers with dry, lustreless corneas. Dear me, there's too many hints here. Too many hints here. What is the most likely cause of the ulcer? Is it Sjogren's syndrome? Is it exposure keratitis? Is it xerophthalmia? Or is it filamentary keratitis? Let's look at that. Again, 56 male with alcoholic liver disease. So remember that whenever you have alcoholic liver disease, all the vitamins get knocked out. Okay, all the vitamins get knocked out. It would be the vitamin B, vitamin A, vitamin D, or vitamin K. So presents with bilateral oval punched out corneal ulcers. So that is a classic description. Look at that. So both eyes and the oval like this, and punched out means clear cut lines. Okay, there's no infiltrate here. Clear cut lines like a punch when you hit with a punch like that, with dry lustreless corneas. That's the further hint. And ladies and gentlemen, the answer should be all clear to you. It is xerophthalmia. It's vitamin deficiency. Remember, alcoholic liver disease does cause vitamin deficiency due to decreased absorption of vitamin A from the intestinal tract. And the hint is dry lustreless corneas again. So this comes when you do in the vitamin deficiency classification. It comes in the X3A stage of corneal ulceration. And xerophthalmia, in xerophthalmia, vitamin, if you remember, 1 was 1A, 1B, then we have 2A and 3A and 3B. This is 3A where the corneal ulcers start producing because the collagen melts down and produces classic. You can see this oval, you can see the whitish area, there's round to circular and oval punched out. As you can see, there's no infiltrate around here. This is a typical vitamin A deficiency corneal ulcer. Okay, this is very typical and you must not make a hash of this in the exam. Patient comes to OPD with intraocular pressure of 25 mmHg. Remember, ladies and gentlemen, that means raised intraocular pressure. It's 25. Anything more than 21 leads to raised intraocular pressure diagnosis. However, the optic disc is normal and the visual fields is normal. Now, can it be glaucoma? It was the diagnosis. Well, the first answer, it's glaucoma suspect. It is not, because there's no question of glaucoma here. Because remember, of the three things that we diagnose with glaucoma with, one is raised intraocular pressure, second is visual field defects, and third is optic disc change. Is it not? So of this, you could, please remember, all of you, that of these three, we require at least 2 out of 3. We require at least 2 out of 3 before we diagnose glaucoma. 1 out of 3 cannot make glaucoma. So since we have only one, raised intraocular pressure, so it cannot be glaucoma suspect. It cannot be normal tension glaucoma. This is not normal tension in any case. It's not secondary glaucoma. For what it is ocular hypertension. Okay, OHT we call it, where the intraocular pressure is high, but as of now, there is no disc damage and there is no visual field defects. Remember, this is not glaucoma. It may convert to glaucoma later or it may not. But right now, it is not glaucoma because you have only 1 out of 3. As soon as there is a disc changes or as soon as you land up with a visual field defect, then the diagnosis converts itself from ocular hypertension into glaucoma. And that you can see here, this ocular with a normal, perfectly normal disc with perfect normal retina, raised intraocular pressure without any other signs of glaucoma is ocular hypertension. Very well. Next question, a purely memory question, ladies and gentlemen. This is one question I beg your forgiveness because I normally do not give in purely memory questions. Mostly you can work it out if you've read the theory, of course. But this is one pure memory question you should have. What is the neurotransmitter of the photoreceptors? That is, rods and cones use one particular neurotransmitter. Is it glutamate? Is it acetylcholine? Is it dopamine, which gives us the rush? No. Or is it serotonin? No, it's not dopamine, which gives us the high. Serotonin, no. Acetylcholine, not. This is not neuromuscular junction. But glutamate is the correct answer, ladies and gentlemen. And I hope you all got this from your physio class at least, where the rods and cones use one particular neurotransmitter, which is glutamate. You have to memorize this. And as I said, I crave your pardon because it's a pure memory question, which you cannot derive unless you have read this and memorized this. A 65-year-old woman is admitted to the oncology department for management of breast cancer, which is metastasized to the eye. Dear me, that's very bad. 1 week after admission, she has sudden painless loss of vision. Now, what could the cause be? It's a difficult question, but very important also because this actually happens very commonly. So, is it retractional detachment? Incorrect. Equivalent detachment? Yes. Central? No. Retinopathitis? No. Remember the answer here, external detachment, and those of you can guess it. If you cannot guess it directly, you can work it out by eliminating the other causes. Tractional detachment would have been, there's no question, there's no traction, nothing pulling the retina off. Retinal neuritis, no, there have been some symptom of pain with loss of vision, with color vision desaturation. None of them is mentioned here. Sentinel arterial occlusion would be sudden painless loss of vision with a cherry red spot and cataract appearance, none of which is mentioned here. So you can derive this accidental detachment just by eliminating the other causes, but also, you gentlemen, remember what has happened is you can see the two metastases here, the patches here on the choroid. Okay, so please remember that the commonest tumor of the eyes in adults, okay, again, commonest overall tumors of the eyes in adults are metastases. They are not primary tumors of the eye. Overall, the most common tumors of the eyes are metastases to the choroid. The choroid has incredible ability to collect almost 81% of the ocular metastases. Almost 81% of the ocular metastases come to the choroid. That's an incredible figure because of its tremendous vascularity. So as the breast cancer metastasis to the eye goes to the choroid, it releases a lot of fluid. This separates the neurosensory layer from the retinal pigment epithelium, causing exterior retinal detachment with a sudden painless loss of vision. So kindly remember, whenever there are metastases to the eye, be it breast cancer, could be lung cancer, could be prostate cancer, whatever the metastasis, following that you have a loss of vision, the answer is going to be exudative retinal detachment. And those who have got it, kudos to you and a major thumbs up to all of you. A patient presents with complaints of inability to drive at night, okay, particularly when it's foggy or raining, when he's unable to distinguish the road from the footpath. Okay, so that sounds very, very real life situations, not particularly in January in Delhi when it's foggy and raining. And his vision, however, 6/6, dear me. What could that be? His vision is 6/6, and yet he's able to drive at night. He's unable to drive at night. So what aspect of his visual performance needs to be looked at? Is color vision, could be visual field, could be contrast sensitivity, or could be stereopsis? This is a good question, and I want you to understand this. You see, because remember, we have these multiple parameters of vision, of which one of the most important, of course, visual acuity. Okay, how much you read on the Snellen's chart. You have color vision, you have visual fields. They are three most important. But I tell you something, ladies and gentlemen, in real life, the single most important quality that is important for visual performance is choice number C, called contrast sensitivity. See, contrast sensitivity tells us when you have the objects are not sharp and clear cut against the background. You see, the Snellen's chart has clear, sharp objects, white, black letters on a white background. Okay, it's easy to make them out. But in real life, things are not so clear. You have diffuse outlines, there's not much light, and in a typical night when it's rain, it's foggy, it's misty, you can barely see anything. And that is when all the problems, particularly at night and it's driving problems occur. This is the situation for you to test the patient's contrast sensitivity. You see this typical condition and many of your faces at night, particularly if you say in the northern part of the country where the fogs are and the cold is intense. And in this condition, if you do not have a good contrast sensitivity, then you are going to land up with an accident. And unfortunately, contrast sensitivity gets reduced in a lot of conditions, like what? Like cataracts, like glaucoma, like optic neuritis, like macular degeneration, like cystoid macular edema. So all these are conditions where it's difficult to distinguish the background from the foreground, particularly when the lighting is less. This is a condition when we must test for contrast sensitivity. And we have this chart here called the Pelly-Robson chart, okay, which is called the Pelly-Robson chart, which is used to measure the contrast sensitivity of patients whom we suspect that may have reduced contrast sensitivity. Remember, the trick is that they will be able to read 6/6 on a Snellen's chart. However, on a real life situation like this, they will have a major problem, particularly if the contrast sensitivity is lower. So that is why I said contrast sensitivity is possibly the single most important performance of an indicator of visual performance in real life. Okay. And with that, ladies and gentlemen, thank you very much for a very patient hearing, and may you all have a very good exam. All the best to you.
All right, hi guys. So let's start discussion of pharmacology that was asked in your computer-based offline test. I saw the question. They were relatively much on the easier side. Only few questions were a little tricky. I hope all of you guys were able to do it. Let us see what are the area that you made a silly mistake and how can we avoid it. The very first question that we are having in pharmacology is going to be about a 34-year-old patient presented with OPD with complaints of fever with chills. Fever with chill and rigor, always think about, or in majority of the cases, it could be a case of malaria. However, peripheral blood smear, they also reveal banana-shaped gametes. So banana is what? Kela, right? Kela is a fruit, right? So whenever you look at the banana-shaped gamete, banana is a phal, है ना? Phal को बोलते हैं. So this will be possibly a case of Plasmodium falciparum. This is possibly a case of Plasmodium falciparum, which was started on a drug artesunate. Okay, so they didn't ask the treatment of falciparum. They are actually asking, the patient was already started on artesunate. What is the mechanism of action of artesunate? Okay, so artesunate is one of the drug. They are asking about artesunate. Artesunate is one of the drug that is actually derived from traditional Chinese medicine, TCM, traditional Chinese medicine. And how I ask you to remember that traditional Chinese medicine, the Chinese people, they are very free people, and as a result of their freedom, we just saw COVID. So free people will be mainly having free radical generation. This is the answer, free radical generation. Parasite heme polymerase inhibitor, which of the following will be parasite heme polymerase? So I used to say heme, sounds like blood, right? So जो आपका खून चूसने वाले MCQs, जो long MCQs होते हैं, they are actually, this is the mnemonic that long MCQs ये हमेशा खून चूसते हैं ना. तो long MCQs stand for drugs like your lumefantrine. This is going to be drugs like your lumefantrine. Then mefloquine, lumefantrine, mefloquine, chloroquine, and Q stand for your quinine. So these are the heme polymerase inhibitor. तो मैं कैसे बोलता हूँ, long MCQ आपका खून चूस लेते हैं, long MCQs. Gametocytic action will be mainly caused by your primaquine, tafenoquine. These are the drugs that we are having. Correct answer for this question is going to be artesunate. Is one of the drugs that is never used alone. It is mainly acting by free radical generation, and remember, artesunate always uses combination, so we call it as the artemisinin combination therapy, है ना, ACT, artemisinin combination therapy, है ना. That is also considered as a preferred drug in Plasmodium falciparum. As a matter of fact, one more question that is very frequently asked, that a patient is coming from Assam with there is some, let's say, loss of consciousness and all. So those condition may, if there is already a diagnosis of cerebral malaria, if there is a diagnosis of cerebral malaria, in that condition we are going to utilize IV artesunate. We are going to utilize what? IV artesunate. That happens to be the drug of choice in a patient with the cerebral malaria. Second question that we are having is, which of the following is true about receptor and action? This is one of the questions from general pharmacology, which is true. You have to find it out. Antagonist has both intrinsic activity and affinity. Now, what is antagonist? I always used to draw this graph. I'm pretty sure all of you guys must have seen this graph already. And in this graph, let's say this is the +1, that is 100% response, and this is -1, that is negative response. Whenever drug acts at the receptor and produces positive action and a maximal response that can be seen, this will be known as your agonist. This is a property of a agonist. Whenever the drug binds with the receptor and produces some activity, and they have some activity, we are going to call it them as a partial agonist. When the drug occupies the receptor and produces no intrinsic activity, we are going to call them as a antagonist, है ना. Antagonist मतलब ये drug क्या करेगा? Drug will occupy the site. They will have affinity, but they will not produce any action. We are going to call them as a antagonist. On the other hand, if you are going to look at one more drug, they will occupy the site and they will have a negative action, or I would say -1, and we call them as a inverse agonist. What do we call them? We call them as an inverse agonist. So please do remember that about all 4 drugs: agonist, this is agonist, partial agonist, antagonist, and inverse agonist. Something that is common between all of them, that they all have high affinity for the receptor. Whenever there is a drug, any drug will have some affinity or ability to bind with the receptor. They all are going to have a high affinity, but they are having a different intrinsic activity. Agonist has an intrinsic activity of +1, that is 100%. Partial agonist somewhere between 0 to 1. This is known as your 0 to 1. Antagonist is going to be 0, and inverse agonist is going to be -1. Now let's read the option. An antagonist has both intrinsic activity and affinity. antagonist has no intrinsic activity. Antagonist has no intrinsic activity. Remember that. No intrinsic activity. They have high affinity but no intrinsic activity. So that is wrong. You have to find out one true statement. Intrinsic activity and affinity are not important. Definitely they are very, very important. Intrinsic activity is very important for the action of a drug. Antagonist has affinity. Yes, as I told you, all 4 types of drug are having affinity. Antagonist has affinity but no intrinsic activity. Antagonist has affinity, yes, and it is having no intrinsic activity. So this happens to be, or this looks a very true statement. Option D, partial agonist has no intrinsic activity. Partial agonist has some intrinsic activity, somewhere between 0 to 1. This is one of the intrinsic activity. भले ही वो agonist के जैसा नहीं है, although it's not same as agonist, but they are having some intrinsic activity, है ना? So correct answer for this one that we are having is going to be C. Next that we are having desmopressin is a synthetic analog of ADH. So we already know desmopressin is synthetic analog of ADH. What else that we know? That desmopressin is considered as a drug of choice in a patient with the central diabetes insipidus. In a patient with the central diabetes insipidus. Now option is saying you have to find out a false statement. All are true except it is a more potent antidiuretic. Of course, the desmopressin is the synthetic one and they are more potent antidiuretic. It is a selective vasopressin agonist. Now remember this desmopressin that we have, desmopressin, it is mainly having V2 receptor agonistic property. V2 receptor agonistic property. Hai na? V1 receptor agonist that we know, there is one specific drug about this one that we know is known as your terlipressin. Terlipressin, it's mainly having V1 receptor agonistic property. Terlipressin is mainly having V1 property. And terlipressin is going to be vasoconstricting in nature. It has little vasoconstricting activity. Terlipressin is mainly having, V1 agonistic activity. Terlipressin is V1 agonistic activity. It is longer acting. Definitely it's a longer acting. So it is a longer acting. That's a true statement. It is a selective V1 receptor agonist. It is selective V2 receptor agonist. It has little vasoconstricting activity. Remember, they are having some vasoconstricting activity also. It is more potent antidiuretic. Definitely, they are more potent antidiuretic. Hai na? So, if you are going to choose out one false statement, it is a V1 receptor agonist. It's not selective V1 receptor agonist. It's a V2 receptor agonist. So let's see the next question about a 40-year-old man with megaloblastic anemia and early signs of neurological abnormality. The drugs that will be probably required is, so both things are there, megaloblastic anemia and neurological abnormality. If there is only megaloblastic anemia, then folic acid and vitamin B12 both can be given. But if there is associated neurological abnormality also, in that case scenario, in a patient with neurological abnormality also, in that case scenario, we will be needing folic acid. Folic acid will be for both megaloblastic anemia and neurological abnormality. This was a pretty simple question. Next that we are having, you started a patient on warfarin. Which of the following factors show the most rapid decline in blood level? Now always remember guys, warfarin that we have, it is one of the competitive inhibitor of vitamin K dependent factor. Vitamin K dependent factors. Now whenever we talk about vitamin K dependent factors, vitamin K dependent, are there only clotting factor or anti-clotting factor? Both. There are both, right? So vitamin K dependent factor can be clotting factor also. Clotting factor like your factor 2, 7, 9 and 10. Next that we are having is going to be your anti-clotting factor. Anti-clotting factor is going to be your protein C and protein S. Protein C and protein S. Both of them will be there. Now the very first factor that is going to be affected is going to be your factor 7. Factor 7 is the first factor that will be affected. That will be around 6 to 7 hours. So it's actually 6 hours, but I'm deliberately writing 6 to 7 so you can remember that 7 will be gone in around 7 hours. Next factor that is going to be affected is going to be, this is the second factor to get affected. Second factor to get affected, that will be around 8 hours. Around 8 hours. Last factor to get affected will be factor 2. That will be taking around 4 to 5 days. That is why complete onset of action of warfarin will be coming in after 4 to 5 days. है ना, इसीलिए bridging therapy भी देते हैं with the heparin. And there is another reason also why heparin is added. Again, we are not going into that detail. What I am trying to explain here, that the first factor to get affected is factor 7. Next factor to get affected, protein C and S, right? So, which of the following show rapid decline in the blood level? Factor 7 is not in the option. The next factor that is available is going to your protein protein C, right? Because between 8 hours and between 4 to 5 days, somewhere 9 and 10 factor will be targeted. So remember, protein C is the answer here, and most of the students made mistake in this question, I believe. Next question that we are having: which of the following prokinetic drug has been implicated in causing serious ventricular arrhythmia, particularly in patient concurrently receiving erythromycin or ketoconazole? Now, do you know that erythromycin or ketoconazole, both of them are actually very potent enzyme inhibitor. Both of them are very potent enzyme inhibitor. Prokinetic drug की बात करेंगे तो we are having 5-HT4 agonist, 5-HT4 agonist. Drugs like your cisapride, drugs like your cisapride, drugs like your mosapride, cisapride, mosapride, tegaserot, and then there is one more by the name of prucalopride. There is one more by the name of prucalopride. I am deliberately writing prucalopride below the line, reason being that prucalopride being a 5-HT4 agonist, they are not associated with the side effect that has been seen with cisapride, mosapride. So cisapride, mosapride, they are mainly associated with your QT prolongation. ये एक reason था why it has been banned and we are not using cisapride and mosapride clinically. Tegaserot is also coming in the same list, right? Now, if you are going to add them with the enzyme inhibitor, the toxicity risk will increase. Remember my story that I used to tell you in class, that if you are getting induced, risk of failure will be high. If there is inhibition, risk of toxicity is going to be high. So correct answer for this question is going to be your cisapride. Cisapride is the one that will be mainly associated with the QT prolongation, and that is why they can cause, serious ventricular arrhythmia. Metoclopramide, it's actually a D2 blocker, and with the metoclopramide, the problem that can be seen will be more and more risk of extrapyramidal symptoms like dystonia, akathisia and all, but domperidone on the other hand will not cause. Prucalopride is also one of the 5-HT4 agonists. They are not having this QT prolongation. That is why prucalopride is not the drug that will be associated with the arrhythmia. Among the given choices, cisapride is the correct answer. Next one is about a 29-year-old patient was started on griseofulvin. Griseofulvin is one of the antifungal drug. It is one of the mitotic spindle inhibitor. It is one of the mitotic spindle inhibitor. Do remember, they are fungistatic in nature. What are they? They are actually fungistatic in nature. Which of the following statement is true about this drug? You have to find out a true statement. These fungistatic drug that we know, few important things. One is they are having aldehyde dehydrogenase inhibiting property. Because of that, there will be disulfiram-like reaction. So will it cause disulfiram-like reaction? Yes. They are also very potent enzyme inducer, plus they also cause lupus-like syndrome. So correct answer for this one is going to be all of the above. What you learned here is not only about this question, but you also learned about a fungistatic drug by the name of griseofulvin, that is a mitotic spindle inhibitor, and they are very potent enzyme inducer. Wherever you give inducer, then say risk of failure will be high. Next question is about a patient has been treated for bipolar disorder for several months using lithium. Okay, lithium is the drug of choice for mania, and for bipolar disorder also in the manic phase we use lithium. Which of the following is a common adverse effect of lithium carbonate? Lithium ka adverse effect I always used to write for all of you guys. Just remember by the mnemonic of lith. Very simple. Lithium will be lith. In addition to देखो nausea, vomiting, diarrhea, वो तो universal side effect है. Nausea, vomiting, diarrhea होता रहेगा. But important side effect that is going to be L stand for your leukocytosis, not leukopenia guys. Leukocytosis है ना. Then insipidus. Insipidus stand for your which type of insipidus? Diabetes insipidus. No, diabetes insipidus. T stand for your tremor. Tremor happens to be the most common side effect. Initially there will be fine tremor. At the toxic dosage there will also be coarse tremor. They can also call you coarse tremor. And other T stand for your teratogenicity. Teratogenicity. If you are going to utilize them in a pregnant female, they can lead to a condition known as your Epstein anomaly. Very common question. Epstein anomaly. इसमें जब आप चेस्ट एक्सरे करते हैं तो आपको मिलता है बॉक्स शेप हार्ट. हाउ डू आई आस्क यू टू रिमेंबर? टिन से बनता है बॉक्स. एब्स्टीन एनोमली है ना, टिन से बनता है बॉक्स. एंड H स्टैंड फॉर योर hypothyroidism. Now all these side effects that I have mentioned here with the simple mnemonic of with a simple mnemonic of lith, they can be seen even at the therapeutic doses. Even at the therapeutic dose can be seen. But again, in the toxic doses, there are multiple other effects that can be seen, but we are not going into that. What we are trying to solve here, that which of the following is a common adverse effect of lithium? Dry mouth, hyperthyroidism, leukopenia, nephrogenic diabetes insipidus. So this diabetes insipidus that they are causing here, it's mainly at the level of nephrogenic only, nephrogenic diabetes insipidus, and nephrogenic. And for the treatment of this nephrogenic diabetes insipidus, we are going to utilize epithelial sodium channel blocker, ENaC blocker, by the name of amiloride. Amiloride is one of the epithelial sodium channel blocker. Triamterene, amiloride, they are the potassium sparing diuretic class में आते हैं. They are the epithelial sodium channel blocker. They will not cause leukopenia. They will be causing leukocytosis. Hyperthyroidism, again, no. They will be causing hypothyroidism. No dryness of mouth. And nausea, vomiting, diarrhea can be seen. Mechanism of action of nevirapine. Nevirapine is one of the antiretroviral drug. ART therapy में utilize करते हैं. It is a protease inhibitor. What do you know about protease inhibitor? That all the protease inhibitor, they are going to end with a navir. I think this is a pretty simple. Protease inhibitor HIV में use याद करना is very, very easy. All the protease inhibitor, they are going to end with the navir. It is a nucleoside reverse transcriptase inhibitor. Nucleoside reverse transcriptase inhibitor, they are a whole family, है ना? जैसे I used to tell you about a family where there is a Ziddi, Dadi, Abbu, Ammi, love sister. That is going to be zidovudine, didenosine, abacavir, emtricitabine, lamivudine, stavudine. They are the NRTI, non-nucleoside reverse transcriptase inhibitor. What did I tell you? That non-nucleoside reverse transcriptase inhibitor are going to be drugs like your efavirenz, nevirapine, delaverdine. They are all going to be the first generation NNRTI, first generation. और जितने भी NNRTI होते हैं, they are a non-nucleoside reverse transcriptase inhibitor. They are the non-competitive inhibitor of reverse transcriptase enzyme. On the other hand, the NRTI, the whole family that I told you, Jiddi, Dadi, Abu, Ammi, those are all competitive inhibitor. There are second generation also, that is going to be your rilpivirine, etravirine, and dolavirine. How do I ask you to remember again? इन सबके नाम के बीच में आपको वायरस वर्ड आता है. rilpivirine, etravirine, dolavirine, सबके नाम के बीच में वायरस आता है. और collectively, if you want to remember, on the right hand side here I have written the second generation, and on the left hand side here I have written the first generation, right? So you can also remember end at किस point पे? End at the red light देख के आप रुक जाइए. End at the red, that is going to be efavirenz, that is going to be nevirapine and delaverdine. End at the red, rilpivirine, etravirine and dolavirine. And at the red, right? So they are actually non-nucleoside reverse transcriptase inhibitor. नाम के बीच में VIR virus word आ रहा है, ठीक है? It is a fusion inhibitor. Fusion inhibitor is going to be your enfuvertide. Enfuvertide is one of the fusion inhibitor. Enfuvertide. Fusion of the virus inhibitor is enfuvertide. ठीक है? Correct answer for this one is C. Interleukin 6 receptor antagonist. This is a directly NEET PG question. Interleukin 6. So I used to tell you that, remember like this. Toxiclizumab, humanized monoclonal antibody. To6. जानबूझ के मैंने 6 यहाँ लिख दिया so that you can remember that tocilizumab is toxiclizumab. B is the correct answer. Daclizumab again interleukin 2. Secukinumab is again interleukin 17. There is one more, interleukin 6 inhibitor that is known as your sarilumab. S से याद कर लीजिएगा, sarilumab. So you can remember S for 6, sarilumab, and 2-6-silizumab. Both of them are interleukin 6 inhibitor that can be utilized in a patient with the rheumatoid arthritis. You can utilize them in a patient with the inflammatory bowel disease. You can also utilize them as an immunomodulator, especially in cytokine storm like scenario. Next question, which of the following agent is used for the reversal of rivaroxaban? So first and foremost, you need to know what is rivaroxaban. 10A पे बैन लगाने वाले ड्रग. So they are the directly acting 10A antagonist. directly acting 10 antagonists. There are drugs like rivaroxaban, apixaban, है ना, all of them their name is going to end with the X A पे ban लगाने वाला drug, 10 A पे ban लगाने वाला drug. And as an antidote, we are going to utilize a drug that is known as your 10A को neutralize करने वाला drug. So I used to write like this: Andixanet alpha, Andixanet alpha, है ना, ये 10A को न्यूट्रलाइज कर देगा. 10A का अगर ओवरडोज हो जाए तो उसको न्यूट्रलाइज करने के लिए विल बी यूजिंग Andixanet alpha. Idarucizumab, it is utilized as an antidote. Idarucizumab is one of the antidote for dabigatran toxicity. It is utilized for dabigatran toxicity. Dabigatran toxicity. What is the name of the compound? That is going to be idarucizumab. तो क्या बोलता हूँ? दबा के दारू. Dabigatran दबा के दारू. Protamine sulfate, it is mainly utilized for heparin toxicity. Protamine sulfate for heparin toxicity. Fresh frozen plasma you can utilize if there is a bleeding after, you know, a warfarin. So warfarin में का overdose में we can utilize vitamin K1, that is phytonadione, or you can also utilize fresh frozen plasma if there is evidence of bleeding. Next is which of the following is used for the reversal of streptokinase. Again hematology से दो क्वेश्चन आ गए. Streptokinase toxicity, तो in hematology I have given you the table, antidote वाला table. Exactly same thing happened in your NEET PG examination and also in Fmge previously they have asked this question. Streptokinase is one of the tissue plasminogen activator. Tissue plasminogen activator. अगर इसकी toxicity हो जाए तो we are going to utilize epsilon aminocaproic acid, EACA, antifibrinolytic बोलते हैं. We call them as the antifibrinolytic. Epsilon aminocaproic acid. Alternatively, we can also utilize one more known as your tranexamic acid. What do we utilize? Tranexamic acid. Protamine sulfate, as I told you, is utilized for your heparin. Protamine sulfate किसके लिए यूज करते हैं? For heparin. This information I have given you previous question as well. Vitamin K and fresh frozen plasma, as I told you, in warfarin overdose. Initially, we can utilize vitamin K if there is evidence of bleeding. Or if the you know, your PTINR is very high, beyond 20, we can utilize fresh frozen plasma. A case-based scenario about a 65-year-old patient with a history of Parkinson's disease was admitted to ICU for his systemic infection. Okay, you have started a systemic antimicrobial. Since he is also an anti-Parkinsonian and a drug like MAO inhibitor. So what are the MAO inhibitors that is used in the Parkinson's disease? So I used to tell you Parkinson's disease में we are mainly going to utilize something known as your MAO-B inhibitor. MAO-B inhibitor. And the drugs in this one is going to be your selegiline. Other one that we are having is known as your rasagiline. Rasagiline, and other one that we are having is known as your safinamide. So कैसे याद करना है इसको? MAO-B sounds like मेरा बेटा, और मेरा बेटा किसके जैसा? सेरा जैसा. मेरा बेटा सेरा जैसा. This is the MAO-B inhibitor. सेरा जैसा ही selegiline, rasagiline and safinamide, they can be utilized in Parkinson's disease. Now let's see the question. You are advised to choose an antimicrobial carefully. Okay, now this is the integration of your CNS plus antimicrobial. Which of the following antimicrobial also possess MAO inhibition? Okay. So again, if the person is already taking MAO inhibitor and you are going to give another drug, another antimicrobial that is also having MAO inhibiting property, the risk of toxicity will increase. So in that case scenario, the correct answer is going to be linezolid. Linezolid, it is a drug, है ना? Linezolid is a protein synthesis inhibitor, 50S में आता है, where it is acting by inhibiting 23S subunit of 50S ribosome. They are having MAO inhibiting property. They are having what? MAO inhibiting property. Do remember that. That is why they are having risk of serotonin syndrome. Which of the following antimicrobial? And so they are associated with your serotonin syndrome because of MAO inhibiting property. Okay? Not bacitracin, which is a cell wall inhibitor. Streptomycin again is a protein synthesis inhibitor. Aminoglycoside, that is highly, you know, aminoglycoside. What are they? They are highly autotoxic and nephrotoxic drug. Polymyxin is actually a cell membrane inhibitor. It's also cidal in nature. Cell membrane inhibitor. They are not having MAO inhibiting property. Correct answer for this one is linezolid. But if the examiner is going to ask you, what is the most common side effect of linezolid? The most common side effect of linezolid, apart from nausea and vomiting, the most common that we are having is going to be bone marrow suppression. और उसमें भी सबसे ज़्यादा जो कम होता है, that is going to be platelet count. है ना? So after initiating linezolid, if there is fall in your platelet count, most likely it's a case of linezolid or drug mediated thrombocytopenia. So platelet count सबसे ज़्यादा affected होता है around 7 to 8 days after therapy. Next question that we are having, which of the following is the recently approved drug for hypoactive sexual desire in female? Recently approved drug, flibanserin is the correct answer for this one. How do I ask you to remember? ये female के libido को increase करता है. So it's a happy drug for male actually. Hypoactive sexual desire in female, flibanserin. This is actually a 5-HT1A का agonist, and it is having 5-HT2 का antagonistic property. It's a drug that is used for the hypoactive sexual desire in female. Female के libido को increase करता है. Lorcaserin is a drug that is mainly utilized for obesity. Lorcaserin is mainly utilized for your obesity. It is your 5-HT2 का agonist. Usually serotonin वाले chapter में मैं बताता हूँ. Always remember the rule of 5 in serotonin. What do I say? That remember the rule of 5. What is the meaning of rule of 5? That we are having different type of receptor. 1, serotonin receptor 1, 2, 3 and 4. 1 and 4 का we always are going to utilize agonist. 1 and 4 का क्या यूज करना है? तो agonist. तो पहले 1 and 4 क्या हो जाएगा? 5 हो जाएगा. 1 and 4 become 5. 2 and 3 का 2 and 3 that we have, 2 and 3 का we will be utilizing antagonist. क्या utilize करेंगे? Antagonist. So 2 and 3 again become 5. So this is going to be again 2 and 3. Rule of 5. Usually 2 and 3 हम पढ़ते हैं, and 2 and 3 become 5. 1 and 4 become 5. So 1 and 4 का agonist and 2 and 3 का antagonist. But here I am telling you there is an exception that 5-HT2 का agonist. 5-HT2 का मैंने क्या बोला? Normally we use करते हैं antagonist. That is psychosis में, in a patient with the psychosis we are utilizing है ना, clozapine, olanzapine, quetiapine. But there is one exception, lorcaserin, जो आपके load को कम कर देता है. क्या करता है? आपके लोड को कम कर देता है. All the mnemonics are highly realistic. You look at the drug and the answer will come out directly. Lorcaserin आपके बॉडी के लोड को कम करता है. Catanserin, ritanserin, they are not very commonly utilized drug. They can be utilized in a patient with the resistant hypertension. We can utilize them in the peripheral vascular disease. Remember, they can also be utilized in the prophylaxis of migraine. They are actually your 5-HT2A by 2C का antagonist. है ना? Peripheral vascular disease, resistant hypertension also can be utilized in prophylaxis of migraine. Correct answer for this question is going to be D. A 45-year-old patient with a history of thrombotic event was started on etopaxar. This agent act by etopaxar. Look at the name. The name will be telling you a lot of things. Etopaxar. Etopaxar. It is going to be protease activated receptor inhibitor. प्रोटीएज एक्टिवेटर रिसेप्टर को एक्स कर दे रहा है, दैट मींस कट कर दे रहा है, इनहिबिट कर दे रहा है. एंड प्रोटीएज एक्टिवेटर रिसेप्टर, द PAR दैट वी हैव, प्रोटीएज एक्टिवेटर रिसेप्टर एक्चुअली is a receptor for thrombin. Protease activator receptor is actually a receptor for thrombin. So saying etopaxar is also saying that they are the protease activator receptor inhibitor or thrombin inhibitor. Let's read the option. ADP inhibitor, protease activator receptor. I think we already have the answer here. Phosphodiesterase inhibitor, GP2B3 inhibitor. Na? So correct answer we have got already. Let's rule out other option. Guys, GP2B3 inhibitor, 2B and 3A inhibitor, that is going to be your abciximab. This is going to be drugs like your abciximab, chimeric monoclonal antibody, abciximab, tirofiban, है ना, B और A, GP2B3A, है ना, tirofiban, eptifibatide, उसमें एक और आता है eptifibatide. ADP receptor antagonist, ADP receptor antagonist will be drugs like your clopidogrel, है ना, clopidogrel, prasugrel. So this ADP actually act through the receptor, and the name of the receptor is P2Y12. So saying ADP receptor inhibitor is also known as your saying P2Y12 inhibitor. The clopidogrel, prasugrel, they are the irreversible one. However, we are having some reversible inhibitor as well, that is going to be your cangrelor and ticagrelor. Reversible inhibitor of P2Y12, also known as your ADP inhibitor, that is going to be your drugs like your cangrelor, जो cannula से देंगे, that means it is IV, and other one is ticagrelor. Tikka is like chicken tikka or paneer tikka that I used to tell you in class. They are the orally available. Tikka, ticagrelor, they are the reversible ADP inhibitor, which is also known as P2Y12 inhibitor. Correct answer for this one is B. A patient presented with sleeping sickness, drug preferred for early phase of West African sleeping sickness. Now, whenever we talk about sleeping sickness, or let's say a West African or East African, first and foremost, let's talk about sleeping sickness. Sleeping sickness का दूसरा नाम होता है African trypanosomiasis. African trypanosomiasis. Trypanosomiasis. Now this African trypanosomiasis, which is also known as your sleeping sickness, African लोग सोते रहते हैं. Just a way to remember, there are two types. One is East African sleeping sickness, and other one is known as your West African sleeping sickness. I always used to say West African are the best African. I don't have any preference for West African, just telling you why, because West African are best, just as a mnemonic, just a story. West African are the best African, and they copy always the Western culture. And what do I mean by Western culture? Western people live in a penthouse, so we can utilize a drug like your pentamidine. They live in a penthouse, that is your pentamidine. Then we can utilize one more drug that is known as your eflornithine. So pentamidine, penthouse, which is having a very nice floor in it. Eflornithine, pentamidine and eflornithine. East African, so इसको दो पार्ट में डिवाइड किया है, अर्ली पार्ट एंड लेट पार्ट. So early part of East African sleeping sickness, जाके उससे बात करिए. If you go and talk him out, where is he or where is the person, they will say सो रहा है. So that is going to be your suramine. The early part में we are going to utilize suramine. ठीक है, कहाँ है, सो रहा है. East African सो रहा है. Late वाले में क्या यूज करेंगे? Sometimes they don't use the term late. Sometimes they give the patient is coming with the CNS involvement. There is neurological involvement already. So late African में क्या देंगे? सो रहा है. कब तक सोएगा? तो बोलेगा मैं लेट तक सोएगा, है ना, ये निमोनिक होगा. So that is going to be your मेलासोप्रोल, है ना, मैं लेट तक सोएगा. Let's repeat again. As I told you, sleeping sickness, African trypanosomiasis. See, there is something called South American, that is Chagas disease, है ना, there where we are using benzimidazole. We already know that, right? But African trypanosomiasis में that we are having East African, West African. How to remember? East African, early phase, late phase. The drug of choice, all of them are drug of choice actually. All these are drug of choice in East African or West African. So early phase में कहाँ है? तो बोलेगा सो रहा है. इन द ईस्ट अफ्रीकन लेट फेज में कब तक सोएगा? तो बोलेगा मैं लेट तक सोएगा, मेलासोप्रोल. वेस्ट अफ्रीकन आर द बेस्ट अफ्रीकन, दोज हु कॉपी वेस्टर्न कल्चर एंड लिव इन अ वेरी नाइस पेंट हाउस which is having a very nice floor in it, eflornithine. West African are the best African, those who are living in a penthouse having nice floor in it. Now let's read preferred drug for early phase of West African. So I think we already have our answer. Benzimidazole, it is mainly utilized for Chagas disease or South American trypanosomiasis. Chagas disease or South American trypanosomiasis. Amphotericin B as a drug, it is the drug of choice for amphotericin B is a drug of choice mainly for your Kala Azar, and they are also utilized as a drug of choice for all the serious or life-threatening fungal infection. Serious or life-threatening fungal infection में mainly we are going to utilize your amphotericin B. Suramine मैंने बता दिया, early phase में we will be utilizing East African, but here examiner is specifically asking West African. Next question is about a patient with HIV was started on antiretroviral agent which inhibit enzyme reverse transcriptase. I think reverse transcriptase का entire summary I have given you. So there are 2 questions on antiretroviral, 3 questions as a matter of fact. Enzyme reverse transcriptase. Which of the following is uncompetitive? Uncompetitive, that means non-competitive inhibitor, and that is going to be your NNRTA. I have already given you the entire summary of NNRTA. They are the non-competitive inhibitor. And at the red, efavirenz, nevirapine, delaverdine. Red is the second generation one, that is going to be rilpivirine, etravirine and dolavirine. Correct answer for this one, look at this. किसके नाम के बीच में वायरस आ रहा है? Delaverdine, है ना? So they are the NNRTA. Stavudine, lamivudine, zidovudine, all other options that we are having, they are the competitive inhibitor and they are the nucleoside reverse transcriptase inhibitor. Nucleoside reverse transcriptase inhibitor. Next question that we are having is about a patient with fungal infection was on amphotericin B. Later, another agent, micafungin, is added. Micafungin, anidulafungin, they are all from the same class. The antifungal micafungin act by. So, they are micafungin, anidulafungin, they are the inhibitor of your cell wall of the fungus. They are the cell wall inhibitor. Squalene epoxidase inhibitor that we have, squalene epoxidase inhibitor. This is going to be your terbinafine. It is going to be your terbinafine. Terbinafine as a drug, guys, remember, it is considered as a drug of choice. Terbinafine is a drug of choice in a patient with the dermatophytosis. For all cases of dermatophytosis, including your onychomycosis, the drug of choice is going to be none other than your terbinafine, that is one of the squalene epoxidase inhibitor. DNA and RNA polymerase inhibitor, they are going to be your 5-flucytosine. The drugs in this one is going to be your 5-flucytosine. 5-flucytosine. 5-flucytosine, they are very effective drug, mainly utilized in a patient with the cryptococcal meningitis. अगर कोई patient आता है cryptococcal meningitis का, so in that the drug of choice is going to be amphotericin B. So in cryptococcal meningitis, it is usually added with your amphotericin B. It is always and always added with the amphotericin B. 5-flucytosine cryptococcal meningitis के लिए we are going to add them, है ना? Protein synthase inhibitor is going to be drugs like your tavaborole. It is going to be drugs like your tavaborole. Tavaborole. Correct answer for this one is going to be cell wall of the fungus A, right? Next question is going to be about a 60-year-old child was started on antimicrobial agent by a quack in a village. Later, he complained of limping and difficulty in walking. The orthopedician diagnosed him to be a case of tendinitis. So, simply which antimicrobial drug is going to cause tendinitis, arthropathy, tendon rupture? That is none other than your fluoroquinolones. Guys, ciprofloxacin, all the fluoroquinolone, they are DNA gyrase inhibitors. So, sometimes they don't give the name of the drug. Sometimes they give you what is the mechanism of action of that drug. So, DNA gyrase inhibitor, all of them, they are cidal in nature, remember. They can produce teratogenic effect, and in adult population also, in you and me also, if we are going to utilize fluoroquinolone, they can cause tendinitis, arthropathy. They will have other side effect like your QT prolongation. They can also cause photosensitivity, but tendinitis and arthropathy is a very specific side effect of fluoroquinolones. Doxycycline again is a tetracycline. They will be mainly associated with teeth staining. They are mainly associated with your teeth staining and bone growth abnormality. They are mainly associated with the teeth staining and bone growth abnormality. Erythromycin अगर congenitally अगर pregnant female को दे दिया गया, so they will be associated with your congenital hypertrophic obstructive pyloric stenosis CHOPS. And cefpodoxime is one of the cephalosporin. A third generation cephalosporin, they are relatively safer in pregnancy. Okay. So again here they have given in a child, not in a pregnant female. In a child they have given. So ciprofloxacin again, it can cause problem in adult also, in child also, and also it will be a teratogenic effect. The tendinitis and arthropathy can be a teratogenic effect as well. This doxycycline mediated teeth staining, this will be also a teratogenic effect. Likewise CHOPS, that is associated with the erythromycin. Next question is going to be about a 55-year-old patient was given an agent that is named torsemide. What is torsemide, guys? It's a younger brother of furosemide. That is one of the loop diuretic. It is one of the loop diuretics. Torsemide is one of the loop diuretic that is acting. The site of action of this one is sodium, potassium, 2-chloride, NaK2Cl inhibitor. Sodium potassium 2-chloride inhibitor, sodium potassium 2-chloride, that is loop diuretic. This is acting mainly at the thick ascending limb of loop of Henle. Thick ascending limb of loop of Henle, that is going to be loop diuretics. What other thing that we know about loop diuretics, that they are actually associated with your hypocalcemia, because loop causes loss of calcium. Loop diuretic causes loss of calcium, hypocalcemia. They can also cause hypomagnesemia, natremia, hypokalemia, सब कुछ कम करेगा. Everything is going to be decreased. Loop causes loss of calcium. Loop loses calcium, right? So can we prefer them in hypercalcemia? Yes, because loop diuretics are very fast acting diuretics. They are actually very potent diuretics, and they can be utilized in hypercalcemia. In addition to their use in emergency condition wherever there is edema or congestion. They cause hypercalcemia? No, they do not cause hypercalcemia. Hypercalcemia can be associated with your thiazides. Thiazides will be associated with your hypercalcemia. They can cause hyperkalemia? No, as I told you, they will be causing hypokalemia, and they never cause hypoglycemia. They can cause hyperglycemia. Reason being that they are going to cause loss of potassium. You see, if there is a loss of potassium, what will happen at the beta cell of the pancreas? Because beta cell of the pancreas always require depolarization, and depolarization के लिए potassium channel का block होना जरूरी होता है. That is why potassium will be stored inside the beta cell of the pancreas, that will be causing depolarization, and that will be causing insulin release. जब potassium पहले से ही कम है, तो there will be risk of hyperglycemia. So be it thiazide or be it loop diuretic, they both can cause, है ना? So I hope it is making sense to all of you guys that preferred in hypercalcemia? No. Remember, the correct answer for this one is preferred in hypercalcemia. Yes, because loop always causes loss of calcium. Loop causes loss of calcium. A is the correct answer. I believe this is the last question. A patient with colorectal carcinoma was started on a chemotherapeutic agent. Later, after looking at the blood profile, he was also started on filgrastim, right? What is filgrastim? They are the granulocyte के stimulant, granulocyte stimulant, and a filgrastim, pegfilgrastim, they are the granulocyte stimulant we are mainly giving in a patient for the neutropenia. If there is any case of neutropenia, then we can utilize them. In a neutropenia cases, we can actually utilize them. Okay, neutropenia. So examiner is asking, this agent is used for, are you using for neutrophilia or neutropenia? Neutrophilia तो होगा ही नहीं ना, chemo induced neutropenia होता है. Anemia के लिए we will be using mainly epoetin. Epoetin, we can also utilize drugs like your darbepoetin, that is chemo induced anemia. Darbepoetin, chemo induced anemia, है ना? Or if there is anemia due to end stage renal disease. Polycythemia, no, neutropenia is the correct answer. है ना? Neutropenia is the correct answer. Now there is another question that chemo-induced chemotherapy induced nausea and vomiting. ये chemotherapy दिया nausea and vomiting होगा, तो उसमें बार बार एक question आता है. We are going to utilize 5-HT3 antagonist. 5-HT3 antagonist. The name of the compound under this one is going to be your drugs like your ondansetron, granisetron, palanosatron. Ondansetron, granisetron, सबके नाम में setron word आएगा, palanosatron. However, if there is a chemotherapy induced, examiner is going to ask you diarrhea. That is another question that has been asked previously. The answer to this question is going to be none other than your loperamide. Loperamide. However, if the examiner is going to ask you chemotherapy induced anemia, then we will be using epoetin, darbepoetin. है ना? If there is chemotherapy induced thrombocytopenia, decrease in the platelet count, thrombocytopenia, chemotherapy induced thrombocytopenia, in that case scenario, you can utilize one of the interleukin 11 agonist. The name of this compound is going to be oprelvecin. नाम में ही सब कुछ है, देखिएगा. Oprelvecin, they are the 11 interleukin का agonist. Oprelvecin. We can use other agents like romiplostim. Now romiplostim क्या है? They are the thrombopoietin receptor agonist. Romiplostim, L-trombopag. Other one is going to be your L-trombopag. Romiplostim, L-trombopag you can utilize. है ना? All of them are working with different mechanism. Interleukin 11 agonist is going to be oprelvecin, and romiplostim, L-trombopag, they are the thrombopoietin receptor agonist. However, if the examiner is going to ask you there is a thrombocytopenia, a tyrosine kinase inhibitor can be also utilized for this thrombocytopenia. And I used to call it as a fostamatinib. Fostamatinib is one of the questions that was asked in the very recent examination of INICET 2023. Fostamatinib. Which tyrosine kinase inhibitor will be utilized? So you can utilize in chemo-induced thrombocytopenia. However, you can also utilize if there is a patient with the idiopathic thrombocytopenic purpura. So also can be used in, it can also be used in a patient with the ITP. What is ITP? Idiopathic thrombocytopenic purpura. Likewise, fostamatinib can also be utilized in chemo-induced thrombocytopenia, can also be utilized in idiopathic thrombocytopenic purpura. So 2023 INICET question was like this. Your patient was presenting with the following feature of idiopathic thrombocytopenic purpura. Which of the following tyrosine kinase inhibitor will be used? Option में oprelvecin भी था, romiplostim भी था. Now remember, oprelvecin is not a tyrosine kinase inhibitor. Tyrosine kinase inhibitor, all of them, they are going to end with the nib, right? So with this one, we are done with our complete question of pharmacology that was asked in INICET. And I hope all of you guys have enjoyed this session. And please make sure that whatever silly mistake that you are doing in the examination, try avoiding that, because if you learn from your mistake, that is the best lesson that we are having, and that is why we are conducting all these computer-based offline tests for all of you guys, so that you can desensitize your nerves, you can actually learn from your silly mistake and you can avoid them, right? So with this, I'll see you in the next class. Thank you very much.
Hello and welcome to the orthopedic session of the CBoT program. Hope the paper was fine and you have enjoyed doing it. The first question is that a 24-year-old runner was jogging downhill when his right knee got twisted, related to which he appeared in the emergency. You see, whenever you get a question in orthopedics where there is a history of twisting injury to the knee joint, then possibly they are asking about a ligamentous injury. Ligamentous or a soft tissue injury in the form of anterior cruciate, posterior cruciate, the meniscal injury, the medial or the lateral collateral ligament injuries. So possibly it is revolving around these soft tissue injuries around the knee joint. Now, on further investigation, it was found to be an ACL injury of the right knee. So obviously, in the question itself, they have diagnosed it to be an anterior cruciate ligament injury. Now, out of the given options, which of the following is incorrect? Which of the following is incorrect regarding the condition, that is anterior cruciate ligament injury? Which of the following is incorrect? Simply, they are asking about it. Now, option number 1 is that it is a result of valgus of the knee in external rotation and flexion. You see, the anterior cruciate ligament, as all of you know, that in between the femur and tibia, this is how the anterior cruciate ligament runs. That means from the lateral to the medial aspect, if this is the lateral part. So this is how the anterior cruciate ligament runs. And the injury to the anterior cruciate ligament is, you have to imagine as if someone is playing a football and there is a sudden twist in the knee joint. Okay, with the flexion of the knee, if there is a sudden twisting of the knee, that might result in the bursting of the anterior cruciate ligament fibers. So this option holds true, that it is a result of the valgus of the knee. That means forceful medial bending of the knee joint with external rotation and the flexion. So twisting of the knee in flexion results in the anterior cruciate ligament injury. So this obviously is the mechanism of injury. Now, this is the mechanism of injury with which the patient is brought to the emergency. Now, what you will do, what you will try to test upon the patient. Now, you will try to keep the patient lie supine. If this is the trunk of the patient is lying supine, and this is the hip joint of the patient. This one is the hip joint, and this is the thigh of the patient. This obviously is the knee joint of the patient, and this is the ankle of the patient, right? So this is how the patient is lying supine with the bent knee. Now, this bending of the knee can be tested, means the anterior cruciate ligament injury can be tested by bending the knees into two proportions. One is with the 90 degrees of bending, and the other one is around 20 to 30 degrees of bending. All right. Now, in 90 degrees of bend, when you try to move the leg anteriorly, and because the anterior cruciate ligament is injured, so there is always a possibility that anterior translation is possible. And this anterior translation, if it is performed with 90 degree of deflection, then this is known as anterior draw test. While if it is performed with 20 to 30 degrees of flexion, then it is known as Lachman test. Now, immediately after injury, it is obviously better to go with the Lachman test, because when anterior cruciate ligament is injured, there is too much collection of the blood inside the knee, and when you bend the knee almost up to 90 degree, as if you are performing the anterior draw test, then the condition would be extremely painful for the patient, because it is further compromising the space in the knee joint. On the other hand, if you flex the knee to just 20 to 30 degrees, then the condition is obviously painful, but not up to an extent of where the pain would be perceived in anterior draw test. So here, Lachman test is more sensitive. It can be easily done. Now here also the same phenomena. You will try to draw the tibia anteriorly. You will try to pull the tibia anteriorly. And if the tibia goes more anterior in comparison to the normal, that means there is no anterior cruciate ligament which was preventing the anterior translation of the tibia. That means presumably it is confirmed, or provisionally it is confirmed, that anterior cruciate ligament is injured by performing this Lachman test. So Lachman test for provisional diagnosis, yes, this is also true. This statement is also true. We are asking about that which of the following is incorrect. Then the third one is immediate MRI. Now you have to rely on investigation in order to gain that what exactly is the diagnosis of the patient. Now, what happens with the immediate MRI, that because of the presence of the blood inside the knee joint, there is always a possibility of relative bad visualization of the anterior cruciate ligament. That means non-confirmatory imaging of anterior cruciate ligament injury when there is hemarthrosis. So actually what we do instead, so practically what is done instead, that provisionally you have already diagnosed that the patient could be suffering from anterior cruciate ligament. So what you will do is that you will immobilize the knee joint in the knee brace so that there is no instability. So you will put a knee brace, and after putting the knee in the knee brace, you can ask the patient to go for early mobilization if X-rays does not confirm any fracture. So if there is no associated fracture, only soft tissue injury, only anterior cruciate ligament injury, so early mobilization can be achieved with knee brace application. But immediate MRI is not the best of the answers, because immediate MRI might not reveal the real nature of the anterior cruciate ligament injury. So it is usually delayed, like after 7 to 10 days, we ask the patient to get this MRI done so that there is a clear-cut visualization of the anterior cruciate ligament injury based on that the hemarthrosis is now settled inside the knee joint. So out of the 4 options, the best one obviously is the immediate MRI. That means immediate MRI is not the answer for anterior cruciate ligament injury. So hopefully you have understood the core clinical concept that how to manage the patient when the patient comes with the anterior cruciate ligament injury. So that was the answer for your first question. The next question is obvious. When you see it on the X-rays, the answer is obvious. All of you know that the Shepherd-Crook deformity of the femur is exactly a feature of, is specifically a feature of fibrous dysplasia. All right. Fibrous dysplasia. As what happens in fibrous dysplasia, that the cortical, the texture of the bone, that is because of the osteoid, because of the cortical origin, is changed by a fibrous tissue, and this fibrous tissue is not adequate to bear weight of the individual. As a result of which, under the compressive forces, this medial cortex will start bending. Imagine this region of the bone is changed into a fibrous tissue. All right. Now, this region of the bone obviously is not capable of bearing weight, as a result of which the medial cortex will start getting compressed. And under the compressive collapse, gradually over a period of time, the hip joint or the proximal femur will start bending. And this bend will take up the shape of a Shepherd-Crook deformity. So this is exactly what is happening, the Shepherd-Crook deformity. All right. So once you have seen the picture, you have already diagnosed the condition, but what else is provided to you in the question? A patient having a progressive deformity with abdominal skin lesions. Now, what is abdominal skin lesion? It is Caffe-Euless spot. All right. So it is a core confirmatory kind of the question, that some of the bits you have taken from the X-ray, some of the bits you have taken it from the question itself. So Caffe-Euless spots having irregular margins, because the Caffe-Euless spot associated with fibrous dysplasia do have irregular margins, and Caffe-Euless spots which are associated with neurofibromatosis type 1 are having regular margins, right? So what is the diagnosis? So answer for this question is straightforward, that is fibrous dysplasia. The name of the syndrome with which it is associated is McCune-Albright syndrome. Now, this is something which you already are aware of, that McCune-Albright syndrome, and what are the conditions, what are the features under this syndrome. The first one obviously is fibrous dysplasia. The second one is the Caffe-Euless spot. And the third one is the precocious puberty. All right. So these are the 3 clinical features, which is a triad of McCune-Albright syndrome, and specifically they have provided you the 2 clinical features in the question. Hopefully the answer for this question is straightforward, and it was so easy for you to mark this answer correctly. Next, coming on to the next one, or the next section, is that a 40-year-old male presented with a history of long-standing back pain persisted in the early morning stiffness. Now you see, whenever we are having a question on the back pain with early morning stiffness, early morning limitation of the movement, loss of extension of the spine, with some segments of disability, along with the sacroiliac joint involvement, then possibly the examiner is asking anything related to ankylosing spondylitis. Now further you have to confirm it, because one of the key clinical feature of ankylosing spondylitis is pain in sacroiliac joint. It has to be provided to you in the question. And the second one is low backache with early morning stiffness. The third clinical feature that the examiners used to give you is that the relief of this pain with exercises. All right. So at least one of the feature is provided to you. So possibly this is the question asked from the ankylosing spondylitis segment. All right. yet not confirmed, but further we have to confirm it. Now, on examination, chest expansion was 3 centimeter. Inhalation, chest expansion was 3 centimeters short or lesser on inhalation. Now, what is happening in this case? That, because of the costochondral ankylosis, there will be a limited chest expansion. All right. And this limitation of the chest expansion will result in the breathlessness of the patient. So the patient will also come with the breathlessness feature, clinical feature. This is again a clinical feature of ankylosing spondylitis with redness of the eye. And you are specifically aware of that the most common extra-articular manifestation of ankylosing spondylitis is acute anterior uveitis. And this acute anterior uveitis is a feature of ankylosing spondylitis. Apart from that, another ocular features like glaucoma. So glaucoma might also result in this. And the third one is the cataract. All right. So this acute anterior uveitis associated with the red eye, your diagnosis is almost confirmed. And what is the most probable diagnosis that the patient is suffering from? Answer for that question is ankylosing spondylitis. So why is it not Dish syndrome? In Dish syndrome, there has to be an X-ray provided. There has to be increased calcification of the pre-existing bones with no calcification of the soft tissue. So this specifically has to be mentioned in Dish syndrome. That is diffuse idiopathic skeletal hyperostosis. In prolapsed intervertebral disc, there has to be a history of weight lift and there has to be a history of acute back pain which might be radiating to the both lower limbs. While in case of tuberculosis of the spine, there has to be an X-ray provided with the single level spondylodiscitis with a long clinical history of fever, low backache, early morning pain. There has to be associated comorbidities. There has to be associated positive history, past history positivity of these kind of the symptoms. So this is how the question is different. And here specifically they have given you the clinical features which goes in the favor of ankylosing spondylitis coupled with extra-articular manifestation on the basis of which you have already confirmed your answer. So hopefully the answer for this question was also very simple. Just in a single go, you have marked the answer for this particular question. Now, during an aggressive gym session, 26-year-old guy came with the bulges as shown in the image. What is the injured location? Now, you know what happens is that this is the biceps muscle and the biceps is originating from the coracoid process. And you know the long head of the biceps, if it is ruptured, the tendon of the long head of the biceps, if it is ruptured, then the entire biceps will be accumulating in the arm. The bulk of the biceps muscles would be accumulating in the arm. And when you flex the elbow like this, that accumulated biceps bulk will be over prominent. All right. So this is the kind of the biceps muscle which is no more connected to the coracoid process. So it is now accumulated in the arm. And when you flex the elbow, there is abnormal over bulging of this biceps bulk. The name of this sign is Popeye sign. Now it is related to the cartoon character that all of you are aware of. Like on the intake of the spinach, there was over bulging of the biceps. So this is something related to that cartoon in particular. And here, this sign is known by the name of Popeye sign. And what is the primary pathology? What has happened? It is the tear of the biceps muscle, biceps tendon. So long head of the biceps tendon. All right. Actually, this is the question which we taught with the hope that one day they are going to ask this question. This question was the first time was asked in 2019 All India examination, right? And since then it has been asked 2 to 3 times again. Hopefully that answer was straightforward again if you have gone through the lectures. Now, which of the following, next question is that which of the following nerve test is depicted in the image shown below? What is the name of the nerve test which is depicted in the image shown below? Obviously, the name of the test over here is pen test. And this pen test you have diagnosed it not by identification of this pen or not by looking at this pen. No, it is the abduction of the thumb that is being tested over here. So it is the thumb abduction that you are testing. And all of you are aware of the fact that abduction of the thumb is the function of abductor pollicis muscle and abductor pollicis is supplied by the median nerve. Simple. So answer for this question is median nerve. So what is being tested in pen test? You ask the patient to abduct the thumb and touch this pen. If the patient is able to do so, median nerve is intact. If the patient is not able to do so, median nerve is injured. So hopefully
You have understood everything related to this particular session. The questions were simpler, the questions was much easier, and this is how the questions are being asked today. With the cognitive improvement kind of the questions, where you can relate multiple of the scenarios which are provided to you in the question and jump on to the conclusion then. All right. All the best. Thank you very much for your time.
Hello. So I hope you had a very good exam, CBoT exam. There were a few questions from anesthesia which I will discuss with you. The first question which was asked was from a very common topic which is very expected question, and that is from Malampati grading in pre-anesthetic evaluation for predicting difficult airway. So question was, a patient's oral cavity was assessed for intubation. She was classified under class 3, Malampati class 3. Of modified Malampati classification. What are visible parts in given classification of Malampati? See, one thing which can create a confusion here is that what is this modified Malampati? What is this modified Malampati? So, modified Malampati is nothing. It's Malampati classification only. The 4th grade was added later. It was not added by Malampati, and when the 4th grade was added, it was called modified Malampati. So, basically Malampati grading. Let us talk about Malampati grading. This Malampati grading is pre-anesthetic evaluation. Pre-anesthetic evaluation to predict difficult intubation. To predict difficult intubation. Okay, and we have 4 Malampati grades: MMP 1, 2, 3 and 4. 1, 2, 3 was originally given by Malampati, and the 4th grade was later on introduced. So, when 4th was introduced, it was called modified Malampati. So, it's same. Okay. So, what it is graded into 4. Now, remember 1 and 2, no difficulty anticipated. 3 and 4, difficulty anticipated. And what do I mean by Malampati grade 1? So, how do I do Malampati grading? I ask the patient to sit in front of me, open his mouth, take his tongue out, and without vocalization, take the tongue out. Tongue should be out of the oral cavity. And then I try to see the structures of oral cavity. If I am able to see all the structures, I write Malampati grade 1. That is hard palate, soft palate, uvula, fauces, tonsillar pillars, everything seen, grade 1. If one like tonsillar pillar is not seen, then grade 2. And if only, let's say, hard palate, soft palate and the base of uvula is seen, not the tip of uvula, then it's grade 3, and grade 4 is only hard palate. So, in grade 3 and grade 4, most of the structures of oral cavity is not visible, which means tongue is obscuring our view. Tongue is big and it will make the laryngoscopy and intubation difficult because tongue has to go out of our way, and then only we will be able to see the epiglottis lifted and see the glottic opening, right? So, in this question, the patient is classified Malampati grade 3. And what I said in grade 3? In grade 3, we are able to see the hard palate, right? And we are able to see the soft palate, and we are able to see the base of uvula, right? Not the tip of the uvula. The hanging tip is not seen. And in grade 4, only hard palate. And these 2 grades are predictive of difficult intubation. So, in this, what will be the answer? Soft palate and base of uvula. This will be the answer. Okay. In grade 4, soft palate is invisible. In grade 1, soft palate, fauces, uvula, tonsillar pillars, everything. Soft palate, fauces, tonsillar pillars, uvula. So, these 2, this is, let's say, grade 1 and this is grade 2, and this would be grade 4, and this is our grade 3. Okay. So, remember this. Okay. Next question. A patient undergoing total thyroidectomy, right, for goiter, multinodular goiter or thyroid nodule, whatever, experiences obstruction and cyanosis after extubation. So, when the patient was extubated, Now, during total thyroidectomy, there are some very common complications, not very common, but some very sinister complications which comes, like hematoma, like trichomalacia, like the nerve of the larynx getting damaged, like your superior laryngeal nerve getting damaged or recurrent laryngeal nerve getting damaged, right? So, we are always watchful for those complications. So, in this question, patient experiences obstruction and cyanosis. So, the vocal cords are not moving, the vocal cords has approximated. That's why patient is having cyanosis, okay? So, injury to unilateral recurrent laryngeal nerve. In unilateral, there would be hoarseness, there would be, let's say, not complete closure of the vocal cord. So, in unilateral, we will have hoarseness and noisy breathing, right? Injury to bilateral, this is injury to bilateral recurrent laryngeal nerve. Well, in bilateral recurrent laryngeal nerve, the vocal cord will approximate. Vocal cord will approximate, they will approximate, and then we will have difficulty in intubation, and what we need now most of the time in this, we get a tracheostomy done. So, answer has to be injury to bilateral recurrent laryngeal nerve. Okay. Injury to unilateral superior laryngeal nerve will again not produce this kind of symptom, and hematoma would cause little obstruction in breathing after, let's say, because of the pressure symptoms which it will create, but it will not lead to, let's say, obstruction and cyanosis, though all these four would produce a little respiratory embarrassment in the patient, okay. But if it is obstruction and cyanosis after extubation, right, most likely it is bilateral injury to the recurrent laryngeal nerve. So, answer has to be B. Okay. A patient undergoing surgery was maintained on halothane. The body temperature of the patient was increased and there was uncontrolled muscle contraction. Which of the following drugs can cause this condition? Well, the body temperature was increased, right? Body temperature was increased and the muscle activity increased. So, increased body temperature, increased muscular activity, Well, this is pointing towards something called malignant hyperthermia, So, we need to look for the drug which precipitates malignant hyperthermia, which is a perioperative complication. So, one drug is your halothane. So, halothane can be the culprit, and what would be the other drug which can precipitate? So, what are the options? Succinylcholine, D-bucurare, rocuronium, atrocurium. Now, these three does not cause precipitate malignant hyperthermia. What precipitate malignant hyperthermia is succinylcholine. The answer has to be succinylcholine. This is a very popular topic again, malignant hyperthermia. And in malignant hyperthermia, we need to know, that drugs which precipitate malignant hyperthermia. So, two sets of drugs is most important which we have to remember. One, your inhalational anesthetic. In inhalational anesthetic, remember halothane, isoflurane, sevoflurane, desflurane, all can precipitate malignant hyperthermia. And the most important drug which precipitates malignant hyperthermia is succinylcholine. So, never forget succinylcholine for malignant hyperthermia. And how do we diagnose malignant hyperthermia? If the CO2 starts increasing, if temperature starts increasing, if blood pressure starts increasing, if heart rate starts increasing, intra-op, and the muscle activity increases, then we say it's malignant hyperthermia. Most probably it's a perioperative complication because it is happening because of the exposure to anesthetic agent. There's one more drug which can precipitate, but let's say human cases yet not reported, animal studies have shown, and that is lignocaine. Right? So, lignocaine can precipitate malignant hyperthermia. So, these are the drugs which can precipitate malignant hyperthermia. Remember. Okay, next question. A 40-year-old patient became unresponsive and unable to record pulse after receiving shoulder block with 0.25% bupivacaine by an anesthesiologist. So, a regional anesthesia was given and the patient became unresponsive and unable to record pulse. That means patient went into cardiac arrest. So, unresponsive and no pulse means cardiac arrest. The best initial step in management. So, anyone going into cardiac arrest, the first thing we always do is CPR. But this is a special circumstances in which the patient has landed up in cardiac arrest post-regional anesthesia. So, it's because of the local anesthetic which would have got systemically absorbed and caused the cardiac arrest. So, we know the cause this time. So, we will manage the patient by CPR, and also we will target the cause. So what is the cause? Cause is local anesthetic systemic toxicity, and the antidote for that is 20% intralipid emulsion. 20% intralipid emulsion. Okay. So along with CPR, we will start the infusion of 20% intralipid emulsion. The local anesthetic gets absorbed in the lipid, and lipid escape of the local anesthetic happens. So this is kind of antidote, the definitive management, right? So we will go for CPR with 20% intralipid emulsion infusion. Okay. So this is the answer. Remember, if the cardiac arrest is post local anesthetic systemic toxicity after the regional block, the management is CPR plus 20% intralipid emulsion. Okay. If the cardiac arrest is post opioid poisoning, so cardiac arrest or respiratory arrest post opioid, then in this we go for CPR plus naloxone, right? If we have cardiac arrest post some specific toxin, we would do CPR plus give antidote for that toxin if we know there is some antidote for that toxin. Got it? So this is how we manage. We go for definitive management along with CPR. Okay. Next question. Which of the following drug is contraindicated in glaucoma and open eye surgery due to its increased effect on intraocular pressure? So we have always discussed only one drug causes increase, IV anesthetic, which causes increase in all the pressures of the body, and that is our ketamine. That is our ketamine. So ketamine increases all the pressures of body. So answer has to be ketamine. Okay. So ketamine is increasing all the pressures of body. Remember this. Okay. So ketamine, which is sympathomyometic. Okay. This is sympathomyometic. So it increases the intraocular pressure. It increases intracranial pressure. It increases intragastric pressure. It increases the blood pressure. It increases the heart rate. So it is increasing all the pressure. Remember this. Okay. So these were the 5-6 questions which was let's say formed for you, and I hope all the 5-6 questions you have answered well, and my best of luck for your exam. Thank you so much.
Hello friends, welcome to the CBoT Part 2 session, and I am Dr. Harmeet Goyal, your Obs and Gynae faculty, discussing the Obs Gynae questions. Question number 1, 28-year-old female came with an absence of periods for 4 months. She also has irregular periods in the past 4-5 cycles. On examination, she looks overweight. Her breasts are normal, no hirsutism. Pelvic examination, including per vaginum examination, is normal. All of the following workups are done initially except. Now, looking at the history, it appears that it is a case of secondary amenorrhea, because absence of periods for 4 months and she has been having irregular periods in past 4 to 5 cycles. But other examination is normal, that breast development is normal and there is no hirsutism and she looks overweight. So which of the following will be done except? So whenever a patient comes with secondary amenorrhea, what is the definition of secondary amenorrhea? Secondary amenorrhea means amenorrhea for 3 consecutive cycles. Amenorrhea for 3 consecutive cycles, or 6 months of amenorrhea in previously normal menstruating females in the absence of pregnancy. That means whenever a female comes with a history of secondary amenorrhea, first thing you should do is do a urine pregnancy test to rule out pregnancy. If you have ruled out pregnancy, then next step is go for a progesterone challenge test. Okay. And look for the withdrawal bleeding. That means you give any progesterone for at least 5 to 7 days. Most of the time we use medroxyprogesterone acetate 10 milligram for 5 days and stop. If the withdrawal bleeding is present, that means the cause of this secondary amenorrhea was anovulation, and the most common cause for anovulation is polycystic ovarian disease. Second close differential diagnosis is late onset of congenital adrenal hyperplasia, and two important systemic causes of secondary amenorrhea you must rule out. That is the thyroid disorders. So you will get a TSH done and you will get a serum prolactin levels done to rule out hyperprolactinemia or hypothyroidism. And if there is no withdrawal bleeding, that means there is a estrogen progesterone might be present or might not be present, but withdrawal bleeding is absent. So in that case, you give estrogen followed by progesterone and stop and wait for the withdrawal bleeding. In case the withdrawal bleeding occurs, that means the cause was at the level of compartment 2, compartment 3 or compartment 4. So compartment 2 means ovarian cause, that means polycystic ovarian disease or Sheehan syndrome or prolactin secreting pituitary tumors. It might be at the level of the pituitary or it might be at the level of the hypothalamus. If withdrawal bleeding is still absent, that means the cause is at the level of end organ, that is the uterus. So in this case, we should be doing urine pregnancy test as a first step. Second will be the progesterone challenge test, and then you have to get the serum prolactin and TSH levels done. But serum estradiol is never our first investigations, because I am not suspecting a case of primary ovarian insufficiency or premature ovarian failure. So according to the question provided to me and the options, I would like to mark serum estradiol as my answer. Now, let us just go through quickly what are these compartments. Compartment 1 is uterus and its outflow tract. Outflow tract means cervix, vagina, hymen. So the causes for secondary amenorrhea can be Asherman syndrome. That means there is synechia between anterior and posterior uterine wall leading to secondary amenorrhea, leading to infertility. So the predisposing factor is any type of curettage. Next is cryptomenorrhea. Acquired cryptomenorrhea, that means it may be like there is conization of the cervix or there may be amputation of the cervix being done and the left out part got stenosed, so the menstrual blood keeps on collecting in the cervix or in the vagina. The next cause is at the level of ovary, that is called as compartment 2. PCOD, premature ovarian insufficiency, radiotherapy or surgery. Compartment 3 is the pituitary, where there is hyperprolactinemia, prolactinomas or Sheehan syndrome, and compartment 4 is at the level of hypothalamus, where there can be a GnRH deficiency because of the stress, exercise or anorexia nervosa. Okay, so whenever a patient comes with secondary amenorrhea, we first do a urine pregnancy test. Urine pregnancy test can be negative or it is positive. If it is negative, you give progesterone challenge test and wait for the withdrawal bleeding. Wait for the withdrawal bleeding. Withdrawal bleeding is present. That means the cause was anovulation, and in anovulation, the most important cause is PCOD. Others can be congenital adrenal hyperplasia. Then there can be hyperprolactinemia, or there can be hypothyroidism. So you can get the serum prolactin and the TSH levels done. If the withdrawal bleeding is absent, that means you go for estrogen and progesterone challenge and then stop and check for the withdrawal bleeding again. If the withdrawal bleeding is present, that means the cause is at the level of ovary or pituitary or hypothalamus. If the withdrawal bleeding is absent, that means the cause is at the level of uterus, that is Asherman syndrome. Okay. So, secondary amenorrhea, first step is urine pregnancy test, next is progesterone challenge test, third is estrogen followed by progesterone. Okay. So, in this question, I am going to do the urine pregnancy test, progesterone challenge test, serum, TSH and prolactin levels done. Okay. So, accordingly, I would like to make my diagnosis, and confirmatory will be the next set of investigations. So, quickly, urine pregnancy test, if it is negative, we go for a progesterone challenge test, look for a withdrawal bleeding. If it is present, that means the cause is anovulation. The cause can be PCOS, congenital adrenal hyperplasia, hypothyroidism or hyperprolactinemia. If it is absent, that means we will give estrogen, progesterone. So, if withdrawal bleeding is present after stopping the estrogen-progesterone combination, then bleeding is present, that the cause is at the level of compartment 2, compartment 3 or compartment 4. If withdrawal bleeding is absent, that means the cause is at the level of Escherman. If there is no withdrawal bleeding, I am going to proceed to the hysteroscopy, because it will confirm the diagnosis of Escherman syndrome, and simultaneously I would like to treat Escherman syndrome. Next, question number 2. A 42-year-old female presents with heavy vaginal bleeding. Her last childbirth was 8 years back. On examination, uterine size is 20 weeks. Okay. So, uterus is coming up to the level of umbilicus. Okay. With irregular multiple fibroids. There are multiple fibroids in the uterus. Okay. And ultrasound has confirmed the multiple fibroids in this uterus. So, what treatment you would like to offer in this patient? So, since the age of the patient is 42 years and she has heavy vaginal bleeding, that means she is a symptomatic patient presenting with menorrhagia, although the duration of menorrhagia is not written, but the size of the uterus is nearly 20 weeks. That means multiparous lady with menorrhagia, with multiple fibroids and a bigger size uterus. What are the options given to me are myomectomy, abdominal hysterectomy, LAVH or GnRH analogues. First of all, 20-week size uterus will not respond much if we are giving any hormonal treatment. Neither she is in the childbearing age. She is already crossed the 40 years of age. So, I am not going to think of doing a myomectomy in this case. But now I am left with two options, abdominal hysterectomy or laparoscopic assisted vaginal hysterectomy. Had it been the size of the uterus less, that is 10-12 week size, I would have thought of doing LAVH. So, in this case, according to the size of the uterus, according to the history, according to the age and according to the symptomatic patient, I would like to perform the abdominal hysterectomy in this case. Now, what are the treatment modalities available in cases of management of fibroid? If the fibroid is asymptomatic and she is in the postmenopausal age group, or she is having pregnancy and then there is a fibroid, or all symptomatic patients of fibroid, I am going to do the expectant management in that case. I am going to do the expectant management in that case. But if it is a symptomatic patient, so I have got three options. First of all, there is a medical management available. In the medical management, there are drugs, that is to treat the symptoms of menorrhagia, where I can give progesterone, I can give tranexamic acid, I can give Mirena insertion, I can give OCPs. This is to treat the symptoms of menorrhagia. It is not going to shrink the size of the fibroid. What are the drugs that shrinks the size of the fibroid? That is GnRH analogues, agonist and antagonist. It can be danazole, it can be ulipristal, or it can be letrozole, which is anti-estrogen in its action. Okay. Now, in the surgical management, if the age of the patient is young, I would prefer, and like she's having infertility, then I would like to go for a myomectomy. If it is a multiparous lady, family complete, menorrhagia, size of the uterus is more, I would like to prefer taking the patient for total abdominal hysterectomy. Now, in the certain recent advances, there is uterine artery embolization that can be done for those females whose family is complete and they are having fibroid, not responding to medical treatment, and either the surgery is contraindicated or they are not convinced for surgery. Then we can go for a uterine artery embolization, or magnetic resonance focal ultrasound that will shrink the size of the fibroid. This is uterine artery embolization. What are the conditions in which uterine artery embolization is being done? Number 1 is fibroid uterus. Doing this treatment, the fibroid will shrink in size. It can be a treatment for the patients of atonic PPH. It can also be a treatment for the patients of cervical fibroid when there is so much of the bleeding which has taken place and we want to achieve the hemostasis. So, uterine artery embolization can be tried. Now, uterine artery embolization karta kaun hai? This is interventional radiologist. Interventional radiologist under deep sedation. Under deep sedation, the femoral artery is being catheterized and from there an embolizing agent is being put. Embolizing agent is polyvinyl alcohol, and from the femoral artery, the uterine artery is being catheterized and polyvinyl alcohol is being injected, which will cause embolization of the uterine artery and blood supply to the fibroid reduces. So, shrinkage in the size of the fibroid is achieved after 6 months. Shrinkage in the size of the fibroid is achieved after 6 months. Next, this is magnetic resonance guided focused ultrasound for uterine fibroids. There is an MRI table and there is a beam of the ultrasonic waves which is being directed towards the uterus which is containing the fibroid. Because of this effect, the fibroid shrinks in size. Next. Another question is a 43-year-old female presenting in the gynae OPD with abnormal uterine bleeding. That means it is a case of AUB for last 6 months. 43-year-old female with AUB for 6 months and pelvic examination ultrasound shows it is normal. What will be your next line of management? When it is a female whose age is 43 years and she presented with AUB for 6 months, where ultrasound comes out to be normal. What is my next line of management? In this case, what I am trying to rule out, a patient which is presented with abnormal uterine bleeding for 6 months and her age is above 40 years. In this case, I want to check the endometrial lining. I would like to check the endometrial lining. So, ultrasound is showing normal. So, I want to take a biopsy that is called as endometrial sampling by using a pipple, or by using a Karman's cannula, whichever is available to me, and then I would like to send it for histopathological examination. For what? To rule out the possibility of endometrial hyperplasia or endometrial cancer. So, in this case, any female whose age is above 40 years presenting with abnormal uterine bleeding and maybe the ultrasound finding or pelvic examination may be normal, okay? I want to check the endometrial lining. For that, I need a sample. So, my preferred investigation will be endometrial sampling. Send it for histopathological examination to rule out the possibility of endometrial hyperplasia or endometrial cancer. I am not going to take up this for hysterectomy because there is no clear-cut diagnosis which has been made. Now, I am not going to do a Mirena insertion, neither I am going to prefer giving her oral contraceptive pills. In this case, my answer will be endometrial sampling. Okay, so this is a pipple and this is a Karman's cannula, and endometrial sample is being sent for histopathological examination in a formalin vial. A vial that contains formalin. Now, you should also know what are the indications of doing endometrial biopsy or endometrial sampling. Just remember, AUB occurring above 40 years of female, you should rule out the endometrial hyperplasia or carcinoma. If abnormal uterine bleeding is occurring in a female whose age is less than 40 years and there is a risk factor present, that is polycystic ovarian disease or tamoxifen, or it is like obesity, or if there is any history or heredity or familial predisposition of endometrial ovarian or breast cancer, then I am going to take up the patient for endometrial biopsy. if the endometrial thickness in a premenopausal female is above 12 mm, then I am going to do endometrial sampling or biopsy. Or if it is a postmenopausal female whose cutoff value for endometrial thickness is 4 mm, if it is crossing that, I am going to take the patient for endometrial sampling. Or if there is a patient of AUB not responding to medical treatment, I am going to do endometrial biopsy or sampling. So, these indications you must remember. Next, a 28-year-old female came to gynae OPD with a history of 2 months amenorrhea. She has come for your advice as she accidentally had exposure to radiation. What is your advice to her? The options given to me are MTP, CVS, chorionic villus sampling, ultrasound, or continuation of pregnancy. Such a question has already been asked in the NEET PG exam as well, and many students make up a mistake, especially the students of Fmge batch make up a mistake of marking the answer as MTP. Friends, one single radiation exposure is not at all an indication to take up the patient for MTP. Remember, the maximal permissible radiation in a pregnancy is 5 rads. Okay. If this is more than exposure, if there is exposure is more than 10 rads, then it is associated with chance of fetal loss. But since it is an accidental exposure to the radiation, so what is advisable is continuation of pregnancy. Next, a 35-year-old priming gravida was admitted in the labor room with 30 weeks pregnancy, having mild labor pains. Per abdomen examination, uterus was over distended, fetal heart rate of both babies. So it is a case of twin pregnancy. Was regular. Per vaginum examination is 3 centimeters dilated. First baby was vertex. Since the first baby was vertex, that is why the trial of labor was given. And presentation is -1 station, pelvis is adequate. 4 hours later, she developed acute pain abdomen and there is bleeding. Ultrasound shows, the per abdomen examination shows it is tense tender uterus, but fetal heart rate was normal and the vitals of the lady was stable. What will be your next line of management? Before I read out the options, this is a case of twin pregnancy, 35-year-old. So 35-year-old is a risk factor number 1 because it is elderly priming gravida. Elderly priming gravida, that is risk factor number 1. Twin pregnancy, risk factor number 2. And now third is pain abdomen, bleeding and tender uterus. This goes in favor of, according to me, is abruptio placentae. So, in spite of the fact the vitals of this patient are stable, in spite of the fact that the fetal heart rate of both the babies are normal, but a elderly priming gravida, 35-year-old elderly priming gravida with a twin pregnancy now developed abruptio placentae, where there is a tense tender uterus. Abruptio placentae means the placenta has already been separated and there may be a chance of retroplacental clot. Keeping in mind the 3 risk factors, one is the elderly priming, number 2 is twins, number 3 is abruptio, I am going to take up this patient for an emergency cesarean section. Okay, since looking at her age, it is elderly, number 2 twin pregnancy, number 3 abruptio placentae. So I am not going to do wait and watch because this placental abruption can increase and the fetus can get compromised. And I am not going to start augmentation drip of oxytocin. I am not going to sedate the patient with Phenargan, whereas I am going to plan an emergency cesarean section in this case. Next, Mrs. Rekha, having her child of 2 years, presents with pruritus vulvae and amenorrhea. Okay, so this is a case of secondary amenorrhea. She gives history of severe blood loss, failure of lactation during pregnancy. She is lethargic, cold intolerance and multiple skin infections and anemia. What is your likely diagnosis? This appears to me a case of postpartum pituitary necrosis. Why postpartum pituitary necrosis? Because there is a history of severe blood loss being given and That is that there was a severe atonic PPH and there was a failure of lactation. So she has presented with secondary amenorrhea, failure of lactation, lethargy, cold intolerance, there is anemia, multiple infections, etc. So this is a clear-cut case of Sheehan's syndrome. It is not Escherman syndrome because there is no history of curettage which is written. It is not hyperprolactinomas because it is failure of lactation. In hyperprolactinemia or prolactinomas, there will be increased milk secretion from the breast, which is not seen in this case. So this is secondary amenorrhea because of postpartum pituitary necrosis, secondary amenorrhea because the anterior pituitary hormones become deficient. So there is an FSH deficiency and LH deficiency leading to amenorrhea, decrease in prolactin deficiency leading to failure of lactation, cold intolerance, etc. That is TSH deficiency, and if there is multiple infections and all that, that means she is prone for like infections. There may be an ACTH deficiency as well if we look into the detailed history of this patient. Next. A 40-year-old woman visits gynae OPD with history of intermenstrual bleeding. Intermenstrual bleeding means it is a case of metrorrhagia. Intermenstrual bleeding, that means it is a case of metrorrhagia. Ultrasound image shows that there is lesions within the endometrial cavity with a feeder vessel sign. Always remember, whenever there is a feeder vessel sign, I have been telling you in my lectures, feeder vessel sign, age of the patient 40, presenting with intermenstrual bleeding. This is a clear-cut case of, what is the options given to me? Endometrial polyps, submucosal fibroid, sarcoma of uterus, endometrial cancer. So this feeding vessel sign does not fit into sarcoma or endometrial cancer, neither it fits into the submucosal fibroid. Feeder vessel sign, if they have written it very, very clearly, it goes in favor of endometrial polyp. So this is how you see in the endometrial polyp there is a feeding vessel sign or feeder vessel sign. So what will be the next gold standard investigation to manage this case? Answer will be hysteroscopy. Answer will be hysteroscopy, because with this you will like to take out the endometrial polyp and you will send it for histopathological examination. Next, which of the following is true statement about complete H-molar pregnancy? Complete H-mole is diploid and abnormal chromosomes are paternal in origin. Abnormal chromosomes are maternal in origin. Abnormal chromosomes are maternal and paternal, or abnormal chromosomes are maternal and paternal, and complete mole is a triploid. Now, what happens in the pathology of the complete mole, complete H mole? Okay. Normally, what happens? There is a ovum which is haploid, one set of chromosomes, it is 23X chromosomal pattern, and one set of chromosomes the child derives from the father. So in this case, there is an empty ovum with no chromosomes and it gets fertilized by a sperm which is 23X. After fertilization, the chromosome of the sperms duplicates upon itself. Okay, duplicates upon itself. So fertilization has occurred, something will be formed. Since there is no chromosomes from the ovum, so it will form grape-like vesicles. So the karyotype in 90% cases will be diploid with 46XX chromosomes. Okay. So another case, 10% of cases it is 46XY where there is empty ovum. Empty ovum gets fertilized by two sperms. Okay. So there is dispermy. Here it is monospermy. Okay. So in this case again the grape-like vesicles will be formed. Okay. And the karyotype will be, here one sperm was 23X, one was 23Y. So it will be 46XY in 10% of the cases. So abnormal chromosomes are paternal in origin. Complete mole is diploid and abnormal chromosomes are derived from the father, paternal in origin. Whereas if it is a partial mole, if it is a partial mole, in partial mole it is triploid. In partial mole it is triploid, 69 XXX. One empty ovum was there in cases of the complete mole. In this case, the ovum has 23 X chromosomes, but it gets fertilized by 2 sperms. So, there is grape-like vesicles and there is a fetus. So, this is partial mole triploid. Okay, again the abnormal chromosomes are derived from the father. So, abnormal chromosomes are always paternal in origin, remember that. Next. A pregnant lady with 36 weeks of pregnancy came with the complaints of blurring of vision, headache, BP was 180 by 120. After repeating for 20 minutes later, the blood pressure is 174 by 110 millimeters of mercury. What will be your next line of management? So, the blood pressure and the warning symptoms like symptoms of end organ damage, which is the visual symptoms and the cerebral symptoms are present. So, this is a case of severe pre-eclampsia. Although the proteinuria is not written in the options and proteinuria does not signify the severity as well. It has been removed from the latest pattern of criteria. Okay, and there are warning symptoms of impending eclampsia present. So, it is a case of severe pre-eclampsia. Let us see what are the options given to me. Admit and observe. If it is so much high blood pressure, you are just going to do wait and watch. This is wrong. Admit, give antihypertensive and continue the pregnancy till term. That's wrong. In high-risk pregnancies, we terminate the pregnancy at 37 completed weeks. So, that is also wrong. Give antihypertensive and follow up in OPD. No way. What is written in the question? It's a question of severe preeclampsia with a warning symptoms. Okay, blurring of vision, headache is there, and blood pressure is very high. She can throw fits. So, we have to admit her, give antihypertensive, and terminate the pregnancy. First of all, what is a very important step is adding anticonvulsant, because we have to prevent convulsion. So, we are starting prophylactic magnesium sulfate, and then we would like to do the per vaginum examination, assess the Bishop score, and then decide the mode of delivery. So, whenever you start the magnesium sulfate, pregnancy needs to be terminated. It's not that you are starting the magnesium sulfate and you are withdrawing the drug. The way you withdraw the drug, the convulsions can get precipitated. So, in a case of severe preeclampsia with warning symptoms or abnormal lab findings, present, in that case, first step is anticonvulsant. And anticonvulsant of choice is magnesium sulfate. And definitive step in management is termination of pregnancy. Termination of pregnancy does not mean every case you will take up for cesarean section. You have to assess the case. Now, a 35-year-old lady was given ovulation induction and beta HCG injections. Later, she came with pain, lower abdomen. On examination, the ultrasound, the bilateral thecal lutein cysts were there. So, there is history of bilateral thecal lutein cysts given to us in the ultrasound finding. So, she is been given ovulation induction with beta HCG injections. Okay. Ovulation induction might be given with clomiphene citrate or letrozole, or it is HMG, human menopausal gonadotropin, and to trigger the ovulation, beta HCG injections was given. But in this case, there is a thecal lutein cyst of 4 cm size. Are you going to put the patient on oral contraceptive pills? No way. Remove them laparoscopically? No. Continue ovulation induction? No. I am going to stop all ovulation induction. For the thecal lutein cyst, to be present, there are few conditions. Number 1, it can be a case of multiple pregnancy, that is twin pregnancy. it can be beta HCG is triggering beta HCG injection that can trigger the theca luteal cyst formation, or it can be gestational trophoblastic tumors or diseases like H mole or residual mole or choriocarcinoma. So if it is beta HCG injection or ovulation induction, you have to stop the ovulation induction and injection that triggers the ovulation. This theca luteal cysts will resolve. Now, causes I have mentioned that multiple pregnancy, gestational trophoblastic diseases and ovulation induction. Beta HCG, why it leads to the formation of theca luteal cyst? Because the alpha unit of HCG resembles that of LH. So, LH is the hormone that is stimulating the theca cells to lead to the formation of the cysts in this case. Okay. So, it is acting on the LH receptors and it will cause stimulation of the theca cells. There will be theca cell hypertrophy leading to the cyst formation. Next, a 28-year-old female presents with her husband, 32-year-old husband, with infertility evaluation. The couple has been trying to conceive over a year without any success. The woman has irregular menstrual cycle. First of all, let me tell you, in some of the questions or some of the guest question series or in the, in the test and discussions, we have already taken up the small, not very lengthy questions. We have given you the single liners, the image based questions, the previous Fmge exam questions as well. But we want to prepare you for a tougher aspect of exam as well. So if there are long or lengthy clinical questions, you should be able to answer. That is what is an idea of keeping this CBoT series, so that you are better prepared for the lengthy set of questions as well, which might be expected in your upcoming exam. So that is why I have added up some of the lengthy questions in this series. So there is a history of irregular menstrual cycles with her last periods occurring 9 weeks ago. Her husband's semen analysis is normal. Vitals, heart, lung, abdominal examinations are normal. Pelvic examination reveals that it is a mobile uterus without adnexal masses. That means it is not a case of endometriosis. Urine pregnancy test was negative. TSH and prolactins were normal. So it is not a case of, not related with any hormonal abnormality. Since the TSH is normal, so that means there is no thyroid disorders. It is not hyperprolactinemia. So you never think of giving any bromocriptine or it is a cause of anovulation. So hyperprolactinemia, hypothyroidism, they have already ruled out by giving you the hint that TSH and prolactin levels are normal. But why she is having irregular periods? Let us see. Her free testosterone levels are elevated. So there is just one finding which I can find here is free testosterone levels are elevated, plus she has irregular menstrual cycles. Irregular menstrual cycles with no other abnormality detected, with a mobile uterus and no adnexal masses, according to this history where the serum testosterone is elevated and there is a history of infertility where semen analysis, ultrasound findings are normal. Looking at this history, we have to make our provisional diagnosis and then look out the options. So my provisional diagnosis in this case will be polycystic ovarian disease, where first investigation we should do is the serum testosterone levels. Okay, so this is not primary ovarian insufficiency, it is not endometriosis since there is no adnexal masses, it is not hypothalamic amenorrhea, this is polycystic ovarian disease. So you will get a complete hormonal profile done, E to E1 ratio, fasting insulin levels, FSH LH ratio, then ultrasound might show the necklace pattern of ovaries, but here it is written ultrasound findings are normal. So my provisional diagnosis in this case will be polycystic ovarian syndrome. I hope you are understanding the explanatory part of this series, and lengthy questions, students, have been made deliberately so that you should get into the practice of solving these questions also very correctly. Now, 39-year-old woman presents with intermittent episodes of involuntary urine loss exaggerated by the exercising, coughing and laughing, with a history of vaginal deliveries and gestational diabetes mellitus. That means she has vaginal deliveries there was gestational diabetes mellitus, and there is, urinary incontinence whenever she is doing some strenuous exercise, she is doing coughing, laughing, sneezing. So is it overflow incontinence, urge incontinence, mixed urinary incontinence, or stress urinary incontinence? According to the history, it is suggestive of the stress urinary incontinence. While she is coughing or laughing, she is urinating. Okay, this is because when there was a childbearing and during the delivery, there might be overstretching of the muscles, perineal muscles or pelvic floor muscles has taken place, and might be there is weakening of the connective tissue supports, which has led to the bladder neck prolapsing into the vagina, leading to the urinary difficulty, where that is stress urinary incontinence. So what is the treatment you are going to give for stress urinary incontinence is TVT, that is tension free vaginal tape, or TOT. TOT is transobturator tape. Next, what is the probable cause of pelvic pain in a 42-year-old female with a painless menstrual period? For few years ago, the patient had tubal ligation after her last delivery. There is heavy bleeding, there is tender uterus on palpation and boggy uterus on examination. So is it adenomyosis, fibroids, endometriosis, or pelvic inflammatory disease? Since one hint in this question is age above 40 years. Number 2, there is a pelvic pain. Pelvic pain. Number 3, there is menorrhagia. Number 4, there is tender uterus with boggy mass. All this history, 42-year pain, menorrhagia, tender uterus, goes in favor of adenomyosis. Adenomyosis is occurring in a 40-year-old female where there is dysmenorrhea, chronic pelvic pain, there is menorrhagia, and uterus is felt uniformly enlarged up to 12 to 14 week size, or it is a bulky uterus, but it is tender uterus. What is adenomyosis? Presence of endometrial glands in the myometrium. Adeno means glands, meiosis means muscle. So this is what is the history and examination findings suggestive of adenomyosis. The investigation that can pick up adenomyosis is MRI scan, but the gold standard will be the histopathological examination. So in this female, first of all, we will offer her the medical treatment, like we can offer her Mirena, progesterone, letrozole, Trenexa MF, etc. But if she is not responding to the medical treatment, we can go for surgery in the form of hysterectomy. Next, a 27-year-old nulliparous woman presenting with left pelvic pain for last 1 year, constant pelvic pressure exacerbated by exercise, sexual activity. During the pelvic examination, uterus appears normal in size with no unusual cervical discharge. The bimanual examination indicates tenderness in the left adnexa. Tenderness in the left adnexa. And ultrasound shows unilocular mass in the left ovary with consistent low-level echoes. What is this condition likely? Okay, there is a history that she is nulliparous. Maybe she is married and she does not have any child. And during the sexual activity, the pain gets exaggerated. That means there is a history of some pouch of Douglas tenderness or pain. Okay, but uterus appears to be normal and there is tenderness in the left adnexa. So tenderness does not signify ovarian cyst. It is not pelvic inflammatory disease, and in young patients usually adenomyosis is very unlikely. According to the history and examination suggestive, my provisional diagnosis will be endometriosis in this case. So why there is pain during the sexual activity? That means there may be puckering, or there may be scarring, or there may be pouch of Douglas endometriosis, which is leading to pain during the coitus. 26-year-old woman at 30 weeks gestation is in her first pregnancy, presenting with severe headache, blurring of vision, history of migraines. She took paracetamol but not relieved. developed a bilateral frontal headache, blood pressure is 160/90, what is your provisional diagnosis? So in this case, blood pressure is elevated and there is some warning symptoms written, which is headache, blurring of vision, and this pain is not been relieved by paracetamol. So this is her first pregnancy and she is hypertensive with the warning symptoms present. So if the warning symptoms present, then we do not call it as a gestational hypertension. In gestational hypertension, there is a blood pressure developing after 20 weeks, there is no proteinuria and there is no warning symptoms. It is likely to be a case of preeclampsia and might be a severe preeclampsia. If the warning symptoms become very severe, we have to go for the lab investigations and accordingly we will be able to correlate the results. There is no history of convulsions, so it is not eclampsia, it is not idiopathic intracranial hypertension, that never presents like this. Okay. So classification of hypertensive disorders in pregnancy. Gestational hypertension means blood pressure developing after 20 weeks of pregnancy and this blood pressure comes down to normal within 12 weeks of delivery. Preeclampsia means blood pressure plus proteinuria, although proteinuria does not signify the severity, but in this question the warning symptoms like headache and blurring of vision is written, so that is case of preeclampsia. Eclampsia means when there is convulsions developing, and chronic hypertension means blood pressure present in less than 20 weeks and there is no proteinuria and blood pressure will not come down to normal after 3 months of delivery. Chronic hypertension, now the warning symptoms have been added or there is proteinuria added, that will become the fourth category, chronic hypertension superimposed by preeclamptic changes. Next, 25-year-old lady came to the OPD with complaints of amenorrhea for 6 weeks, history of tubal pregnancy previously, serum beta Hcg levels are estimated after 48 hours. What are the following findings that will increase the chance of ectopic pregnancy in her? Okay, in this case, she is a case of 6 weeks amenorrhea. She is a case of amenorrhea, 6 weeks. There is history of previous ectopic pregnancy, which is again a risk factor for the next ectopic pregnancy, and serum beta Hcg levels were done. Okay. Now, which of the following will be consistent with the finding of ectopic pregnancy? Beta Hcg levels decrease. No, that will decrease. That means it is a missed abortion. Beta Hcg levels are elevated significantly. Beta Hcg increases but does not double, or beta Hcg doubles after 48 hours. If beta Hcg doubles after 48 hours, that will be an intrauterine pregnancy, which is not there in this case. So here it will be beta Hcg increase, but it will not double. When does therapeutic folic acid to be started in a case of a lady comes to you for preconceptional counseling? So always remember, when there is preconceptional counseling, folic acid should be started before conception. That means preconceptional phase. And the dose is 4 mg and it should be started 2 months before planning the pregnancy and it should continue for the first trimester of pregnancy. After the first trimester is over, you will give iron plus folic acid, that is 60 mg of elemental iron and 0.4 mg of folic acid for the second trimester, third trimester and in the lactation. So let us read the options given to us. 4 mg of folic acid in the first trimester, 4 mg of folic acid 2 months before planning pregnancy, 0.4 mg 2 months before pregnancy, or 0.4 mg in the first trimester. So the correct answer here is 4 mg of folic acid 2 months before planning the pregnancy and it should be continued in the first trimester. Next, a 24-year-old female presents with infertility. Her marital period is 3 years, semen analysis is normal, ovulation is normal. So husband's semen analysis is normal, ovulation studies is normal, HSG shows bilateral proximal tubal block. What is your next line of management? So most common cause for bilateral proximal tubal block is bilateral cornual tubal spasm, which is physiological. So in this case, I am going to confirm that it is actually a spasm or it is some pathological condition of the tubal block. So I would like to take this patient for hysteroscopy. So under hysteroscopic guidance, I would like to cannulate the fallopian tubes. So I will pass a hysteroscope. Under hysteroscopic guidance, I would like to do the tubal cannulation. If I am able to achieve this cannulation, I would like to do a laparoscopic chromotubation to check for the tubal patency. If it is a tubal spasm, I will be able to achieve this cannulation and I can check the tubal patency by injecting a methylene blue dye into the uterus and looking at the blue liquid seen in the peritoneal cavity. So management of a proximal tubal block is hysteroscopic guided tubal cannulation. So that is what is shown, hysteroscopic guided tubal catheterization. Next, a 24-year-old lady wants medical termination of pregnancy at 8 weeks of gestation. Medical termination, that means she is asking for drugs. She does not want any surgical intervention. Which of the following is most appropriate method to perform MTP in her? Medical abortion with mifepristone 200 mg orally, misoprostol 800 micrograms vaginally. Medical abortion with mifepristone 200 mg orally and misoprostol 400 micrograms orally or vaginally. Suction evacuation with Carman's cannula number 8 or number 10. So since she is asking for a medical abortion, we have to give the tablets. So the correct answer in this question is A, medical abortion with mifepristone followed by misoprostol. What is misoprostol? Prostaglandin E1. And what is mifepristone? RU486, that is anti-progesterone. So MTP by the drugs can be given within 9 weeks of pregnancy. Okay, next. 40-year-old female came to gynae OPD complaining of pain during periods. Periods have been heavy for last 3 years. So it is menorrhagia for last 3 years. Pain starts 2-3 days before the onset of periods, lasts for a week, and she has 2 normal deliveries. So there is a history of congestive dysmenorrhea, there is a history of menorrhagia, and there is tenderness in the abdomen in the suprapubic region. So it is tender uterus. Congestive dysmenorrhea, 40-year-old female, menorrhagia with a tender enlarged uterus, and there is no mass in the adnexa, so it is not endometriosis. So what is the diagnosis? In this case, I can see that there is myometrial thickness which has been increased. Comparatively, we see myometrial thickness is been increased. That means it is a case of adenomyosis. Let us see endometriosis. They say there is no adnexal mass. It is not ovarian cyst. It is not fibroid, because in fibroid, there is no question of dysmenorrhea. Number 2, there is no question of uniformly enlarged and tender uterus. So it's a clear-cut case of adenomyosis. Next, all of the following decide termination of pregnancy in preeclampsia except Doppler ultrasound showing reversal of diastolic blood flow in the umbilical artery, correct. NST showing deceleration, that is dipping of the fetal heart rate, correct. Deranged KFT, LFT, yes. Diastolic notch in the uterine artery at 20 weeks is wrong, because diastolic notch is normally present till 20 weeks, but if it is persisting beyond 20 weeks, then that is abnormal, but that is not an indication for termination. The 3 mentioned in the options are the indications for termination of pregnancy in case of preeclampsia. Next, a 30-year-old female was using copper T. Now she has come with 8 weeks amenorrhea and copper T in situ. On examination, thread is visible. What will be your next line of management? So she has been using copper T, okay, but she has conceived with copper T. Now, what is your next line of management? Remove copper T, give her a choice of MTP. Copper T is to be removed as it is teratogenic. Ask her to continue the pregnancy and remove copper T after delivery. When the thread is visible, always mark your answer as remove copper T. You remove copper T not because it is teratogenic. It is never teratogenic. You are removing the copper T because it is a source of infection to the fetus and the uterus, and give her a choice of MTP. After removal of copper T, you ask the patient, she wants to continue pregnancy or she wants MTP. So the correct answer is give her a choice of MTP and remove copper T. But if in the question it is written copper T thread is not visible, copper T thread is not visible, in that case you allow her to continue the pregnancy, you allow her to continue the pregnancy and remove copper T at the time of delivery. So I have told you both the questions, students. Just listen to me very carefully. If the copper T thread is visible, then you remove copper T and give her a choice of MTP. But if the copper T thread is not visible and she is conceived with copper T, in that case, you ask her to continue the pregnancy and give her a choice of, remove the copper T at the time of delivery. Now, which is the most cost-effective screening test for cervical cancer screening? Now, first of all, you should be clear what are the screening tests being done. So, number 1 is pap smear, number 2 is HPV DNA testing, and number 3 is VIA, that is visual inspection under acetic acid. But colposcopy is always a confirmatory test. But in this question, they are not asking which is a screening test, they are asking which of the following is the cost-effective screening test for the cervical cancer screening. So, according to the WHO guidelines, where there is resource limited countries, the cost-effective method recommended is VIA, that is visual inspection under 5% acetic acid. Now, 5% acetic acid, the normal areas will appear as pink, whereas abnormal area will appear as aceto-white. Abnormal area will appear as aceto-white. Okay, so answer here will be VIA. So this is VIA negative and this is VIA positive. You can see that there is aceto-white areas, and while you are taking the patient for a colposcopy, in the colposcopy you can visualize this under the green filter and you can take the colposcopic directed cervical biopsy. Now, image shown is nuchal translucency, congenital goiter or anencephaly. So, what I see is this thickness is increased. This thickness has increased. So, this is a case of nuchal translucency, which is an aneuploidy marker in the first trimester ultrasound, and this you check it at 11 to 14 weeks time, and it is a dual screening for aneuploidy when you are combining it with maternal blood markers like beta Hcg and PAPA, pregnancy associated plasma protein. Beta Hcg level rises, PAPA decreases, and if nuchal translucency is more than 3 mm or 3.5 mm, that is abnormal. Okay, if this findings is giving you clue towards trisomy 21 or Downs, then next step would be chorionic villus sampling. So this is nuchal translucency. So nuchal translucency means there is a normal fluid filled subcutaneous space and it is being tested by ultrasound in the first trimester, and there is increase in the nuchal translucency, which is a marker of aneuploidy, trisomies, Turner syndrome, congenital heart disease, Noonan syndrome or skeletal dysplasias. Next, identify the type of placenta in a baby born to this patient. So this is a type of placenta and this is a very, very pale baby. We see such a condition where this type of placenta, what is it? Placenta previa, battledore, circumvallate or filamentous. This is filamentous insertion of placenta where the umbilical cord, the vessels are attached to the fetal membrane. So there is laceration of this membranes, and this condition where this baby is born pale, this is vasa previa, and the type of placenta responsible for vasa previa is filamentous insertion, and it is a type of APH where the blood is fetal in origin. Blood is fetal in origin. Now there are various other types of placenta you can see. This is Battledore placenta where umbilical cord is attached to the margin of placenta. This is different types of placenta previa. There can be an image based question, that is why I have added up these slides. This is succenturiata lobe. Succenturiata lobe, which is a cause of secondary postpartum hemorrhage, that is there is accessory lobe of placenta. And this is circumvallate placenta where the fetal plate is smaller than the maternal plate. Next, Cole-Exner bodies are seen in fibroma, thecoma, mucinous cyst, adenocarcinoma or granulosa cell tumor. So answer is granulosa cell tumor. Granulosa cell tumor is estrogen secreting sex cord tumor. So this I have already mentioned that this is Battledore placenta. This is succenturiata lobe, which is a cause of secondary PPH. This is circumvallate placenta, and this is placenta previa. Okay. So Cole-Exner bodies are seen in granulosa cell tumor. Granulosa cell tumor is a sex cord tumor which is estrogen secreting. This is the tumor where the tumor marker is inhibin. This is the tumor where metastasis to contralateral ovary is seen. This is a tumor where histopathological finding shows Cole-Exner bodies and coffee bean nucleus. This is a tumor. If it is occurring before puberty, it causes precocious puberty and precocious menstruation. So this is Cole-Exner bodies that is seen in granulosa cell tumor. This is Samoma bodies. Samoma bodies are seen in, students, tell me, Samoma bodies are seen in? Samoma bodies are seen in serous tumors, and this is Schiller-Duval bodies. Schiller-Duval bodies is seen in yolk sac tumor. Okay. Now, dysgerminoma, what are the tumor markers? It is LDH and alkaline phosphatase. Yolk sac tumor, it is antitrypsin and alpha-fetoprotein. Antitrypsin and alpha-fetoprotein. Choriocarcinoma, tumor marker is beta-HCG, and granulosa cell tumor, the tumor marker is inhibin. So remember this is important for Fmge exam. Now, serous tumors, it is Samoma bodies. Yolk sac tumor, it is Schiller-Duval bodies. Granulosa cell tumor, it is Cole-Exner bodies, and Krukenberg, it is signet ring cell. So many times a question is being asked from this single liners as well. Next, hormonal profile in a menopausal lady is increase FSH, increase LH, decrease FSH, decrease LH, increase FSH, decrease LH, or FSH down and LH increased. So hormonal profile in a menopausal lady is FSH and LH high. That means gonadotropins are high because ovarian follicles have been depleted. So there is no ovulation, estrogen progesterone is down. So there is no negative feedback at the level of pituitary. Pituitary keeps on secreting these hormones. So age at menopause worldwide is 51 years and in India it is 47 years. What is menopause? 12 months of amenorrhea continuously after the age of 40 is menopause. Next, double decidual sign is seen in ectopic pregnancy, normal intrauterine pregnancy, twin pregnancy or molar pregnancy. The correct answer is normal intrauterine pregnancy. Now, what is double decidual sign? Double decidual sign is an ultrasound finding where the gestation sac is surrounded by two echogenic rings of endometrial tissue. Endometrial lining in pregnancy is called as decidua. There are three parts of decidua: decidua basalis, which forms placenta; decidua capsularis, that covers the implantation site; and decidua parietalis, that is rest of the endometrial lining. Okay, so this is decidua capsularis and decidua parietalis, which is just forming the two echogenic ring beyond the, like around the gestation sac. Okay, so this is first sign is intradecidual sign, that is seen a gestation sac on ultrasound. The next is double decidual sign, where there are inner ring and outer ring surrounding the gestation sac, that is decidua capsularis and decidua parietalis. And there is double bleb sign, which is yolk sac and amniotic sac. All of the following are components of biophysical profile except NST, non-stress test, fetal breathing movements, gross body movement, or contraction stress test. Contraction stress test is not a finding of biophysical profile. Biophysical profile is also called as Manning score, and it is a special ultrasound done in high-risk pregnancies where we check NST, amniotic fluid index, fetal tone, fetal breathing movements, and gross body movements. And to each we give a score 2 to 2. So normal score is 10 by 10. Normal score is 10 by 10. What do you understand by modified biophysical profile? That means NST plus amniotic fluid index. This is modified biophysical profile. Now, image shown here is early deceleration, late deceleration, variable deceleration. If you see clearly, there is dip of the fetal heart. This line is fetal heart rate. This is CTG image, cardiotocographic monitoring, and next is the uterine contractions. So when there is a peak of uterine contraction, there is dip of the fetal heart rate. This is what is early deceleration. That is a finding seen in fetal head compression. Okay, late deceleration is seen in chronic placental insufficiency or fetal hypoxia, that is seen in IUGR, seen in preeclampsia, seen in chronic hypertension, etc. And variable deceleration is seen in umbilical cord compression. So this is very, very important. So this is late deceleration seen in fetal hypoxia, and this is variable deceleration which is not related with the uterine contraction. So this dip of the fetal heart rate occurs after the uterine contraction is over. Next, identify the maneuver. This maneuver, the baby is seen in the breech presentation, and this is a tapping done in the popliteal fossa and leg will be flexed. The flexed legs will get extended and the breech extraction is done. This maneuver is done in OT under general anesthesia. This is breech extraction. So this is what is shown in this image is a Pinard's maneuver. Burn-Marshall technique and modified Morrissey-Smiley-Wyatt technique are used for after coming head of breech. Lofset's maneuver is done for breech with extended arms. Pinard's is breech with extended legs. Okay, just have a look. This is Burn-Marshall, this is Morrissey-Smiley for after coming head of breech, and this is Lofset's maneuver. So hope this session was useful to you, and all the best, and be prepared for the lengthy set of questions that can be asked in the clinical subjects. So stay connected and all the best for your exam. We will bring out another CBoT 3 before your Fmge exam comes. So all the best.
Hello, my dear friends. A very warm welcome to all of you in this CBoT PSM paper discussion session. So let's start doing question. If you have any doubt, any question, I would love if you will ask it in the chat group. जो भी मन की बात हो, शंका लघु शंका, कान में नहीं, यहाँ पर आके कर देना चैट बॉक्स में, ओके? यूट्यूब पे कमेंट कर देना. चलो देखो, पहला क्वेश्चन है कि यू आर स्टडिंग बिटवीन अल्कोहल एंड ओसोफेजियल कैंसर यूजिंग ए केस कंट्रोल स्टडी. Which of the following bias cannot affect a case control study? तो केस कंट्रोल स्टडी में जो सबसे मेन बायस है, द मोस्ट इंपॉर्टेंट बायस ऑफ केस कंट्रोल स्टडी इज रिकॉल बायस. रिकॉल बायस सिंपली मीन्स कि केस रिमेंबर पास्ट हिस्ट्री बट कंट्रोल फॉरगेट अबाउट इट. ओके, केस रिमेंबर पास्ट हिस्ट्री, कंट्रोल फॉरगेट. फॉर एग्जाम्पल, suppose you are taking the past history why phocomelia happened, and you took two group. One group are case are those mother whose children have phocomelia. They will remember that they have taken some extra drug in the pregnancy for preventing vomiting, and they will give you the history, because before you ask they already thinking that what is the mistake they have done, why their children are without limbs. So case will remember because something abnormal has happened with them. But if you will ask the same question from a mother who have delivered normal child, that what all medicine you have taken in your pregnancy, she will say कि अरे पगला गए हो क्या, हमको कल क्या खाए हैं याद नहीं है, आप पूछ रहे हो प्रेगनेंसी में क्या खाए हो, इतना मेमोरी तेज होता तो हम डॉक्टर नहीं बन गए होते. She would never remember that because her child is normal, so she will not stress on her mind to bring back the memory of the past. As a result, the case will recall but control will forget. That is recall bias, which occur only in case control study, not in any other study. Now, selection bias means, suppose you are trying for a new drug and you gave your new drug to young people. You are trying your new drug to decrease obesity. You gave your drug to young people, and the old drug to decrease obesity is orlistat. And you give orlistat to old age people, more than 50 years. Of course, young people have more chance of losing weight because they are more conscious about their image and all. So they will lose weight. Old age will not lose weight. And as a result, the result will come that drug X is better than orlistat because one group is losing weight, one is not. So this type of bias where you are selecting two different type of people in two group is known as selection bias. And in case control study also, we can take two different type of people, and that's why we can do that. Confounder again can be present in any kind of study, but there are two bias which mainly occur only in cohort study. One is attrition bias. What is attrition bias? It simply means loss to follow up bias. See, in cohort study, we go in future. And when you will go in future, after 3-4 year or 5 year, you will try to see what are the outcomes. So in that 3-4 year, some participant will leave the study now. And that's why it can occur only in cohort, not in case control. Because in case control, you are taking past data, which can be taken in one day. So no one can leave that. And like let's say you want to know whether BD smoking cause esophageal cancer or not. So one group are esophageal cancer patient, one are normal. And you will ask them, do you smoke BD? Yes or no? So in this, the study can be done in one day. And you are asking the past history, it's a case control. So here no one can leave, attrition bias cannot be there. But let's say you are doing a cohort study on this topic. One group you have taken BD smoker, one group you have taken those people who are non-smoker, and you are following them for 10 years. And you want to know who will develop esophageal cancer. So in this two group, there is a 10 year of timing. Of course, smoker will not like this study because every day you are poking in their bad habit and they know they are doing something wrong. So they will not be comfortable with you asking this question again and again. So many of the smoker out of 100, let's say 60 will leave the study before completing it. But these non-smoker, they don't have any problem in telling about the history because they know they are not doing anything wrong. So in this, no participant leave. All 100 will give history. So one group will leave before completion, one group will continue till end. This is known as attrition bias. And as you can see, it occur in cohort study. Okay. Now, second type of bias which occur mostly only in cohort study is Hawthorne bias. Hawthorne bias का दूसरा नाम है attention bias. It simply means that whenever you are under attention, your behavior will change. For example, let's say you are in a mall or in a class or somewhere and you suddenly notice that the girl you like is looking at you. Suddenly you will start behaving more manly and you will start putting hand in your hair again and again. And you will start talking like yo, style and all. So your natural behavior will not come out under observation. And it's not only for boys. Even girls' body language change when they know, suppose a girl know that the boy she is interested is looking at her. So she will play with her hair, she will smile more, she will play with her eyes and all. So the natural behavior will not be there. That is Hawthorne bias. For example, if there are 100 smoker, and you are doing this cohort study in future, and every day you are asking from them that, did you develop any complaint in your throat? Did you develop cancer? Did you develop cancer? For 10 years, if you are asking it again and again, did you develop cancer? Did you develop cancer? Within 1-2 years, out of these 100 smoker, 20-30 will stop smoking because you are constantly poking them with fear of cancer. So they will not be comfortable with it and they will change their smoking behavior and many of them will become non-smoker. Sorry. So you will not be able to get the natural outcome because under observation, their behavior change. That is why cohort study is also not bulletproof, 100% correct, because it has these two type of bias. These occur in cohort. Remember, as I told, in case control study, most common bias is recall bias. Now, in cross-sectional study, the most common bias is apprehension bias. Apprehension bias means people change their response when they start thinking about the interviewer or start thinking about other people's opinion. And a very good example of apprehension bias is white coat hypertension. As soon as patients see doctor in a white apron, the BP of patient rises. Not because the doctor is hot. Doctor can be hot. But the BP is rising because patient is thinking कि पता नहीं कहाँ उंगली कर दे. The patient is scared that which diagnosis will come out and what checkup they will do on me. So the BP rising because the participant start thinking about researcher or other people. This is common in cross-sectional study. Now let's come to this question, a very common question, very good multi-star. Yes, Hawthorne bias is also one thing which occur in cohort. Let's see whether you can give correct answer to this question number 2. Nature with Modico, Mayank Patel. Roshan Kumar is asking, कैसे हो बिडू लोग? मस्त बिडू, मजे आ रहे हैं लाइफ में, सही चल रहा है. Thank you for asking bro. इस क्वेश्चन का आंसर देके देखो. और ये कॉमन क्वेश्चन है, नीट में ऑलरेडी आया हुआ है और दिस इज ए कॉमन टाइप ऑफ क्वेश्चन विच कैन कम इन FMG एग्जाम और again in NEET exam also, very common. They are giving you a mean value and don't think it is math so it will be difficult, not necessarily. They are giving you the mean value. Mean value is 95 and they are giving you standard deviation. Standard deviation you can see is 15. Now you must know the two simple formulas which are there in standard normal curve also, and when we read confidence interval also there is this two formula. That 68% confidence interval means mean plus minus 1 standard deviation. and 95. Without knowing this formula, you should not go in the exam. It is so commonly asked. If they will ask numerical, there is 90% chance they will ask numerical from this formula only. It is so common. The formula for 95% confidence interval is mean plus minus 2 standard deviation. And we use this 2 formula if population word is not given in the question. Because if population word is given, then we don't use standard deviation. Then we use standard error. Okay. So here they are asking what percentage will get between 65 to 125. So let's first try to find out what will be the 68% confidence interval. Mean value is 95. 95 plus minus 1 into 15. सिंपल है, 95 से 15 माइनस और प्लस कर लो, कितना आएगा 80 to 110. But they are saying their mark is coming between 65 to 125. तो ये 1 स्टैंडर्ड डिविएशन वाला जो आंसर है वो तो 80 से 110 है, यानी 68% वैल्यू 80 से 110 के बीच में आएगी. 68% people will have between 80 to 110. Now when you will calculate 95%, it will be 95 plus minus 2 into 15. 95 से प्लस माइनस 30 को कर लो, तो 30 को प्लस माइनस करोगे तो कितना आएगा सॉरी भाई, लगता है टीबी हो गया है. 65 से 125 जो हमारा आंसर है. तो 65 से 125 मार्क्स कितने परसेंट में आएगा? 95% में. बी आंसर है जो सुभाष कुमार, गोकुल, डॉक्टर Fmge तीनों ने दिया था, 95%. तो इस तरह के क्वेश्चन को कैसे किया जाए? देखो सिंपल सी बात है, आपको इस तरह के क्वेश्चन में फर्स्ट यू हैव टू लुक एट द मीन वैल्यू 95, देन यू हैव टू लुक एट द रेंज and look at any one side. Let's say look at the lower side. 95 is how much more than 65? 95 is 30 more than 65. And what is the standard deviation? 15. 15 is the standard deviation. So 30 का मतलब कितना standard deviation हो गया? 15 एक standard deviation है. So 30 will mean 2 standard deviation. So 30 simply means 2 standard deviation. And I hope you all know this formula, that mean plus minus 2 standard deviation have 95% area, mean plus minus 1 standard deviation have 68% area. So you just have to see the mean and any one value and see how far is the value from the mean. If the value is 1 standard deviation away, answer will be 68. If the value is 2 standard deviation away, answer will be 95. If the value is 3 standard deviation away, answer will be 99%. Okay? So very good. Thank you Mayank Patel. Mayank Patel within week हो गया है सर. क्या बोलना चाह रहे हो मयंक? भावनाओं को समझा नहीं मैं तुम्हारे. आगे बढ़ते हैं. Now let's come to the next question. A study is being conducted on quality of life after radiotherapy in breast cancer patient like me. And the ordinal data for this study can be represented by. So in this type of question, they are just asking ki ordinal data, and I hope you all know ordinal and nominal data. Both of these are type of qualitative data. Qualitative is also known as categorical data. So what they are asking is, कि out of these 4, which one is used to represent qualitative data? Okay. For qualitative data, there are 5 methods of qualitative data representation. One is bar chart. Second method of qualitative data representation is pie chart. Pie chart is also used to represent balanced diet to layman. Okay, it will have I hope you all know this type of circle, and they will tell what are the balanced diet, like 70%, 50 to 70% should be carbohydrate, then there should be protein, then there should be fat, like that. And third type of diagram is spot map. Spot map is used to represent or identify source of outbreak. How does any epidemic or outbreak started? For example, the spot map which was drawn for cholera epidemic in London, it showed that if this is the Broadway street, most of the death occur near Broadway street. So the hand pump which was supplying Broadway street of London, that was the source of outbreak. That is spot map. Now, if they ask this question in exam, that which method will represent doctor to patient ratio best? Answer will be pictogram. Pictogram is best method best method to represent doctor patient ratio. Okay, they will draw a doctor, MBBS doctor, like this, hey, steth and all, and they will write that one MBBS doctor is at 5,500 Indian, like that. So this type of diagram will be pictogram. This is the fourth method. The fifth and last method of qualitative data representation is fish diagram. This is being recently asked in INICT question, so it can come again. Fish diagram, what is that? Let's say you want to know my cause. I want to explain to you why I am obese, although I am working on reducing it. Acha, Mayank was saying ki you are looking weak and coughing, so it can be TB. Yeah, Mayank, I got it now. So, in fish diagram, if you want to know the reason of my obesity or the reason why I am looking weak, let's talk something positive. So, why I am looking weak? There can be multiple reasons. One reason is that I am trying to eat salad more. Second reason is, let's say I am trying to do some exercise. Third reason can be, there can be multiple reasons for it. And third reason can be that I am drinking this isbagol, Phycilium husk. I read that. And this is very good advice which I would like to give to you before exam or during any time, and especially if you are staying in Gautam Nagar or places like that, your abdomen can be a bit upset and all. The gastritis, constipations or bowel upset things can be there. So just pour half teaspoon of Phycilium husk, which come by the brand name of Isbagol husk. In overnight, you just put it in 1/2 glass water, half teaspoon of Isbagol husk with some sugar or something if you want to make it more tasty. But I am drinking it even without sugar and it is drinkable. So overnight it will swell up. Then churn it with your one finger and then drink it. So if you will drink it, this Phycilium husk, all the problem which you have of constipation or let's say gastritis or even weight loss will be there. And there are some other added advantage. And Phycilium husk is Ayurvedic medicine being written in K.D. Tripathi, also pharma book. But it is one thing which is not having any side effect. So it's a good thing which I am doing. Thank you, Saswat. You are also saying I am looking a bit slim. So thank you. I am working on it. And I have reduced my smoking also, and all those things help. So this is all quality. I am looking weak or losing some weight only. That is just a quality. And this type of diagram is fish diagram. See, can you see? It is like a fish. They will write the multiple reason, like let's say decreased smoking is second reason. Then some other reason can also be there. So all this, diary writing is one thing which also can help. Diary writing, or you can take regular photo of your activity. So in that way, you will be conscious what you are doing and you will be more consistent. Diary writing can help you in your last 15-day, 10-day preparation before exam also. If you are writing on diary, how many hours you study and anything good that happen, good event. So in that way, every night before sleeping, if you take 1 minute out and write how many hours you study, what are the good things that happened in the day, you will be very happy remembering the day, and you will be appreciating yourself at the end of the day. And that will bring you happiness, and that will bring you satisfaction and content. And you will focus on the day, because all the stress which occur in our life is mostly because we are thinking constantly of the future, what will happen in the exam and all. But if we are focusing on the day, this moment, where is the tension? No tension. So if you focus on the day, that will decrease all kind of anxiety. And a very good way to focus on the day is this thing, diary writing or daily photo taking, or telling to someone on WhatsApp what are the good thing you are doing. Like I'm sharing my good event with my psychiatry friend Ankur Jain sir, and we are sharing this thing, so we are more consistent there. Anyway, it can help you in study also, hours of study. And this physiology husk can really help you in your bowel activities, and you will be feeling more light, more focused in your study. So these two habits can help you in your study also. That's why I shared. Sorry for taking that time, but just some advice. Now, next question is, so I hope you understand the point which I want to tell you, that there are only 5 methods of qualitative data representation. Bar diagram, pictogram, fish diagram, spot map. So if they are asking ordinal data, answer will be one of the qualitative data representation method, which is option is bar chart only. So bar chart will be the answer. Rest all 8 methods are quantitative. Only these 5 are qualitative. And better than bar chart is fish diagram. Bar chart sometimes can represent frequency distribution also, but fish diagram is always qualitative. So if in any question bar and fish both are given, you will tick fish diagram. Okay, that's a recent question, so I am emphasizing. And moreover, I hope you all know that in bar chart there can be 2 different type of bar chart. If we are drawing one bar and then putting some other color bar above it, this is component bar chart. Component bar chart. And if I am drawing bar chart 1 and then 2, then again gap, then 1 and then 2. So gaps are coming again and again. This will be multiple bar chart. Okay. Now, if I am drawing a graph something like this, where there is one graph, then there is second, then there is third, then there is a gap, and then after gap there is again 1, 2, 3, 4, 5, like that. So which type of diagram is this? Is this a multiple bar diagram or is it a histogram? So this type of diagram where gap is not coming at equal interval. You can see there are 4 bars and then there is only one gap, and then there are 5 bars and all. So gap not after equal number of bars. This will represent histogram. It will not be multiple bar chart. In multiple bar chart, you can see here in this part that the gaps are occurring after every 2 bar. So in multiple bar chart, gap will be again and again at same interval. In histogram, it will not be like that. Very good, Dr. Fmge, you are right, it is histogram. Chalo, next question. Before going to outreach session, A&M took partially used OPV vial and hepatitis B with intact VVM. And the vial was opened 15 days before. So in this situation, what will we do with the use of this vial? What is the correct answer? If you know, please answer. What will you do with these 2 vials? So this is a question from open vial policy. Open vial policy means some vaccines can be used up to 4 weeks of opening the vial. You can use it if the VVM is intact and vaccine is stored adequately between 2 to 8 degrees Celsius. We can use it till next 4 weeks. So what are those vaccines? Very simple. Just say it with me and you will remember. Hep B, PCV, all tetanus, all polio. Hep B, PCV, all tetanus, all polio. These vaccines follow open vial policy. And Mayank Patel is right, she can use both this vial in the vaccination session. Because you can see, hepatitis B can also be used up to 4 weeks. all polio means OPV and IPV, FIPV. And it is fractioned IPV, not fucked IPV. So OPV, IPV and Hep B, these two things can be used up to next 4 weeks. So both Hep B, OPV we can use. PCV, of course, pneumococcal conjugate vaccine, which is especially given in all splenectomy patient, HIV patient, immunocompromised patient, because they all die with pneumonia. So PCV is the one vaccine given to all of them. Sickle cell anemia patient also we give PCV because they are immunocompromised due to multiple blood transfusion and all. And all tetanus means 4 type of vaccines. DT, TT, DPT and pentavalent. So total if you see 4 plus 2 plus 2, 8 are there. But we can simply remember it by Hep B, PCV, all tetanus, all polio. Okay. And she can use both. So Nature with Medico, Multistar, Jayendra, Nadoda, Praveen Kumar, Subham Rana, and of course Mayank Patel. All of you are right. Okay. Yes. Chalo. So this is a very common area of question. Do remember it. Next question. The term demographic bonus. I hope you all remember in your childhood days or all, whenever a parent get bonus, that was a good news. Bonus is always a good news. And dependency is not a good thing. We want less people to be dependent. So demographic bonus will be there when there is decline in dependency ratio. Whenever dependency ratio become less, only then demographic bonus is there. And this demographic bonus is same as demographic dividend. डिविडेंड का हिंदी मतलब देखो तो सूद है, इंटरेस्ट को सूद कहते हैं, बस वैसे ही है डिविडेंड, जो उससे निकल के आया फायदा है. So dividend and bonus both are good news. Now, what is dependency ratio means? I hope you know. It simply means those people who are dependent less than 15 year and population more than 65 year, they are dependent on whom people? They are dependent between 16 year to 64 year population because they are earning. And we can multiply it by 100 if we want to get answer in percentage. So, whenever dependency ratio is less people dependent, that's a good news. Now, how can you decrease dependency ratio? One way is directly produce children who are between 16-year-old. Not possible. Second way, kill all old age people. Again, if I will say it to my mother, she will kill me with her slipper only. So not possible. Only one thing we can do is stop producing children. If we decrease the fertility rate, this part will decrease, and as a result, dependency ratio will decrease. So dependency ratio will decrease due to decrease in fertility rate, not increase. Decrease in fertility rate. Okay, so correct answer will be D. It was a confusing question. All of the friends who are attending online, you all were confused, and it is a PYQ question. So please, I hope you understand the point. To decrease dependency ratio, fertility rate should decrease. In that way, less young children will be there and our population will be more young. But it will remain young only for next 40-50 years. Then because we are not producing children, we will also have more old age people and the demographic bonus will go away. Right now, India is in phase of demographic bonus. Now, the major contribution of Colombo plan. Does you know the answer? What does Colombo plan? Acha, Praveen Kumar has a good question here. What is the difference between bonus and burden? See, as I was saying, demographic bonus means less dependency ratio due to less fertility rate, and demographic bonus simply means more earning people. This is bonus. And what is demographic burden? Demographic burden means burden means, of course, there are more people who are dependent. So burden will be more when dependency ratio will increase. And how dependency ratio will increase? If we have more dependent people. How we will have more dependent people? Most of the time, this more dependent people are because old age are more. Old age, more than 65 year more. Like in Japan, Germany, a lot of European country and Scandinavian country, there is demographic burden now because earning people are less and dependent people are more. So that's not a good thing, and India is right now in demographic bonus. But in this demographic bonus, if we are unable to give job to this earning people, then the demographic bonus, if no job given, this demographic bonus will become demographic catastrophe. समझ रहे हो? अवसर आपदा में बदल जाएगा. The opportunity will turn into a threat. So that will be demographic catastrophe. Okay, so please. Dr. Subham is saying, sir, I send you question from last guest paper, which you want me to explain. Please, I might have missed it. If you can send it again, I will definitely answer it right now. Just message me that question again, which you want me to explain. What is the major contribution of Colombo plan? If you can give, please answer. Sorry, Subham, for not responding it, not replying it. You can send it here and now we will answer it there. Okay. What is Colombo plan? Colombo plan focus on two things. Can you answer it? It was a tough question a bit, but if you have read it in detail or listened to the lectures in detail, you know it. One is industrial and agricultural development. Second is cobalt therapy unit. These two things is done by Colombo plan. Now, nutritional program, ICDS and Anganwadi program, these all is being done by CARE Foundation. तो कैसे याद करोगे? देखो, बच्चों का खाने पीने का केयर रख रहे हैं, तो केयर इज ऑफ फूड एंड आंगनवाड़ी. सी कोलंबो CO कोबाल्ट, कोबाल्ट थेरेपी यूनिट, एग्रीकल्चरल इंडस्ट्रियल डेवलपमेंट, कोलंबो प्लान. वॉर विक्टिम रिलीफ एंड डिसास्टर मैनेजमेंट, दिस इज रेड क्रॉस. एंड सैनिटेशन वर्क एंड नेशनल इंस्टीट्यूट ऑफ हेल्थ एडमिनिस्ट्रेशन, दिस इज फोर्ड. कैसे याद करोगे? फोड़ के हगा, सैनिटेशन वर्क है. फोड़ के हगने के बाद क्या करोगे? नहाओगे. तो दिस इज सैनिटेशन वर्क, फोड़ के हगा, एंड देन नी हाई, नेशनल इंस्टीट्यूट ऑफ हेल्थ एडमिनिस्ट्रेशन, बोथ आर बाय फोर्ड. Other than that, we can remember like some 2-3 more things. One is like Rockefeller Foundation, which they ask again and again. No, they have not asked it yet, but there is a high chance they will ask. Rockefeller Foundation. Rockefeller Foundation try to make our foundation rock solid by funding research. So Rockefeller Foundation fund research activity, and it also fund National Institute of Virology. These two things is funded by Rockefeller Foundation. Okay. So these are the 5 organization work which you have to remember for sure. कैसे? Rockefeller, Rock Solid Foundation, and Care Nutrition, Ford Sanitation, Colombo Cobalt Therapy Agricultural Industrial, and Red Cross War Victim. Along that, with that, you should also remember that SIDA fund TB program. S for SIDA, S for Sputum TB program. Danida fund eye program. Netradan eye donation. So Danida eye program. USAIDS, it fund malaria program. UNDP, United Nations Development Program, it funds sustainable development goal. UNICEF fund seed and manure of applied nutrition program. And along with seed and manure of applied nutrition program, it also fund maternal and child health program. That's why in UNICEF logo there is mother and child. So, and plus United Nations Fund for Population Activity, this fund family planning program. So many of this question has already been asked. Please do revise this question before going to your exam. Now, let me show you the question which Dr. Doctor has shared with me. Let me show you the question directly. I have the airdrop facility. I can do it, and so you have. If you have any question, just like Dr. Subham, you can WhatsApp me your question, or you can ask it on the chat box. I don't know where it went. Here it is. My phone number on which you can give it is 8860796675. There is a psycho photo there. The question is that which type of graph is given here, and the cases are occurring from 13 May to 16 May. 13 May to 16 May means there are 13, 14, 15, 16, 4 days in which cases are occurring. And it is written in the question, if you will focus, that incubation period for Salmonella is 1 to 3 days. So, if cases occur within one incubation period, it is point source or single source, common source, single exposure. अगर एक इंक्यूबेशन पीरियड के अंदर सारे केस होते हैं तब हम इसको पॉइंट सोर्स या कॉमन सोर्स सिंगल एक्सपोजर कहते हैं, और अगर एक इंक्यूबेशन पीरियड से ज्यादा टाइम लगता है, द टाइम ड्यूरेशन इज मोर देन वन इंक्यूबेशन पीरियड, देन वी कॉल इट कॉमन सोर्स कंटिन्यूअस एक्सपोजर. So here you can see time taken is 4 days, incubation period is only 3 days. So cases are occurring in more than one incubation period. So that's why we are calling it continuous source epidemic. Answer was continuous source epidemic. Now the question by Dr. Subham was कि अगर 13 में 8 AM से काउंट करेंगे तो टोटल 3 डे नहीं होंगे क्या सर? और उसने काउंट भी किया 13 मई 8 से लेके 16 मई 8 बजे तक. तो 13 मई 8 एक दिन, फिर 14 हुआ दूसरा दिन 14, फिर 15 तीसरा, फिर 16 चौथा, 4 दिन तो हुए ना यार. अगर 16 8 बजे भी है तो भी चौथे दिन जाके केस तो हो रहे हैं ना. 13 से 16 में तो 4 दिन है ना मेरे भाई. बट फिर भी अगर हम शुभम के एंगल से इस क्वेश्चन को देखना चाहें और मान लो यहां 16 में नहीं लिखा होता, सपोज इन प्लेस ऑफ 16 में द लास्ट केस ऑकर ओनली ऑन 15 में. सो इफ द लास्ट केस ऑकर ऑन 15 में इट इज 3 डे. ठीक होगा क्या? 13 14 15, हाँ 3 डे. So if all cases occur in 3 days, yes Subham, you are right, then we will call it common source single exposure or point source. If cases occur in 3 days, then answer will become A, point source epidemic. And most of the food poisoning are point source only. But if cases are taking more than 3 days, more than one incubation period, then we call it continuous source epidemic. So I hope Dr. Subham is clear. Yes, Subham, I hope it is clear. Let me know. Subham, do you agree? And the answer is continuous. It's the page from which I am taken this question is one of the PYQ of US Assembly, and they have also given the same answer. If the last case occur in 15 May, then answer can be point source. Because it is 16 May, so it is common source continuous exposure. Still, if you disagree, let me know, my dear friend. Okay? Chalo. No, Subham is saying yes. Okay, so it's done. Let's come back to our CBoT session. A nurse spills some blood on floor from a patient who is HIV negative. It doesn't matter, HIV negative or positive. If blood is spilled on the floor, you have to pour 1% sodium hypochlorite. That will make it sterile. After pouring 1% sodium hypochlorite, you will wipe it with cotton or any absorbable material. Now, in marrow and some other places also, in the question bank they have said that if the blood is spilled, first step should be just wipe it. So if you are wiping the blood without sterilizing, that surface will remain a continuous source of infection. If any food item fall on it, or if any contact of person came through that surface, then the infection can spread to other people. So this can never be the first step. आप बिना, जैसे मान लो आपके हाथ से थोड़ा सा खून गिर रहा है, तो क्या आप डिटॉल लगाए बिना उसको वाइप कर दोगे? नहीं ना, पहले डिटॉल लगाओगे. क्यों? क्योंकि वो सोर्स ऑफ इन्फेक्शन बना रहेगा. In the same way, if it is on the floor also, if you did not pour 1% hypochlorite, that place is infective. So first you have to sterile the place, then wipe it. So this is always second step. I hope you understand the logic. And by logic, if you are agreeing on it, then it's okay. Plus it is written in PARC also that if it is blood spilling, pour 1% sodium hypochlorite, then wipe it. So this will always be first step, and wiping will always be second step. Okay? That will never be the first step. So I hope you agree. If you disagree, you can let me know. 70% ethyl alcohol is mostly we use for hand sanitization. And remember, hand sanitization is something which is not done on visibly soiled hand. अगर हाथ में देख के ही लग रहा है कि गंदा काला काला लगा हुआ है, तो साबुन पानी से धोना पड़ेगा ना, सैनिटाइजर डाल के क्या होगा, है ना. इफ इट इज विजिबली सॉइल्ड, यू हैव टू वॉश इट विद सोप एंड वाटर. ओके, so this was an INICT question, do remember. We don't do sanitization on visibly soiled hand. Next question, there were 30 cases of influenza-like illness were reported and diagnosed to be COVID-19 in city X. No case of COVID-19 were seen in city X in the past. Anil is a 30-year-old male, was the first case who developed symptom. Then he infected Sunil, who went to the hospital and was reported to the health system. So what is Sunil here? In this story, Sunil क्या है? Sunil क्या है? Option A, is he a index case? Option A, is he a primary case? Primary case means first case who got infection. So Anil here in this story, Anil is a primary case because he got infected first. If Anil go to hospital and got reported, if Anil is reported, then Anil will become index case also. But here Anil was not reported. Who was get into contact with health system? Sunil. So Sunil became index case, Anil remain primary case, and they are asking about Sunil. So Sunil is the index case. Did you understand this thing, or do you need a story for that? Let me discuss a very small story. I was in China in December 2019. I was in China and I came back to India on 24th of December 2019. After coming back, I had a class in Kerala, so I went to take class to Kerala directly. From flight I landed, and then I took 1 hour, 2 hour of, there was some transit time of 4 hour around, and then I had a flight. I went to Kerala. In Kerala, so this is me, Ashwini Ranjan, who got infected, or maybe he is coming from China from that time. In Kerala, first case reported from an foreign student on 31st of December 2019. So this student who was reported as COVID positive, because he was reported, he became index case. Because he was reported. And who was the primary case? Kerala student was not the primary case in this story. I was the primary case. So you can say I spreaded corona in the whole India. कभी घमंड नहीं किया मैंने, but काम बड़े अच्छे अच्छे किए मैंने. So you understand the concept. The one who is the first case. Suppose at Delhi airport they caught me. If they would have caught me, then I would have become primary case and index case both. If they have caught me, but they did not caught me, they caught it someone else, so that become index case. Whoever got caught, come to health system is index. Okay. Coming to next question. A 50-year-old sugarcane. Also, You very good. Most of you were answering A only, but I hope it is clear to you, dear Mayank Patel, Madhumita, the logic for this. Okay. A 50-year-old sugarcane mill worker present with complaint of breathlessness. Sugarcane and cardboard factory worker. Both of these, they suffer from which disease? Biogasosis. And bagasosis will have, what is the causative organism of bagasosis? If you know, please message me on YouTube. What is the causative organism? They have asked already in one of the exam. Like they have also asked what is the causative organism of farmer lung. Farmer lung causative organism is Micropolyspora fani. Okay. For bagasosis, the causative organism is, I am waiting for it. Please do tell me who is the causative organism of bagasosis. Bicyanosis occur in cotton mill or textile factory worker. In asbestosis, you will see mesothelioma cancer of lung pleura. Lung pleura means in the basal part of lung, you will have deposition and cancerous growth. I am waiting for someone telling me the causative organism because it has been asked in a PYQ. The causative organism for bagasosis is thermoactinomycetes. Thermoactinomycetes saccharine. So, my dear multi-star, Dr. Multi-star has given correct answers. Saccharine, thermoactinomycetes saccharine is the causative organism. Do remember both the causative organism. Okay. They can also ask if X-ray is suggestive of snowstorm appearance. फेफड़ों में तूफान आ गया है ना, there will be fog like thing on X-ray going from one side to another. Which type of disease it is? It is representing silicosis. And it was in PYQ in Fmge exam that silicosis patient, their lung is damaged due to silica exposure from cement factory or glass factory or tiles factory. And in that damaged lung parenchyma, TB bacteria can easily go and cause TB. So silicosis patient should have annual inspection for TB also. Annually, TB screening should be done in them. Okay, annual TB screening should be done. Very good, Afia, Asif, you are right. Thermoactinomycetes saccharine is the one which is causative organism for bagasosis. Very good, dear. Now, Deep is also right. Silicosis will have snowstorm appearance. Very good. Now, let's move ahead. The uses of iodized salt advocated by Iodine Deficiency Control Program in endemic areas is. So, anyway, why are we using iodized salt? Because there is a risk of slow mental growth or hypothyroidism, mainly slow mental growth. And the IQ can get affected, especially in children and all. So the risk is present and disease is absent. It is not the treatment of a low IQ child. It is just given to prevent low IQ thing. So whenever the risk present and disease is absent, we call it primary level. Okay, risk present, disease absent. If suppose I am giving health education to a population on using iodized salt, on vaccination, on hand washing, on family planning, any health education, on diet, on smoking, anything. All the health education is better written as primordial because it is even given in non-endemic areas. It is even given to children. So health education will be primordial. All vaccination, hand wash, chemoprophylaxis, isolation, quarantine, wearing condom, seat belt, helmet, all of these are primary. And in this question, if suppose I also write the option specific protection, then your answer of choice should not be primary, your answer of choice should be specific protection. If primary specific both are in option, you will choose specific. That is a better answer. Okay. I hope this is clear to you. Yes, Madhubita, Subhas, Kumar, all of you are right. Afia Asif is also right. Dr. Mercury is also right. Very good. Jayendra is also right. Let's go to next question. Low stationary growth is in which stage of demographic cycle? Low stationary growth. It's a very, I think it's a, if you remember the phases, you can do it easily. Try to guess it. There are 5 phases, of course. And the first phase is known as high stationary. So in high stationary, birth rate, suppose this black is birth rate and this blue is death rate. So birth rate, death rate, both are maximum. So this is one question they can ask. In which phase birth rate is maximum? Answer is high stationary. Okay. Sorry, मरूंगा मैं. TB के साथ लगता है HIV भी हो गया है. So both maximum in high stationary. Then, like in India, before 1950, India was in high stationary. You must have heard 8 children, 10 children, out of which 7 die, 6 die. So these were high stationary. Then we all go to early expanding. I am just trying to brief you all the 5 questions which can come from this topic. Early expanding is second phase. In early expanding, birth rate start decreasing. No. Birth rate does not start decreasing. In early expanding, death rate start decreasing. I should have drawn death above, birth below. Sorry for that error. This blue one is the birth rate, and suppose the black one is the death rate. Now that's better. So in early expanding, death rate start decreasing. Why? Because gradually there is advancements of medical facility and delivery start happening in hospital, and infant mother death decrease. So death rate start decreasing. Birth rate is still high. India was in this phase between, you can say, 1950 to 1980 was in this phase, India. And this early expanding, you can see here the gap between birth rate and death rate is maximum. And this gap is known as growth rate. So they can ask in which phase growth rate maximum. Early expanding, late half, growth rate maximum. Okay, in second phase growth rate is maximum. Now in third phase, death rate again decreased, but in the third phase birth rate also start decreasing. So they can ask in which phase growth start decreasing. So growth rate start decreasing here. This phase is known as late expanding. India is in this phase right now. So in late expanding, growth rate start decreasing. After late expanding, country enter in low stationary. So there are only 2 stationary, very simple to remember, high stationary, low stationary. And they are asking in this question, low stationary growth rate, which phase? So that is phase number 4. Answer is D, phase 4. Now, in low stationary, birth rate, death rate, they again become almost similar. So the growth of population is not there. But after late stationary, this birth rate decreased further, become very low. And you all know death rate cannot be decreased after some limit. We cannot prevent people from dying. So death rate start increasing in a way, you can say here. This phase is declining. So if they ask which phase has negative growth rate, negative growth rate is in declining phase, negative growth rate, declining phase. Okay. So do remember the 5 questions. What are the 5 questions? India is in which phase? Quickly answer, late expanding. Second question, which phase has maximum birth rate? High stationary. Third question, which phase has minimum growth rate. Minimum growth rate is in low stationary. Here, growth rate is minimum. But here in the last, growth rate is negative. So this was the third, where growth rate is negative, phase 5. Where growth rate is minimum, phase 4, low stationary. Then the remaining two questions, where growth rate is maximum, late half of second phase. Where growth rate start decreasing, early half of third phase. Okay, so these are the 5 questions which can come from here. I hope you will remember. And the answer is simple. And it is easy to remember, believe me. How? First and fourth you have to remember high stationary, low stationary. In between, 2 expanding are there, early expanding, late expanding. And then last is declining. Okay. Next question. Research is being conducted to find out the association between benzene exposure and bladder cancer in workers who have worked in industry for more than 25 years. 2 groups were formed. One directly involved with chemical handling, other group consistent of office clerk, not directly exposed to benzene. Year of occupation were noted of the record. What type of study is there? So first of all, there is 2 group. Whenever there is 2 group, it cannot be cross-sectional ecological because they are usually done on 1 group, 1 population. And remember, in cross-section, we are asking question from everyone. In ecological, we do not ask question from anyone. We only collect population data and correlate it with hospital data. So cross-sectional ecological, I think, is clear. Now, if there is 2 group, it can be cohort, case control, or 2 other type of cohort, retrospective cohort and mixed cohort. Remember this thing, whenever they are using written work record data, see they have written noted from record. Okay, written work record data. It means they are not asking personal history. They are just using the data of last 25-year work. The answer of such question will be retrospective cohort. Written work record you find in any question, answer is retrospective cohort. But suppose they write that along with written work record, there is future follow up for 3-year or 5-year also. So now you can see they are going in the back direction and forward direction both. So if both part is written, both 2 are written, both present, it is going in both directions, so now you can call it mixed cohort. It is going in both directions, so now you can call it ambispective cohort. This question has been asked already in NEET and NICT, this similar question, so very likely to come in recent exam again. Do focus. Now, from the last question, Uttam is asking, Dr. Uttam is asking, Uttam Pagdal is asking me a question that, sir, late transition phase is same as late expanding? Yes, dear. Early expanding can also be known as early transition, and late expanding can also be known as late transition. So this is the same thing. They can use expanding or transition word interchangeably. So what I am trying to say, if you are taking past written only, this is retrospective cohort, and sometimes retrospective cohort is also known as historical cohort. But if you are taking past data and also future data, you are going in both directions, so it is mixed cohort, ambispective cohort, and this is also known as nested case control. See, why are we calling it nested case control? Because out of these 2 work, collecting past data and future follow-up is more difficult. Past data can be collected by click of a computer. So main work is cohort. In the cohort, past data is inserted. Cohort में case control ने घोंसला बना लिया है. That's why it is nested case control, because in cohort we are inserting data of past work record. So these 3 can be remembered by the mnemonic MAN. Mixed cohort, ambispective, nested case control. MAN can go any side, both side, backward, forward, both. And this 2 can be remembered by the mnemonic RH, retrospective, historical. And we all know RH positive man and RH negative woman can lead to ABO incompatibility. So this can be remembered by this. Now, why it is not a case control? Because in case control, we take personal history. Here we are only using written work record data. So the answer is retrospective cohort. Is it clear to all of you? Here Dr. Afia Asif is asking a question. No, it's just explaining that retrospective cohort, because they are using going back. Retrospective cohort, Dr. Afia Asif is saying retrospective cohort because they are going back and then they are coming forward. No. In this question, they are not coming forward. You can see here, we have not written future follow-up. So they are only going backward. That's why retrospective cohort. If they are going backward plus future follow-up, then the answer will be mixed cohort, ambidextrous or nested case control, which is not given in the option also. So they are only going back. That's why histro. History and retro both means only backward. Mixed when there is backward plus future follow-up. And ambidextrous nested is also same. Backward plus future, if it will be like what Dr. Afia is saying, then it will be mixed cohort, ambidextrous or nested case control. Is it clear, or should I give one more example? Yes, Nitin Jat is right. If they are going both direction, it is mixed. Dr. Afia, let me know if it is clear or not. Otherwise, I will give you one more example to make it more clear. So let's come to the next question. A 30-week primary gravida, compare of reduced vision at night. She avoid eating papaya, mango and other fruit throughout their pregnancy. As she think they could get, villagers say that papaya have papain, so it can cause abortion. So which primary duty is to counsel the patient and refer to higher center? This is mainly the duty of ASA to do home visit and search for such issue. ASA do home visit before delivery also and after delivery also. And then she search for such cases and refer. This is mainly the work of ASA. Remember, ASA minimum education is only 8th pass, not 10th pass, written at 3 places in park. If you don't believe me, just tell me. I will send you the, I will show you the copy of park with that thing written 8th pass there. And her, there should be only 1 ASA per 1000, not 2 ASA 1000, 1 ASA per 1000. But in urban area, we have USHA, which is 1 per 1000 to 2500 population. So USHA urban area have 1 USHA per 2000 roughly. Okay, but in rural area, 1 ASA per 1000. Do remember this point. Dr. Afia, please let me know, was the last question clear to you or not? Madhumita is making it clear. Backward plus future is retrospective. No. Backward plus future is only mixed, ambidextrous or nested case control. And many a time in question banks, those people are preparing question banks who are not expert in the subject. Like surgery guy can write PYQ of all the subjects. PYQ can be written by any faculty. But if there is any controversy between PYQ book and faculty, any faculty, not only me, any faculty, try to trust the faculty, because the faculty is specific in that area. Okay, so please don't doubt this thing. If there is backward plus future, it is mixed, na? It is quite logical also. It is mixed because it is both the side. Backward plus future is ambidextrous because both direction. And is nested case control, I explain you why, because in the cohort, data of past is inserted. If you look at the word only, retro means past. So retro only means past work record data. History means only past. So history only have past word record, written record of work. Retro and history do not include future follow-up. Retro and historical is only when past written record is there. Okay, so please get it clear. Madhumita is saying many places that answer is given. Many places does not matter. Main thing that matter is your logic and evidence. You can trust expert, but main thing is evidence and logic. You tell me by logic only, retro or history. Can it means future? No. History means backward. Retro also means backward. That's why case control is known as retrospective study. So they will only have backward component, not future. If I would add the question, I would add the word that along with previous follow-up, along with previous work record data, future follow-up is also given in question, then answer can be mixed cohort and all. But here only past data was given in the question, only past work record data. That's why the answer is only retrospective cohort. Okay, dear? Yes, I hope it is clear. Madhumita and Dr. Afia, please let me know. Afia said it clear. Thank you so much, Afia. Shukriya. Madhumita, dear Madhumita, please let me know if it is clear. Do you agree? Or if any controversy, let me know. In a hospital, the management want to know how much time each doctor spend with the patient on average. This is known as work sampling. If you want to select out of two doctor, to select one doctor out of two, you can select by three methods. First, you can call their hospital where they were working in the past and ask from the staff how was their work. This is known as Delphi method, which is a group method. Group response is taken. You will take the response of whole group to come to a decision. Second way of choosing people is based on their extracurricular work. And of course, doctor will not dance and all. Na? They will do the extracurricular work of marketing of hospital and explaining the prognosis to the family. So one doctor is doing marketing plus job, both the thing. So how will you select that doctor? This is known as system analysis. If you are selecting doctor based on their cost effectiveness, that is system analysis. And if you are selecting doctor based on time taken to do the specific work, let's say one doctor is doing hernia surgery in half an hour, second doctor is doing hernia surgery in 1 hour. Work sampling simply means choose the one doctor who take less time, who do the hernia surgery in half an hour, choose that doctor. So work sampling means making decision based on time taken to do work. And you are comparing based on that. But I think this is not a correct way, because the doctor who is doing hernia repair in half an hour may be connecting wrong wire. In this patient, when he will cough, maybe there will be erection. That can be problematic. So always choosing the one who is taking less time is not good, but this is known as work sampling. Okay. So this is the three way, and all these three has been asked in PYQ. So do remember it. Yes, Dr. Yasra Wasif, you are right. Jayendra, you are also right. Madhumita got it cleared. Very good. Thank you. Gokul is saying, Doc, can you please explain cost effectiveness versus cost benefit? Yes, Gokul. Anything for you. Anything. And anyway, your name resembles my childhood friend Gopal, and we were very close to each other, and like really good friend. And used to take bath together, like so close. Come here. So Gokul question is cost benefit and cost effectiveness. A lot of question come from it. Very simple to understand. Focus. Benefit means money. Cost benefit means how much money you invested in anything is compared with money which you earned, or money as outcome. Simple. Okay. Like you all have invested around 40 to 50 lakh in doing MBBS. If some student is doing MBBS from abroad, around 50 lakh rupees they have invested. And after 5-6 years of their clearing MCI exam and then JR-ship, they will be earning around at least 2.5 lakh rupees per month. So in 2 years, you can recover all the money which you have invested in the past. That is why this investment is really good, and your parent has done that investment. And so don't be under pressure of taking parent money. Whatever money you are taking in a half year, 6 months, you will return it in 1 month. And you will keep earning from your 30-35 year till your 60 year. So you will be giving crores of rupees to your family member. So don't worry about the money which you have invested. It's a good investment, trust me. If you ever doubt it, let me know. So that is cost benefit. Now what is cost effectiveness? Cost effectiveness means how much money you invested. And we are doctors, so we not only produce money, we also save life, improve quality of life. So you are comparing money invested is compared with quality of life improved or number of lives saved. Okay. Like your parent could have invested 30-50 lakh rupees in starting a business for you also. But business can never give you satisfaction of saving life of a patient. And people will never respect a businessman as they are respecting a doctor. And especially if the doctor is good and not doing wrong things. So that is cost effectiveness. How much money you put with how many life you save. This is your effectiveness. This is your utility. And if you are comparing two doctors based on cost effectiveness, let's say after your this clearing MCI exam, you are confused whether to open a nursing hospital with delivery facility or to open a OPD with lab and pharma. Always open these two things, that will triple your income. So you are confused between these two things. And suppose both of them, they both need 20 lakh rupees of investment. Suppose. But with nursing, you are saving every month 100 life and you are improving life of, let's say, 500 patient every month. And with OPD and lab, you are improving life of 1000 but saving only 20 life per month. So this comparison, money is same. Which one is more life saving? This comparison of cost effectiveness is known as system analysis. System analysis simply means you are comparing two work or two person based on who is more effective. Like when you are comparing doctor based on extracurricular activity, one is more cost effective, you are choosing that. So whenever you compare two cost effectiveness, that is system analysis. And when you are looking at your cost effectiveness only, one person, no comparison, that is cost effectiveness. So I think cost benefit, cost effectiveness, system analysis is clear. If it is not clear, Gokul, please ask it again. Okay. Now, Dr. Nitin Jat has a question in the YouTube that what is the treatment for HIV positive mother who is not on antiretroviral therapy? Okay. The question which Nitin has asked is that there is a HIV positive mother not on antiretroviral therapy and she delivered a child. What is the treatment which you will give to this infant? Okay, she delivered infant, which should be treated by, how you will treat him? So the answer to this question is that we definitely gave, first of all, syrup nevirapine. Nevirapine is started as soon as the child is born. It is given 2 milligram per kg per day. But nevirapine can given only up to 6 weeks because nevirapine is hepatotoxic. So you cannot give it after 6 weeks. Now after 6 weeks, we stop nevirapine and we start giving lamivudine plus zidovudine. These two drugs are given after 6 weeks to 6 months, at least till 6 months. Because this HIV positive infant, you will do DNA PCR testing of this infant at 6 weeks and 3 months. You will do 2 DNA PCR testing. If anyone came positive, you will give the medicine lifelong. If both came negative, some guidelines say that do a confirmatory at 6 months also. And suppose all 3 came negative, stop treatment at 6 months. So this is the 3 drug which we usually give, nevirapine plus lamivudine plus zidovudine. In some cases, these 2 drugs are not sufficient to control the HIV. So in that case, we can add raltegravir. So ideally, 4 drugs should be in the answer. Now, Nitin Jat has given 4 options. First option is cotrimazole 2 week with ART, of course. Cotrimazole, remember one very important question here, is only given if CD4 count is less than 350. Cotrimazole given if CD4 count less than 350 to prevent the child or the patient from opportunistic fungal infection. This is not given without doing CD4 count. And here CD4 count is not given. So cotrimazole answer can never be the correct one. So both option A and B have cotrimazole, so they are ruled out. Option C, they have given cotrimazole 4 week plus nevirapine. Option D, they have said none of the above. So all the 4 options are wrong, dear. And this can happen because many a time recall, especially in Fmge exam, the recall is never reliable. Remember, cotrimazole given only if CD4 count less than 350. And here CD4 count not given, so none of these are correct. But let's say I have to choose out of one. Of course, the better answer will be cotrimazole plus lamivudine plus nevirapine plus zidovudine, option B. And that will be good. We will not give antiretroviral therapy directly to the infant because in antiretroviral therapy, the 3 drugs which are given is LTD. Suppose I developed HIV, as you can see by my cough and losing weight. So you will give me 3 drug, limited addition, lamivudine, tenofovir, dolutegravir. Now this LTD is the drug, simple to remember, na, limited. Tenofovir is tough. So it is given in adult but not in adolescent. So you cannot give tenofovir to infant. That's why we should never give ART directly to infant. To infant, the 3 drug given is nevirapine plus lamivudine plus zidovudine. If you have to add any other extra drug, you can add raltegravir. Okay. So Nitin, let me know, is it clear? The correct answer in your option will be lamivudine plus nevirapine plus zidovudine. Okay. Option B will be more correct in your 4 option. Chalo. Nitin Jat is saying, okay sir, cleared a lot of confusion. Thank you dear, I am here for that only and I love to clear your confusion. If you have any other confusion, feel free to ask it, I would love that. Thank you Nitin for asking question. Next one is one question which I left. A lady like me presented with fatigue and tingling sensation in both hand and all the 2 legs. Now on examining, she is found to have fissure tongue, lesion at the angle of mouth and peripheral neuropathy with reduced glutathione reductase activity. This was a biochem question, how it came in PSM. Glutathione reductase. Which vitamin is likely to be deficient? I don't know the answer, man. It biochem question wrongly came in my slide. Glutathione reductase. Do you know the answer? Please answer. I don't know it. I need to see this thing online to answer it. And I cannot answer it like that. Let's come to PSM question, man. Okay. But anyway, let me think of some. Let's say I don't know the answer, which I don't know actually. If I have to guess, fissure tongue, lesion at the angle of mouth, peripheral neuropathy. Lesion at the angle of mouth, this answer. This is talking about angular stomatitis. And angular stomatitis occur with riboflavin deficiency. So answer will be riboflavin. Wow, I can answer it without knowing the enzymes. With the symptom, you can answer it. So answer is riboflavin because riboflavin deficiency, riboflavin is vitamin B2. Vitamin B2 deficiency lead to angular stomatitis, in which if lip is also getting infected, it is known as cheilosis. So if they write like that, cheilosis and all, answer will be riboflavin. And if they write that a patient have dryness around nose and mouth, what is the answer in this case? Here the answer will be zinc deficiency. Dryness around nose and mouth. But if there is cracking of angle, riboflavin deficiency is there. Very good. Buzz Lightyear. Star command say Buzz Lightyear is right. Angular stomatitis will be the answer. Very good. Chalo. AAA. Yes. Yasra, Mayank, Multistar. Thank you for answering. Yes, Gokul, you are also right. Which of the following is most sensitive indicator for recent transmission? Recent transmission infant parasite rate is best. Why? Because infant is only less than 1 year. If infant have malaria parasite in their blood, it means infection has spread in the area in last 1 year. So recent transmission, infant parasite. Annual parasite incidence tell about two things. I for incidence, I for impact. It tell incidence and impact of malaria control program. If malaria control program is working good, API will be less. Remember, if API is more than 1 per 1000, this state is known as state of intensive control. We need to do control of malaria rapidly. If API is more than 2 per 1000, 1 per 1000, 2 per 1000. If it is more than or equal to 2 per 1000, then we call it high risk area. So these two questions can also come. And remember, API tell impact. Slide positivity rate can tell about spread of malaria in that area, how many people are getting infected. And it can tell about spread. As for slide, as for spread of malaria in that area. Annual blood examination rate, it will tell whether people are making slide or not. So annual blood examination rate tell about operational efficiency of malaria control program. Okay, malaria control program, whether people are making slide or not. So these 4 indicators you should remember. They ask it again and again. And do remember, if you have histidine containing RDT kit, that will detect only Plasmodium falciparum. Optimal kit can detect both Plasmodium falciparum and Vivax. Okay, both falciparum and Vivax. And optimal RDT kit for malaria have lactate dehydrogenase enzyme. But histidine kit only falciparum. Neat question again last year. Which is the minimum recommended amount of free chlorine in water in swimming pool? In swimming pool, it is 1 milligram per liter. Now, if they ask about chlorine normally it is 0.5 to 0.7. And in one of the MCI exam 3.5 years back, they have asked about fluorine concentration. Chlorine is 0.5 to 0.8. This is normal concentration. So it's very easy to remember. Fluorine, chlorine, both are very close to each other. And in swimming pool, you know, na, some people do hanky-panky. So we need higher concentration in swimming pool, around 1. And in flood and cholera, here chlorine should be 0.8. Because you know ना, कुछ लोग इतने मौका फरस्त होते हैं कि बाढ़ में बहते पानी में पॉटी करते हैं और बम भी धो लेते हैं ना. They do fecal contamination in the same water which is flowing, and they wash their bum also in the same water. So we need higher concentration there also. Okay, around 0.8. Now, next question is a 23-year-old married female presented with chief complaint of curdy white discharge per vaginum, irritation and itching within around the introitus. It's the same complaint which I am having right now. Which of the following kit should be given to the patient? So, discharge per vaginum is the kit 2, and kit 2 is green. Kit 1 is grey, and grey kit is for urethral discharge, is for cervical discharge, is for anorectal discharge, very commonly asked. So grey is 1, 2 is green for vaginal discharge. After grey green, simple to remember, WBR, just like WBC, WBR. Both are for genital ulcer. In white, kit number 3, we give penicillin, and some people are allergic to penicillin, so in blue we give doxycycline. Red is for viral genital ulcer, where we give acyclovir. But let's say a female came with complaint of lower inguinal pain or lower backache, there we give kit number 6, which is yellow. Most commonly given is yellow. It is given for PID, lower backache and lower inguinal pain. Very commonly asked area of question. Kit 7 is last one black, and it is for inguinal bubbo. Bubbo means lymph node swelling. And most common bacteria for it is Chlamytobacter. They have asked it also. Chlamytobacter is most common, okay, which cause inguinal swelling. So doxycycline is given for 21 days in case of category black. Do remember this, because derma, PSM, gynae, they all ask question from it. Okay. If they have written that there is cervical erosion and vaginal discharge, answer will still be green, because cervical erosion is not always pathological. So focus on vaginal discharge, answer will be still green. Okay. Next question, in a village in UP, there is increased number of patients with complaint of bilateral pitting edema. Bilateral pitting edema on leg. This is typical feature of epidemic dropsy, which is due to poison sanguarine. And they have also written mustard seed. And also mustard seed is contaminated with Argemone maxicana, which is known as Satyanasi, destroyer. So Argemone maxicana also have yellow flower and black seed like mustard. They get mixed and they produce the disease epidemic dropsy. Okay, ascites. Of course, the abdomen is swelling, pate is swelling. So P for pate, stomach, and P for pyrrozolidine. So the poison of ascites is pyrrozolidine related with ascites pate. Aflatoxin occur when someone is eating contaminated groundnut. Again and again ask, do remember it. Contaminated groundnut or maize with aspergillus flavus. It will lead to hepatocellular carcinoma of liver, of course. Letharism, as you know, will have cross-leg walking on toe. It is due to poison boa, and for treatment we give vitamin C. So cross-leg walking, neuroletharism. A 15-year-old boy come to emergency with history of dog bite. Fully vaccinated for rabies. Who? Dog. This does not matter. Dog is fully vaccinated or unvaccinated, treatment will remain same. On examination, there are multiple abrasion but no bleeding. So if there is no bleeding, it is category 2. No bleeding but abrasion, category 2. In category 2, we wash and we give rabies vaccine. We do not give immunoglobulin. We give immunoglobulin when there is category 3 wound. And category 3 wound can be due to 4 reasons. First, licking on mucosa. Kutta आया और स्मूच देके चला गया. Licking on mucosa, category 3. Scratch on face is category 3. Chamagadad, bat bite is category 3. And wound with bleeding is category 3. So these 4 area we give immunoglobulin. If there is no bleeding but abrasion, category 2. If there is only scratch, category 1. Oh, sorry. Only scratch or abrasion without bleeding is category 2. But if there is only licking, and licking should not be on mucosa, only licking on intact skin, this is category 1. And in category 1, there is nothing we do, only wash. Okay. So here, what is the answer? Immediate vaccination, wound management. This is option D is correct. Okay. Yes, correct. Afia, Dr. Amir, Yasra, Nitin Jat, Mayank Patel, all of you are right. Thank you so much for replying. A screening test was carried out in 114 patients, out of which 15 had disease. Test came out positive for 22 patients, out of which 14 had disease. What they want to say this thing? See, positive is 22. 14 had disease. See, there are 2 types of positive. Positive total is 22. This is 2 types of positive. True positive and false positive. True positive are the one with disease. Okay. So how many are, and false positive are those which are non-disease but came wrongly positive. They are false positive. So here they have written 14 out of 22 came positive and have disease. So they have given true positive 14. Okay. And what is the formula of sensitivity? Sensitivity simply means true positive by disease. We can multiply it by 100 if we want to get the answer in percentage. So here true positive is 14 and they have written 15 have disease. So 14 by 15, option A will be correct. Okay. Power of Shiva is saying, when are you coming to Jaipur to eat Khatu Shyam ke chaloge is bar? Yes, bro, we will again go to Khatu Shyam and have good time. Coming soon, bro. Just busy with some children, and I recently became father of second child, so busy there. So come here. Very easy to remember the formula of sensitivity. It is true positive by true positive and just opposite of that. Opposite of true is false, positive is negative. So this is the formula of sensitivity. What is the formula of specificity? Just remember true negative. In the denominator, there will be true negative and just opposite of that. Opposite of true will be false, opposite of negative will be positive. So if you just remember sensitivity is true positive, formula is true positive and just opposite false negative. Specificity, if you want to remember the formula, just remember true negative. True negative above, true negative and just opposite of that, so false positive. And you can never forget this formula. So do remember it. Okay, correct answer A. Afia and Govindram both are right. Very good. Next question. Which of the following will be disposed of in black bin? Black bin is for garbage. Plastic wrapper of syringe is a garbage. Along with plastic wrapper, doctor prescription, which is also a garbage, will go in black. Gloves with blood, without blood does not matter. All kind of gloves goes in red. Even with blood goes in red. Blood bag have infectious material, so it will go in yellow. Pacemaker is metallic implant, so it will go in blue. Okay. Remember, in yellow we also throw culture medium and culture plate. It is written in park. And we also throw cytotoxic drug vial here. But vaccine is not cytotoxic now. I hope you all know. So vaccine vial goes in blue. A lot of book has written it wrongly. Vaccine vial in yellow. No. Vaccine vial intact or broken does not matter. Does not have cytotoxic material, so it will go in blue. But culture medium, culture plate, cytotoxic drug vial, they all will go in yellow. In red, you also have urine bag. Okay. These are some controversial here. Do remember in yellow, we also throw cotton. And there are 6 things which goes in yellow. Anatomical waste, liquid waste, microbiological waste, discarded medicine or expired medicine, soiled waste and cytotoxic waste. Chalo. What is the correct sequence of event leading to disability? Mnemonic is DIDH. Disease, impairment, disability, handicap. Disease, impairment, disability, handicap. So second option is impairment. This is correct answer. Mnemonic is DIDH. Okay. Yes, gloves when contaminated with blood. If you will throw, most of the gloves have some blood spot on it. If you throw this much of plastic in yellow color will have incineration, it will burn. And after burning plastic, there will be a lot of polyvinyl chloride which will be produced, which will lead to hepatocellular carcinoma of liver. So according to logic, remember all gloves with or without blood will go in red, because it's not that blood is filled in the gloves. It's only 1-2 spot or some gloves, some blood. And so in red, when we throw the things, we do autoclaving. So after autoclaving, we recycle it. So it's no problem in throwing it in red, because we do autoclaving, we will sterile it, and after sterilization, we will recycle it. So all gloves with blood also will go in red. Okay, thank you for asking, Uttam. I hope you agree. If not, let me know. Next question. After earthquake, a paramedical team reached there. How will you color code this patient? So color code is always that green people with minor injury and limb fracture. This is correct. Green is ambulatory. Then yellow is not ambulatory. They have asked this question in recent exam. If they say relatively stable patient who needs surgery in 6 to 24 hours, they will go in yellow. Black is for dead moribund patient. I hope you all know. and red is for those who need surgery in 6 hours. So remember this thing, relatively stable, yellow. Correct answer is of course A, which is green, ambulatory patient. Uttam has a question, sir, what is the role of isolation in patient of cholera as it is spread by fecal-oral route? That is exactly the role of isolation. If I drink this water, okay, and I am suppose having cholera, and someone else came and drink this water also, so then cholera can transmit, na? You have to isolate me from my family member because they can come and eat this water, drink this water. So isolation is done in cholera, but and the main reason is it is all the disease which are by fecal-oral route or respiratory route. In all those we do isolation and quarantine, and do remember that of course respiratory route quarantine isolation is more important, fecal-oral route transmission less important, but still it is important. And do remember all the fecal-oral respiratory route disease, even if not 100% are vaccinated, 95% are vaccinated, 5 will be protected by herd immunity. In case of tetanus, we also isolate because with stimulation patient turn into opisthotonous bow-like shape. But remember, tetanus and rabies are two diseases which is not transmitted by fecal-oral route. So in this case, herd immunity has no role. If a dog bite me, even if all my friends are vaccinated, rabies can infect me. So herd immunity is in tetanus, rabies. Okay. Health worker nurse got an accidental prick, not with me, by HIV plus positive needle. Parameter used to take for confirmatory diagnosis is Western blot. This is the confirmatory test. DNA PCR is not so confirmatory. That's why we repeat DNA PCR at 6 weeks and 3 months. We do 2 HIV DNA PCR. If suppose you got needle prick injury or any nurse got needle prick injury, 6 weeks and 3 months, 2 HIV DNA PCR is done. Plus for 28 day post-exposure prophylaxis is given, in which 3 drugs are given. Mnemonic is Raul 10 EMI, Raultegravir, Tenofovir, Imitricitabine. These 3 drugs are given for 28 days, written in Park, latest edition. Next question, you have to match it. Remember, Nischay. Nikchay. Nikchay means, Nik means no, Chay means loss of TB. Nikchay is software for reporting TB data, correct? 99 dots help in remembering the patient that they have taken medicine or not. Suppose I am taking TB medicine, after taking out some pill, there will be a secret number written behind it. I have to give a missed call on that number. If I did not give missed call, central government will come to know that I am not eating it. So 99 dots medicine reminder. Unmol. Unmol is the software given to ANM for data entry. So ANM operate data. When this software has given, most of the ANM in central and eastern part of India, they said, sir, it's okay, you gave us software. Where is the hardware? Where we should put this software? Because computer is not there in most of the sub-centers. But in southern part, it can be really useful to give the software. M cessation is not for mobile cessation, it's for smoking cessation. If you want to quit smoking, give a missed call on the number given by the government and they will call you again and again, so that you will quit mobile phone, not smoking. That's why it's M cessation. They think it's so easy to quit. But actually quitting cigarette is very easy. Very easy. I myself had quit cigarette 48 times by now. Very easy thing. What is Kilkari? Kilkari is the first cry of the child. It is mobile app to promote immunization and child care. And recorded messages will be given to mother. Mother will listen to the message and will keep care of their child. Nikust is portal for case management of leprosy. So these are the 6 new mobile-based programs. Do remember them. And the matching is there, which is very difficult to do, but still let me do. A with 1. So A with 1 is only in option A. That's why answer correct is option A. Next. Which type of plot is it? Oh, it is overlapping, but I hope, it's overlapping, but there is two ways to find the answer. Whenever the answer is in percentage, remember percentage and proportion is for qualitative or categorical data. Like I can know that how many percentage of a student are boy or girl. Percentage will tell you about your sex, which is quality. So percentage qualitative, and in qualitative we use chi-square test. Second thing, which graph they have given? Multiple bar chart here. And bar chart we just read is for qualitative data. So second hint, it is qualitative. Third hint, they are talking about infection. And infection we can only categorize into mild, moderate, severe infection. We cannot say a patient that you are 2.9 infected with COVID. So infection is also qualitative data or categorical data. And in categorical data, we apply chi-square test. So answer is B, very good. Kehkasha Khan, you and me. Dr. Amir, Yasra, Wasif, Subhas Kumar, all of you are right. It is chi-square. A child is 10 years is showing sign and symptoms suggestive of chicken pox. What will you do? What is correct? So CP is written in chicken pox. CP, and CP means centripetal. Chicken pox is centripetal. By centripetal means it will occur in the center of the body, on trunk and my bum and back, but not on palm and sole. Remember, monkey pox and smallpox are centrifugal. They can occur on palm and sole, but not chicken pox. So centripetal is correct with no rashes on palm and sole. Second thing, why they call it chicken pox? Because just like beak of chicken, it come out from the face. Chicken pox. Chonch ki tarah nikalta. This is very important to remember. They will give the picture of face of the child with chicken pox and measles rash. Measles will be in the skin surface. Nothing will be coming out. But chicken pox come out from a skin surface. So use that trick to remember and differentiate between those two diseases. Moreover, measles will be with cough, cold, coryza, conjunctivitis, and rash may start from back of ear or back of hairline. Chicken pox and rubella both are dry fever without any secretion. Measles will have water coming out and all. Measles rash will not come out. They will be in the skin surface. Okay. An infant is given buffalo milk. It is superior. No, never. It is not superior. It is inferior. Sorry for saying that. It is buffalo milk is inferior. But anyway, if they want to know what are the good thing in buffalo milk have high calorie and buffalo milk have high protein. These two things are good in buffalo milk. So correct answer is A. But why I am saying that it is not superior? Because all the iron and calcium and protein which are there in buffalo milk are poorly absorbed by human infant. So even if the iron and calcium are more in buffalo milk, they all go out. They are not absorbed. So it is not so useful. Remember, high chlorine, high calorie, high protein, high fat, all are these things are high in buffalo milk. No one can beat a bhainsia. Everything is high there except three things. Water, lactose, which is carbohydrate, docosahexaenoic acid, taurine and cysteine amino acid. These three things, these are maximum in human milk. So remember, human milk do not have carb or protein, do not have protein or fat maximum, but carbohydrate are maximum in human milk. Okay, that's why. And these three things are needed for brain development. That's why we need to give the child human milk, not buffalo milk. Chalo. Next question. A country is suspecting cholera. What is the time period within which it should be reported? 24 hours it should be reported to PHC. Any outbreak should be reported within 24 hours. That was a PYQ. So that's all from this session. I hope you all know marriages should be reported to sub-center. Birth and death are reported under civil registration system. And birth and death are reported at PHC within 21 days. And this is civil reporting or civil registration system. Okay, do remember it. Keep rocking, keep enjoying your life, whatever the situation is. And focus on the day. Fix the target and see whether you have achieved 80% of your target or not. If you have achieved 70-80% of your daily target, don't forget to appreciate yourself. That's very important to stay positive. Self-appreciation. Keep doing it. So, bye-bye. Hasta la vista. Dasvidania. We will meet again someday, sometime. Bye-bye. Thank you so much. Any question, any doubt, if you want to have, feel free to ask it. Thank you. Love you. Bye-bye. Thank you so much. You and me, I also love you. Okay. Bye-bye. Abhishek Sankla saying big fan. I love you, bro. I'm just because of your loves, I am earning good money. So thank you.
Hello. Hi, my dear students. How are you doing? In this session, we will have the questions of CBoT, Biochemistry section. Myself, Dr. Fmge. So let's start. The most potent antioxidant among the followings. So guys, there are a lot of antioxidants. Among the most potent antioxidant is biologically vitamin E. So vitamin E is the most potent antioxidant. Though there are others also mentioned, glutathione is an antioxidant. Yes, correct. Quercetin is an antioxidant, guys, found in the fruits and vegetables. This is a kind of flavonoid or the polyphenolic compound. You know, guys, what is quercetin? Actually a polyphenol. Okay, so polyphenol is found in the various fruits and vegetables. So that is the most potent antioxidant. Fine. Moving to the question number 2. A person was fasting for the 24 hours. Which of the following is the source of blood glucose? So guys, 24 hours. So if you remember that first 12 hours, only liver glycogen is used. Okay, that is a major source. Then 13 to 17 hours, liver glycogenolysis plus the gluconeogenesis, they vary. Then more than equal to 18 hours, liver glycogen is finished and gluconeogenesis is the only source. So here the answer is gluconeogenesis, because by the 18 hours, the liver glycogen is depleted. Right? Remember, that is a separate MCQ. Okay. And guys, muscle glycogen do not participate in the maintenance of blood glucose. Why? Because the muscle glycogen cannot, add glucose to the blood. Why? Because the last enzyme of the gluconeogenesis or the glycogenolysis, that is glucose 6-phosphatase, is missing in them. So muscles don't have which enzyme? Glucose 6-phosphatase. That is why they don't participate or they don't contribute to the blood sugar maintenance. Okay. 8-year-old girl was referred for the recent UTI, low back pain. Ultrasound shows kidney stones. Okay. And on analysis of the stones, let's say, suppose if they were passed, they are of cystine. Okay. So this information may be given in the MCQ on both the sides and the grade 2 hydronephrosis on the right. A diagnosis of renal basic amino acid transporter defect was made. So guys, basic amino acid transporter defect. So this is a case of cystinuria, right? Cystinuria it is. And guys, in the cystinuria, the basic amino acid transporter is defective. Okay. And guys, in the Hartnupp's disease, the neutral amino acid transporter is defective. Hartnupp's has neutral. Guys, when I write Hartnup, Hartnupp's. So in the Hartnupp's, you remember like this. Always write Hartnup like this. Neutral amino acid ureas. Okay. That is in the Hartnupp's. And in the cystinuria, there is the basic amino acid transporter. Fine. So what are the amino acid which appears? COLA. Cola appears in the urine. C for cysteine, O for ornithine, lysine and arginine. So cysteine, ornithine, lysine and arginine. These are the 4 amino acids which will appear in the urine. Right guys? So question is, which amino acid is not seen? So guys, cysteine is not seen. Cysteine is seen, right? Cysteine and cysteine are the two different amino acids, as we all know. Cysteine is nothing but when I join two cysteine together by the disulfide bond, that is called as cysteine. Okay, Cy is cysteine and S is a sulfur. So when these two sulfur are joined of the two cysteines, this becomes cysteine. Got it? So actually cysteine is the oxidized form of cysteine. Fine guys. So that is your, in this case guys, there may also be rotten egg order in the urine, and there may be hexagonal crystals in the urine, hexagonal cysteine crystals in the urine, and crystals means microscopic. We have to see them under the microscope and they will have a beautiful hexagonal shape. Correct guys? Okay, and the rotten egg order. 7-day-old girl admitted to the pediatric metabolism clinic with a suspicion of PKU after the newborn screening program. So they are asking which technique is used for the newborn screening program. So guys, this is a very important question, and that is mass spectrometry. So for most of the, the screening programs for the newborn disorders, we use mass spectrometry. For all the inborn errors of metabolism, we use mass spectrometry. Right, guys, also the dope test, this is also a question, dope test. That is for the illegal drugs or the drugs which are performance enhancing, like in the athletes. That is also done through the mass spectrometry. Guys, mass spectrometry can also find the new biomarkers. Okay. Just say, like for example, we know that PSA is a marker of prostatitis or the maybe prostate cancer. But, such biomarkers discovery can be done using the mass spectrometry. Right, guys? Okay. Next is a case of urea cycle disorder with the CPS1, that is the rate limiting step, and the first step of the urea cycle will have the following findings in the blood. So guys, when the first step is missing, when the CO2 plus ammonia, I have to, just fuse them. So this is the enzyme that is called as CPS1, which is activated by N-acetyl glutamate as the allostric activator or the obligate allostric activator. Remember, NAG is the obligate allostric activator of CPS1. Obligate matlab chahiye hi chahiye. Like, this is a must requirement. Okay. So, guys, obviously, when this enzyme is missing or deficient, the ammonia will be free. So, there will be high ammonia for sure. So, answer can be A or B. But, guys, there can be high glutamine also. Ammonia is carried in our blood in the form of glutamine, right? This is a separate question, that ammonia is transported in the human body in a non-toxic form in and as glutamine. Correct? So that is my answer number A. Orotic acid is not seen here. Orotic acid urea is part of ornithine transcarbamylase, second step, OTC deficiency. So guys, urea cycle disorders are very important, and just 5 or 6 names that you should know, and very, very important questions in the exams. 8-year-old girl presented with xanthoma and acute pancreatitis. TG levels of 2000 mg, which is very high. Normally it should be less than 150. Blood vacuotinal looks milky, so milky plasma. Okay, which of the following defect can cause such presentation? So guys, this is a case of type 1 hyperlipidemia, right? And the defect in this case is lipoprotein lipase deficiency. Okay, guys, as we all know, type 1, type 2 and type 3, we have to remember. In the type 1, there is a deficiency of lipoprotein lipase. In the type 2, there is a deficiency of LDL receptor. In the type 3, there is ApoE2 expression. There is no deficiency, but E2 variant is expressed instead of E3. E3 is normal, E2 is abnormal. Okay, so these are the findings. Here the TG will be very high with the normal cholesterol. Here the cholesterol will be high or the LDL will be high, right? Where the TG may be normal or maybe high, but mostly normal. Okay, and in this case, there will be TG plus cholesterol equal. Guys, this is special case where you find, suppose 300 mg of both, TG be 300 hai, cholesterol be 300 hai. So that is your type 3 hyperlipidemia. Correct, guys? So remember all the hyperlipidemias, especially these three. Which of the following lipid parameter is abnormal in the following case? So this is a case of orange tonsils. Orange tonsils are seen in Tanger's disease. And guys, in the Tanger's disease, what is the defect? The ABCA1. Okay, ABCA1 is defective in the Tanger's disease, and there is a low HDL, right? There will be very low HDL, which is less than 10. Normally in the males, they should be more than 40. In the females, it should be more than 50. Fine. So that is a finding that we have to remember in this case. So a case has been given, guys. Okay, so the baby is 7 months old. Okay, present to the emergency with a vomiting. Okay, and formula feed and grape juice history is there. And infant wake up screaming and turned pale and went limp. Right, he did not have any seizure-like activity or apnea. His mother rushed him to the emergency room. Sugar was found to be very, very low. Right, he was given apple juice initially, right, which further causes more lethargy. Then he was given the dextrose saline, and his blood sugar rose. Right. So which of the following enzyme deficiency explains the above case? So guys, sugar level are low. History of fruit juices. It's a typical case of hereditary fructose intolerance, isn't it? Right. So guys, hereditary fructose intolerance, and the deficiency is aldolase B. Okay. Just to remember that all the B's, right, that is aldolase B, they love high fructose items. Okay, so this is like, let's make it love. So all the B's, they love high fructose items. Okay, so that is hereditary fructose intolerance. Clear, guys? Let's move to the next point. So guys, why there is a low sugar in the hereditary fructose intolerance? What do you think? Why there is a low sugar? Guys, there is a low sugar because of the two reasons. Actually, guys, the fructose actually converts into fructose 1-phosphate by the second enzyme. But fructose 1-phosphate is not further metabolized because of deficient aldolase B. So fructose 1-phosphate accumulate, and guys, this fructose 1-phosphate inhibits the enzyme that is called as the glycogenolysis enzyme, that is glycogen phosphorylase. Okay. So glycogen phosphorylase will be defective here. You got my point? Okay. So a 3-month-old baby presented with the poor feeding, jaundice and hepatomegaly and the clay-colored stools. So that means a jaundice. He was diagnosed with classical galactosemia. So already given. Which of the following is not a classical finding in this case? So what are the classical findings and what are the not? So guys, classical findings are a lot. Starting from as soon as the baby was given the milk, baby has vomiting. So that is intolerance to the milk. Yes. Second, oil drop cataract because of accumulation of galactitol. Yes. Third, there is E. coli sepsis. Fourth, there is jaundice and hepatomegaly. 5, there is later on, mental retardation and premature ovarian failure. So almost 7 I told you. So guys, intolerance to soya milk. This is actually the mainstay of treatment you can use. Nowadays, no doubt the formula milks are available without lactose, or the lactose-free milk supplements are available. But soya milk is also used as a therapy. Correct, guys? Next question. A chronic alcoholic presented with the confusion, nystagmus and unable to balance. So guys, this is a typical case of Goa. A person went to the Goa, global confusion, ophthalmoplegia, that is nystagmus, and ataxia, unable to balance. So an assay of which of the following enzyme can determine the reason for his symptoms? So answer is transketolase. Guys, there are only 3 vitamin tests you have to remember, right? For the, if I have to say test for vitamins, thiamine, if I have to say thiamine. So guys, thiamine, the test is transketolase, right? Then if I say riboflavin, then the glutathione reductase. Okay, that is glutathione reductase. Fine. And guys, we have to remember B6 also, that is pyridoxine. Okay, so that is, the test is called as xanthurenic acid test. Okay, xanthurenic acid test. Fine, guys. So here Guys, how we can remember? See, pyridoxine, X. Just remember like this. So for pyridoxine, the test of dox, X for xanthuronic acid. For riboflavor, guys, remember this mnemonic like this: great flavor. Great flavor. So what is great flavor? Glutathione reductase test for the riboflavin. Flavor means mouth. Mouth means cut at the angle of mouth. Right, like this. So flavin, flavor, cut at the angle of mouth. Thiamine. Guys, just again starting with the T. So the test is also starting with the T. Trans keto. देखो ऑप्शन में हो सकता है examiner can give you trans aldolase also, one of the enzyme of HMP shunt, but not this is the answer. Trans keto. So again one more T is here, right? So just remember the T's and T's, not trans aldolase, trans ketolase, right? Tolase, thiamine, right? Fine. Then guys, next test. So guys, remember these three important test name. Fine. Glucose tolerance test factor is an essential dietary agent that potentiates the action of insulin, right? Glucose tolerance factor, yes. And guys, the question is, which of the following mineral requires for the synthesis of glucose tolerance factor? So guys, chromium is the answer, right? Chromium is required for the synthesis of glucose tolerance factor. That is why guys, you might have seen or you might have read already that in the diabetes treatment, chromium supplements have been tried and they were found to be effective in a large group of patients, right? Not in every case, but yes. Because diabetes is again a disease which is very complicated. What causes the insulin resistance is maybe, very difficult to analyze. Okay, but yes, this may help. Okay. 1-year-old child present with a jaundice, abdominal distension and weakness. On examination, she had hepatomegaly. Blood examination shows the deranged LFT and the liver biopsy revealed precipitates of glycogen in the... See guys, anything precipitates when it is not soluble, right? So which disease has a low solubility of glycogen? Anderson's disease, right? And they have also mentioned the amylopectin-like structure. So this is a case of Anderson's disease. Right, what is the name of enzyme deficient? Branching enzyme deficiency, right? Branching enzyme A, B, C, D, Anderson branching, Cory's D branching. And also guys, the least soluble, solubility will be very low in the Anderson's disease. Why? Because branch nahi hai to soluble nahi hai. I told you, like, more the branching of the glycogen, more is the contact with the water and more is the solubility of the glycogen. Okay, so it is like this. A man working in an oil refinery presented with the cough, vertigo and shortness of breath. Soon after admission in the hospital, he became unconscious and he had an odor of rotten egg from his breath. So guys, odor of rotten egg in the breath is because of hydrogen sulfide poisoning. Even if you don't know, they have already mentioned this, that probable toxin is inhibiting complex 4. So complex 4 and again hydrogen sulfide is the answer, right? So answer is H2S. Because guys, in the cyanide poisoning there is no such odor, in the CO poisoning there is no such odor. They may be, appearance of the skin may be something like cherry red, but not the odor. Even in the azide poisoning, which is very rare, there is odor from the breath. Correct guys? So H2S. And guys, one more thing, oil refinery, this is a occupational hazard. The people who are working in the oil refineries, ONGC for example, बोल दूं मैं, या Indian oil refineries, जहाँ पे भी refineries होती हैं, these incidents may happen. Coal mines, right? So in the mines and all, right? So this can happen. Which of the following is not associated with the increased risk of atherosclerosis? So guys, atherosclerosis or the high risk of cardiovascular disease. Homocysteine, yes, it is associated. Lipoprotein little a, yes, because it is competing with plasminogen. Okay, homocysteine, yes. Homocysteine causes LDL oxidation and LDL, making the LDL particles to aggregate. So LDL aggregation it causes, right? So LDL becomes large in size and causes the deposition in the vessels, right? So atherosclerosis can happen. Lipoprotein little a competes with plasminogen, very important MCQ. not plasmin, plasminogen, right, which converts into plasmin and breaks the clot normally. So lipoprotein little a competes with the normal clot lysis process. Trans fats, yes, trans fats, like animal fats may have trans fats, so they are also considered bad for the heart. High fish oils, guys, omega-3 high fish oil. Omega-3s are considered as the most cardioprotective, right? This is already MCQ also like this way. Most cardioprotective fatty acids. So that is omega-3. Clear, guys? 27-year-old male presented with the erosions at the mucocutaneous junctions, right? So let's say mouth and the anal canal, right, which is spreading to the periphery, and recurrent diarrhea is also there. He had hair loss is there. Poor wound healing is there. So guys, for me, like as a student, if I sit in exams, poor wound healing, and because question has all the options in the minerals, so this can be the very important clue for me, even if I don't remember anything else. Poor wound healing. He married, and he also reported a recent consultation for infertility, right, or the impotency. Okay, he was treated with the systemic steroids but did not have any improvement. Which of the following nutrient? So guys, answer is zinc. Fine. Zinc is a very important mineral, guys, right? And the deficiency of zinc causes acrodermatitis enteropathica. So these are the symptoms, that is acrodermatitis. Okay, that is not mentioned here. The acral regions, these are the ants of the body, acral regions. So there is dermatitis, right? For example, even at the mouth and anus, ants of the body, scalp, let's say even the face is considered an ant of the body, and then the anus or the genitalia, you can say completely. They may be just penis or the vagina or the the anal canal. So everything is included in that. So ants of the body, acrodermatitis. Okay, so acrodermatitis. Enteropathica means diarrhea. Fine. So deficiency of zinc causes acrodermatitis enteropathica. Then deficiency of zinc causes infertility or hypogonadism. Right? Why? Because guys, zinc is a part of steroid receptors. Right? Steroid like testosterone, if I say, steroid receptors are zinc fingers. What are zinc fingers? Zinc fingers are the name given to the steroid receptors. Clear? So that is why, guys, the answer will be zinc. And for me, the most important line here is poor wound healing. So remember this, guys. A 7-month-old baby present with the scissors, partial blindness and the paralysis. She have a cherry red macula. Now, guys, remember one thing, that cherry red macula, if mentioned, and they are asking any question, so the first thing that should come in your mind is Tay-Sachs disease. Okay, because cherry red macula may be present in other disorders, but not consistently, not always. But in the Tay-Sachs disease, it is a finding which is very, very important to remember always, right? So which of the following enzyme deficiency can explain this case? So answer is hexosaminidase A. Other points here are scissors, partial blindness and paralysis. Paralysis is one of the common symptom in the early age, right, where the baby presents with the Tay-Sachs disease, right, guys? And cherry reds. So remember 2 points, paralysis and cherry red macula. Which of the following amino acid? Ajay, guys, in the cherry reds macula, remember one more thing. I mean to say, in the Tay-Sachs disease, always remember one more thing. Onion skinning of lysosomes on the histopathology will be seen, right? And hexosaminidase enzyme is deficient. Accumulation of GM2 will be there. GM2 gangliosides will be there, right? Okay, and the similar disease is also called as Sandhoff's disease. But guys, in the Sandhoff's disease, there is hexosaminidase A and B, both are defective. Here it is A. That is the name we have to remember. Alpha galactosidase A is deficient in Fabry's. Glucocerebrosidase is deficient in the Gaucher's. Galactocerebrosidase is deficient in the Krabs disease. Clear? Which of the following amino acid is used in the purine synthesis but not in the pyrimidine synthesis? So guys, the difference in purines and pyrimidines is very important. So if I talk about purines and pyrimidines, so the amino acid that is used in purine synthesis is glycine, but here it is not. Guys, folic acid is used directly, right, in the ring synthesis. Here it is only in conversion of uracil to thymine. I will use the folic acid. Then guys, in the purine synthesis occurs exclusively in the cytoplasm. Here it is cytoplasm plus one step in the mitochondria. Right, so this point you should also remember. Guys, PRPP is the start point. I start with the PRPP. Here I end with the PRPP addition. Phosphoribosyl pyrophosphate I add first, then start the purine synthesis. Here it is the last point. Clear guys? So these are the differences. And guys, the uric acid is the end product, and here the uric acid is not, but beta alanine is the end product, especially from cytosine and uracil. Okay, cytosine and the uracil. Clear guys? So these are the differences between the purines and the pyrimidines. You got it guys? So very simple. I have tried to cover all the points which are needed for your exams in this paper, right? So all the best, and keep revising, keep practicing, right? And make tables, right? And fix this, paste these tables on your wall, right? Where you visit at least once a month. So thank you so much guys. Bye bye. All the best.
Okay guys, so let's start pathology session. Let's start with pathology. Chalo, first question. Which of the following is correct? बता दो मुझे आंसर. Whole blood packed RBC stored at 2 to 6 degrees Celsius 42 days. सही है गलत है? Absolutely correct statement sir. FFP is kept below 18 degrees Celsius for 10 years. पागल है क्या? 10 साल तक FFP स्टोर करेगा? It is stored for 1 year. Third, platelets are kept at 20 to 24 degrees Celsius for 5 days with continuous agitation. With continuous agitation. सही है गलत है? बिल्कुल सही है सर. Cryoprecipitate is kept below 18 degrees Celsius for 10 years. पागल है क्या? 10 साल तक थोड़ी you can store this in the blood bank. एक साल तक होता है. So what is the correct statement, my dear students? It is option 1, 2 and 4 are correct. Option 2 and 4 are correct. गलती कुछ नहीं रखना बॉस. Everybody, whole blood को हम 2 to 6 degree Celsius पे रखते हैं for 42 days. Can you recall and tell me 42 days रखने के लिए कौन सा solution best था? I hope all of you remember it is Sagam solution, which consists of saline, adenine, glucose and mannitol. ये whole blood के लिए हो गया सर. प्लेटलेट्स को आपको याद होगा, सबसे इंपॉर्टेंट MCQ यही होता है. प्लेटलेट्स को हम रूम टेम्परेचर पे रखते हैं 20 to 24 डिग्री सेल्सियस. ध्यान से क्वेश्चन पढ़ना. विद एजिटेशन लिखा है एग्जाम में या विदाउट एजिटेशन लिखा है? इट इज विद और विदाउट एजिटेशन. विद एजिटेशन यू कैन स्टोर इट फॉर 5 days and without agitator you can only preserve or store it for 1 day, right? So this is about whole platelets. क्योंकि I hope all of you remember, because platelets are stored at 20 to 24 degrees Celsius, so platelets almost at room temperature, so there is maximum chances of infection with the platelets. Out of all the blood components, platelets have got the maximum chance of infections, right? Then and cryo and FFP और cryo की बात करूं मैं अगर, both are stored at less than minus 18 degrees Celsius, but for 1 year. But for 1 year, not 10 years. जाते जाते एक चीज और बता दो मुझे, जो क्वेश्चन बहुत बार एग्जाम में आया है. What are the components of cryoprecipitate? बता दो मुझे सर. Cryoprecipitate, yes sir, von Willebrand factor, clotting factor number 8, और क्या क्या होता है सर? फैक्टर नंबर 13 और लास्ट में फिब्रिनोजन. इसको स्टार मार्क करके लिख लेना. ऑल दीज आर कंपोनेंट्स ऑफ क्रायोप्रेसिपिटेट, राइट? 8th, 13th, VWF and fibrinogen. Move to the next question. A newborn baby with profuse bleeding from the umbilical stump after birth. PT and APTT are within the normal limits. Umbilical stump हमने डिस्कस भी किया था सर गैस सीरीज में. umbilical stump से ब्लीडिंग हो रही है, PT APTT नॉर्मल है. Probable diagnosis, the answer is Glanzmann thrombasthenia. The answer is Glanzmann thrombasthenia. सर जब भी मैंने आपको लास्ट क्लास में बताया था बर्नार्ड सोलियर में और ग्लैंसमैन थ्रोम्बस्थीनिया में, आई एम श्योर ऑल ऑफ यू रिमेंबर, बर्नार्ड में GP1B की डेफिशिएंसी है, ग्लैंसमैन में GP2B3A की डेफिशिएंसी है, राइट? बर्नार्ड में भी ब्लीडिंग टाइम बड़ा आएगा, ग्लैंसमैन में भी ब्लीडिंग टाइम बड़ा आएगा. दोनों में PT APTT विल बी नॉर्मल, दोनों में it will be normal, right? So please remember, and last सबसे important चीज कैसे differentiate करना था? बर्नार्ड सोलियर में generally symptoms occurs at the late childhood, क्योंकि adhesion defect is late childhood, whereas Glanzmann thrombasthenia का the characteristic picture is umbilical stump bleeding. ये लाइन याद रख लेना, बहुत इंपॉर्टेंट है, umbilical stump bleeding. सर तो मेनली डिफरेंशिएट कैसे करते थे? ओल्ड टेस्ट हो गया, रिस्ट्रोसेटिन टेस्ट, मैं बार बार नहीं बताऊंगा, आई होप ऑल ऑफ यू रिमेंबर रिस्ट्रोसेटिन एग्रीगेशन टेस्ट. बर्नार्ड में इट इज एबनॉर्मल एंड ग्लैंसमैन में इट इज नॉर्मल. तो रिस्ट्रोसेटिन टेस्ट इज एबनॉर्मल इन बर्नार्ड सोलियर सिंड्रोम एंड नॉर्मल इन द ग्लैंसमैन सिंड्रोम. और लास्ट में दोनों का इन्वेस्टिगेशन ऑफ चॉइस पूछा गया. प्लीज रिमेंबर, इन्वेस्टिगेशन ऑफ चॉइस फॉर बोथ whether it is Bernard Solier syndrome or Glanzmann, it is flow cytometry. It is flow cytometry, right? Then move to the next question. 16-year-old leukemia patient having decreased platelet counts, prolonged PT and APTT. PT भी बढ़ा हुआ है, APTT भी बढ़ा हुआ है. Peripheral smear is given. Most likely cytogenetic change पूछा है. दिल मत तोड़ना करम जलो, सही में मुंह तोड़ूंगा दिल तोड़ा तो. क्या दिख रहा है अपने को? सर अपने को दिख रहा है एक सेल जिसके पास और रोड्स हैं, एक सेल जिसके पास और रॉड्स हैं, और एक सेल जिसके पास मल्टीपल और रॉड्स हो, जैसे मुझे दिख रहा है. इस सेल को अपन क्या बोलते हैं? दिस सेल्स आर कॉल्ड एज फेगोट सेल्स. दिस सेल्स आर कॉल्ड एज फेगोट सेल. मैं सही में दिल तोड़ दूंगा, मुंह भी तोड़ दूंगा, सब कुछ तोड़ दूंगा अगर आपने नहीं बताया तो. वो सेल्स जिसमें और रॉड्स दिख जाएं, वो सेल्स को अपन क्या बोलते हैं? दिस सेल्स आर कॉल्ड एज माइलोब्लास्ट. तो एक चीज तो कंफर्म होगी सर, जो मुझे सेल दिख रहे हैं वो माइलोब्लास्ट हैं, और माइलोब्लास्ट दिख रहे हैं तो मेरे दिमाग में आना चाहिए कौन सा ल्यूकीमिया इस पेशेंट को? हमने अच्छे से पढ़ा था, माइलोब्लास्ट मींस इट हैज टू बी AML. अब क्वेश्चन यार है AML में साइटोजेनेटिक एब्नॉर्मेलिटी कौन सी है? कंसेप्चुअली चलेंगे. AML साइटोजेनेटिक एब्नॉर्मेलिटी, द आंसर इज 15 and 16. AML जैसे मैं बात करूं स्पेशली M3 की, आई होप ऑल ऑफ यू रिमेंबर AML M3 के बारे में हमने पढ़ा था, मैक्सिमम और रोड्स दिखते हैं. AML M3 में ही मैक्सिमम और रोड्स दिखते हैं, और M3 के बारे में आपको ये भी याद आ रहा होगा, इट हैज मैक्सिमम चांसेस टू कॉज DIC. तो M3 DIC तो हमें पता लग गया AML M3 का क्वेश्चन है, और हमने अच्छे से पढ़ा था AML M3 में ट्रांसलोकेशन इज 15-17. आपको याद आ रहा होगा 15-17 की जीन क्या है? PML रारा जीन. इसलिए ट्रीटमेंट में हमने पढ़ा था AML M3 ट्रीटमेंट क्या है? यू गिव एट्रा, you give all trans retinoic acid, right? So it is 15-17 the best answer. आगे भी बता दो सर, गलती नहीं करनी. 12-21 कहाँ होगा? फटाफट. 12-21 is seen in BALL. It is seen in BALL. ALL में 12-21 की ट्रांसलोकेशन मिलती है. 8-14 नहीं तो भूलने का ही नहीं. 8 जैसा तो Burkitt's lymphoma. 8 is used for Burkitt's lymphoma, और 9-22 is used in CML. So here the best answer of AML would be 15-17 translocation, right? Next question. 2-year-old child present with scattering permeating lesions in the skull. इलेक्ट्रोमाइक्रोस्कोपी दे दिया, और क्या दे और जान लोगे चिड़ी कहाँ जाके मरे? सिंपल तो क्वेश्चन है. इलेक्ट्रोमाइक्रोस्कोपी में कौन से ग्रेन्यूल्स दिख गए? सर टेनिस रैकेट अपीयरेंस दिख गया मुझे सर, और मुझे टेनिस रैकेट अपीयरेंस दिखते ही मैं समझ गया सर ये कौन से ग्रेन्यूल्स हैं सर? इट इज बिरबेक ग्रेन्यूल्स. और बिरबेक ग्रेन्यूल्स दिखने का मतलब मैंने डायग्नोस लगा दिया सर, इट इज LCH. इट्स अ केस ऑफ लैंगरहैंस सेल हिस्टियोसाइटोसिस. तो लैंगरहैंस सेल हिस्टियोसाइटोसिस में क्या पॉजिटिव आएगा? ABCD. कम ऑन, यस, इट हैज टू बी CD1A. Langerhans cell histiocytosis is positive for CD1A. Can you tell me the even better answer? The most specific marker? Yes, you use CD1A, absolutely. The most specific marker is Langerin. Most specific marker is Langerin, which is CD207, which is the most specific marker for Langerhans cell histiocytosis. Yes, it is positive for CD1A, even ascended also. But remember, Langerin is the most specific marker, which is CD207. Right? Simple question था. जाते जाते बता ही दो सर मुझे CD10 के बारे में क्या पता है? CD10 is also known as काला molecule. हम काले हैं तो क्या हुआ? CD10 वाले हैं. So it is काला molecule. CD95 बता दो यार. CD95 is a marker for apoptosis. It is marker for apoptosis. और CD99 कितनी बार याद कराऊं करम जलों? It is positive in Ewing sarcoma, and it is also positive in the granulosa cell tumor ovary. Ewing sarcoma and granulosa cell tumor होगी, right? Then moving to the next question. 9-year-old boy with a mass in abdomen. On imaging, the para-aortic lymph node is enlarged and the biopsy has revealed the following histopathological change. What is the most likely underlying abnormality in this condition? बता दो चांद तारे तुम्हें कौन सा अपीयरेंस दिख गया? मैं इस पे टाइम वेस्ट नहीं करूंगा. It has to be starry sky appearance. कुछ चीजें आती थी, they will be keep on coming, they will be keep on repeating. तो दिस इजी क्वेश्चंस को तो करना ही नहीं गलत बॉस. स्टारी स्काई अपीयरेंस मुझे दिख गया सर. स्टारी स्काई अपीयरेंस का मतलब मुझे दिख गया इट इज बर्केट्स लिम्फोमा. बर्केट्स लिम्फोमा तो बता दो विच ऑफ द फॉलोइंग मोस्ट लाइकली. P53 जीन म्यूटेशन होती है क्या? पागल है क्या? P53 जीन म्यूटेशन से कौन सा सिंड्रोम होता है सर? इट इज ली फ्रॉम एनी सिंड्रोम. आरबी जीन होती है. पागल है क्या? आरबी जीन से तो रेटाइनोब्लास्टोमा होता है और आई एम श्योर आपको पता होगा रेटाइनोब्लास्टोमा वाले पेशेंट को और क्या होने के चांसेस रहते हैं? ऑस्टियोसार्कोमा. ऑस्टियोसार्कोमा. बीसी अरेबियल जीन. पागल है क्या? ये तो सीएमएल कॉज करता है बॉस. एंड मिक जीन. एब्सोल्युटली मिक जीन. याद करो 3 मिक पढ़ी थी अपन ने. सीमिक, एलमिक एंड एनमिक. फटाफट. सीमिक तो अभी भी पढ़ी अपन ने, बर्किट्स में होती है. एलमिक से एल फॉर लंग, लंग कार्सिनोमा स्मॉल सेल, और एन फॉर न्यूरोब्लास्टोमा. ये भी अपन ने पढ़ लिया. तो सिंपल क्वेश्चन, बर्किट्स लिम्फोमा इज सीमिक म्यूटेशन, राइट? मूव टू द नेक्स्ट क्वेश्चन. All of the following are correct about amyloidosis except AIPP involved in with insulinoma. Yes, सही है गलत है? बिल्कुल सही स्टेटमेंट है. Most common cause of secondary amyloidosis is tuberculosis. पागल है क्या? Most common cause of secondary amyloidosis is rheumatoid arthritis. It is rheumatoid arthritis. Now, most common clinical manifestation of amyloid is massive proteinuria. Absolutely. Amyloid deposit extracellularly. Yes. बाकी सब स्टेटमेंट है. सेकेंडरी एमाइलोइडोसिस का मोस्ट कॉमन कॉज ट्यूबरकुलोसिस नहीं है, इट इज रूमेटॉइड आर्थराइटिस. एमाइलोइडोसिस के बारे में छोड़ना बहुत बड़ा पाप हो जाएगा. 2 टाइप की एमाइलोइडोसिस है, सेकेंडरी एंड प्राइमरी एंड सेकेंडरी. दिल मत तोड़ना. मोस्ट कॉमन कॉज ऑफ प्राइमरी एमाइलोइडोसिस आया तो मल्टीपल माइलोमा पे टिक करके आना है. मोस्ट कॉमन कॉज ऑफ सेकेंडरी एमाइलोइडोसिस आया तो रूमेटॉइड आर्थराइटिस पे टिक करके आना है, राइट? इतनी चीजें अगर आपको याद है तो ये भी बता दो. Primary amyloidosis, multiple myeloma. Which type of amyloid is seen? It is AL type of amyloid. And secondary rheumatoid arthritis वाली amyloidosis में it is AA type of amyloid. It is AA type of amyloid. सबको पता है सर, बार-बार टाइम वेस्ट करने की जरूरत नहीं. Alzheimer's में A बीटा, ये चीजें will keep on revising. I know you know this, but we'll keep on revising. 1-2 क्वेश्चन इसमें से will not get it wrong in the exams. Alzheimer's में A बीटा. Dialysis के पेशेंट में yes, it is A beta 2 microglobulin. A beta 2 microglobulin, राइट? देन मुझे फटाफट बता दो सर, ये मेरे को बताया मैं दिल खुश हो जाएगा सर. सेनाइल अमाइलोइडोसिस, अगर आपने ये बता दिया मेरा दिल खुश हो जाएगा सर. सेनाइल अमाइलोइडोसिस में कौन सी अमाइलोइड होती है? कम ऑन कम ऑन कम ऑन. यस सर, इट इज वाइल्ड ट्रांसथायरेटिन. वाइल्ड ट्रांसथायरेटिन इज इन्वॉल्व इन सेनाइल अमाइलोइडोसिस. क्वेश्चन गलत मत करके आना. आई एम श्योर आपको पता है सर. सेनाइल अमाइलोइडोसिस का मोस्ट कॉमन ऑर्गन इन्वॉल्व. प्लीज 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 आवाज आनी चाहिए यहां तक, जयपुर तक आवाज आनी चाहिए. सेनाइल अमाइलोइडोसिस मोस्ट कॉमन ऑर्गन इज हार्ट. सो हार्ट इज इन्वॉल्व इन. हार्ट 2 जगह इन्वॉल्व होता है, प्यार में और सेनाइल अमाइलोइडोसिस में. और अगर सिर्फ अमाइलोइडोसिस पूछा उसने, सो ओवरऑल मोस्ट कॉमन ऑर्गन ऑफ सेनाइल अमाइलोइडोसिस इज हार्ट, बट जनरली अमाइलोइडोसिस इट इज किडनी, राइट? हम सबको पता है, राइट? और अमाइलोइडोसिस का मोस्ट कॉमन ऑर्गन इन्वॉल्व किडनी, बट मोस्ट कॉमन ऑर्गन ऑफ सेनाइल अमाइलोइडोसिस इज हार्ट, राइट? मूव टू द नेक्स्ट क्वेश्चन. फॉलोइंग एससीसी मार्कर्स को एसोसिएटेड मैलिग्नेंसी से यू हैव टू मैच. टाइम वेस्ट करने का ही नहीं, अभी भी डिस्कस किया. CD99 इविंग सार्कोमा. HMB45 you need to tell me this, you need to tell me this. HMB45 malignant melanoma. Desmin rhabdomyosarcoma. Desmin rhabdomyosarcoma. Arginase हिपैटोसेल्युलर कार्सिनोमा. ये क्वेश्चन फैक्ट बेस, यू नीड टू रिवाइज, और इन दोनों पे तो स्टार मार्क कर लेना. HMB45 मैलिग्नेंट मेलानोमा एंड डेस्मिन इज फॉर मसल ट्यूमर रैप्डोमायोसार्कोमा. तो इस क्वेश्चन का बेस्ट आंसर क्या हुआ? A3, B2, C4 एंड D, राइट? चलिए मूव टू द नेक्स्ट क्वेश्चन. ऑल ऑफ द फॉलोइंग आर करेक्ट अबाउट एम्फाइसीमा एक्सेप्ट मोस्ट कॉमन फैक्टर स्मोकिंग. यस. Alpha 1 antitrypsin deficiency cause pan-acinar. Yes. न्यूमोथोरेक्स इज मैक्सिमम एसोसिएटेड विद सेंट्री एसिनार। पागल है क्या? ये स्टडीड दिस, ये ग्रॉस क्वेश्चन, ये सेम क्वेश्चन अभी हमने पढ़े थे, सेंट्री एसिनार के साथ नहीं, इट इज एसोसिएटेड विद पैरासेप्टल एम्फाइसीमा। It is actually paraseptal emphysema. Small size involved in centrifugal? Absolutely. So here the best answer would be the pneumothorax is associated with paraseptal. ये हमने डिस्कस भी किया था सर, सेंट्री एसिनार के बारे में हमने पढ़ा था। सी से सारी बातें याद रखनी है। सी से ये सिगरेट पीने वालों में होती है सेंट्री एसिनार। सी से कमान बता दो मुझे, सी से ये सीलिंग में होती है। सीलिंग मतलब अपर लोब ऑफ द लंग्स में होती है। इट इन्वॉल्व्स अपर लोब ऑफ द लंग्स। सी से आपको और कुछ भी याद आ रहा होगा सर, कॉमन बता दो। इट इज द मोस्ट कॉमन एम्फाइसीमा। तो स्मोकर्स में सबसे कॉमन सेंट्री एसिनार, जो लंग्स के अपर लोब में हो, सेंट्री एसिनार। फिर अपन ने पी से पैरासेप्टल भी पढ़ा था, और मैंने यही आपको पी से याद करने को बोला था। पी फॉर कॉमन बता दो मुझे। पी से इट इज प्रेजेंट नियर द प्लूरा, एंड पी से इट इज एसोसिएटेड विद न्यूमोथोरेक्स। एसोसिएटेड विद न्यूमोथोरेक्स। तो इस क्वेश्चन का आंसर सेंट्री एसिनार नहीं, इट वुड बी पैरासेप्टल एम्फाइसीमा। वैसे अपने तीसरा एक और पढ़ा था, कमन पैन एसिनार एम्फाइसीमा। पैन एसिनार, मैंने कहा था पान खाना बुरी बात है, तो हम सब पान के एंटी होने चाहिए। पान है इसमें छिपा हुआ एंटी, तो एंटी ट्रिप्सिन डेफिशिएंसी से जो होता है दैट इज पैन एसिनार। और पान खा के अपन कहाँ थूकते हैं? नीचे, लोअर लोब पे। सबको सिंपली रूल याद है, मैंने सिखाया था। सिगरेट हम ऊपर देख के पीते हैं तो सिगरेट वाला लंग के अपर लोब को इन्वॉल्व करता है। पान खा के अपन नीचे थूकते हैं तो पान लंग्स के लोअर लोब को इन्वॉल्व करता है, राइट? So that is all about the emphysema. Move to the next question. All the following are correct about FAP syndrome except, हमने डिस्कस किया ये क्वेश्चन भी। नहीं सर, टर्कॉट सिंड्रोम मेनिंजियोमा कॉज नहीं करता। टर्कॉट, टरकाता, याद करके बोलो। टरकाता है तो लाइफ में कुछ नहीं करेगा। कल से जिम जाऊंगा, कल से पढ़ाई स्टार्ट करूंगा। टर्कॉट सिंड्रोम में मेड्यूलोब्लास्टोमा। अगर आपने ग्रॉस सेशन लिया था तो ये तो बहुत इजी क्वेश्चन हो गया। मेड्यूलोब्लास्टोमा इज द फर्स्ट इज द रॉन्ग स्टेटमेंट। टर्कॉट सिंड्रोम मेनिंजियोमा नहीं होता, मेड्यूलोब्लास्टोमा इज द मोस्ट कॉमन ट्यूमर। टर्कॉट सिंड्रोम क्लासिकल फैप 100 पॉलिप्स, यस। गार्डनर सिंड्रोम ऑस्टियोमास, एब्सोल्युटली करेक्ट। FAP is associated with APC gene mutation, absolutely correct statement. The first answer is a wrong statement. Move to the next question, sir. अरे, characteristic feature of hemolysis बता दो। hemolysis के पेशेंट में क्या क्या मिलता है? रेटिकुलोसाइटोपिनिया, पागल है क्या? रेटिकुलोसाइटोसिस होता है। इन hemolysis patient there is reticulocytosis, पीनिया नहीं होता, बढ़ता रेटिकुलोसाइट। हेप्टोग्लोबुलिन डिक्रीज, एब्सोल्युटली करेक्ट स्टेटमेंट। यही तो इस क्वेश्चन का आंसर हुआ। हिमोलिसिस जितनी ज्यादा होगी, हीमोग्लोबिन बाहर आएगा, हीमोग्लोबिन विल बाइंड टू हेप्टोग्लोबिन एंड हेप्टोग्लोबिन अमाउंट विल डिक्रीज। श्रंकन स्प्लीन, पागल है क्या? हिमोलिसिस हुई है तो भैया स्प्लीन का काम तो बढ़ा ना, स्प्लीन तो हिमोलिसिस कर रहा है, तो स्प्लीनोमेगेली होगी, श्रंकन स्प्लीन नहीं होता। तो हियर द बेस्ट आंसर विल बी डिक्रीज हेप्टोग्लोबिन। सो हिमोलिसिस में रिमेंबर रेटिकुलोसाइटोसिस बढ़ता है और स्प्लीन का साइज बढ़ता है, कम नहीं होता। स्प्लीन का साइज बढ़ेगा और रेटिकुलोसाइटोसिस विल बी आल्सो देयर। नेक्स्ट, फॉलोइंग ग्रैनुलोमास विद एसोसिएटेड ऑर्गेनिजम्स। हमने पढ़ा है क्वेश्चन, फटाफट। स्टेलेट ग्रैनुलोमा, कैट स्क्रैच डिसीज। स्टेलेट ग्रैनुलोमा, कैट स्क्रैच डिसीज। और ये ऐसे लड़कियां कहाँ मिलती है अपने को, जो हमारी बॉडी में कैट की तरह वाइल्ड कैट बन के स्क्रैच दे दे, बार में। बार्टोनेला हेंसले। डर्क्स ग्रैनुलोमा, प्लास्मोडियम फैल्सीपैरम। डोनट ग्रैनुलोमा, मैंने आपको बताया था, डोनट ग्रैनुलोमा क्यू फीवर। और लड़की बोले डोनट खिला दे तो उसको बोलना क्यों खिलाऊं। तो दैट इज क्यू फीवर कॉज्ड बाय कॉक्सेला ब्रुनेटी, एंड केशिएटिंग ग्रैनुलोमास इज हिस्टोप्लाज्मोसिस। So here the first answer, the best answer would be first B, second A, third is C, fourth is D. राइट, हमने पहले भी डिस्कस किया था। तो सिंपल क्वेश्चन, रिमेंबर दिस, वेरी वेरी इंपॉर्टेंट। इनमें से एक क्वेश्चन मत भूलना, सबसे इंपॉर्टेंट। एक तो नॉन केशिएटिंग, कोई मुझे बता दो जाते जाते नॉन केशिएटिंग ग्रैनुलोमास कहाँ मिलते हैं, प्लीज मत भूलना। ये बहुत बार क्वेश्चन आया। सार्कोइडोसिस में मिलते हैं, क्रॉन्स डिसीज में मिलते हैं, लेप्रेसी में मिलते हैं, और यस टीबी में भी मिल सकते हैं। टीबी में भी केशिएटिंग, टीबी पे इम्यूनिटी पे ऑल डिपेंड्स। इफ द इम्यूनिटी इज गुड यू विल हैव केशिएटिंग, अगर पेशेंट की इम्यूनिटी इज बैड यू विल हैव नॉन केशिएटिंग ग्रैनुलोमा। सिंपल क्वेश्चन। मूव टू द नेक्स्ट वन। अरेंज द फॉलोइंग, ये भी हमने पढ़ा सर। अरेंज द सीक्वेंस ऑफ मॉर्फोलॉजिकल चेंजेस ऑफ एमआई ऑन लाइट माइक्रोस्कोपी। एमआई के लाइट माइक्रोस्कोपी पे चेंजेस, हाँ पता है सर, हमें पता है सर। द आंसर इज पहले वेवीनेस, देन कोएगुलेटिव नेक्रोसिस, देन न्यूट्रोफिल्स, देन मैक्रोफेजेस। आई एम श्योर आपको अच्छे से याद आ रहा होगा। माइक्रोस्कोपिक चेंजेस ऑफ एमआई, हमने अच्छे से पढ़ा था। माइक्रोस्कोपिक चेंजेस की बात करें अगर अपन, तो देयर इज, याद करो निमोनिक, वी कैन, कमन कमन बता दो मुझे फटाफट, वी कैन नेवर मेस विद आर गर्लफ्रेंड, राइट। आई एम श्योर आपको सब याद आ रहा होगा। अरे पैथो पे तो टाइम वेस्ट करना ही नहीं, वेविनेस 2x करो, आगे बढ़ते चलो। कोएगुलेटिव नेक्रोसिस, नेवर से आपको याद आ रहा होगा न्यूट्रोफिल्स। M से then macrophages will come. Macrophages will be further replaced by granulation tissue. Finally, there will be fibrosis. Right? So very very important question. यहाँ पे time अगर ऐड करना हो, can anybody tell me MI के बारे में दो चीजें पूछना चाहूंगा। Whenever there is MI, how much time does it take to form a scar tissue? Yes, fibrosis होने में यानी scar tissue होने में कितना टाइम लगता है? Yes, it is more than 2 months. अगर दिल पे चोट लगे तो टेक्स मोर देन 2 months टू फॉर्म अ स्कार टिश्यू, वेरी वेरी इंपॉर्टेंट। एंड देन लास्ट और सबसे सबसे इंपॉर्टेंट क्वेश्चन, 2 महीने के बाद स्कार बनता है, बट उसने पूछा मायोकार्डियल इंजरी इरिवर्सिबल कब हो जाती है? कम बता दो, इरिवर्सिबल आफ्टर 20 to 40 minutes, on an average 30 minutes. Please remember, myocardial injury becomes irreversible after 20 to 40 minutes, on an average 30 minutes के बाद it becomes irreversible। तभी हम CPR कब तक देते हैं? For 30 minutes. Before 30 minutes it is reversible injury, after 30 minutes it becomes irreversible, right? Then next question, toluidine blue staining is used for identification of, stain देके क्वेश्चन बड़ा सा बना दिया, पर सिंपल पूछा toluidine blue is used for mast cells। मैंने कहा था FMGs अपन तब तक, जब तक अपना एग्जाम नहीं निकल जाता तब तक हम मस्ती तोल के करेंगे। प्लीज रिमेंबर, मस्ती, मास सेल अभी तोल के, मास एक बार निकल गया FMG फिर बेतौल होके पूरा लुटा देंगे बॉस। बट मास सेल्स इज फॉर टोल्यूडिन ब्लू। फटाफट, कोलेजन, कोलेजन मेसन, कमन आवाज नहीं आई, मेसन ट्राइकोम स्टेन। मेलानिन, मेसन फोंटाना स्टेन। You have Mason Fontana stain. Myelin sheath. Come on. Luxol blue. Very good, sir. Very good, sir. Luxol blue stain. Right? My Lux sabun. So myelin is for Luxol blue stain. Right? Done. चलिए नेक्स्ट पे चलते हैं। Which of the following is not an AIDS defining cancer? ये क्वेश्चन हमने सब पढ़े हैं, ये क्वेश्चन आपको पैथोलॉजी बहुत इजी लग रहा होगा। नॉट एन एड्स डिफाइनिंग कैंसर हमने पढ़ा था, मेलेनोमा। याद करके बोलो, एड्स डिफाइनिंग कैंसर हमने किस निमोनिक से पढ़े थे? KBC से। K फॉर कापोसी सार्कोमा, B फॉर बी सेल नॉन हॉजकिन लिम्फोमा, एंड C फॉर सर्विक्स कार्सिनोमा। C फॉर सर्विक्स कार्सिनोमा। प्लीज दिल मत तोड़ना, दिस आर द 3 कैंसर सीन इन एड्स पेशेंट, बट इन तीनों में से मोस्ट कॉमन पूछा गया तो बी सेल नॉन हॉजकिन लिम्फोमा। बी सेल नॉन हॉजकिन लिम्फोमा। फटाफट बता दो, कापोसी सार्कोमा का कॉस्टिव एजेंट ह्यूमन हर्पिस वायरस 8। बी सेल नॉन हॉजकिन लिम्फोमा का इट इज एप्स्टीन बार वायरस, एंड सर्विक्स कार्सिनोमा का ह्यूमन पैपिलोमा वायरस। वी हैव डिस्कस्ड दिस क्वेश्चन, आई होप इट बिकम्स इजी फॉर यू इन द एग्जाम्स आल्सो, राइट? व्हिच ऑफ द फॉलोइंग इज नॉट अ स्मॉल राउंड सेल ट्यूमर? Which of the following is not a small round cell tumor? See, question is blastoma. एक ही में blastoma नहीं है, only one there is no blastoma, so that would be the answer. ये mnemonic एग्जाम में मत बनाना। Ewing sarcoma is a small round cell tumor. The answer is hemangioblastoma. The answer is hemangioblastoma, sir. Small round blue cell tumor एक special category है where you have a small hyperchromatic cells, हाइपरक्रोमैटिक सेल्स, जहां पे सारे सेल्स अपने को स्मॉल, राउंड और डार्क ब्लू कलर के मिलेंगे। ऑल दिस ट्यूमर्स आर नाउ पुट इनटू अ सेपरेट कैटेगरी कॉल्ड एज SRBCT। और क्वेश्चन आता है एग्जांपल्स ऑफ SRBT, व्हाट आर द एग्जांपल्स ऑफ SRBT? सो याद रख लेना, स्मॉल राउंड ब्लू सेल ट्यूमर में रिमेंबर दिस सिंपल निमोनिक स्मॉल CM, ऑफ कोर्स CM इज अ स्मॉल पोस्ट, लार्ज तो PM पोस्ट होती है ना, तो सब CM छोटा होता है, PM बड़ा होता है। तो ऑल दीज आर एग्जांपल्स ऑफ स्मॉल राउंड सेल ट्यूमर। एवरीबॉडी, आपको याद आ रहा होगा स्मॉल सेल कार्सिनोमा, CM से आपको C से याद आ रहा होगा वेरी वेरी इंपॉर्टेंट कार्सिनोइड ट्यूमर। M से क्या याद आ रहा होगा? मेडुलरी कार्सिनोमा थायराइड। लार्ज से लार्ज सेल कार्सिनोमा ऑफ द लंग। P से फियोक्रोमोसाइटोमा, you have फियोक्रोमोसाइटोमा। M से मर्कल सेल कार्सिनोमा, मर्कल सेल कार्सिनोमा। सो वेरी वेरी इंपॉर्टेंट क्वेश्चंस। ऑल दिस ब्लास्टोमास, ऐसे याद रख लेना, सारे के सारे ब्लास्टोमास आर स्मॉल राउंड ब्लू सेल ट्यूमर एक्सेप्ट Hemangioblastoma. Hemangioblastoma is not a small round blue cell tumor. We have small CM and large PM. All these are small round blue cell tumor. इन सब में और कॉमन क्या है? All जितने भी ट्यूमर्स अभी हमने पढ़े, all these are neuroendocrine tumors. All these are neuroendocrine tumors. You call them small round cell tumors. You also call them neuro because they have neurosecretory bodies. You also call them neuroendocrine tumors. तो क्वेश्चन आया, all the following are neuroendocrine tumors, तो we use the same mnemonic. And I'm sure आपको पता होगा सारे के सारे neuroendocrine tumor, whether it is pheochromocytoma, whether it is small cell carcinoma, सबकी ISC क्या होती है? बता दो मुझे. Come on, yes, you got it. Synaptophysin और chromogranin. इन सब की कॉमन की बात करो, chromogranin. You have synaptophysin, and also you have CD56 and NSC. Please make sure you know this. चाहे वो स्मॉल सेल कार्सिनोमा हो, चाहे वो लार्ज सेल हो, चाहे वो फियोक्रोमोसाइटोमा हो, चाहे वो कार्सिनोइड ट्यूमर हो, all these carry the same ISC, right? Adrenal mass है with chromogranin positive, go with pheochromocytoma. Lung mass है with synaptophysin or chromogranin positive, go with small cell carcinoma. So remember, chromogranin, synaptophysin, very very important. All these are the IST for neuroendocrine tumor, CD56 and non-specific annullase. Right, done. Patient presents with tinnitus and hearing loss. The following is the histopathological examination of CP angle tumor. Hearing loss tinnitus हो रहा है. The patient has a CP angle mass. And then an image is given. और क्या छाती निकाल के रख दे बाहर? Everything is given. I'm sure all of you recognize this. This is which tumor? This is schwannoma. Patient has come to with deafness, hearing loss की complaint है, CP angle mass है, schwannoma. I'm sure आपको पता है, अब तो बता दो सर. तो diagnosis is schwannoma. हमें यहाँ कौन सी bodies दिख रही हैं? I am sure all of you must have appreciated that the bodies are Verruque bodies. Verruque bodies क्या होती हैं? They are the examples of true palisading. याद करो true palisading का मतलब क्या था? The cells एक के ऊपर एक without any serpentine necrosis. True palisading is seen in schwannomas. And what do you call these bodies? Verruque bodies. So guys, Verruque bodies are seen in schwannomas. Everybody फटाफट में बताता schwannoma के बारे में. जब भी मैं schwannoma को पढ़ता था, I always remember that schwannoma में S है, तो S से मुझे याद आएगा it is S100 positive. schwannoma में S100 पॉजिटिव आएगा और schwannoma में AN छिपा हुआ है सर, और AN से मुझे क्या याद आएगा? Antony A and Antony B areas are seen. तो schwannoma S is for S100 and AN is for Antony A and Antony B areas. And I'm sure you know CP angle is the most common site. It's also called as CP angle tumor. Right? Glioblastoma क्यों नहीं है ये? Glioblastoma में true palisading थोड़ी मिलती है. In glioblastoma, you have pseudo palisading, not the true palisading. Glioblastoma will have pseudo palisading. Meningioma क्यों नहीं है? अगर meningioma होता तो किसकी इमेज दे रखी होती? Psammoma bodies की इमेज दे रखी होती सर. It would have been meningioma, आपको Psammoma bodies की इमेज दे रखी होती. Pilocytic astrocytoma होता तो चाइल्ड होता और उसको CP एंगल नहीं, उसको फ्रंटल लोब में मास होता. और उसके अंदर वेरुके बॉडीज नहीं. कम ऑन, किसको याद है? पाइलोसिटिक एस्ट्रोसाइटोमा में कौन से स्पेशल फाइबर्स मिलते हैं? यस, यू गॉट इट राइट गाइस, हमें रोजेंथल फाइबर्स मिलते हैं. यू गेट टू सी रोजेंथल फाइबर्स. पाइलोसिटिक मैंने आपको बताया भी था, पाइलोसिटिक में पिल्लो है, और पिल्लो है, हम लड़की के साथ पिल्लो पे सोते हैं, ताकि पहले उसको पिल्लो पे सोने के लिए हमें उसको क्या देना पड़ता है? रोज. तो रोज एंड पिल्लो, इट्स अ रोमांटिक ट्यूमर. रोज पिल्लो, रोजेंथल फाइबर्स आर सीन इन पाइलोसिटिक एस्ट्रोसाइटोमा. Remember, this is about pilocytic astrocytoma. Right, done. Move to the next question. Patient with obstructive pulmonary disorder है. FeE1 ratio spirometry पे typical obstructive pulmonary disorder की हिस्ट्री दे रखी है, and they have examined cytologically. The finding is shown below. Which of the following is true about this tumor? बता दो मुझे सर, क्या appreciate हो रहा है आपको? सर मुझे सर बहुत अच्छे से रोड शेप्ड सर, इनफैक्ट नीडल शेप्ड रेड क्रिस्टल्स दिख रहे हैं सर. मुझे इओसिनोफिलिक रेड कलर, पिंक कलर के इओसिनोफिलिक नीडल शेप्ड क्रिस्टल्स मिल रहे हैं सर. एंड इओसिनोफिलिक नीडल शेप्ड क्रिस्टल्स, आई एम श्योर ऑल ऑफ यू रिमेंबर, दीस आर कॉल्ड एज चारकॉट लेडन क्रिस्टल्स. अब तो बता दो आंसर क्या होगा. विच ऑफ द फॉलोइंग इज ट्रू अबाउट दिस इमेज? कर्शमैन स्पाइरल पागल है क्या? क्रियोला बॉडीज पागल है क्या? चारकोल लेडन क्रिस्टल्स, और पूछा गया चारकोल लेडन क्रिस्टल्स मेड अप ऑफ गैलेक्टिन 10. It is made up of galactin 10. That is the true statement. Asthma, I'm sure इतना तो आपने पहचान लिया होगा. The patient has asthma, और asthma कौन सी hypersensitivity है? Type 3. पागल है क्या? Asthma is a type 1 hypersensitivity reaction. So out of this galactin 10 is a component. किसको याद है? When we studied asthma हमने 3 C याद रखे थे, 3 C. पहला तो चारकोलेडन क्रिस्टल्स, आपको याद हो चारकोलेडन क्रिस्टल्स किससे बनी होती हैं? गैलेक्टिन 10 से. इओसिनोफिलिक मेम्ब्रेन प्रोटीन विच इज गैलेक्टिन 10. फिर हमने एक और सी पढ़ा था, दूसरे सी हमने क्या पढ़े थे? कर्शमैन स्पाइरल. कर्शमैन स्पाइरल किससे बने होते हैं बॉस? कमन कमन, कर्शमैन में एम है तो म्यूकस प्लग्स. एम फॉर एम, म्यूकस प्लग. तो अगर जो म्यूकस के प्लग्स होते हैं देयर फ्रॉम कर्शमैन स्पाइरल. क्रियोला बॉडीज में आर ई है. आई होप ऑल ऑफ यू रिमेंबर, क्रियोला में आर ई है, और आर ई का मतलब दे आर नथिंग बट रेस्पिरेटरी एपिथेलियल सेल्स. They are respiratory epithelial cells. So remember, Kirschman में M is for mucus plug, Criolla में RE stands for they are nothing but shed of respiratory epithelial cells, और चारकोट लेडन क्रिस्टल्स made up of गैलेक्टिन 10. मैंने आपको पढ़ाया भी था, चार गल्ला करिए प्यार दिया, चार गल्ला, चार कोटलेडन गल्ला, गैलेक्टिन 10, चार गल्ला करिए प्यार दिया. So that is for asthma, and asthma is not type 1, it is type 1, not type 3, it is type 1 hypersensitivity reaction. Next question, asbestosis of the lung. एक क्वेश्चन तो हमको पता है, एक या दो तीन भी आ सकते हैं फ्रॉम ऑक्यूपेशनल लंग डिसऑर्डर और न्यूमोकोनियासिस. asbestosis of lung is associated with all of the following except पूछा my dears, which of the following is not true about asbestosis? Ferruginous bodies are seen, absolutely correct. Progression of lesion even after stopping exposure to asbestosis, absolutely correct. Even though you stop asbestosis factory, एक बार lesion develop हो गया, the disease can still progress. So this is a correct statement. Even though you stop after you develop lesions in the pleura, you stop going to that factory, the progression of the disease will still continue. That is correct statement. Nodular lesions involving upper lobe, asbestosis, upper lobe, पागल है क्या? सर आपने हमें बहुत अच्छे से पढ़ाया था, asbestosis involves lower lobe. एक्सेप्ट पूछा है ना सर, इजी क्वेश्चन. एक्सेप्ट ध्यान से, नोडुलर लीजन्स, यस, देयर इज नो अपर लोब, यू हैव लोअर लोब इन्वॉल्वमेंट इन एस्बेस्टोसिस. एंड एडिनोकार्सिनोमा इज द मोस्ट कॉमन कैंसर. यस सर, मोस्ट कॉमन इज एडिनो, बट मोस्ट स्पेसिफिक इज, कम ऑन, स्पेसिफिक इज हम सबको पता है, मीजोथेलियोमा. प्लीज रिमेंबर, सिलिकोसिस एंड कोल इन्वॉल्व्स अपर लोब, एस्बेस्टोसिस इन्वॉल्व्स लोअर लोब. राइट, दैट. मूव टू द नेक्स्ट क्वेश्चन. Adult female is diagnosed with gastric tumor as sub. Gastric tumor on biopsy shows cells which are CD117 positive. Gastric tumor CD117 positive. अब भी पढ़ना है क्या आगे? सर बता दो सर. Yes, the answer is GIST. The answer is GIST. मैंने आपको GIST के बारे में पढ़ने को बोला था, और GIST से GIST याद रखना. याद करो, G से तुम्हें क्या याद आएगा? It arises from gastric mucosa. तो रिमेंबर, जिसकी मोस्ट कॉमन साइट इज गैस्ट्रिक म्यूकोसा यानी स्टमक. फिर आपको आई से याद आ रहा होगा, विच सेल्स ट्यूमर? इट इज ट्यूमर ऑफ इंटरस्टिशियल सेल्स ऑफ कहल. इट इज इंटरस्टिशियल सेल्स ऑफ कहल. एस से आपको याद रखा होगा, एसडीएच जीन म्यूटेशन होती है इसमें. और टी से आपको ये भी याद आ रखा होगा, ट्राइड. जिस इज अ पार्ट ऑफ ट्राइड. अरे कौन सा ट्राइड, ये भी तो बता दो मुझे. इट्स अ पार्ट ऑफ कार्नीस ट्राइड. कार्निस के निमोनिक बता दो मुझे. कार्निस में कार है, कार, और कार में क्या लगा चाहिए, होना चाहिए? जीपीएस. आपको याद आ रहा होगा, जिस्ट. कार्निस के पेशेंट को जिस्ट होता है. पी सेकंड नंबर पे, इसलिए दो चीजें, पैरागैंग्लियोमा और पल्मोनरी एनकोंड्रोमा. और ऐसे आपको याद आ रहा होगा, देयर इज नो जेनेटिक इन्वॉल्वमेंट, इट इज अ स्पोरेडिक डिसऑर्डर. सो कार्निस हैव गॉट जीपीएस, जिस्ट, paragangliomas. Fixed question है, all of the following are a component of GIST except. So remember, GIST, paragangliomas and pulmonary enchondromas are a feature of Carney's triad, जो हम GIST की यहाँ बात कर रहे थे. तो GIST के बारे में इतनी बातें की हैं, तो एक बार ये भी बता दो, मोस्ट कॉमन जीन आया तो प्लीज रिमेंबर, इट इज सीकिट. एसडीएच सेकेंड मोस्ट कॉमन है, मोस्ट कॉमन इज सीकिट, और हम सबको पता है सीकिट इज ऑल्सो कॉल्ड एज CD117. तो आईएससी और जीन दोनों सीकिट इज CD117. सर यही अगर उसने गैस्ट्रिक ट्यूमर की जगह सेम चीज लिखी होती, CD117 पॉजिटिव लिखा होता, बट गैस्ट्रिक की जगह अगर उसने, इफ यू वुड हैव रिटन टेस्टिकुलर ट्यूमर, इंस्टेड ऑफ गैस्ट्रिक इफ इट वुड हैव बीन रिटन टेस्टिकुलर ट्यूमर, तो आपका आंसर क्या होता? सेमिनोमा। प्लीज ध्यान से एग्जाम में पढ़ना। Seminomas are CD117 positive and GIST also is CD117 positive. Both are CD117 positive. Gastric है तो go with GIST, testis है तो go with seminomas. इसीलिए उसने पूछा एग्जाम में, सर CD117 तो पॉजिटिव नहीं है, तो स्पेसिफिक नहीं है, तो CD117 इज नॉट स्पेसिफिक फॉर GIST, तो उसने GIST का मोस्ट स्पेसिफिक पूछा, तो आपका आंसर क्या होगा? आई एम श्योर मुझे आपको भाऊ भाऊ याद आ रहा होगा, भाऊ 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 भाऊ, यस सर, इट इज DOJ1, detector of GIST, DOJ1, put a star mark sir. GIST का most specific tumor is, most specific ISA is DOJ1, right? Move to the next question. अरे यार कितनी बार ये क्वेश्चन पढ़ा हूँ सर। ब्रेस्ट लंप है, नोजिया है और ये इमेज दे रखी है, मैं नहीं पढ़ा रहा सर बार बार ये क्वेश्चन, मुझे अच्छे से दिख गए सर, मुझे अच्छे से कौन सी रिंग दिख गई सर? मेरे को पता है सर, ये क्वेश्चन मैंने पहले भी देखा है सर। दिस इज सिग्नेट रिंग्स, दिल मत तोड़ना सर। सिग्नेट रिंग अगर ब्रेस्ट में दिखे तो क्या होगा, अगर स्टमक में दिखे तो क्या होगा डायग्नोसिस, और अगर आपको दिखे कहाँ पे, ओवरी में, तो क्या होगा डायग्नोसिस? फटाफट। ब्रेस्ट में आई एम श्योर ऑल ऑफ यू रिमेंबर इट इज लोब्यूलर कार्सिनोमा। सिग्नेट रिंग सेज ऑन ब्रेस्ट लोब्यूलर कार्सिनोमा। स्टमक में अगर सिग्नेट रिंग दिख रही हैं, इट इज डिफ्यूज गैस्ट्रिक कार्सिनोमा। द आंसर वुड बी डिफ्यूज गैस्ट्रिक कार्सिनोमा। एंड ओवरीज में I am sure all of you remember it is Krukenberg tumor. So please signet ring देखते बावड़े मत हो जाना। Signet ring cells on breast, lobular carcinoma, on stomach, diffuse gastric carcinoma, and on the ovary it has to be Krukenberg tumor. पूछा गया the following is incorrect. Incorrect. Multifocal bilateral बिल्कुल सर, discoaxial बिल्कुल सर, Indian file pattern बिल्कुल सर, and remember ये क्वेश्चन में पहले भी देखा था, there is no over expression of E-cadherin, there is down regulation of E-cadherin. My intent is totally clear boss, just giving you new questions won't help you. My focus is कि आप उन क्वेश्चंस पे सबसे ज्यादा फोकस करो जिनके टॉपिक्स रिपीट होते रहते हैं, so there is no point bringing time all the new questions. Important is जो important topics, not the question, the topic we should keep on revising जो important है, right? चलिए, done for this session guys. Thank you very much from my side. Thank you for having me. God bless you guys. Keep studying well. अभी बहुत टाइम, अभी तो हम बहुत बार मिलेंगे सर. Keep studying well guys. God bless you. Take care.
Okay, so hello and welcome everyone to this anatomy discussion. I am Dr. Ankit, your faculty of anatomy at Next. Let's start the first MCQ. The question says, which of the following is not a derivative of the dorsal mesentery? Options over here are greater and lesser momentum, linorenal ligament, gastrophrenic ligament. Here the question is about the basic embryology and also about the gross anatomy, adult gross anatomy. See, what happens is, if you consider this as a part of the gut, okay, initially we have what? We have a ventral mesentery and we also have a dorsal mesentery, okay. If we label it like the ventral mesentery and a dorsal mesentery. Now see, what happens is that the gut over here, particularly the foregut, it rotates 90 degree to the right side, So what happens is that the ventral mesentery over here, will go where? Suppose this is the ventral mesentery, it will go to the right side and the dorsal will come to the left side. So remember, the ventral will go to the right side and the dorsal mesentery derivatives will go to the left side of what? Of the gut. So now if you look at the adult gross anatomy, suppose this is the stomach over here and that is the duodenum, that is the esophagus, then whatever is onto the right side of the stomach is all derivative of the ventral mesentery, and whatever is to the left side of the stomach, everything will be derivatives of the dorsal mesentery. So this is all ventral, this is all dorsal. So now what is on the right side of the stomach? On the right side of the stomach, if we say of the ventral mesentery, we all know we start with what? We start with the lesser omentum. Then that goes to the liver. So you have all the peritoneal coverings of liver. Then from liver goes to the ventral body wall. We have the falciform ligament. All these are ventral mesentery. The dorsal mesentery, on the other hand, the biggest over here is the greater omentum, right? That policeman of the abdomen hanging down. Then from stomach to spleen, we have the gastrosplenic ligament. From spleen to kidney, we have the splenorenal or the linorenal. From stomach to diaphragm, we have the gastrophrenic ligament. So all these are derivatives of dorsal mesentery. Now the question, come to the question. Now this was the topic. This is the concept of the topic. Question is, which is not a derivative of dorsal mesentery? Here the greater omentum, it is a derivative. Yes, it is a derivative. Lesser omentum is a derivative of ventral. Therefore, lesser omentum should be the answer. Let us see the other options. Linorenal, gastrophrenic, all are derivatives of dorsal mesentery. Therefore, answer over here is option number B. Okay, let's see some images as well. Here is an image showing us aorta over here. So it is lying posteriorly and that is anteriorly. Now, this is ST for the stomach. Okay. This is L for the liver, right? This is SP for the spleen, right? So if a question comes like this in an image-based question, they ask you what is number 1 over here is from liver to the entry abdominal wall, the falciform ligament, right? Think about it. Number 2, from stomach to liver, it is lesser omentum. From stomach to spleen, number 3 will be the gastrosplenic ligament. And going behind the spleen towards the kidney and the posterior part, this would be number 4 would be the linorenal or the splenorenal. They are the same thing. Okay. That's another image. The same thing what we saw on the adult part. The stomach over here, it's the main stomach. There's always written lesser omentum and that is a greater omentum, the gastrosplenic, gastrophrenic. So now we all know that this is dorsal mesentery derivative. And this over here will be the ventral mesentery derivative. Right. So concepts should be clear. Answers will come automatically. The next question, which of the following muscles of larynx is known to be the tensor of the vocal cord? Now see, larynx, we all know in larynx, inside the larynx, we have this structure that is known as the vocal cord or vocal ligament, right? It is running from where to where? It is from posterior to anterior. Behind what we have, it is attached behind to the arytenoid cartilage, right? And anteriorly it attaches to the posterior aspect of the thyroid cartilage. Now whenever we are speaking, right now I'm speaking, there's a vibration of the vocal cord. So the muscles which move the larynx are known as the muscles of larynx, and there are muscles which are inside the larynx. They will be known as the intrinsic muscles of larynx. Intrinsic larynx muscles. Now they will be doing a lot of functions. They will be closing the laryngeal inlet. They will be modulating the vocal cord, increasing its frequency, decreasing its frequency. Here the question is, which is a tensor? Now suppose the vocal cord, both the vocal cords are arranged like this. Now if you want to relax it, then the vocal cord will be like this, they will be relaxed. If you want to tense it, obviously they will be stretched. Now increasing the tension, here if we increase the tension, the frequency will increase or decrease? There will be increase in the frequency. Increase in the frequency, the voice more of a female voice. Decrease in frequency, here if we decrease the tension, the more of the voice on the decreasing tension, decreasing the frequency, more of a male voice, more of a female voice. Understand this. So what muscle is there which will actually pull the arytenoid and the thyroid cartilage apart? In between the vocal cord, they are more stretched. Remember the trick over here, I'll show you the images. Always remember that CT is the tensor. What is the tensor? CT. CT is the tensor of the vocal cord. What is CT? CT over here refers to the muscle known as cricothyroid.
cricothyroid are known as tensor. With the image only we can understand why it is a tensor. We'll see it. So in the meanwhile, we all know that okay, cricothyroid over here is the answer. But understand over here the other options. Questions normally come from PCA, the posterior cricoarytenoid. PCA, remember, it is the only abductor of vocal cord. It abducts the vocal cord. So more air can come in and out, right? It is the only abductor, very important part. Though the answer over here is option number D. Cricothyroid is a tensor. Now let us see with the help of images how it happens. This over here, what we are looking is the anterior view of the larynx. Anterior view, like this. If you remove the skin and fascia and the strap muscles from here, this is what you see. If you remove the thyroid gland as well. This is the thyroid cartilage, below cricoid, above you have this as the hyoid bone. Remember, hyoid bone, it is not a part of larynx. That was also a previously asked question. Hyoid bone is not a part of larynx. Thyroid cartilage, cricoid cartilage, arytenoid cartilage lying posteriorly, they are a part of the larynx. Epiglottis, it is a part of larynx, the one that closes the laryngeal slit. So this over here is the anterior view. We just started understanding it. Now in the next image, this over here is the posterior view. Now understand the thyroid cartilage which we saw in the previous image, it appears like a V shape, but that is opened from behind. The cricoid cartilage, C for cricoid, C is for the complete ring. It is a complete ring. Okay, so cricoid cartilage will be complete ring, but thyroid cartilage is opened from behind. It is opened from behind. Understand this part. The thyroid cartilage, it is opened from behind. Cricoid cartilage is a complete ring. Now let's see the posterior image once again. Here what you see, this is the thyroid cartilage. You can see it is open from behind. And here you see the cricoid cartilage is coming from behind as well. Over the cricoid cartilage, posteriorly is seated the arytenoid cartilage. So arytenoid is seated over the cricoid cartilage. Now what happens is that from the arytenoid cartilage over here, I am putting some arrows. The vocal cord, the vocal ligaments go from arytenoid posteriorly to the thyroid anteriorly. Okay, so this is the position of the vocal cord. Now see what happens is, if there is a muscle over here, if you contract this muscle, if the muscle over here is contracted, okay, then what will happen is that there will be a more distancing between the thyroid and the cricoid cartilage. So what happens is the arytenoid does not move. Okay, it is the cricoid and thyroid, they are moving apart. And once they move apart, there is more tensing of this vocal cord. There is a tensing of the vocal cord. And the muscle over here which we are referring to, that muscle is the cricothyroid muscle. Now, so where is the muscle? Let us see next image. Here is a superior view of literally all the important muscles of the larynx. So what you see over here, you can identify the structures. See what is happening over here. This, understand the image first of all. This is the posterior part. Why is the posterior part? Here you can see the lamina of cricoid cartilage. You can see this V-shaped structure going on like this. So that is the anterior part. Okay, and this is the vocal process of arytenoid cartilage. So this is all arytenoid cartilage. So where will be the vocal cords? If I put some arrows over here, these would be the location of the vocal cords. Okay, the muscle over here, this is the cricothyroid muscle, which is the main focus muscle over here. The moment it contracts, it separates away the cricoid from thyroid. And the moment the cricoid thyroid they separate, there is more tensing of the vocal cord. Now the converse may also be asked, though not frequently asked. So what relaxes the vocal cord? Here we are saying, okay, CT is the tensor. What relaxes the vocal cord? See, the muscles which are lying right over the vocal cord, these muscles, if you contract them, then arytenoid and the thyroid will come closer. Moment they come closer, suppose this span over here is a vocal cord, arytenoid and the thyroid, fine. Now the cricothyroid is tensing it, and the muscle which is directly located over the vocal cord, if you contract that muscle, then there will be relaxation of the vocal cord or laxity of the vocal cord. Which muscle causes it? The muscle that causes it is basically our thyroarytenoid muscle lying over here. So this muscle increases the laxity of the vocal cord. Apart from cricothyroid and the thyroarachnoid, don't ever forget the posterior cricoarachnoid, most frequently asked. What I said, I'm repeating it again. It is the main abductor of vocal cord. All of them are supplied by which nerve? Let us do an extra bit over here. All of them are supplied by which nerve? So understand, all the muscles of the larynx, they are basically supplied by the 10th or the vagus nerve. Which branch of vagus? The recurrent laryngeal nerve. Question. All the branches, there is one exception. Which exception is there? The main exception over here is the muscle. That was the answer over here. Which muscle? Exception is the cricothyroid muscle. Is it not supplied by vagus? It is supplied by vagus, but not this branch. Then the external laryngeal branch of superior laryngeal nerve. Again, it's a branch of vagus only, but the branch of vagus is different, of superior laryngeal nerve. Remember, this is also frequently asked question. Let's see the next one. In a fetal heart, the blood flows from the right atrium to the left atrium. We all know it passes through the foramen ovale in fetal heart only. What would form the floor of this structure after it closes post-delivery? After delivery, there is closure of the foramen ovale. They are asking, fine, it closes, that is a good thing. If it doesn't close, there is a ASD, there is a atrial septal defect. But normally it closes. So when it closes, then what structure will form the floor of this foramen ovale? Basically, it's a question from embryology. Okay. So for that we need to understand the basic embryology of the formation of the interatrial septum. Let us see, then we'll come to the answer over here. So here is an image. This is a developing heart, right? What we can see over here, this portion is the right atrium, that portion is the left atrium, this would be the RV and the left V, that is the ventricle. Focus mainly between the right and left atriums. If we focus over here, and what happens is that this structure over here, which is coming from above, is the septum primum. It actually fuses with the endocardial cushions over here. But then, before it fuses with the endocardial cushion, it leaves a gap over here. That is the gap which is known as what? That is known as the foramen primum, then becomes foramen secundum. Fine. But that gap, actually it can't be open like this. So it is covered on its right hand side by the septum secundum. So we have a septum primum, we have a septum secundum. Where does the blood flow? That also we should know. The blood is actually coming to right atrium, then it passes from here, then it reaches the left atrium. Now they are asking, fine, we are not asking about the fetal circulation. But post-delivery, when it closes, how it closes? Actually, this will merge onto it. So it closes. Then they ask me what forms the floor of this structure. So now understand, the floor of this structure is basically this area. This area will form the floor if you view it from the right hand side. What is the structure? It is basically septum primum. So therefore, the answer over here is going to be our septum primum. It's not going to be tricuspid valve, nor the endocardial cushion, nor the tricuspid valve orifice. They've given 2 times, but no need. Answer is option number A only. Let us look at an adult heart. How does it look like? Now, what we are witnessing over here is we are looking at inside of the right atrium in an adult heart. How does it appear? You're looking at a smooth wall of the right atrium. These are the rough or the muscular part of the right atrium. This is the smooth part of the right atrium. You can see the wall is very smooth. Another question, let me remind you, what forms this smooth part of the right atrium embryologically? Answer for that is always going to be the sinus venosus, also known as sinus venerum. Remember this question as well, sinus venosus or sinus venerum. Now coming to the part, the question over here, where is the floor of that foramen ovale? This over here, this oval shaped structure, that is basically what they are asking. This is the septum primum embryologically, that forms the floor of this structure, right? Other structures are also there, like this will be the opening of the coronary sinus, there will be the IVC over here, the SVC comes from above and all that. But this over here is the floor. Okay, so here is your answer for this question, that is the septum primum. Let's see the next one over here now. A 6-year-old child was playing with a little toy automobile. Soon thereafter, he placed the car's wheels in his mouth and started choking and coughing. Where within the tracheobronchial tree does a foreign object most frequently becomes lost? This is actually the question. Be it a 6-year-old or a 60-year-old, where within the tracheobronchial tree does a foreign object most frequently becomes lodged? So you have two routes to go. See, you have a road over here, and that road bifurcates into two roads. Okay, now they are saying, okay, you have a foreign object which came from here. Where probably will it go? Will it stuck over here, or will it go to this road or that road? That is the question. Now this is a normal road. Now understand, if there is a road over here, right, and there are two, and you are riding a four-wheeler. Just imagine you have bifurcation over here. One bifurcation is going like this, okay, and one bifurcation is going like this. Now suppose you are running on a highway. Just imagine you are driving a beautiful four-wheeler. Where would you normally take turn? Will you go to the left side? That is, will you go to this side, left, or the right side? Most of you, with applying common sense, will go to right side, because that appears like a continuation, that appears. Same thing happens over here in our body. We have this huge trachea, then we have the right bronchus, which is more aligned and a bit broader than the left bronchus. So the foreign object, once it goes down, once we aspirate it, unluckily, that normally goes to the right main bronchus. Normally goes to the right main bronchus. Therefore, answer over here is going to be our option number 4, the right primary. Primary is the right main bronchus. Okay, the beginning of the trachea. Now, beginning of the trachea obviously can't stuck over here, not the carina, not the left. The answer over here is going to be the right primary bronchus. Let us see an image over here as well. Here, all the bronchopulmonary segments are shown. Just go through it. Just remember, you have 10 bronchopulmonary segments on the right side, and you have 10 bronchopulmonary segments on the left side. The foreign object will normally come down, and most often it will move to the right side. Then depends on the patient is lying down or sitting or standing or walking, in which bronchopulmonary segment that might go, or in which secondary bronchus it might go. But normally it enters into the right main bronchus. That is a basic, and that should be very much clear. Also, why right bronchus is more wider? That should be a question. Because the right lung is a bit heavier than the left lung. Why so? Because on the left side we have the heart. On the left side, the organ over here, we also have a heart over here, which is actually covered by mainly the left side. So the left lung volume-wise is smaller than the right lung. When the right lung is bigger, it needs more air. How it can have more air? Because the pipe, the main bronchus, should be bit more wider than the left one. That is also one logical explanation, right? Fine. Now let's see the next one. Which of the following is true about D. curvens tenosynovitis, a very common condition? What is this? Here, D. curvens is the name of the scientist. Tenosynovitis. Teno means tendon, right? Sino means a synovial sheath covering the tendon. Itis, we all know, is the inflammation, right? So there is inflammation of the synovial sheath of the tendons. Of which finger or which tendon? It's basically the tendons of the thumb. Going to be mainly the pollicis side, right? So which pollicis? The most laterally found, the tendons of the first compartment of the extensor. Here what we have, abductor pollicis longus, extensor pollicis brevis. These two tendons are commonly affected over here. How is the patient going to represent? Pain while moving the thumb, pain while extending the thumb. On the lateral side, this is how the patient is going to present over here. Most oftenly, it is treated conservatively, right? So if you look at the options, index finger is most commonly no. Fingers are held in mixed mid-extension, no. Yes, option number C will be the answer. So answer over here is option number C. It affects APL and EPB. APL and EPB are abductor pollicis longus, extensor pollicis brevis. They are the tendons in the first compartment of the extensor of forearm. That also is a knowledge you should know. Treatment of choice surgery, no. Treatment of choice is simple conservative management. If at all there are many months have passed, still there is a pain, then the surgery is the last option over here, where we open it up, we open the tendon synovial sheath, so that the synovial sheath is opened up from the tendon, and there's no more, there's a stretching of the synovial sheath. Here we can look at a image also over here. So here if you look, then this is the abductor pollicis longus and extensor pollicis brevis. These are the ones which are involved in a D. curvens tenosynovitis, remember. The other tendon that is going to the thumb is the extensor pollicis longus. And between these two tendons, that is the extensor pollicis longus and extensor pollicis longus, and these two tendons, the structure over here, if I just highlight it, this is the anatomical snuff box. This over here is the anatomical snuff box. That is also one thing that you should remember, whose main content is going to be the radial artery. Okay, therefore answer is option number A over here. Again, the hand over here, look at these two tendons again. These were what they were involved in the decorn synosynovitis. Normally, the test also done is known as a Finkelstein test. That also you can remember. It's a provocative test. Okay. The next question, all are important structures present behind the marked structure except. So, what is the marked structure over here? The H-shaped suture. A very famous suture bounded by which bones? The frontal, the parietal, the temporal, and the sphenoid bone. That is known as the pterion. It's the H-shaped suture. You can see this form like goes like this, H-shaped suture. Why it is very much famous? Because a damage onto this side will lead to or can lead to epidural hemorrhage because of rupture of the anterior division of middle meningeal artery. The artery is located where? Outside the pterion, that is superficial pterion, or deep to it. This artery is located deep to pterion. So it is located on the inner side of the pterion. That's a very important structure over here. So now they are asking you which is not present in the marked structure. Anterior division, yes, it is present. Anterior cerebral artery, remember, if you go to the neuro part, the vascular supply of the central nervous system, that is the brain, we will realize that this artery is a branch of internal carotid artery, and then it runs medially. It runs right over the medial. Medially means between the two cerebral hemispheres. It runs medially over the corpus callosum. So that is very, very much medial, anterior cerebral artery. Therefore, this artery is the main artery which supplies the medial surface of the brain. Medial surface of the brain, the main artery over there is the anterior cerebral artery. So it is lying very, very medially. Obviously, can't be deep to pterion. This would be the answer. Looking at other options, middle cerebral artery. This artery runs laterally, so it again comes close to the pterion. Because the main artery supplying the lateral surface of the brain is middle cerebral artery. And finally, sylvian fissure. If you look at the brain over here, if I make the brain lateral surface, right, this over here is the sylvian fissure, also known as the lateral sulcus. Again, that is lying laterally. And from here only, you have the middle cerebral artery branches that come off from here. So they are both lying laterally. Sylvian fissure is the fissure, the lateral sulcus, that separates the frontal lobe above from the temporal lobe below. Okay, so remember, this might also be present. Therefore, the answer over here is obviously option number B. Let's see the next one. A 1-month-old infant was kept under observation in the neonatal ICU. On examination, it was found that he has congenital hypoparathyroid, so decreased parathyroid, okay. Hypoplasia of thyroid, decreased thyroid, and absent thymus. So thyroid and thymus both are decreased, okay. Which of the following pharyngeal pouches? Question is coming from the topic branchial arches, embryology of head and neck. So which of the following pharyngeal pouches will most likely result in these abnormalities if they develop abnormally? Here we should know the derivatives of the pharyngeal pouch, is simple as that. Okay, and parathyroid, thymus, thyroid, they are coming from which pharyngeal pouches? Remember, in our lectures, we have learned that there is a first pouch, there is second pouch, there is third pouch, there is fourth pouch. There are 4 pouches. Why? Because there are 5 arches. Now, if we recall the derivatives, the first pouch gives rise to mainly the middle ear and the eustachian tube. The second pouch mainly gives rise to the palatine tonsil. Third pouch, if you remember, we used to remember it by THIRD, third, right? And what is this THIRD? TH refers to the thymus, and I is the inferior parathyroid gland. The fourth pouch over here, it gives rise to what? Superior parathyroid gland. And anything else? Yes, it also gives rise to your ultimobranchial body, which will give rise to the C cells of thyroid. Now, this basic idea should be at the tip of your tongue. So now if you look at the question, what is missing over here is the parathyroid, the thyroid, and the thymus. So parathyroid, thymus, all of this referring to pouch number 3 and 4 only. Answer has to be third and fourth, and here it is, third and fourth pouches. See, simple knowledge will lead to the exact answer without a bit of confusion. If you look at the image of a coronal section over here, look at this image, you will realize this is third pouch, that is fourth pouch. What are they giving rise to? Inferior parathyroid, thymus, superior parathyroid, ultimobranchial body, and this was our question. and third and fourth is our answer. First pouch gave rise to what? Middle ear and eustachian tube. Second pouch gave rise to palatine tonsil. Okay, basics. Okay, let's see the next one. After a car accident, a 26-year-old lady is rushed to the hospital with significant head injuries. Her uvula is deviated to the left. Okay, so normally if you do oral examination, the uvula comes out like this. Okay, imagine the right and left side, but here they are saying uvula is deviated to the left side. So you can say the uvula is deviated to the left side as determined by a neurological examination. Which nerve is probably impacted to cause this deviation? Okay, so left and right, uvula is deviated to the left side. So uvula going where? To the left side. So basically uvula is being pulled to the left side. What is uvula and how it can be pulled? Is there a muscle and which part of the body it is? Uvula structure is basically hanging down from the soft palate. Okay, the muscle in the uvula is known as musculus uvuli. Musculus uvuli. The nerve that supplies all the muscles of soft palate are basically coming from the pharyngeal plexus. Major, we can say 10th nerve. So all the muscles of soft palate are supplied by the 10th nerve. Yes, but there's always an exception. So there's one small exception here also. What is that exception? That one muscle not supplied by the 10th in the palate is the tensor palatinum. So which nerve supplies it? It is the V3, that is the mandibular nerve supplies the tensor palatinum. Fine. So now uvula is being pulled to the left side. It means that here the muscles are working fine, plus. But see, body is all about balance. Uvula is right in the midline. It means that the muscles on the right side are not working. Therefore, the right vagus nerve or the muscles of the right side are not working. So they are saying which nerve is probably impacted. It has to be the right pharyngeal plexus or the right vagus. Here it is. Now looking at other options, light glossopharyngeal. Glossopharyngeal is also part of pharyngeal plexus, but it is mainly sensory. Hypoglossal is basically supplying the tongue region, not the uvula or the soft palate. Okay, so ruling out A, B and D, you come to the direct answer, option number C. A simple examination. You ask the patient to open the mouth, protrude your tongue, and then just say ah over here so you can visualize the uvula with a torchlight. You will see definitely. Okay, so next question says 52-year-old is taken to the emergency with a severe pain in the jaw. The temporomandibular joint is acutely inflamed as a result of arthritis seen in MRI. So MRI was done and the TMJ was found to be inflamed. Okay. Which muscle listed below is likely to be impacted by this joint's inflammatory process? See, there is a pain in the jaw and the joint is inflamed. They are asking which muscle. So is there any muscle out of these four which is directly related to inside the joint? And the answer is a big yes. The muscle over here is the lateral pterygoid, and how it is related to inside the joint, its derivative is said to be the articular disc which lies inside the TMJ. So if the TMJ is inflamed, the articular disc will be obviously be involved. And the muscle that is reaching the articular disc is the lateral pterygoid. So obviously the lateral pterygoid, option number A, will be the answer over here. Let us see that with the help of an image as well. Okay, so here you have the lateral pterygoids, upper and the lower head of lateral pterygoid, and here you see the articular disc. This area is the TMJ over here. This area is the TMJ. Hence, option number A is the answer over here. Okay, so coming to the next question now. A 32-year-old patient is taken to the emergency for visual difficulties. So 32-year-old and visual difficulties. A radio examination reveals that the anterior pituitary gland harbors a tumor. Okay, so there is a visual difficulty, problem in vision. And what is the involvement over here? The pituitary gland has some tumor. Okay, mainly pituitary adenoma. Most commonly tumor are there are adenoma. Both eyes have lost the lateral portion of the visual field. See, when we see any structure in the outside environment, there is lateral vision to the sides and there is medial vision or the central vision to the center. There is loss of the lateral vision. It means what? Light travels in a straight line. So when the lateral vision is lost, understand this part. Suppose this is I'm making inside of the eye over here. Okay, so these are both the eyes over here, the right eye and the left eye. When the lateral vision is lost, I'm highlighting that area. Suppose lateral vision over here, the lateral vision over here are lost. What does it mean? It means that the light which was coming from here would be touching this medial part of the retina on both the eyes, right? So therefore, this part of the retina is involved, medial half or nasal half, medial half or nasal half of retina is involved. Now the optic nerve fibers coming from this medial part of the nasal half of the retina, the optic fibers which are coming from here, they basically cross where at the optic chiasm. So what's the thing over here is, if this is the optic chiasm over here, what is sitting below the optic chiasm is the pituitary gland. Pituitary gland is sitting right below the optic chiasm. So if there is a tumor in the pituitary gland, it can involve this part of the optic chiasm, leading to damage or compression to this fibers coming from the nasal or the medial half of retina. Therefore, the lateral vision is lost. Understand this part. Now, what they are saying is, which among the following was probably affected by compression of the tumor? We have seen it has to be optic chiasm because the nasal half of retinal fibers, both the eyes, they cross over here. So it has to be what? Optic chiasm. Now, if we look at other options, try to rule out. See, abducens nerve is basically involved for the lateral rectus muscle. So if suppose abducens nerve is involved, that is not involved, it is not related to the pituitary gland. But if it is involved, there is going to be the medial squint of eye. The eyeball will be rotated more medially. Optic tract and optic nerve. If the optic nerve is involved, optic nerve of any one eye, there will be complete blindness of that eye. There will be complete blindness of that particular eye, be it right or left. If the optic tract is involved, option number C, optic tract is post the optic chiasm. We'll see in detail. But if the optic tract is involved, there's always going to be the contralateral homonymous hemianopia. You will see what it actually means. Contralateral homonymous hemianopia. Answer therefore is optic chiasm for sure. Let us look at an image over here. This beautiful image, now see over here. Start from here. Start right from the top. The left and right side, the visual field, N and T are the nasal and the temporal sides. Okay. So what was missing over here? What was missing over here was the lateral visual field. That means these areas were missing over here or not being, the visual field loss was from here. So nasal retina of both the eyes was, damaged. Optic chiasm lesion was where? Lesion was at option number D over here. Option number D, have a look, bitemporal heteronymous hemianopia. Both here, this dark area, this is the visual field loss over here, lateral side. And look at number C over here. This is the region of what? This is the region of optic tract. What happens? The contralateral homonymous hemianopia. So if there is a lesion of the right optic tract, listen to my words very carefully. There will be visual field loss on the left half of the visual or the space. So there is going to be left homonymous hemianopia. And the A means optic nerve is involved. If the optic nerve is involved, A, you can see the right side, there is complete blindness of the right eye. This is all, this optic visual field effects, but we have to understand pituitary gland is seated right below optic chiasm, so you don't have to think of too much, but have a general idea of this at least. Okay, fine. Let's see the next one. A cricket bat struck a 48-year-old man in the mid region of his arm. Arm is this humerus area, remember. The clinical assessment reveals an inability to extend the wrist and sensory loss in a small area of skin on the dorsum of the hand between the first two fingers. So there is inability to extend the wrist. What is there? Wrist drop is there. Okay. So 2-3 things. There is a injury in the mid region of the arm. There is, second thing is wrist drop is there. Third thing is there is sensory loss there, or the dorsal aspect on the lateral side of the fingers. What nerve supplies? All these hints are telling us that there is involvement of radial nerve. Why? Because radial nerve runs in the mid region of the arm. Where? It runs in the spiral groove or the radial groove of the humerus. Then when the radial nerve is damaged, it leads to paralysis of all the extensors of forearm, because the posterior interosseous nerve is also involved. So this is going to be wrist drop. Third thing, radial nerve branch gives off a superficial branch that is sensory to that dorsum aspect. All of this is telling us radial. The answer is radial nerve. If you have just one idea, mid region of the arm, radial nerve, wrist drop, radial nerve, sensory loss in this area, radial nerve. There are 3 hints for one answer. Answer is radial nerve, right? Let us see an image over here. This is where the radial nerve normally lies, in the spiral groove in the humerus. This whole area is the arm. This whole area is the arm from shoulder to elbow. Then over here you can see, if you look at the fingers over here, this is the dorsal aspect, that is the palmar aspect. And dorsal, they said between the first 2 fingers there is sensory loss. So this area, if you look over here, superficial branch of radial nerve supplies this area. Again, therefore, this is telling us that this is the probable answer over here. Radial nerve is the one that is defective over here. Okay. A violent bite from a German Shepherd dog resulted in a rupture of a tendons of the first dorsal compartment of the wrist in a 21-year-old lady who was brought to the nearest hospital. Which of the below muscles would be affected by the tendon injury? So we have just did it a few minutes back. Remember the question on decurvent stenosynovitis. The tendons were abductor pollicis longus, extensor pollicis brevis. Fine, but then at then and there only I said that they are lying in the first compartment or first extensor compartment. So see, answer already is out. It's already out. So you have to search for these 2 options. Answer is straight away abductor pollicis longus, extensor pollicis brevis. But there, how many compartments are there? There are many compartments. Look at this image. This is the dorsal side, right? Posterior side of the, you can say the lower part of the forearm and the hand. This is the lateral, that is the medial. There are total, how many compartments are there? There are total 6 compartments. There are total 6 compartments. Okay, and compartment numbers, the number compartments start from lateral and they go medial. Let us number them. I will number it for you, don't worry. This is compartment number 1. Look at these 2 tendons. This is 1. Compartment number 2, look carefully, I am changing the color to red one. This is compartment number 2. ECRL, ECRB must have been written over here. ECRL, ECRB, compartment number 2. Compartment number 3, coming again to the blue color, this is compartment number 3, pollicis longus. Compartment number 4, this whole is compartment number 4 over here, extensor digitorum. All these extensor digitorum and extensor indices, they come in compartment number 4. Compartment number 5 and 6 are over here, 5 and 6. What are these muscles? Compartment number 5 over here is extensor digiti minimi. And 6 over here, compartment is extensor carpi ulnaris. So there are total 6 compartments from lateral to medial side. You should know their names, which compartments are those. Compartment 1, again I am repeating, decurvent stenosynovitis, that we already have done. These are 6 compartments over here. Bounded up, see, they are bounded above. They are strictly bounded above by this extensor retinaculum. Okay, it's like a wristband, tough wristband. Okay, in preparation for isolating the proximal section of the femoral artery, the vascular surgeon removed it delicately from the surrounding tissues. What muscle comprises the lateral part of the femoral triangle floor, posterior to the femoral sheath? Basic idea we should over here is, what is this femoral triangle? Okay, so if you look over here, above we have this as the inguinal ligament going from anterior superior iliac spine to pubic tubercle. Then we have a huge muscle coming from the ASIS running down is the sartorius, right? And then we have the muscles lying in the floor. What are those? Here we have adductor longus. Then what we have the pectineus. Then we have the psoas major and we have the iliacus. We'll write it them. This is sartorius. This is inguinal ligament. And this is the muscle adductor longus. This is pectineus. This is psoas major. And this is iliacus. We can remember it by mnemonic up A, P, P and I. But from medial to lateral, so remember the mnemonic also A double P I. From medial to lateral, these muscles, they form the floor of femoral triangle. What is the boundary of femoral triangle? Understand that too. See, the boundary of the femoral triangle, is the medial border of the sartorius, the medial border of the adductor longus, and the inguinal ligament. So this over here is the boundaries. These are the boundaries of the femoral triangle. And these muscles over here, APPI, they are basically forming the floor of the femoral triangle. And what they said, what muscle comprises the lateral part of the triangle's floor? It is iliacus and psoas major. So iliacus therefore is the simple straightforward answer over here. Now they just tried to put a clinical image, proximal section of the femoral artery. We all should know that over here we have what? We have the femoral sheath running down like this. This is, imagine the femoral sheath. And what is lying in the femoral sheath? Let us do that too. Most laterally what happens is you have the femoral nerve coming out. Okay, most laterally we have the femoral nerve coming down. Then inside the femoral sheath we have what? We have the femoral artery, into which there runs a small nerve known as femoral branch of genitofemoral. Medial to femoral artery we have this femoral vein. This is the femoral vein. And more medial to it we have actually an empty space over here known as femoral canal. And that is very important. Why? Because this is the canal and that is anatomically important for femoral hernia. Understand this? But the answer is straightforward, iliacus. Just giving you a more overview. And if you look at this cadaveric image, here also you will understand. If we just zoom on to one, let me outline the boundaries of femoral triangle. This is sartorius. This is the medial border of sartorius. This is adductor longus. I am writing AL, medial border adductor longus, and that is inguinal ligament. If you look at the muscles, adductor longus, pectineus, PM, psoas major, I for iliacus. What they asked? They asked this iliacus over here this time. Be prepared. Where will the femoral artery be? Femoral artery running somewhere around here in the midpoint. Femoral vein medial to it. And that side is a femoral canal over here, which might give rise to femoral hernia. Okay, so understand this basic femoral triangle. Okay. Next question says, for a 34-year-old worker sustains a large cut to his right buttock after falling into a rusty metal mesh. When the paramedics arrive to take him to an emergency, it is observed that he has trouble using his right leg to climb into the ambulance. To climb into the ambulance, obviously you have to take 1 or 2 stairs to reach the inside the ambulance. Which nerve must have possibly been affected? So problem over here is he is not able to climb. And where is the injury? Injury is in the buttock region and he is not able to climb. That is the two main things. They are asking you which nerve. So in climbing, suppose these are the stairs over here and a person has to climb the stairs. Let us simply make, okay, only 1 or 2 stairs. Let us simply make these stairs. And a person has to climb the stairs. Suppose the 1 foot is on the ground over here and the 2nd foot the person tries to put over here and then he is trying to climb. Okay. Now when he is trying to climb, obviously what is happening is he has to lift his entire weight like this. His hip joint is basically, if we say that this is the, say the right and the left lower limb over here. The right lower limb hip joint is in which position? It is in flexion position right now. So he flexed, he put his right foot on the stairs. Now when he has to climb, he has to go from flexion to extension of the hip joint. Then only can he climb. That is not being possible. So which muscle is the main extensor of the hip joint? That you have to think. And the main muscle over here which acts as the extensor of hip joint is gluteus maximus. And it is present in the buttock region. And what is the nerve supply of gluteus maximus? The nerve supply of Gmax is the inferior gluteal nerve. It is not the superior, it is the inferior gluteal nerve. It is the chief extensor, the main extensor. Also, when we ask someone to this practice or the exercise more the Gmax, the gluteus maximus, we ask them simply walk up the stairs as much as possible. The more you walk up the stairs, the more the gluteus maximus is being exercised. Answer therefore over here is bound to be our inferior gluteal nerve, the nerve that supplies the Gmax, because that is the one that is involved in climbing the stairs, on climbing the ambulance. Okay. Here we can see at the muscle, the Gmax over here, this is a posterior view. You can see the sacrum over here. So the moment this muscle contracts, contraction means the fibers, they decrease in length. That is what is known as contraction. The moment this contracts, the whole lower limb will go from flexion to extension. Suppose the lower limb is going like this, so this will go from here to here. This will be the flexion to extension. Is Gmax. Main muscle involved is Gmax, supplied with the inferior gluteal nerve. Right? Okay, next one. A 73-year-old lady arrives at the accident and emergency after falling down the stairs. The talocrural, what is talocrural? Tibiotalar articulation had been damaged. What movements usually occur at this joint? Don't get this intimidated by what is this talocrural tibiotalar. It is between tibia and talus. What is the joint between tibia and talus? Tibia is the leg bone and talus is the tarsal. So between the lower leg or the lower end of the tibia and the talus, the joint is ankle joint. Coming to the basic, the gross, the basics or the general anatomy, gross anatomy. Ankle joint is which category of joint? It's a synovial. Which variety of synovial? It's a hinge variety of synovials. Only uniaxial movement. Which movement? Only one movement can occur. Or in one axis, only the movement in one axis can occur. The movement over here is your extension and flexion. Right, and when we say flexion, it is basically your plantar flexion. When we say extension, it is basically the dorsiflexion. This is the only movement, plantar flexion, dorsiflexion, or extension flexion, that can occur at this joint. Therefore, what is the answer? Inversion, eversion, plantar flexion, B and C. Option number D will be the answer over here. Both B and C. What about option number A? This occurs at the subtalar joint, below the talus. That is talocalcanean joint, all those joints, not at the ankle. Right? Here, what we are looking at, the few of the tarsal, this is the mainly the talus over here, this is the calcaneum over here. The inversion, eversion, I oblique E, they occur at this joint. The flexion, extension, or the plantar dorsiflexion, they occur at the ankle joint. Okay, let's see the next one. What is the volume of adult male prostate? So that is a straightforward factual question. Even if you don't have an idea, normally we read a lot of stuff that somehow we miss this very, very basic. This is written in the first paragraph of any chapter of any topic. Volume of this, or length of this, or length of that. Apply your common sense over here. You must have seen in dissections the bladder, male bladder, below this you must have seen the prostate sizes somehow like this. In large prostate this, normal prostate this. Now see the options. 100 cc. You should have idea how much is 100 cc. Should have idea how much is 100 cc. You should have idea what is 50, 20, 75 and 20 cc. Then roughly around C, the prostate gland is like this. The length and breadth are this much. It looks like can't be 100 or 50, 75. Max to max might be around 20, 30 cc. Common sense. So therefore, the answer will be straightforward 20 cc. Problem will arise if they give you options like 20, 25 cc, 30 cc, but that would not be a good question because it is slightly variable, obviously. Answer therefore is obviously our option number D, 20 cc. Okay. Okay, coming to the last one over here. A 36-year-old is taken to the emergency with breathing difficulties, vertigo, and a severe chest pain. On the chest radiograph, the big arrow denotes the location of the pathology. What is the site? They're asking you simply, can you identify where is this arrow pointing towards? Is it the arch of aorta? Now, just remember, if you look at the heart over here like this, arch of aorta comes and goes like this from front to back. Okay, is it the pulmonary artery? The pulmonary artery is actually in the concavity of the arch of aorta. Okay, is it the superior vena cava? Superior vena cava normally runs on the right side. Is it the left ventricle? Left ventricle is over here. What do you think over here? This is basically, we all should be knowing, this is basically the image of the aortic knuckle in the radiograph, and that is the arch of aorta over here. This is the arch of aorta over here. Okay, simple. You should know the basic idea where which structure is located. Okay, so that's all from my side. Thank you. I hope you enjoyed. All the best.
Hello friends, this is Dr. Dipali Gupta, your pediatrics faculty at Allen Next. So welcome to the discussion of questions which came from pediatrics in CBoT today. So without wasting your single minute, let's get going. So the first question was, a term infant is born by spontaneous vaginal delivery to primiparous woman who received a dose of meperidine 2 hours before delivery. The baby is apneic. The most important immediate management is to do what? That's what has been asked in your question. So in this, the first thing you have to understand is that the mother was given meperidine, and very importantly 2 hours before delivery. Does it cross the placenta? Will it affect the fetus? Of course it will does, and especially the peak levels of meperidine, which we know commonly as pethidine, that is achieved in 2 to 3 hours. So usually in this case 2 hours have passed and now the delivery has taken place. So definitely we are expecting a depressed child. We are expecting a child who might have problems with the establishment of normal respiration, right? So what are we supposed to do? Administer naloxone in the endotracheal tube, obtain cord blood, then perform bag and mask ventilation or begin chest compression. Definitely obtaining a cord blood would not help at this time. We have to resuscitate the baby because invariably this child will be having respiratory depression. Now, how do we treat this? I know most of you would get confused whether to go for naloxone or perform a bag and mask. I'm sure most of you would also understand that giving naloxone would not establish the respiration, especially when the child is already apneic, right? So for an apneic child, I've told you 100 of times, in the past discussions, 3 indications of bag and mask: heart rate less than 100 per minute, although heart rate is not mentioned over here, or if the child is gasping, or if the child is having apnea. So after performing initial steps, that is, warming the child under the radiant warmer, covering it with a towel, and, trying to clear the secretions from the mouth. These are the initial steps, and slightly extending the neck. After all these steps, if the child is having any of these 3 problems, then one has to go for bag and mask ventilation. Right now, there is no role of giving any medicine, including naloxone. Although we know, yes, meperidine or pethidine, as we call it, is an opioid analgesic, and naloxone would be a perfect antidote in this case. But first, we have to go for bag and mask ventilation. Give rescue breaths to the child, and of course go as per the neonatal resuscitation protocol, where we have seen that after bag and mask, still if the heart rate remains less than 100 after 30 seconds, then we do the ventilation corrective steps. We ensure adequate ventilation while doing the ventilation corrective steps. Still, if the heart rate is less than 60, then we add chest compressions to the positive pressure ventilation. At this stage, it is your wish whether you want to continue the positive pressure ventilation in form of bag and mask or go for the endotracheal intubation. Even after 60 seconds of chest compressions, if the heart rate is less than 60 per minute, then you go for medications. Of course, in this case, the medication what we would consider is straight away naloxone, because we know the child has been under the influence of or has been under the effect of pethidine or meperidine, as it is given in the question. So always remember, here you are going to do what you are going to do. You are going to perform the bag and mask ventilation. Rest of the options are not valid over here. I hope you got this question right. Coming to the next question, then a newborn presents with anuria and further evaluation reveals bilateral renal agenesis and pulmonary hypoplasia. There is also a history of oligohydramnios. The most probable diagnosis is. I know these questions really bug you when they ask you syndrome, but believe in me, every time one or the other syndrome is usually asked, and we're just discussing here the commonly asked syndromes. So whenever you have bilateral renal agenesis, as there is in this child, plus pulmonary hypoplasia, plus very obviously, I don't need to write plus, but still I would like to highlight over here oligohydramnios. The 3 conditions given in this question, straight away your diagnosis should become what? It should become Potter syndrome. Because Potter syndrome presents with such a phenotype, and you should be knowing the mnemonic of Potter syndrome. I'll just write it down for you so that it is easier for you to remember. POTTER. So P stands for pulmonary hypoplasia, and you will be amazed to know this is actually the commonest reason of mortality of these children. Of course, bilateral renal agenesis is incompatible with life, but still pulmonary hypoplasia has a significant contribution in determining the mortality or survival in this child. So P stands for pulmonary hypoplasia, O stands for oligohydramnios, right? And then T stands for twisted skin, and another T stands for twisted face, right? So twisted skin, which is seen in this child, wrinkly skin you can call it, and twisted face, which is so characteristic, also known as Potter facies. I am going to tell you what is Potter facies in a short while, just bear with me for a few seconds. So double T we have already done, twisted skin and twisted hair. And then E stands for extremities defects, which is so very characteristic in this child who is suffering from Potter syndrome. And R of course stands for renal agenesis, which is usually bilateral. So this is the mnemonic Potter which you have to remember, and this is Potter syndrome for you. Now the question is, why oligohydramnios? I have told you umpteen number of times, whenever there is a kidney congenital renal problem, congenital renal defect, then definitely the urine formation would be affected. And always remember this fact that after 16 weeks of gestation, the amniotic fluid, the major contributor to amniotic fluid is the fetal urine, the urine made by the fetal kidneys. So fetal urine is the major contributor to the maternal amniotic fluid, and no wonder if as I am telling you that this child is not having the kidneys at all, there is bilateral renal agenesis, definitely the urine formation would not be there, and definitely the child is, the mother is going to have oligohydramnios, right? Now the question arises, what is Potter facies? So Potter facies, as you can see over here, this is a child with Potter syndrome. So they have low set ears. The low set ears are very characteristic, and very importantly they have a flat nose, as you can see over here. Eyes are widely separated. So eyes are widely separated, and there's a small receding chin. You can see in this diagram, there's kind of retrognathia or micrognathia. Retro-micrognathia, that means small chin and receding chin, right? And moreover, there is prominent epicanthic folds with downward slant of the eyes. The slant of the eyes is downward, right? And prominent epicanthic folds are there. And very importantly, you can see the limb deformities which I was talking to you about. So the only facial features I have described for you, as I have told you, there's flat nose, there's wide space between the eyes, and there's downward slant of the eyes, and moreover even the nose is beaked. We can write over here, beaked nose is also a very important feature. If you have to see over here, I'll just see. So this beaked nose is a very important feature of Potter facies, right? So that is what is known as Potter facies, associated with limb abnormalities and pulmonary hypoplasia, which is responsible for the respiratory failure in this child. Pulmonary hypoplasia will give rise to respiratory failure, right? Okay, so apart from that, Potter syndrome can be characterized by many other kind of renal defects also. If the bilateral renal genesis is not there, then the child can have cystic renal dysplasia, obstructive uropathy, infantile polycystic kidney disease, renal hypoplasia. So this all would come into picture, when the bilateral renal agenesis straight away is not there. If it is written bilateral renal agenesis, it becomes very easy for you to make a diagnosis. Now, one thing I would like to, emphasize over here, especially, there was one option given in your question, that is what Pierre-Robin sequence. So what is Pierre-Robin sequence? Just in case you get a question directly on Pierre-Robin sequence. So again, this is a congenital birth defect, which occurs during the fetal development. The cause is not fully understood. There is some isolated genetic mutation, and it is a part and parcel of a syndrome which is known as a Stickler syndrome. So Stickler syndrome, in this we can get to see what I am telling you, Pierre-Robin syndrome or Pierre-Robin sequence, as it is more commonly called. And now, how does this child look like? So there is very characteristic feature of this sequence or syndrome, as you would like to call it. In Pierre-Robin syndrome, you get to see as we call it, glossoptosis. So what is glossoptosis is when the, there is backward position tongue. The tongue is positioned actually backward, and because of that backward position tongue, that tongue actually, obstructs the respiratory pathway. So respiratory passage is actually obstructed by the backward position of the tongue. That is known as glossoptosis. And very importantly, as you can see in this figure, why I have put this figure for you, again, there is a receding jaw. The jaw is very much, underdeveloped. There's underdevelopment of the lower jaw, and it is kind of receded. And because of this, there's very less space for the tongue to occupy in the anterior part of the mouth. So it is pushed more posteriorly, hence obstructing the respiratory passages. So that is what is Pierre-Robin sequence for you that you should be knowing. The other two options given in that question were the Downs and the Turner syndrome. I don't need to, explain to you. I'm sure by now you must be very, very clear how does a child with Down syndrome look like. Of course, the flat facial profile would be there, the mongoloid slant would be there, there would be epicanthal folds, and there would be, sandal gap and clinodactyly and Singer-Palmer crease. We know about all this, and of course, microcephaly and many other features which are not given in the question, and hence Down syndrome is not the answer. Again, the Turner syndrome would be described in a female, and of course, where you would get to see a wide carrying angle and a low hairline and webbing of the neck, widely spaced nipples, shield chest. All these are features of Turner syndrome. In our question, there was nothing like that given. So therefore, these are definitely ruled out. Pierre-Robin syndrome, I've already told to you that this is how it looks like. This is straight away the diagnosis in this case is going to be Potter syndrome, right? Or Potter face, because, and plus you should be knowing a few things about Potter syndromes which we have already discussed, right? Okay, now let us move on further to the next question. So the next question tells us that there's a successful ventilation. How do you determine successful ventilation? So successful ventilation is determined by all of the following except heart rate more than 100 beats per minute, zero reading of end tidal CO2 measurement, symmetric breath sounds, adequate chest rise. See, friends, this question can come in some other way also, which is the best marker which tells you that the bag and mask ventilation being carried out in during neonatal resuscitation is actually working. The answer to that is when your heart rate increases to more than 100 beats per minute, then we know that we are doing a bag and mask in an effective manner. So definitely, as it is asked in this question, which of the following features does not indicate successful ventilation? So definitely the first option does indicate successful ventilation. Symmetric breath sounds, of course, on auscultation you should get symmetric breaths, you should get to hear symmetric breath sounds. So therefore this is also a part and parcel of successful ventilation. Adequate chest rise, again a very important marker by which you come to know whether you are able to deliver successfully rescue breaths or not. What is not a marker of successful ventilation is the zero reading of end tidal CO2. So your answer becomes zero reading of end tidal CO2 measurement. So for the uninitiated, if you want to note, actually, if you want to understand what do you mean by end tidal CO2 measurement. So this is how, ETCO capnograph would look like, which is known as the endotracheal CO2 monitoring during cardiopulmonary resuscitation. For people who are not aware of what is ETCO2 monitoring, so this is done by seeing this capnograph. So ETCO2 monitoring during CPR can be explained by a mnemonic which is known as PQRST. ETCO2 monitoring during CPR can be explained by a mnemonic which is PQRST. Now you've heard of these PQRST waves in ECG. Remember, here we are going to not see the ECG. It is just a mnemonic. For mnemonic, we are utilizing these alphabets PQRST, which will give you an idea why ETCO2 monitoring is done. And what is ETCO2? ETCO2 is endotracheal tube CO2. That means the CO2 which is being exhaled out by the endotracheal tube. If we monitor that, that gives us a lot of idea about many things. So let us see what does it give idea about. First of all, P. P stands for position of the endotracheal tube. Of course, if you are getting a normal ETCO2, that means the position of endotracheal tube is just perfect, right? Then Q tells us about the quality of CPR which is going on. So again, if the EtCO2 is normal, that means the quality of CPR is perfect. And how do we come to know is, if the EtCO2 is always more than 20 mmHg, that means the CPR being done is totally okay. Then ROSC, it also gives us, R stands for ROSC. ROSC means return of spontaneous circulation. How do we come to know? If EtCO2 suddenly, rises above 40 mmHg, right? So that tells us there's probably return of spontaneous circulation in this child or in this neonate, in whomever you are doing the resuscitation is going on. So R tells us about the ROSC. ROSC stands for return of spontaneous circulation. Then what does S tells us? S tells us, helps us in determining the strategies for further treatment and ventilator settings. So that means if you are not getting a perfect EtCO2, then we can strategize about further treatment. That means we have by changing the ventilator settings, right? By changing ventilatory settings. Now, what does T stands for? So, T, let me start, write in another font or another font color. So, T here stands for, it also, EtCO2 monitoring also helps us in determining when to terminate the CPR. That means if persistently EtCO2 is less than 10, even after 20 minutes of CPR, it is better that we terminate the CPR. There's no longer probably, the child is not responding to our CPR and it is futile to carry forward, right? So it helps in termination of CPR. And what is the cutoff? But if the EtCO2 is less than 10 mmHg, okay, for 20 minutes, then that is an indication that we terminate the CPR. So PQRST is a mnemonic by which you come to know that how EtCO2 or monitoring is helpful in, actually managing the CPR when it is going on, right? So that is how, let us come back. So if there's zero reading of end tidal CO2 measurement, that never indicates a successful ventilation. That indicates, actually that's a cause for alarm, that why the zero reading is coming. Probably there is something majorly wrong with that technique, or maybe the child is not responding, right? So that is it. So this, the answer, correct answer over here is going to be zero reading of end tidal CO2 measurement. Okay. Now let us move forward. The next question is, icterus neonatum is due to. So first of all, icterus neonatum, as you can, if you have no idea about this, let us say term. So let us, break this term and understand. Icterus means, we all know it means jaundice, right? And neonatum means in the neonatal period, right? So jaundice in the neonatal period, just not other jaundice. You have to understand what we mean is, very importantly, physiological jaundice. Remember, physiological jaundice is a feature, very commonly seen in the neonates, which does not indicate any pathology in the body of the neonate, but it is simply imbalance between the load which is put on the immature neonatal liver. Now the question arises, why does icterus neonatum takes place? Why does physiological jaundice takes place? So there are many reasons for it. So let us analyze those reasons first. The first reason for icterus neonatum is increased bilirubin production. Now you will ask me why bilirubin production is more. Let us, analyze right from the base. So there's increased bilirubin production occurring in the reticuloendothelial system. Why it is there? Because we know in a neonate there is increased RBC volume, there is more number of RBCs. We also know that in the fetal period and in the neonatal period, the RBC survival is definitely decreased. How do we know that? Because in our body, the survival time of RBC is 120 days versus 90 days in the newborn. So definitely there's decreased RBC survival. Moreover, there is increased ineffective erythropoiesis which is occurring. So increased ineffective erythropoiesis, that is another reason. That means more and more RBCs are getting found, but then at the same time they are getting lysed also. That again puts an extra load on the liver of bilirubin, okay, right? And there is increased turnover of non hemoglobin proteins, right? So, increase turnover of non-hemoglobin heme proteins, and you know actually the bilirubin is derived from the heme moiety of the hemoglobin, right? Globin part goes for recycling, while the heme moiety gets converted to bilirubin. So, non-hemoglobin heme protein, that also turnover is more. So, that is one broad reason why there is increased bilirubin production, that again puts an extra load on the neonatal liver. Another reason for increased jaundice is because of the defective hepatic uptake of bilirubin by the liver, by the neonatal liver. Why defective uptake by the neonatal liver, and why, what is the reason behind it? Because we know there is decreased concentration of ligandin. If you have done your biochemistry well, you will know, or your physiology well, that ligandin is the substrate which binds to the bilirubin from the albumin and takes it inside the hepatocyte. So, if there is decreased ligandin, obviously the hepatic uptake of bilirubin is going to get compromised. The third reason as to why we have again increased jaundice during the neonatal period is defective bilirubin conjugation or decreased bilirubin conjugation ability. Why? Because we know there is an enzyme which is known as UDPGT, uridine diphosphoglucononyl transferase. This enzyme, the activity of this enzyme is severely compromised during the neonatal period normally. It is not that it is being compromised in some disorder or disease or in specific neonate. No, in all neonates there is decreased UDPGT activity, and that is the reason why there is decreased bilirubin conjugation taking place over here. Next pitfall is decreased hepatic excretion of bilirubin. That means everything is done, the glucuronidization is done, the bilirubin has been conjugated well in the hepatocyte, but the problem is again the liver is not able to excrete out the conjugated bilirubin efficiently. So, decreased hepatic excretion of bilirubin, that is another reason why you get to see physiological jaundice. And final and the most important reason is because one more reason is increased enterohepatic circulation. Now, what is this enterohepatic circulation? Always remember that at any point of time, if the intestine, if the conjugated bilirubin gets converted to toxic unconjugated bilirubin, it is thrown back to the liver, and this recycling or this throwing back of the bilirubin from the intestine to the liver is known as enterohepatic circulation. Seems logical. Entero means the intestine, hepatic means the liver. So, enterohepatic circulation will take place. Now, what are the reasons? Why will the intestine throw back bilirubin into the liver once again to get conjugated, and then that further increases the load on the liver whose activity is already compromised because of its immature physiological function. So, now the reason is, first of all, there is increased glucuronidase activity. So, what is glucuronidase? Glucuronidase is an enzyme which is present in the lumen of the intestine, which helps in the which is involved in the cleaving of the glucuronyl moieties from the bilirubin, hence converting the conjugated bilirubin to unconjugated bilirubin, and this increased glucuronidase activity results in the formation of more and more unconjugated bilirubin, and this unconjugated bilirubin is then thrown back to the liver, right? Another reason is decreased gut motility and decreased intestinal bacteria, because that intestinal bacteria actually they act upon the conjugated bilirubin and they convert it into stercobilin and urobilin, and then stercobilin gets excreted out into the feces, and thus urobilin gets absorbed into the blood circulation and gets excreted out, gets filtered at the level of kidneys, and is responsible for giving the color to the urine, right? So, this urobilin and stercobilin, they are formed because of the action of the intestinal bacteria, and in fact intestinal bacteria at this point of time they are helpful because very less than conjugated bilirubin is left to be acted upon by glucuronidase. Now, if we have decreased intestinal bacteria, then more and more conjugated bilirubin is available to be acted upon by glucuronidase enzyme, and this will convert the again conjugated bilirubin to unconjugated bilirubin, resulting in increased enteropathic circulation. So decreased intestinal bacteria again results in more or less more amount of physiological jaundice. So these are all the reasons why there is physiological jaundice in neonates. Now coming back to the question, so icterus neonatum is due to, so is it because of breakdown of fetal RBCs? Of course, it seems to be the right option. Then limitation in the conjugation of bilirubin by the immature neonatal liver. Of course, we know this because of the decreased UDP-GT activity we just discussed, right? And third option given is erythroblastosis fetalis. Now, erythroblastosis fetalis refers to the lysing of the RBCs because of RH incompatibility. So that will not give rise to physiological jaundice. This will give rise to pathological jaundice. Always remember that, right? So this is not physiological at all. So that is why the correct option would be the option containing A and B as the option, and that is the third option. So third over here is the correct answer, which you have to mark in this case, right? Okay, I hope this was clear to you. Let us move forward. There was a camp arranged in primary health center where the awareness for breastfeeding of children was the topic. Which of the following is not a feature of breastfeeding jaundice? So we know there are two types of jaundice. In fact, there are many types of jaundice, but one thing which every child gets confused between is, one is breastfeeding jaundice and the other is breast milk jaundice. Now, what is the difference between two? Oh, very simple to understand. What comes before? F comes before M. So that means breastfeeding jaundice comes on day 2 to day 3 of life. Remember that. And breast milk jaundice comes around the week 3 of life, right? So, because M comes after F, remember like that. Number 1. Number 2, breastfeeding jaundice occurs because of decreased intake of milk by the neonate, right? Because in the initial 2-3 days, the mother is not very comfortable feeding the child. You know, she has difficulties in adjusting as a new role, as a caregiver, as a milk giver to the baby. The baby is also not that much adapt to the frequent suckling on the breast. So overall, there is decreased intake of the milk by the baby, and that increases the jaundice. Why does it increase the jaundice? Because decreased enteral intake, decreased intake of the milk would result in decreased intestinal motility, and we have just seen decreased intestinal motility increases the physiological jaundice, right? So that is why the breastfeeding jaundice occurs over here. Now, breast milk jaundice occurs around week 3 of life, and the cause of breast milk jaundice is entirely different. It occurs because of something in the milk, breast milk, which is found exclusively in the breast milk, and that is pregnant diol. Now, pregnant diol inhibits or suppresses the UDP-GT activity, the enzyme which is responsible for converting the unconjugated bilirubin to less toxic conjugated bilirubin. So if UDP-GT activity is suppressed, then definitely there will be more and more of unconjugated hyperbilirubinemia, and that results in the child developing jaundice. So that in the causes of jaundice is entirely different. Now let us see what is being discussed over here. Unconjugated hyperbilirubinemia is seen. Yes, that is correct. Occurs in the first week of life. Yes, we are talking about the breastfeeding jaundice, though that occurs in the first week of life. It is seen in breastfed infants because of decreased milk intake. This is also correct. What we are going to mark is something which is not correct, right? So the not correct portion is the fourth option. The treatment is to withhold breastfeeding. Remember, the cause of breastfeeding jaundice is decreased intake. Will you further decrease the breastfeeding? No, you will not. In fact, you encourage more and more breastfeeding. So that is why this is the incorrect option, and hence the answer to this question. What about in breast milk jaundice? Everybody would have this query, ma'am, there is some problem of in the breast milk jaundice, which is in breast milk, which is in fact causing the breast milk jaundice. So what is the treatment of the breast milk jaundice? Do we stop breast milk? Please remember, this is again a very important MCQ. In breast milk jaundice, I am saying it very clearly, in breast milk jaundice also, we do not stop breastfeeding. Breastfeeding has to be continued because the levels, the bilirubin levels, serum bilirubin levels, which are seen in breast milk jaundice are not severely high to actually have any effect on the well-being of the fetus, of the newborn, right? So therefore, in breast milk jaundice, in spite of a factor present in the breast milk, which is in fact responsible for causing jaundice, we do not stop breastfeeding. In fact, we do not even convey this to the parents, because if we tell them about the factor present in the breast milk, then they will stop on their own. So nothing to be done, just assure them the levels of the bilirubin are well under control. You don't have to worry. Yes, the child is icteric to look at, but not a thing to worry. Samajh mein aa gaya? So that is what it is over here. Let us move further. Which of these is commonly seen in an infant of diabetic mother? So hyperglycemia is not very commonly seen. What is seen instant is hypoglycemia, right? So this, we are not happy with the A option. Hypocalcemia, of course, we get to see hypocalcemia. And why do we get to see hypocalcemia? You should always know the nadir in the serum calcium levels in an infant of diabetic mother is usually seen around 24 to 72 hours of life, not in the first 24 hours of life, after the 24 hours of life. And this nadir or this dip, nadir refers to the dip in the serum calcium levels or decrease in the serum calcium levels, and this dip, you know, continues for another 72 hours of life. And why does it occur? It occurs because of many reasons. First of all, there is immaturity of your PTH, and because of which it is unable to play its physiological role, and that is maintaining the serum calcium levels to the optimal level. So that is not being done properly by the parathormone, and that is one of the reason. Another reason for this dip in serum calcium level is there is vitamin D antagonism at the intestinal level. Now what is meant by this is, you know, vitamin D is the rickshaw for the calcium. You know, without vitamin D, the calcium cannot be absorbed. So if there is vitamin D antagonism at the intestinal level, then the serum, then the calcium which is being, you know, which is there in the intestine does not get absorbed effectively, and hence serum calcium takes the hit. That means serum calcium levels, they dip down, they decrease. The third reason is again prematurity. So these are the three reasons why we get to see a dip in the serum calcium levels, usually after 24 to 72 hours of life. If you just see in infant of diabetic mother, one first factor, second factor or third factor may be operable. You know, sometimes infant of diabetic mother, because of their large size, they go, you know, the mothers, they tend to go into the preterm labor. So prematurity can be the factor over here. And if the child is a term infant of diabetic mother, right, then immaturity of PTH and vitamin D antagonism are other two factors which result in hypocalcemia, especially in infant of diabetic mother. So that is one thing. Now coming to so this is definitely there in infant of diabetic mother. Neural tube defects, are they seen? Of course, yes. We all know, we all have, you know, ratified this, that sacral agenesis, that is nothing but a neural tube defect. Remember that, and that is characterized by the absence of the vertebral segment that forms the sacrum. That hence the name sacral agenesis. That's a neural tube defect, and it is considered to be the most specific congenital defect associated with infant of diabetic mother, right? So neural tube defects are very much there, and not only sacral agenesis. Remember, there are many neural tube defects which occur in infant of diabetic mother apart from sacral agenesis. This infant of diabetic mother is prone to develop even anencephaly. Remember that. Also prone to develop meningo or meningomyelocele. Anything can occur out of these two, and sometimes they are also prone to develop many other neural tube defects. So that is why neural tube defects are very commonly seen. So this is also correct. Then macrosomia, of course, we know the large baby is a feature when you see any mother having gestational diabetes. Why? Because of the uncontrolled blood sugar levels in the mother. The high blood sugar levels get reflected into the fetal circulation also, and that results in outpouring of insulin from the pancreas. And we all know the growth factor for the fetus are two. In the fetal state, there are two factors which regulate the growth of the fetus. The first factor is insulin, and the other factor, other hormone is thyroxine. It is not growth hormone. This is again asked in your MCQs. So insulin and thyroxine, they are responsible for the growth of the fetus. Now at any point of time, if my insulin levels peak, why does the insulin levels peak in the fetus of the diabetic mother? Because of the high blood sugar levels, and that is why these babies, they grow in size to a large extent, and hence they become macrosomic. So that is also a feature of infant of diabetic mother. IUGR, is that commonly, see what is asked is most commonly, is that a feature of infant of diabetic mother? Let me tell you, IUGR can occur in infant of diabetic mother, but here what is asked is most commonly. So therefore, we would like to go with the three most common, because that is 3 options only are admissible over here. So the 3 most common would be B, C, D. So therefore, the correct answer is going to be B, C, D. Remember, there is a theory which goes by the name of selfish mother hypothesis. Now this selfish mother hypothesis, what does this theory says? It is a proposition, nothing has been proved. So this says that in mothers who are having gestational diabetes, sometimes what happens is all the substrate is there on the maternal side only, and none of it gets transferred to the fetal side, and hence because of this, the fetus that that suffers from intrauterine growth retardation. So therefore, IUGR is seen in the fetal state, and that is why infant of diabetic mother can be having intrauterine growth retardation also. It is not, however, more commonly seen is macrosomia, but always keep in mind that IUGR can also be seen. So had there been the fourth option also, that is 4 choices were admissible over here, then I would have gone for IUGR also. But what they have asked is most commonly, so most commonly we will go for hypocalcemia, neural tube defects and macrosomia. Be very clear about it, right? Okay, then the mother is said to have had a substantial volume of amniotic fluid at the time of delivery. The infant began to spew. Spew means vomit a minor amount of mucus and very importantly bile stained fluid 4 to 6 hours later. The infant appears normal upon physical examination and an X-ray of abdomen is taken. Which of the following describes this infant's illness most likely? So very characteristic, the X-ray which is given. This is such simple giveaway, as I always tell you, halwa question for you. So what you can see over here on the X-ray is the double bubble sign. Can you see the 2 bubbles over here? And we know double bubble sign is a feature of not only duodenal atresia, right? It can be the feature of even annular pancreas. You always keep in mind over here, right? And even duodenal obstruction can also give rise to double bubble sign. So anyways, let us see what have they asked. Is it gastric duplication? Is it jejunal and ileal atresia? Is it sigmoid volvulus? Is it duodenal atresia? So straight away our answer becomes duodenal atresia. Now somebody would say, ma'am, what is gastric duplication? Or more commonly this is known as gastric duplication cyst. So there's gastric duplication cyst would be still entertained as a differential diagnosis if the vomitus would be non-bile stained, because the obstruction in gastric duplication cyst would be at the level of pylorus and it would not be later on. So that is why the bile stained vomitus is just something which does not explain the gastric duplication cyst. That much you must know. Then other is, why not jejunal and ileal atresia? So ma'am, why not jejunal and ileal atresia is because you can see that in jejunal and ileal atresia you get to see a triple bubble sign. So you can see classic 1 bubble, 2 bubble and 3 bubble. So triple bubble sign is seen over here, because of the jejunal atresia. You can see over here also one more X-ray where you get to see a triple. In fact, this is this bubble. So this is what is seen over here, right? So triple bubble sign is seen, and therefore in our question, what is given is double bubble sign. So hence jejunal and ileal atresia would not be the differential diagnosis over here, although bilious vomiting can be a feature of jejunal and ileal atresia also. Another thing what was given in the question is sigmoid volvulus. In sigmoid volvulus, usually it is very rare entity, however can be seen in neonates. But remember, in sigmoid volvulus, what we get to see is a coffee bean appearance of the abdominal X-ray. So this is a typical abdominal X-ray what is being shown over here, and in sigmoid volvulus actually the intestinal loops, they twist on their blood supply itself, and that gives rise to a coffee bean appearance. You can see this is the coffee bean appearance, right, which is so characteristic of, this is actually coffee bean, right? This is actually coffee bean, and this is how they have compared the radiology. One more radiology of another child, you can see this is the coffee bean appearance which is seen in sigmoid volvulus, right? So here, and this is usually associated with Hirschsprung's disease and usually presents with acute abdominal distension and constipation. While these are not the features which are being described in the question, hence straight away, anyways this was a giveaway question, but it was my duty to tell you why other three, or in which scenarios you would consider the other three diagnoses. I hope you will remember it, right? So let us move forward to the next question. A 5-year-old boy from an upper socioeconomic background presents with bowing of legs. On workup, serum calcium was 9 mg per deciliter with serum phosphate of 1 mg per deciliter with normal serum alkaline phosphatase and normal serum PTH. X-ray of the wrist joint is given. Comment on the diagnosis. So X-ray, you can see, yes, there are features of rickets. There is, splaying and cupping is there. So rickets is definitely there. Now, what is our diagnosis? Is it hypophosphatemic rickets? Is it Bartter syndrome? Is it chronic renal failure, or is it polycystic kidneys? First of all, I would like to rule out something which is so much not a differential diagnosis over here in any way, and that is Bartter syndrome. So what is Bartter syndrome is, always remember 4-5 words and you will be sorted out. It is hypokalemic, remember hypokalemic, hypochloremic, metabolic alkalosis, right, with hypercalciuria and salt wasting. If you can remember this sentence, that sums up Bartter syndrome perfectly. Remember that, right? So when you have hypokalemic, hypochloremic, metabolic alkalosis with hypercalciuria with salt wasting, then you have to consider Bartter syndrome, right? It is an autosomal recessive disorder and nothing of this sort has been given in the question. So straight away I strike out this. This is not the answer. Another thing which is straight away, not in my differential diagnosis is chronic renal failure, because in chronic renal failure, typically the serum phosphate is going to be very high. Here it is in fact on the lower side. So again, this is not my differential diagnosis. Then another thing which which is not a differential diagnosis over here is polycystic kidneys, because we know usually in children we get to see autosomal recessive polycystic kidney disease, and usually they present during the neonatal period with bilateral flank masses, and usually there is associated pulmonary cyst also, and hence the child has respiratory distress, spontaneous pneumothorax, and apart from bilateral flank masses we also get to see malignant hypertension in autosomal recessive polycystic kidney disease. Nothing of this sort has been given. Rickets is not an occurrence with polycystic kidney disease. Even if we want to discuss the adult variety, that is autosomal dominant polykidney disease, they usually present beyond the 3rd decade of life with episodic hematuria, palpable lumps, that means palpable kidneys, hypertension, and a gradual decline in the renal function. But that is beyond the 3rd decade of life. Anyways, here is a 5-year-old boy. So polycystic kidney disease, I would not entertain over here at all. So by exclusion, straight away my diagnosis become hypophosphatemic rickets. Now let us see what is hypophosphatemic rickets all about. So hypophosphatemic rickets, as we know, here the problem is with the decreased serum phosphate. Now why there is a decrease? This is a flow chart of refractory rickets, rickets which do not respond to the usual vitamin D dosage, and in this you can see that in hypophosphatemic rickets the PTH and calcium is going to be normal. That is what is given in the question. While the serum phosphate is going to be on the lower side, the blood pH is going to be normal. So this is a normal blood pH over here, right? And therefore, that is one thing. Another thing which is very important in hypophosphatemic rickets is that you should know in mineralization of the cartilage, we require both calcium and phosphate. So when calcium is there and phosphate is lacking, then again the proper mineralization of the cartilage, the bone formation would not take place. Hence, we get to see cupping, splaying and fraying, since the problem is not that much of vitamin D as compared, although here vitamin D levels are also on the lower side, but the problem is that what vitamin D what we give during the regular treatment of rickets is 25 hydroxy vitamin D. Always remember that, and that is converted by 1 alpha hydroxylase of kidney. So this is given by us. to the child, right? And this is converted by 1-alpha hydroxylase present in the kidney, right, to 125 dihydroxy vitamin D. Or remember that, right? This is the normal scenario how we treat rickets. This is the active form of vitamin D. But remember, we are not giving active form. We are giving this form of vitamin D. So that means to convert this form to the active form of vitamin D, we require 1-alpha hydroxylase enzyme which is present in the kidney. Now here comes the catch, that in hypophosphatemic rickets, 1-alpha hydroxylase is not working well. Remember that. And that is why even the active form of vitamin D is not there. That is also deficient. Moreover, there is increased phosphate loss in the urine. And why there is increased phosphate loss in the urine is because there is a mutation in the gene which is known as the Phex gene. And this Phex gene, right, it gives rise to endopeptidases. And what does endopeptidases do is, it cleaves or it destroys FGF23. This is the villain of the story. Now what happens is, when this Phex gene is not working well, let us say now this is not working well, there is a mutation over here. So therefore endopeptidase level will also decrease, and hence FGF23 level will increase, and this FGF23 is responsible for, yes, you got it right, phosphaturia. So because of phosphaturia, the phosphate levels are low, and hence the child lands up with rickets, and this is hypophosphatemic rickets. Another very important feature of phosphatemic rickets is that usually this is, always remember, X-linked dominant disorder. It is a X-linked dominant disorder. You have to remember this. That means the mother would be affected and both the siblings would be affected, right? Both the male and female siblings can be affected, and specifically what we get to see is the bowing of the legs is there, right? Mother may have bowing of legs and short stature, and usually in this case even the children, they land up with lower limb deformities in form of coxa vara. Lower limb deformities is there, right, in form of coxa vara or genu valgum, as you can see in the photograph, right? So this is all is seen, and moreover dental abnormalities are also very common. And which kind of dental abnormalities are common? Like frequent dental abscesses, that is common, and intraglobular dentine, even that is very commonly seen. So when you have features like this, although all these things were not given in your question, only and only what was given is low phosphate and a normal serum calcium and phosphate level, and normal serum calcium and alkaline phosphatase level. But when you have this kind of scenario, then always think of phosphatemic rickets, hypophosphatemic rickets, and especially do not forget the inheritance pattern, that is X-linked dominant, right? So that you have to remember. So I think that brings us to the end of this question. So this answer is X-linked hypophosphatemic rickets. Now let us come to the other question. A child can walk well holding on to the furniture but is slightly wobbly when walking alone. When shown how to do so, she can pick up a pellet with a neat pincer hold. So this is a very important thing, and release a cube into a cup. She makes sporadic attempts to construct a tower out of 2 cubes. Most likely the following age is. Can the child walk at 4 months? No. Straight away gone. Can a child walk at 6 months? Again gone. Hardly the weight bearing starts at 6 months, so cannot. Now you're caught between 9 months to 1 year. In 9 months also the child would be cruising around furniture. So this is saying can walk well holding on to the furniture. So works well with the 9 months. But the problem is, very importantly, the child picks up a pellet with a neat pincer grasp. Remember, 9 months is the age when the child will be having an immature pincer grasp. Here what is given is a neat pincer grasp. If there is a neat pincer grasp, always come to the 1 year of age, because the pincer grasp becomes neat or becomes mature by 12 months, that is 1 year of age. So that tells us this is 12 years old. Moreover, the child is releasing a cube into the cup. This releasing tendency comes around 1 year of age. The child starts throwing things onto the ground, throwing everything on the ground, which is also referred to as casting. So this typically comes by 12 to 13 months of age. So this again tells you this child is definitely not 9 months but more than 9 months, right? And then sporadic attempts to make a tower 2. Remember, tower of 2 consistently is made at 15 months. But here at 1 year, we would still consider this at 1 year because sporadic means occasional attempts. She is making attempts to make a tower of 2. So that is why here correct would be age of 1 year. Now question is, if you ask me, ma'am, agar 4 months would not have been given and the D next option would have been 15 months, do we go for 15 months because she is making up a tower of 2? No. 15 months the child will be able to walk independently. Here, look here, over here, the child is wobbly when walking alone because at 1 year the child walks with one hand held, cannot walk independently, right? So therefore 15 months is not the age. The correct age in this case would be 1 year. So be very smart. I'm sure you all have ratified your milestones very nicely, but be very smart while attempting the question. So here, even if the 15 months was the option, I would still go for 1 year of age. I've told you why, right? Chalo. Next question is, an infant experiences drooling and abdominal distension soon after birth. Her first feeding causes her to choke and cough and it flows out of the side of her mouth. Tachypnea, bilateral pulmonary rales and intercostal retractions are found on physical examination. Which of the following best describes the esophageal abnormality that most frequently results in these symptoms and signs? So you know the complete scenario very much goes with the diagnosis of tracheoesophageal fistula, where the child is having frothing from the angle of the mouth, and you know, if you have to make a diagnosis, then the most common variety is where the upper end of the esophagus is blindly ending and the lower end is connected to the trachea, right? And which is that variety? This is this variety over here, right? Image D is the variety over here where you get to see this, right? So let us see again over here. These are the different varieties over here. Actually, this is given the name C. This is the third variety in this case, but you just go by the figure. Here they have given image D, so the correct answer would be image D. But if you go by the proper classification, you know, they may confuse you like that as it is given the question. So don't ratify image C, ratify what is there in the image C. So in the image C, you can see this is the most common variety. This is known as type C variety of TEF, where the upper pouch of the esophagus that ends blindly and the lower, which is attached to the stomach, is actually connected to the trachea. So this is the most common variety which we see, and this is, you know, sometimes having two communication would be having, this is the H type variety, right? And the other variety, A variety, there would be both the ends of the esophagus would end blindly with no communication with the trachea. That means there would be no fistula in this case. It is only and only atresia and there is no fistula, right? And here you would get a gasless stomach because there is no communication with the exterior. See, stomach is closed over here, so you get to see a gasless abdomen over here, right? And usually you have a very long gap between the two ends of the esophagus. The other variety is where the upper part would communicate and the lower would not. Again, here we will get to see a small stomach and a gasless abdomen, and often again it has a long gap, right? And third variety we have already discussed. And then there is the fourth variety where we have the both proximal and the distal fistulas, right? So this is known as a double fistula variety. This is the D. D stands for double fistula variety. And then we have the H type, which is the E-shaped variety, right? Which comes to our attention quite later. It is not caught at birth. At birth, therefore, it is a dictum that we pass a feeding tube inside every child, right? And if it is, you know, if it is not going inside, if it is kind of coiling, then we take the radiograph with the feeding tube in situ, and there you get to see a classic coiling over here. So this is the classic tracheoesophageal fistula. How do you make a diagnosis soon after birth, right? So that is it. I think we come to the end of discussion of the questions today. Keep MCQing. All the best. I'm sure you're going to rock well in your exams, right? Thank you. This is Dr. Dipali Gupta signing off, your pediatrics faculty at Allen Next. Bye.
ओके गाइस, तो इस वीडियो में हम CBOT का डिस्कशन करेंगे। तो स्टार्टिंग विद फर्स्ट क्वेश्चन, व्हिच इज द फॉलोइंग कंडीशन कैन मिमिक अस्थमा। तो अब आपको पहले इस क्वेश्चन को देखने से पहले आपको समझना है कि अस्थमा के क्या क्या सिम्टम होते हैं। तो अगर आपके पास कोई पेशेंट है जिसको, इफ यू सी लाइक दिस पर्सन हैविंग अस्थमा, इन दैट केस यू शुड रिमेंबर लाइक देयर मे बी कफ, there will be sputum, on auscultation there will be expiratory wheeze. Then what else you can see in a patient, like sometimes you can see chest tightness, and this can manifest in the form of chest pain. तो क्वेश्चन आपसे क्या पूछा है कि अस्थमा को मिमिक क्या करेगा और क्या होगा? शॉर्टनेस ऑफ ब्रेथ, देयर कैन बी शॉर्टनेस ऑफ ब्रेथ। सो पहले आपके दिमाग में, इन योर ब्रेन यू शुड थिंक ऑफ सिम्टम्स ऑफ अस्थमा. So now let's see the option congestive heart failure. So these are main symptoms which we see in asthma patient. So congestive heart failure can have shortness of breath. Congestive heart failure will have inspiratory cramps, but shortness of breath is there. They may have cough, they may have sometimes sputum, they can also have chest pain. So this symptom, this disease can mimic asthma. Coming to GERD, GERD can cause chest pain, even severe GERD can cause, I can say, a cough also. So that's why GERD can also mimic asthma. Exercise induced dyspnea can mimic exercise induced asthma, because here also you can see dyspnea. Cystic fibrosis, here patient can have sputum, there can be cough, there can also be expiratory wheeze, and sometimes there can be a lot of mucus production, means lot of sputum. So I can say like all these disease will have symptom. All these disease will have symptom which can mimic asthma. So heart failure can mimic asthma. So let us discuss more things, how we can differentiate. In heart failure, there are symptoms which will resemble asthma, but in heart failure you will see like other symptoms, like you can see pedal edema, you can see S3, S4 heart sound, we call them gallop rhythm. So these are, then we can see inspiratory cramps. So by these three features we can differentiate asthma from heart failure. GERD will not have that severe shortness of breath, will not have that expiratory wheeze. So this is how we can differentiate. But you can see all these diseases will have shortness of breath. So that is why I can say the answer for this question will be A, B, C, D. So answer is D. All disease can mimic asthma. Simple. Easy question, easy one. Moving to next, you can see this question. Identify the disease associated with the following histopathological preparation of respiratory specimen. So first thing is you have to make a diagnosis on the specimen. So if I zoom it out, then you can notice something. You can see these spiral structures. These spiral structures, इसको क्या बोलते हैं? इसको हम बोलते हैं Kirschman spiral. So first thing is you should know like what are these are, ये है क्या? तो अगर आपको ये समझ में आ जाएगा, this is Kirschman spirals. So these structures are called as Kirschman spirals. अब इसको समझते हैं, like what they're asking you, where you will see Kirschman spiral. So understand this, asthma is a condition where we will see 3C. आपको 3C दिखती हैं, तो 3C में क्या होगा? We have Kirschman spirals. So मैं short में लिख दे रहा हूँ. Then we can have like cruella bodies. These are made up of like sloughed epithelia and some inflammatory cells. Cruella bodies. And we can have Charcot Leyden crystals. Charcot Leyden crystals. अब इसको समझो एक एक करके, just try to understand. These Charcot Leyden crystals, we call this 3 C's of asthma. So Charcot Leyden crystals you can see in many conditions. So they are seen in asthma, but you can also see this like these crystals in hypersensitive pneumonitis, some diseases where we have hypereosinophilia and some parasite infection. So these are seen in asthma but not specific. Coming to cruella bodies. Cruella bodies, understand. So basically यहाँ पर क्या मिलेगा आपको? Sloughed epithelia and inflammatory cells. So again cruella bodies also you can see in many conditions. So what they're asking you, Kirschman spirals कहाँ मिलेगा? So one thing like we all know, it is definitely seen in asthma. It is definitely seen in asthma. Now understand, these are like a coiled cast structure which are made up of thick mucus. So basically ये Kirschman spirals हैं. Now can we see, sometimes we can also see these in conditions where we have a lot of sputum. So out of given condition, bronchitis is also obstructive disease, and it's like chronic bronchitis type of COPD. तो यहाँ पर भी आपको कशमैन स्पाइरल्स मिल सकते हैं. Heart failure will not have, and cystic fibrosis, you can have sputum production, you can have bronchiectasis, but you will not have bronchitis or asthma. So here you will not see. So that's why like answer for this question will be 2, means A and B. So A and B, they are given in option number B. So इस क्वेश्चन का आंसर क्या होगा? तो याद रखो, कशमैन स्पाइरल्स you will see in asthma and sometime in COPD also, means chronic bronchitis is an example of COPD. So पहले आपको बस समझना है, just you need to see the image, then you need to make your diagnosis. Okay, moving to next question. A patient on following condition will not give a negative methacholine test. Okay, now just try to understand. First of all, you should know what is a methacholine challenge test. So methacholine challenge test, basically it's a provocative test. It's a provocative test used to diagnose asthma. इससे आप अस्थमा का डायग्नोस बनाते हो. So understand this. So basically what I mean by this test, in this test what we can see like FEV1 value will be reduced, and that is measured. So we can see like how much FEV1 is reduced. So if it is like reduced by 20% or more, or then we make a diagnosis of asthma. तो आपसे क्वेश्चन पूछ रहा है which of the following condition will not give a negative methacholine test. So understand, this test is positive in asthma, but sometime suppose we have a person, अगर आपके पास एक patient है like who is on steroid, means जो patient लंबे टाइम से steroid पे, on steroid from long term, or this patient is taking LABA, long acting beta agonist, or this patient is taking mast cell stabilizer like ketotifen, sodium chromoglycate, or this patient, I can say this patient is taking some leukotrienes inhibitors like montelukast, rafirlukast, pralucast. Understand this thing. If this patient is taking any of these things, so here you can see test can be negative. So methacholine challenge test, basically what you are seeing like a methacholine, you are seeing the FEV1 value. तो यहाँ पर आप देखोगे this test can be negative. But a person who is taking SABA, अगर किसी पेशेंट को SABA चल रहा हो, short acting bronchodilator, they will provide only symptomatic relief. So that will not make any difference. वो आपको कुछ difference नहीं देगा, because these are the things which patient is taking from long term. So a patient taking short acting bronchodilator will not give you a negative test. So again, it's a question which is very conceptual. So methacholine challenge test आजकल हम use भी नहीं करते. So now how we make a diagnosis of asthma? Understand this. To make a diagnosis of asthma, what we need? क्या क्या चाहिए आपको? So we can use this test, that is methacholine challenge test. But अब इसको नहीं use करते. So now what we do spirometry, pre and post bronchodilator. A post bronchodilator, understand this. If you see like FEV1 is improved by more than 12% above the baseline or more than 200 ml, then that is something a reversible condition. Reversible means asthma. अगर improve नहीं हुआ, if it is not improved by 12% or more than 200 ml, then it is COPD. So basically आप पेशेंट को ब्रोंकोडायलेटर देखते हो, उसके बाद देखते हो कि इम्प्रूवमेंट हो रहा है कि नहीं. अगर इम्प्रूव हो गया तो रिवर्सिबल, नहीं हुआ तो इरिवर्सिबल. रिवर्सिबल मीन्स COPD. So with this one test we can make a diagnosis of both asthma and we can rule out COPD. So that is why this is the investigation of choice to make a diagnosis of asthma. आप एक्सरे भी करा सकते हो, but again एक्सरे will not give you any classical information. Okay, what is the device in the picture used by patient? बताओ क्या है? What you can see? So this device is called, yes, spacer है. Spacer ऐसा उठा हुआ होता है. It's not a spacer. Digital spirometer है? No. Incentive spirometer, it is peak flow meter. So this device is called peak flow meter. अब इसको समझो एक बार. Now understand this peak flow meter, this will measure the flow rate, right? So this is nothing, it is used to measure the flow rate which any person is exhaling or inhaling. तो इसको हम बोलते हैं peak flow meter. Very important. So simple image based question कभी एग्जाम में नहीं आया तो लेकिन आगे फ्यूचर में आ सकता है, इसलिए this is very very important. Moving to next one. So let us see this question. 53-year-old man. So first hint in the MCQ is age. Comes to medicine OPD with progressive shortness of breath. सांस फूल रही है. From past 10 months. पिछले 10 महीने से फूल रही है, means it's a chronic disease. So just you can see. आप जो कुछ हिंट को अपने दिमाग में लिख लो, ये chronic disease है कोई. That exacerbate during strenuous activity. His work colleagues have similar symptom. तो अब आप देखोगे and when you look at the option, it's a case of pneumoconiosis. Means colleagues को भी हो रही है. He is known case of hypertension and type 2 diabetes. On pulmonary auscultation, diffuse fine crackles. Fine crackles are heard. On doing chest radiograph, nodular densities are seen in the apical region. Nodular densities are seen in the apical region. So apex में अगर कोई disease है, bronchoscopy with transbronchial biopsy of a calcified node. So calcified node भी एक hint है. And under polarized microscopy, you will birefringent particles surrounded by collagen fibers were seen. Exposure of which of the following substances most likely is seen in this patient? So let us see this question. अब जब आप इस क्वेश्चन को देखोगे लाइक ऑर्गेनिक डस्ट से, ऑर्गेनिक डस्ट विल कॉज हाइपरसेंसिटिव न्यूमोनाइटिस. हाइपरसेंसिटिव न्यूमोनाइटिस you will see it will have CD4, CD8 count. This will be affected in a patient who is having hypersensitive pneumonitis. So ये आप बाल में मेजर करोगे. Then beryllium will have non-cacheating granuloma. Beryllium में non-cacheating granuloma मिलेगा. And there will be like it's a rare disease. तो rare disease होगा. तो you can see like some hint related to aerospace industry. अब यहाँ पर ऐसी कोई hint दी नहीं है. Asbestos is ruled out because asbestos will affect base. अगर आप यहाँ से देखोगे apical is involved, apex is involved. Now when I see this question, so what are the points suggesting of silicosis? So देखते हैं इसको एक बार. Silicosis के फेवर में कैसे जाएगा क्वेश्चन, तो देखो एक बार. First hint is patient is having chronic disease. So silicosis कैसे हो सकती है? It can be acute silicosis भी हो सकती है, but in that case you need heavy exposure of silica, but that is rarely seen. Then there is like colleagues having similar episodes, so this can be seen in all these 4 conditions. So that is no hint such. So his known case of hypertension type 2, again कोई hint नहीं मिल रही, but you can notice here apical region and nodular density. This is a very very important hint. So nodules are feature of silica, one thing. Then you can see a calcification in the node is seen. So that calcification you can see hilar lymphadenopathy. We call this a popcorn calcification. So these are features suggestive of silica, and you can notice like the clearly hint is the biggest hint in the MCQ by refringent particles. So this is classically seen for silicosis. So question क्या होगा? It's the case of chronic silicosis, and always remember silicosis will increase the risk of tuberculosis as well. So silicosis increase risk of TB. इसको हम बोलते हैं सिलिको ट्यूबरकुलोसिस. तो आंसर क्या होगा इसका? सिलिका. अगले क्वेश्चन पर चलते हैं. Now see a 5-year-old boy, 5 साल का बच्चा with known case of cystic fibrosis. Cystic fibrosis, तो आप देखोगे सिम्टम क्या होंगे पेशेंट को? cystic fibrosis में bronchiectasis हो सकती है. Then you can notice like patient can have excessive sweating, so that we call this salty baby syndrome. CFTR gene का mutation है. Is brought to emergency with severe shortness of breath. सांस फूल रही है. Fever, chills and productive cough. So these are usual symptoms. Cystic fibrosis में ये होता ही होता है. For past 2 days. The temperature is 39, means fever. BP is 92, ठीक है, उतना कम नहीं है. Pulse is slightly higher. Respiratory rate is 36, बढ़ी हुई है. Tachypnea है, tachycardia है. SpO2 improve हो गया, तो मीन्स पहले कम था. Examination shows intercostal retraction and nasal flaring, and auscultation reveals bibasilar crackles and expiratory wheeze. Crackles भी हैं, expiratory wheeze भी हैं. On chest radiograph, infiltrates were found in the right and lower lobes. So आप देख रहे हो कि right and left lower lobe में infiltrate भी हैं. Child had a history of multiple skin infection requiring incision and drainage with multiple hospitalization for respiratory illness. This is the very important. अब देखो हिस्ट्री है, मल्टीपल मीन्स बार बार स्किन इन्फेक्शन हुआ कोई ना कोई, एंड मल्टीपल हॉस्पिटलाइजेशन. एंटीजन टेस्टिंग फॉर इन्फ्लुएंजा केम आउट टू बी पॉजिटिव, तो साथ में पेशेंट को इन्फ्लुएंजा भी है. सेफिपाइन एंड ओसेल्टामिविर आर एडमिनिस्टर्ड, तो पेशेंट को आप सेफिपाइन दे रहे हो, ओसेल्टामिविर दे रहे हो. फॉलोइंग एंटीबायोटिक्स शुड बी एडमिनिस्टर्ड टू दिस पेशेंट. ओके, पहले तो लाइक टू सॉल्व दिस क्वेश्चन यू शुड नो लाइक व्हाट इज द हिस्ट्री, एंड इन दिस हिस्ट्री व्हाट यू कैन सी, क्या आपको लग रहा है, क्या डायग्नोस होगा, राइट. So you can see like bibasilar crackles है, then I can highlight the hint for you. You can notice कि patient can infiltrate मिल रहे हैं right and lower lobes में, so it is a case of pneumonia. So secondary infection, secondary pneumonia in a patient of cystic fibrosis. Now you should relate pharmacology. Cefepime चल रही है, cefepime क्या है? Cephalosporin. Now tell me cefepime is third generation or fourth generation cephalosporin? So cefepime, pyram, I think these are fourth generation cephalosporin, and oseltamivir ये एंटीवायरल चल रही है. अगर मैं देखता हूँ कि इस बच्चे को निमोनिया है, दिस पेशेंट आई कैन सी इज हैविंग निमोनिया, तो सिस्टिक फाइब्रोसिस पेशेंट कैन डेवलप सूडोमोनास इन्फेक्शन, right? This pseudomonas infection they can also develop infection of Staph aureus, and even sometime there can be infection of MRSA or MSSA. MSSA is methicillin sensitive Staph aureus, MRSA is methicillin resistant Staph aureus. अब देखो जब सेफिपाइम चल रही है, so amoxicillin is no superior than this, इससे ऊपर की दवाई तो नहीं है. Cefepime can target Pseudomonas as well as MSSA, but cefepime cannot target MRSA. Ciprofloxacin mainly target gram-negative bugs. Azithromycin oral we can use whenever we suspect some atypical pneumonia. लेकिन यहाँ पर जो feature है वो कैसे दिख रहे हैं? Infiltrates are clear, so you can see it is a case of typical pneumonia. So basically, when you want to add some antibiotic, patient might be having high-grade fever, so he can land up in sepsis. For this, we should also cover MRSA. तो MRSA का कवर करने के लिए आपको क्या देना पड़ेगा? Vancomycin. So the next antibiotic which I should add in this patient is vancomycin. Again, अगर आपको नहीं पता तो just use your logic. Amoxicillin is no more superior than cefepime, तो इसको मैं नहीं दूंगा. Ciprofloxacin काम ही नहीं करेगी because सारे almost you can see these are gram positive bacteria, so ciprofloxacin is not effective. Azithromycin will target mainly I can say your atypical pneumonia like mycoplasma, then we can use this in viral condition. So यहाँ पर आपको you can add linezolid, or you can add vancomycin, or you can add daptomycin. So these drugs are to be added in this patient. Or you can stop all these and you can switch to meropenem or tazobactam, which are way superior and which are like stronger antibiotic. Because patient को अभी भी अच्छा खासा symptom है, you can see high grade fever, BP is low, tachycardia, tachypnea. So I hope the explanation is clear. So answer will be vancomycin. Okay, then coming to next one. So let us see this next question. So 19-month-old girl is brought to emergency department due to decline in energy level. So she is having fatigue. Over the past 3 months, her parents have observed increased fatigue after play, and this fatigue has progressively worsened. Since transitioning from breast milk at 12 months, now she is 19 months, so it means like if you see 19 minus 12 means almost 7 महीने हो गए. She has been consuming 1 liter of cow milk daily and is a picky eater. Physical examination reveals notable pallor, anemia है, hemoglobin 2.4 very low, and negative stool culture test. The stool culture test is negative. The patient is admitted to hospital for iron deficiency anemia. Iron deficiency anemia हो गया, resulting from poor dietary intake. Picky eater means she is very choosy in eating the things, and receive 20 ml per kg of packed RBC over 3 hours. अब सपोज यहाँ पर नहीं दिया, लेकिन आपको सोचना है कि सपोज 19 मंथ का बच्चा है, तो इसका अगर मैं बोलूँ कि इसका वेट सपोज करो 5 किलो इसका अगर वेट मान लो, तो यू कैन सी लाइक इफ यू डू 5 into 20, So this will be like per kg you are giving, if 5 kg is the weight, so you are giving almost 100 ml of packed RBCs over 3 hours. 1 hour after completion, she developed respiratory distress with a temperature of 37.2, blood pressure of 132, pulse of 162, respiratory rate 46, pulse oximetry indicate saturation pressure 88. So you can see like there are many things. आगे देखते हैं. Patient exhibit grunting with retraction. Grunting with retraction. Tachycardia with an S3 gallop on cardiac examination but no friction rub. And diffuse crackles bilaterally on lung examination. Oxygen is administered. What is the most appropriate step in managing this patient? Now understand, you need to see this question and you will get an idea what is the diagnosis. तो पहले आपको diagnose बनाना है. अब अगर मैं बात करूं तो इस पेशेंट की, if you see this case, so first hint in the MCQ, the age, then you can see she is having a lot of symptoms. इतने सारे symptom है, but from here you can see like hemoglobin is less, anemia है, then you are giving what? You are giving packed RBC. After giving packed RBCs, you can see her condition is deteriorating. She is developing respiratory distress. Right now, when you give blood, after giving blood, you can notice there are two possibilities. So either it could be TRALI. TRALI means transfusion related acute lung injury, और क्या हो सकता है? It could be a TACO. TACO means transfusion associated circulatory overload. Now understand this thing. TRALI is generally seen with massive blood transfusion. Massive blood transfusion. और TRALI में क्या होता है? TRALI means it's a type of ARDS. So patient will develop non-cardiogenic pulmonary edema. But if you see this question, TACO, in TACO what you can see? तो दोनों में difference क्या है? TRALI is something which is a non-cardiogenic, means heart is not involved. And in TACO you will see cardiogenic pulmonary edema. So you can see patient का SpO2 कम है. So first hint in the MCQ is SpO2 is less. Can you see SpO2? SpO2 is 88. Then second hint in the MCQ, I can see crackles. अब आप बोलोगे crackles तो दोनों में मिलेंगी. Crackles तो देखो आंसर तो इन दोनों में से होगा. So TRALI generally बहुत सारा blood चढ़ाने के बाद होगा. TRALI is seen after a lot of blood transfusion. TACO you can see even after little blood transfusion. Crackles you can see in both. SpO2 is decreased in both. Then third hint you can see tachycardia. Again ये भी दोनों के अंदर मिलेगा. So you cannot differentiate. Then grunting. Even grunting you can see in both. So again that is not the answer. Diffuse crackles मैंने लिख दी. और कोई hint दिख रही है आपको? मुझे एक hint दिख गई है. I have seen one hint. Can you see any other hint? I am giving you time. Sometimes in clinical case you just need one hint. आपको सिर्फ एक hint चाहिए. So वो hint आपको दिखी नहीं दिखी अभी तक. Let us see what you can see. What is the hint? That hint is S3 gallop. Very, very important. Now see, when you see a gallop rhythm, S3 gallop, it means heart is involved. So it's a case of TACO. So this is what I can say. It is transfusion associated circulatory overload. So ये TACO का केस है. अब TACO का केस है तो आपको क्या करना है? You have to relieve the congestion, right? So epinephrine we will give whenever patient is having some sort of anaphylaxis. So ऐसा कुछ है नहीं, इससे blood से कोई allergy तो नहीं हुई है. So there is circulatory overload. To get rid of the circulatory overload, what we have to give? We have to give furosemide. Iron overload का है ही नहीं ऐसा कुछ. Respiratory support only, no. So basically it's the patient who is developing, I can say, circulatory overload. So there is congestion because of involvement of heart. Patient heart failure की तरफ जा रहा है. So in that case we have to give diuretic. The diuretic of choice is furosemide. Now you are saying BP इसका देखो ठीक है. So that's why there is no such contraindication. You can continue with furosemide. अगर BP कम होता तो एक तरफ हम BP को बढ़ाते, we will give some inotropes and we will also simultaneously we have to give furosemide. So it's a case of TACO. Okay, let's see. A 39-year-old man, 39 साल का आदमी, present to office after coughing up a small amount of bright red color. He has experienced 4 days of fever, pleuritic chest pain and cough producing thick brown sputum. And despite initiating oral antibiotic for these symptoms 3 days ago, there has been no improvement. Means he have taken antibiotic course but there is no improvement. Patient underwent allogenic stem cell transplantation for acute myeloid leukemia 6 weeks ago. तो 6 हफ्ते पहले क्या हुआ है? Means stem cell transplant complicated by acute graft versus host disease and prolonged neutropenia. So this is the hint in the MCQ. मुझे hint मिल गई. So first hint in the MCQ is like patient is having prolonged neutropenia, means neutrophil counts are less. So when neutrophil counts are less, this will attract many infection. His vital signs are temperature of 39, थोड़ा febrile है, BP is okay, pulse rate of 110, slightly higher, again not that significant. Pulmonary examination reveals right sided crackles. Laboratory result indicate hematocrit of 28. So whenever they are giving hematocrit 28, तो इसको 3 से divide कर दो. तो hemoglobin, if you want to calculate hemoglobin, so hemoglobin is like hemoglobin into 3 is hematocrit. Hemoglobin, suppose my hemoglobin is 15. If you multiply this by 3, so hemoglobin into 3 is hematocrit. So अगर मेरा hemoglobin 15 है, if I multiply this by 3, so my hematocrit will come 45. So यहाँ पर hematocrit दिया हुआ है. So if you divide this by 3, so 28 divided by 3. 28 if you divide by 3, so this will come around 9. So hemoglobin 9 के आसपास है इसका. Platelet of 1,40,000 lesser, leukocyte 1,500 कम आ रहा है. Chest X-ray shows a dense right upper lobe infiltrate that has increased in size compared to the X-ray from 2 days back. So you can see like X-ray is having increased changes बढ़ते जा रहे हैं. A CT scan of the chest reveals multiple nodular lesion with surrounding ground glass opacity in right upper lobe. Sputum gram stain demonstrate inflammatory cells but no organism. What is the most likely diagnosis? Now understand. First hint in the MCQ is neutropenia. So if you see this type of question, अगर आप इस तरीके का question देखोगे, now first hint is sputum gram stain. So let me highlight this. Sputum gram stain में कोई organism नहीं है, तो ये TB rule out हो गया, right? TB rule out हो गया. Now coming to cytomegalovirus, अगर आप देखोगे CMV, so you will not see like these ground glass opacity, you will not see this pneumonitis like feature. आपको ये वाले feature नहीं दिखेंगे upper lobe infiltrate. You can see more and more of interstitial inflammation, right? So understand this thing, and you can see like a patient can later on develop even GGO can occur, but this is not a classical finding. So I can say we have two options, like it could be invasive aspergillosis और इट कुड बी नीमोसिस्टिक जीरो बेसिक न्यूमोनिया. तो अगर मैं बोलूँ लाइक जो हिंट एमसीक्यू में आपको मिल रही दैट इज न्यूट्रोपेनिया. सो न्यूट्रोपेनिया, रिमेंबर दिस, न्यूट्रोपेनिया विल इंक्रीज द ससेप्टेबिलिटी ऑफ मैनी opportunistic infection in your body, and one of the infection is your aspergillus. तो aspergillus का इन्फेक्शन जनरली कब होता है? It is generally seen like in a patient who is suffering from some sort of immunocompromisation. So हो सकता है पेशेंट को न्यूट्रोफिल्स कम हो गए, या पेशेंट is on glucocorticoid therapy or on any immunosuppressant drug, or this patient might be suffering from HIV. Then remember how you will manage this case. So it's a case of invasive aspergillosis. अब इसको ठीक कैसे करोगे? So we have to give voriconazole. So how we manage? We can use voriconazole. Sometime like we can give alternative to this like bosaconazole, or we can add caspofungin or micafungin. So these are the drugs we use to treat this condition. Clear? Okay, so अब आप लोग सोच रहे होगे like in this question you can see these are the hints you can notice like but there is nothing like hemoptysis ऐसा halo sign कुछ नहीं दिया हुआ है. तो halo sign दे रखा है, but you can notice like neutropenia is the biggest hint. So that's why आई विल से न्यूट्रोपेनिया क्यों हो रहा है, बिकॉज पेशेंट का GVHD भी हुआ है, ट्रांसप्लांट भी हुआ है, तो कई टाइम से स्टेरॉइड पे भी होगा. सो दिस आर द हिंट्स सजेस्टिव ऑफ इन्वेसिव एस्परजिलोसिस. मूविंग टू नेक्स्ट वन, विच पैरामीटर्स आर यूज्ड टू कैलकुलेट मैड्रिड स्कोर. मैड्रिड स्कोर क्या था? CBI, क्रेटिनिन, बिलिरुबिन, INR. सो ये जो आपके सामने लिखा दिस वन, दिस इज मेल्ट, दिस इज मेल्ट स्कोर. क्लियर? सो आफ्टर अ मेल्ट स्कोर, if you see the next score which is important, like they ask in exam is BI, just BI. BI में क्या क्या आएगा? You can see bilirubin and INR. So this is your Madrid's discriminant factor. सो कहीं पर बी और आई दिया हुआ है ऑप्शन में, बिलिरुबिन दिया हुआ है। आई की INR की जगह क्या, आई मीन्स they can give you I means INR, or if INR is not given they can give you PT. So answer will be C. Now if you see BMI AST-ALT ratio diabetes, इसको बोलते हैं बार्ड स्कोर. दिस इज बार्ड स्कोर एंड दिस बार्ड स्कोर कहाँ पर मैंने बताया था आपको बार्ड स्कोर. बार्ड स्कोर इज यूज टू डायग्नोस NAFLD एंड NASH. अगर किसी को NAFLD NASH है तो क्या होगा, बार्ड स्कोर. देन यू कैन नोटिस लाइक SBI जो पैरामीटर मैंने यहाँ लिखा हुआ है, दिस इज SBI. तो मैं एक बार इसको थोड़ा सा आपको ऐसे करके दिखा देता हूँ. यू कैन नोटिस दिस इज फर्स्ट थिंग SBI, SGOT, बिलिरुबिन, INR. SBI, दिस इज CBI. CBI मैंने आपको बताया था MELD स्कोर में, एंड MELD स्कोर इज स्कोर फॉर CLD. CBI, SBI मीन्स इट इज SGOT, बिलिरुबिन, INR. तो ये हमने पढ़ा था विल्सन डिसीज में. तो दिस इज फॉर लाइक वी कॉल दिस नेजर prognostic index. Means we need to decide like which patient of Wilson need medical management and which patient need transplant. This is BI. So this is Madry's discriminant factor. कहाँ यूज करते हैं इसको? We use this in alcoholic hepatitis. And last is this BARD score. BARD. This is BARD score. BARD score means BMI, AST-ALT, R means ratio, D is diabetes. This is for non-alcoholic fatty liver disease. So ये सारे स्कोर आपको याद रखने हैं. तो मैट्रिक्स व्हाट वी हैव प्रोथ्रोम्बिन टाइम मींस बिलिरुबिन एंड INR. INR की जगह क्या हो सकता है, प्रोथ्रोम्बिन टाइम. मूविंग टू नेक्स्ट वन. All are histopathological changes in autoimmune hepatitis. So AIH is autoimmune hepatitis. ओके इसको देखते हैं. मैंने आपको बताया था, आई टोल्ड यू लाइक autoimmune hepatitis is a condition which is more in females, and it's a condition which rarely will transform into CLD. But suppose if it get transformed into CLD, then we need to do liver transplant. But since we cannot remove autoimmune antibodies, so this can occur even after transplant. So it can reoccur. It can reoccur even आफ्टर ट्रांसप्लांट. तो ये ट्रांसप्लांट के बाद भी हो सकती है. सो लेट्स सी ऑटोइम्यून डिसीज है. सो कैन वी सी लिम्फोप्लाज्मोसाइटिक इन्फिल्ट्रेट. सो यू कैन सी दिस लिम्फोप्लाज्मोसाइटिक इन्फिल्ट्रेट यू कैन सी इन एनी ऑटोइम्यून कंडीशन. ये आपको किसी के अंदर मिल सकते हैं, किसी भी ऑटोइम्यून कंडीशन के अंदर. नाउ अंडरस्टैंड, यू कैन सी लाइक इंटरफेस हेपेटाइटिस. So interface hepatitis, like we call this, you can see some periportal lesion, right? That may spare biliary tree. So ये भी आपको मिलता है. Peripolysis, ये मैंने I think I told you, like when one cell go into another cell, we call this like presence of an intact cell within the cytoplasm of other cells, means one cell moving into another. That's a feature. Councilman bodies, these are apoptotic or dead hepatocytes. Apoptotic or dead hepatocytes. And where we see this? These are seen in acute viral hepatitis. ये कहाँ मिलेगी? Acute viral hepatitis में. तो ये आपको याद रखना है. Autoimmune hepatitis. Anterior uveitis is seen in all except. So again, it's a tricky question. देखो SLE में uveitis होता है. Even like ulcerative colitis can have uveitis. Basic disease में तो हमने पढ़ा था uveitis होता है. Rheumatoid arthritis में अगर होता then I could have told you. So rheumatoid arthritis will not have anterior uveitis. So rheumatoid arthritis में इसके अलावा क्या होगा, इसकी जगह keratoconjunctivitis होगी. सिक्का syndrome, dryness होता है. So if I want to tell you like what are the condition where we can see anterior uveitis. So anterior uveitis you can see in many condition. You can see this in ankylosing spondylitis. So you can see this in SLE. तो मैंने आपको बताया था एक बार सीरो नेगेटिव अर्थराइटिस. सीरो नेगेटिव में क्या क्या आता है? जयपुर मीन्स JRA, जुवेनाइल रूमेटॉइड अर्थराइटिस, एंकालोसिंग स्पॉन्डिलाइटिस, IBD एसोसिएटेड. arthritis, psoriatic arthritis, undifferentiated, and reactive arthritis. Reactive को क्या बोलते हैं? Reactive arthritis or Ritter syndrome. So these are called seronegative. Seronegative means here rheumatoid factor will be negative, but these are positive for HLA-B27. So uveitis is a feature of these seronegative arthritis. Rheumatoid arthritis is rheumatoid factor positive, उसमें नहीं मिलेगा. इसके अलावा other than this you can see this uveitis in SLE patient, you can also see this in leprosy. So याद रखना these are the condition where you will see anterior uveitis. तो जितने भी seronegative हैं, these are called seronegative, and these two. Ulcerative colitis कहाँ दिया हुआ है? लिखा हुआ है यहाँ पे. Yes, this IBD associated means Crohn's disease, ulcerative colitis, both can have anterior uveitis. Clear? Okay, moving to next one. तो ये मैंने क्वेश्चन जानबूझ के डालता जिससे आपसे गलती हो. And I know some of you made mistake. A patient has history of multiple episodes of painful swelling of ankles and big toe, which is relieved with NSAIDs. So diagnosis is gout. All drugs should be avoided except. Understand? Cyclosporin is a drug which can precipitate gout attack. So we will not use this drug. पायराजिनामाइड से भी गाउट का अटैक होता है, तो ये भी आपको नहीं देना है. अब रही बात फ्यूरोसेमाइड की और हाई डोज सैलिसिलेट की. सो रिमेंबर फ्यूरोसेमाइड इज अ डायूरेटिक. इवन लाइक दिस फ्यूरोसेमाइड कैन आल्सो ट्रिगर द अटैक, तो ये भी करा सकता है. तो अब जो गलती आपसे हुई है वो ये हुई है. तो रिमेंबर लो डोज सैलिसिलेट will increase uric acid, so they should be avoided. But remember this is on higher dose you can give. So इसको याद रखो कि देखो यूरिक एसिड जमा हो रहा है आपके जॉइंट्स के अंदर, ब्लड में ज़्यादा नहीं है. इफ़ यू गिव फ्यूरोसेमाइड देन दैट विल डिक्रीज योर ब्लड यूरिक एसिड. इज इट क्लियर? तो फ्यूरोसेमाइड जनरली दे आर नॉट नीडेड. हाई डोज सैलिसिलेट, अगर आप सैलिसिलेट नॉर्मल डोज में देते हो दैट विल इंक्रीज uric acid, but high dose it is not a contraindication, so that's why something. So remember इसको avoid नहीं करना है. So ये I want to tell you this thing, like in gout patient we can use high dose aspirin, high dose salicylate or high dose aspirin, we can use this. Okay, coming to next. A 30-year-old woman present with recurrent oral genital ulceration. Inflammatory skin reaction was observed after intradermal administration of normal saline. So basically diagnosis बन गया. Recurrent oral ulcer, recurrent genital ulcer, and positive pathology test. ये line का मतलब क्या है? The meaning of this line is positive pathology test. So diagnosis is Behcet syndrome. Right? Now they are asking you which of the following statement is incorrect. Associated with HLA-B51, Behcet syndrome is classically associated with this. Can you see peripheral vein thrombosis? Yes. Can you see erythema nodosum? Yes. ये भी होता है इसके अंदर. Associated with painless scarring oral ulcer. Painless होता है यहाँ पे. Understand this. Remember here both these ulcers, these are painful, not painless. So this is a wrong statement. So what you have to remember, you will see painful, not painless. So answer for this question will be A. Clear? तो यहाँ पर ये option गलत दिया हुआ है. तो answer is A. Moving to next one. A patient from hilly areas का patient है, suppose मनाली का रहने वाला, was referred with a partial small bowel obstruction confirmed on CACT. Conservative management was tried for a week, but he continued to deteriorate and was taken up for emergency laparotomy. On post-operative day 7, he developed atrial fibrillation. Investigation revealed elevated free 3 and free T4. What is the most probable cause? इसको समझो एक बार. Now just try to understand this. Now understand, you can see like here what is the hint in this question? आपको कुछ hint समझ में आ रही है? So patient came with bowel obstruction. Bowel obstruction था, CCT में confirm किया, right? So 1 week we tried conservative management, but he continued to deteriorate and was taken to emergency laparotomy. On post-operative day 7, he developed atrial fibrillation and elevated free T3 and free T4. So you can see what you can notice in this case. You can notice something. The biggest mistake or biggest hint I can say कि this patient is developed like ये CCT जो उसको दिया है, because of CCT you are giving them contrast. So contrast यहाँ पे जो दिया है, right? So because of this contrast, like he is developing hyperthyroidism. So just remember the CCT. So probabilities is CCT में हम contrast use कर रहे हैं, right? And following this contrast, you can notice his T3 नहीं लिखूंगा मैं, FT3 लिखूंगा, means free form. Following this contrast, his free form of T3 and free form of T4 have increased. क्या हो गया एकदम से कंट्रास्ट देते ही आप देखोगे T3 T4 बढ़ गया. So what is this? It is Wolff-Chaikoff effect? No, it is plumber. Plumber disease क्या होती है? Plumber disease is toxic multinodular goiter. Goiter तो कोई बना नहीं. Is it based disease? No. So it is a Jod based phenomena. So understand this thing. So it is Jod based phenomena, means you are giving something, then this is increasing your T3 T4 level. So जोड़ से जुड़ रहा है, ज़्यादा हो रहा है, तो T3 T4 ज़्यादा हो जा रहा है, तो J4 जोड़ J4 ज़्यादा हो जाना. Simple. मोस्ट अबंडेंट हार्मोन प्रोड्यूस बाय पिट्यूटरी ग्लैंड. बताओ, सिंपल है तो इजी क्वेश्चन है. सबसे ज़्यादा क्या होता है? पिट्यूटरी विल रिलीज फ्लैट पिग. फ्लैट पिग means FSH, LH, ACTH, TSH, prolactin, growth hormone. Understand the main cells, the major cells are somatotropes and they produce growth hormone. So most important or most abundant hormone produced by pituitary gland will be growth hormone. Important. Following feature will you expect to see in a patient with acromegaly? So in acromegaly you will see impaired glucose tolerance, means क्या उसको pre-diabetes होती है, सही बात है. क्या पेशेंट को गैलेक्टोरिया होगा? अगर फीमेल पेशेंट होगी, मेल फीमेल मेंशन, तो ऑफ कोर्स गैलेक्टोरिया भी होगा, हो सकता है. कैन पेशेंट डेवलप हाइपरटेंशन? यस. कैन यू सी सप्रेशन ऑफ ग्रोथ हार्मोन विथ ग्लूकोज? सो व्हाट वी डू, हम पेशेंट को ग्लूकोज देते हैं, 75 ग्राम ग्लूकोज, वी कॉल दिस OGTT. So even after giving 75 gram glucose, what is seen in acromegaly, you will see growth hormone fail to suppress, fail to fall. ये suppress नहीं होता. So this is a wrong statement. Serum phosphate level is low. No, it can be normal. It can also be like increased, but not low. So what you will see, तो आपको देखोगे first 3 statement. If you say this question, तो first पहले के शुरू के तीनों statement सही हैं, तो answer will be 1, 2, 3. 1, 2, 3 means A. Simple. 35-year-old man was admitted following a crush injury. Crush injury हो गई to his left leg. 2 days later, his urine plasma creatinine levels are less than 20. What is the likely cause? Simple है तो easy question है. अब देखो crush injury हुई है, crush injury to his left leg. So left leg में injury हुई है, crush, तो myoglobin निकलेगा muscle से, muscles will release myoglobin. So there will be myoglobinuria. So that is due to rhabdomyolysis. Right. So there are no other features suggestive of hypovolemia. कोई liver damage की पुरानी history नहीं है, so it's not hepatorenal. No other features suggestive of heart failure. No pedal edema, no S3 as for gallop rhythm, no tender hepatomegaly. Then you can see like no PND or dyspnea. ऐसा कुछ है ही नहीं. So it's simple, easy. I think this is one of the easy question. Rhabdomyolysis. So क्या हो रहा है basically? Crush injury will produce rhabdomyolysis. Ultimately there will be more value of CPK. In CPK mm बढ़ जाएगा. So it's a simple case of rhabdomyolysis. Moving to next one. A 1.5-year-old child. 1.5-year-old child is brought to OPD with complaint of blood in his urine. Hematuria. Hypertension. Examination reveals a non-tender mass in left flank that doesn't cross the midline. Imaging reveals a left renal tumor. What is the most likely diagnosis? So again, this is also a simple one. अगर मैं बात करूँ इस question की, if I talk about this question, you can see like out of these 4 options, there are 2 tumors which we usually see in children. So remember, all blastoma, they are seen in children. RCC is a tumor which we will see like in either early 20s. So it is due to a VHL gene mutation and is mostly bilateral. VHL is von Hippel-Linde gene. RCC can be seen in elderly people, old age, because of increased age, because of smoking. So these are risk factors for RCC. सो आरसीसी या तो देखो 20-30 साल के बच्चों में होगा, 20-30 साल के आदमी में, या फिर ये 50 साल के बाद होगा. Angiomyolipoma is a rare benign tumor, right? And this benign tumor is associated with tuberous sclerosis. This is associated with tuberous sclerosis, very rare, and it is a benign tumor. RCC is malignant, and I can say it is most common malignant kidney tumor in adult. अब दो ऑप्शन बच गए, नेफ्रोब्लास्टोमा और न्यूरोब्लास्टोमा. Now, if I talk about neuroblastoma, so neuroblastoma, this will originate from where? To understand this, neuroblastoma, it's a tumor that's originating from adrenal medulla. And most common tumor of kidney in pediatrics will be nephroblastoma. And nephroblastoma is also called as Wilms tumor. So, अगर पेशेंट को हेमाचूरिया वाले फीचर हैं, you can see. So, adrenal medulla tumor will not have these features. So, you will notice like it's a case of nephroblastoma or Wilms tumor. So, pain, right, mass and hematuria. So, pain mentioned here, but you can see hematuria is there, mass is there. The most common tumor in pediatrics, that will be Wilms tumor. So, this is a feature, these are the feature in children. Same feature you can see in adult, that will be seen in RCC. तो ये pediatrics का tumor है, इसको बोलते हैं Wilms tumor. Just remember, Wilms tumor is associated with two syndrome. One is three syndrome. One is called Wager syndrome. So Wilms के साथ में कुछ syndrome होते हैं. One is called Wilms tumor, aniridia, genitourinary defect, and retarded growth. Wilms, aniridia means absence of iris. So this is Wilms, aniridia, genitourinary defect, and retarded mentally means retarded growth. Second syndrome which you have to remember, second syndrome जो Wilms के साथ होगा, that is called Beckwith-Wiedemann syndrome. Beckwith-Wiedemann syndrome. And third is Denny-Drash syndrome. So Beckwith-Wiedemann syndrome will have organomegaly. Denny-Drash में क्या होगा? Pseudohermaphroditism. So these are the same syndrome which you have to remember. Patient diagnosed with FSGS. Which variant has worst prognosis? So FSGS के type होते हैं, cellular type, nose tip variant is also called nose tip type, collapsing type, perihalar type. So out of this, remember this collapsing type is seen in HIV, and this collapsing type is having worst prognosis. So focal segmented glomerulosclerosis के type होते हैं, collapsing type is in HIV. This collapsing type जो HIV के अंदर मिलता है, इसको हम बोलते हैं HIVAN. HIVAN means HIV associated nephropathy. Very, very important. Okay, moving to next one. What is predominant electrolyte abnormalities in a patient with advanced CKD? So advanced CKD में क्या मिलेगा आपको? Okay, hypokalemia मिलेगा advanced CKD में, hypokalemia मिलेगा नहीं, hyperkalemia मिलेगा, right? Hyponatremia you can see, but again it is not that classical feature. Now coming to hagma and nagma. This is hagma. This is nagma. So just try to understand this. So generally what we can see like hyponatremia हो सकता है, but hypokalemia generally नहीं होता. Hypokalemia कब होता है? When you have a CKD patient and you are doing dialysis. तो कभी कभी dialysis के बाद hypokalemia भी हो सकता है. So most people with CKD will have hyperkalemia. Hypokalemia कब होगा? Suppose like you are doing dialysis. और dialysis में आपने like you have started dialysis and you forgot to stop other like K binders and everything. So patient को potassium एकदम से drop कर गया. Now hagma nagma, what you can say, दोनों होती हैं. But if you see like they are asking you advanced disease, what you will see in advanced cases में आपको क्या मिलेगा? Hagma. So hagma nagma means you can see a normal NN gap, you can also see a high NN gap. दोनों हो सकता है. ये भी हमने पढ़ा था. I can like in our next class notes we have discussed this topic, simple one. Okay, moving to next one. A 56-year-old man present with fever and abdominal pain for 2 days. He has been on peritoneal dialysis. Fever, abdominal pain, peritoneal dialysis for past 1 year. Abdominal distension guarding and rebound tenderness. So what is the diagnosis? पहले मुझे diagnose बनाओ. You can see abdominal distension, guarding, rebound tenderness. इसको बोलते हैं Blumberg sign. This rebound tenderness. So diagnose क्या बन गया? It's a case of peritonitis. See once again, fever है, abdominal pain है, gorging when you see this word rebound tenderness or Blumberg sign. So these are feature of peritonitis. So they are asking you like what is most common cause of this condition. So अब आपको देखना है कि peritonitis का common cause क्या होता है ना. Try to answer. So when you suspect a patient after peritoneal dialysis, this is also the hint. So in patient after peritoneal dialysis, you will see like he will develop peritonitis due to gram-positive cocci. So remember, gram-positive cocci are the main bacteria which can cause this. So again, this is again a straightforward question. Following is incorrect about rejection reaction following a kidney transplant. What is incorrect? तो इसको देखते हैं एक बार. Acute rejection can occur due to both type 4 and type 2 hypersensitive reaction. मैंने आपको बताया था like we have hyperacute which is due to like preformed antibody. Acute and chronic are both type 2 and 4. This line I told you, and so it's the correct statement. So we have graft rejection. It can be hyperacute, that is due to preformed antibody, which is a type 2 hypersensitivity, and then we have acute, that is due to T cells, so which is a mixture of type 2 and 4, and then we have chronic. In chronic, you can see there is fibrosis and vasculopathy. That fibrosis and vasculopathy will lead to more sclerosis and fibrosis in the newly transplanted kidney and the vessels. So here it's the correct statement. Hyperacute rejection is a type of type 2 hypersensitivity. ये भी मैं यहाँ लिख ही देता हूँ. So we have hyperacute, acute and chronic. So hyperacute, remember it's a type 2 hypersensitivity. फिर आप देखोगे acute is 2 plus 4. Chronic is also 2 plus 4. So hyperacute is due to preformed antibody. Acute is due to T cells, and chronic is due to fibrosis and vasculopathy. Fibrosis and vasculopathy. तो ये भी सही स्टेटमेंट है. Induction therapy for prophylaxis of rejection is cyclosporin, azathioprine, prednisolone. सही लग रहा है तुम्हें, ये गलत लग रहा है? Induction therapy का मतलब क्या होता है? Like you understand this? Suppose when you are doing a transplant, whenever there is a poor HLA match, so what we give, देखो transplant में इतना waiting period है, so we are doing induction therapy. So induction therapy is something which we will give whenever there is a poor HLA matching. लेकिन एक therapy होती है जिसको बोलते हैं maintenance therapy. So maintenance therapy is something which we give to all patients. So understand this thing. Induction therapy में आप क्या use करते हो? So understand in induction therapy we can use alemtuzumab, we can use ATG. ये जो लाइन लिखी है ये यहाँ से लाइन तो ठीक है, but this is not induction therapy, it is maintenance therapy. So this is why it's the wrong statement. Let me see one more option. Alemtuzumab is monoclonal antibody against CD52. It's a correct statement. So देखो मैं इसको ऐसे लिख देता हूँ to solve this. Acute rejection can occur. It is a correct statement. So it's not the answer. Hyperacute is type 2. It's a correct statement. So not the answer. It's a wrong statement. So this is the answer, and this is also a correct statement. ये anti-CD52 ही होती है, right? So induction therapy में आप क्या दे सकते हो? You can use high dose steroid, you can use alemtuzumab, you can use anti-thymocyte globulin, and मैंने एक drug आपको बताया था. We can use some more drugs like basiliximab. So these are the drugs which we can use. So mainly जो आपको याद रखना है induction therapy में ATG, anti-thymocyte globulin, and alemtuzumab. Most common site of Berry aneurysm. ये easy question है. Vertebral artery is not a common site. Bifurcation of MC is not a common site. Junction of PCA with anterocarotid, no. So most common site is junction of ACA with tensiocerebral artery. तो ये क्वेश्चन तो बार बार पूछते एग्जाम में, इसलिए मैंने लिखा है. एंड आई एम थिंकिंग लाइक इट्स एन एक्सपेक्टेड क्वेश्चन इन दिस अटेम्प्ट. वेरी वेरी इंपॉर्टेंट. ओके, अगला चलते हैं. इन द गुलियन-बारे सिंड्रोम ड्यू टू एंटीसेन इन्फेक्शन विद कैम्पेलोबैक्टर जेजुनी, ऑटो एंटीबॉडीज आर मोस्ट कॉमनली डायरेक्टेड अगेंस्ट द फॉलोइंग. सो बेसिकली आपसे पूछ रहा है कि ऑटो एंटीबॉडीज कॉमनली कौन सी होती हैं. तो मोस्ट कॉमन एंटीबॉडी यू विल सी विल बी IgG क्लास, एंड दिस एंटीबॉडीज आर एंटी GM1. So anti GM1, these are most common. अगर मैं बात करूँ GD1A, सो अंडरस्टैंड दिस GD1A ये कहीं पे मिलती है आपको? GBS के कुछ वेरिएंट होते हैं, उसका एक वेरिएंट होता है, उसको बोलते हैं अमन, मेरे नाम से ही है, एक्यूट मोटर एक्सोनल न्यूरोपैथी। सो मैं फिर से एक बार याद दिला रहा हूँ कुछ GBS के कुछ टाइप मैंने आपको बताए थे, एक्यूट टाइप, क्रोनिक टाइप। क्रोनिक इज कॉल्ड CIDP, क्रोनिक इन्फ्लेमेटरी डीमाइलेटिंग पॉलीन्यूरोपैथी। एक्यूट में मोस्ट कॉमन टाइप is CIDP, but in acute we have few more types, like we can have AMN, acute motor axonal neuropathy, acute motor sensory axonal neuropathy AMSN, and we have Miller-Fisher syndrome. Miller-Fisher syndrome. So देखो most common antibody, most common type is CIDP, and here you will see anti-GM1. If I talk about AMN, here you will see GD1A. यहाँ पर क्या मिलेगा? GD1A. जो GD1B, if you see this 1B is seen sometime in AMSN, and sometime like we call this, एक और टाइप होता है ataxic type, उसमें मिल जाएगा ये. So we like again it's a very rare type, we call it ataxic type. And last one you can see like this is GalNAc GD1A, ये भी एक rare type होता है, that is seen in very like pure motor type or pure axonal type. So that is again a rare one. So this ये rare होती है. So most common antibody they are asking you, that will be antibodies against GM1. Simple. Following statement is false regarding demyelinating. Demyelinating हमने पढ़े थे, like we have diseases like multiple sclerosis. Yes, it is most common. What else? We have progressive multifocal leukoencephalopathy. और कौन सी पढ़ी थी? subacute sclerosing panencephalitis. Then we have studied like a disease, इसको बोलते हैं OATS, osmotic demyelination syndrome, और central pontine myelinolysis. So multiple sclerosis, progressive multifocal leukoencephalitis, then we have subacute sclerosing panencephalitis, osmotic demyelination syndrome और central pontine myelinolysis. और क्या पढ़ा था हमने? Then we have studied some of the like disease in biochemistry, like leukodystrophies. So leukodystrophies like metachromatic leukodystrophies, aryl sulfatase deficiencies, right? Then we have adrenoleukodystrophy. So अब इसको देखते हैं, फॉल्स स्टेटमेंट पूछा है आपसे. दे आर इम्यून मीडिएटेड. मोस्ट कॉमन इज मल्टीपल स्क्लेरोसिस, इसमें तो एंटीबॉडी होती है. तो यस, दैट्स द करेक्ट स्टेटमेंट. कॉमनली प्रेजेंटेड, सो जितनी भी ऑटोइम्यून डिसीज होती हैं वो अडल्टहुड में तो आती हैं. तो मोस्ट ऑफ द ऑटोइम्यून कंडीशन दे को प्रेजेंट इन अडल्टहुड. अगेन मोस्ट कॉमन इज MS. ये क्या हो गया? अब मुझे पता है तीन तो करेक्ट स्टेटमेंट है, तो मुझे पता है तो तीनों करेक्ट है. अब चौथा देखते हैं. It is caused by biochemical abnormality of myelin. अब ये मुझे बताओ, ये सही स्टेटमेंट है कि नहीं है? बताओ. Understand this thing. The disease which occur due to biochemical abnormality of myelin, उनको बोलते हैं dysmyelinating disorders. So this is dysmyelinating disorder. And disease which occur due to autoimmunity, due to removal of myelin, right? Due to some antibody mediated response that is causing like loss of myelin, उसको बोलते हैं demyelinating. Is it clear? So this is, I can say, a false statement. So it is not caused by biochemical abnormality of myelin. So myelin तो है, but उसको कोई auto antibodies निकाल रही हैं, right? Coming to next one. Following condition will you suspect in a patient who has bladder dysfunction early in progression of disease? मीन्स ब्लैडर फंक्शन अर्ली आ गया. तो अब इसको देखो, इफ यू सी दिस GBS, गिलियन-बारे सिंड्रोम एंड ALS, इन दीज टू कंडीशन, GBS में तो बहुत रेयर होता है एंड ALS में तो ना के बराबर होता है. तो दीज टू कंडीशन यू कैन सी, इन दीज टू कंडीशन ब्लैडर इन्वॉल्वमेंट इज वेरी लेस, मीन्स अनलाइकली. Now coming to cauda equina and conus medullaris. So understand this thing. If you see like in cauda equina syndrome, there is sparing of bladder control. So bladder control यहाँ पर भी normal होता है. तो by ruling out what we see conus medullaris. तो GBS में बहुत rare होता है, बहुत rare. ALS में ना के बराबर cauda equina में होता ही नहीं. So answer will be conus medullaris syndrome. You can see early dysfunction will be seen in conus medullaris syndrome. All are narrow complex tachycardia except. So देखो जितने भी एट्रियल, PSVT इज नैरो कॉम्प्लेक्स, यस. फिब्रिलेशन नैरो कॉम्प्लेक्स होता है, यस. मैट होता है, यस. तो नैरो कॉम्प्लेक्स कौन से होते हैं? all the supraventricular or atrial. ये सारे नैरो कॉम्प्लेक्स होते हैं. वेंट्रिकल वाले कैसे होते हैं? ब्रॉड क्यूआरएस होते हैं. सिंपल. Identify the marked feature in the patient diagnosed with VT. So VT means ventricular tachycardia. So if you see this feature, so VT will have something. So देखो, if you see this structure CCG, you can see. If you see this like QRST, P, QRST, then let me just label this to make you a better understanding here. You can see this is P. एकदम से पूरी बीट नॉर्मल आ रही है, तो अगर नॉर्मल आ जाती है उसको बोलते हैं कैप्चर बीट, राइट. बट इफ यू सी हियर, दिस इज लाइक QRS, P इज फिक्स्ड हियर, तो अगला T QRS आपस में फ्यूज कर गया है, तो दिस बीट इज कॉल्ड फ्यूजन बीट. This beat will be called fusion beat. So understand this thing. What I mean by fusion beat, you can see. Let's समझो इसको मतलब एक बार. Capture beat means whenever you see a normal QRS, एकदम से like a heart is capturing the rhythm. So when you see a normal QRS means पूरा proper आपको दिखेगा P QRS T. So that is called a capture beat. In between abnormal, all of a sudden you get a normal. We call this capture beat. But when they are fused with each other, we call this fusion beat. So all these are features. All these are features of VT. But remember, fusion beat is something when you see like P is fused with QRS and T. इसको बोलते हैं fusion beat. Okay, most common protein mutation seen in hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy में most common is beta myosin heavy chain. Beta नहीं लगाया तो आंसर फिर भी ये होगा. अल्फा नहीं होगा, लेकिन आंसर होना चाहिए बीटा मायोसिन हेवी चेन, लेकिन बीटा उन्होंने लगाया नहीं. कार्डियक ट्रोपोनिन नो. टाइटिन म्यूटेशन याद रखना. टाइटिन म्यूटेशन सीन इन DCMP. टाइटिन का म्यूटेशन कहाँ होता है? DCMP में डायलेटेड कार्डियोमायोपैथी. A patient present to emergency with symptom of unstable angina. ECG done in pain-free interval. Biphasic T wave in precordial leads without ST changes. Cardiac troponins are normal. Angiography revealed stenosis of proximal LAD. What is the likely diagnosis? Now understand, Barlow syndrome. Barlow syndrome is mitral valve prolapse. So it will not have this like this type of finding. Biphasic T waves नहीं होगा. So ये actually a classical finding है. It's a classical finding which we see. Or when I told you this thing, like Brugada syndrome will have like a curved pattern of ST elevation. Broken heart syndrome is like Takotsubo cardiomyopathy, where you can see markers will be elevated and you can see sometimes ST elevation also. But this biphasic T waves in precordial lead without ST changes, it is a pattern which is considered MI equivalent, and this pattern is what we call this valence pattern. Simple. Which following is criteria for severe aortic regurgitation in transthoracic Doppler echocardiography. Vena contracta क्या होता है इसको देखो एक बार. Like a part with the maximum jet velocity is called vena contracta. So vena contracta is less than 0.6. So vena contracta less than नहीं होता, अगर ये more than होता है. So this is more than 0.6 centimeter. That is considered severe. So it is not a criteria. Clear? Regurgitant fraction less than 66. ये ejection fraction नहीं, it is regurgitant fraction. If rigor means more speed, if it is more, then more severe will be disease. So this is again, it should be more than 66, not less than. Regurgitant volume more than 60 ml per beat. So this is correct statement. आगे अगला ऑप्शन पढ़ते हैं. Effective regurgitant orifice less than 0.3 square centimeter. Orifice means if you see this is wall, this orifice, more the orifice more जितना बड़ा होगा उतना chance होगा regurgitation का. So again this is also more, not less. So answer will be regurgitant volume more than 60 ml per beat. So this is like a criteria in severe AR. Okay, ABG का क्वेश्चन है. pH 7.55. pH है 7.55. 7.35 to 7.45 normal. बड़ा हुआ है pH. PCO2. This is PCO2 is 54. ये भी बड़ा हुआ है. Same direction, right? So disorder is metabolic. It is not mixed because you will not, अब देखो bicarbonate बढ़ रहा है, it means there is some sort of compensation. So bicarbonate is increasing, it means there is some sort of compensation. So it's a metabolic alkalosis with compensatory respiratory acidosis, right? So you can see like both are in same direction, so it's always metabolic. pH is increased, so it is alkalosis. And you can see bicarbonate from 26 it is going to 40. It means it is increased. It means there is some sort of compensation going on. So it's a case of metabolic alkalosis with compensatory respiratory acidosis. So answer will be B. Okay, अगला बताओ. Following ECG depict which is the following condition. So you can see PQRS. उसके बाद बार बार क्या हो रहा है, QRS extra आते जा रहा है. So if you see this, you can see PQRS, you can see an extra QRS. This is one complete. Then again you can see an extra QRS. So this extra QRS means what we call this Biochemistry. Means extra means it's a type of VPC, means VPC, ventricular premature beats. Okay, PSVT में क्या होगा, narrow complex होगा, right? And you can see RR interval will be regular. Ventricular Biochemistry, it is not P pulmonal. P pulmonal तो कुछ ऐसे दिखेगी. Reentrant, no. So it is a case of ventricular Biochemistry. So I hope we have discussed these questions. So even like you have your booklet with you. So review your questions. So I hope you enjoyed this session. I know it was a pretty tough thing. थोड़ा सा paper को tough बनाया गया था intentionally because don't panic when you see this toughness, because it's medicine. There are many more topics in medicine which sometime I want to cover through these MCQs, right? So it's a big subject. You cannot finish everything with entire Harrison in 7-8 days. So these are some those topics which I want you to study, because in exam they can ask. These are like future questions which they can ask in exam, because these questions have been testing on INI, CET and super specialty exams. Some of these topics I have taken, and some of these topics are repeated. So here a student get confused on alpha or beta, so that's why I intentionally want you to get confused. So again, if you are scoring a good mark in this paper, that's very good. It means your preparation is up to the mark. If you are scoring less, then don't afraid. It's slightly on a tougher side. Thank you so much. Keep working hard. Bye-bye.
Hi friends, now we are starting up with the explanation of this particular CBoT for the Fmge exam. And as you know that microbiology is a subject which integrates with many others. So the real aim is that you get a hint regarding some of the questions which are like might come in the integrated fashion also. And if we could prove what helpful in your journey, that's what the main aim is. Okay, so let's start up with the first one. In the context of assessing the efficacy of the given instrument, which biological indicator is commonly used to ensure the complete sterilization of the medical instruments and the equipment by this? So one thing is for sure that what it is autoclave. Okay, and in the autoclave we already know that this is which type of sterilization? Yes, moist heat sterilization. What is the temperature? 121 for 15 minutes at a pressure of 15 psi. Yes or no? So this is the standard ones which is there for the autoclave. And what you sterilize by that? Mostly the surgical instruments except the sharps. Along with that, surgical sutures except the catgut, and all the culture medias except LJ and LSS. And LJ and LSS, they are sterilized by what, guys? Inspissation. That is also a moist heat sterilization, but yes, that is below 100. It is above 100. Fine. Then other things is that how to assess up that your autoclave is working fine or not. The autoclave assessment is done by this particular biological indicator, and the biological indicator used is the spores of Bacillus stereothermophilus. Okay, the spores of Bacillus stereothermophilus and the similar spores, that is of Bacillus stereothermophilus, they are used up in the plasma sterilization also. Okay, so that also needs to remember. that they are also used up in what? Plasma sterilization. Along with that, the Bacillus globigi is there, which is used for the ETO, that is ethylene oxide, as a biological indicator. For the hot air oven, it is now Bacillus atrophius more than the Bacillus subtilis. And regarding the filtration, if somebody asks you, that is Brevundium diamonata. And regarding the radiation and all, that is Pumilus, Bacillus pumilus. Basically, the various species of Bacillus, they are being used as a biological indicator to assess whether that particular thing is working fine or not. Okay, and you know the chemical indicator here, Brownies tube and all that. And along with that, the Boyd-Dick method is also being used for the autoclave. So these names at least you should know. Fine. With regard to the culture media, which of the following combination is correct? So chocolate agar, Haemophilus influenzae, this only is correct. You know the Haemophilus group loves what? Chocolate. And what is chocolate? Hem, X and V. What is X and V? Hemin and NAD. Okay. Lophless serum flow is enrichment media? No, it's a enriched media. Okay, it's an enriched media and selective for Condibacterium diphtheria. Smith-Noguchi media is used for syphilis. Okay, that is Treponema pallidum, which is a spirochete, not the Streptococcus. Mekong agar is a selective media. In a way, you can say it's a selective media, but not exactly. Okay, so selective media, along with that, it is differential also, and it is indicator also. So the most correct answer will be going off in the favor of A, that is chocolate agar, Haemophilus influenzae. Fine. A 48-year-old female developed perioral rashes. After an episode of fever, the DNA viruses was suspected as the etiology of it. What is the most probable diagnosis and the treatment of the same? Okay, as you can see up in the picture, it is around the lips. Okay, around the lips, and you know that which particular virus does the same. So that is herpes simplex, and that is the herpes labialis which you are seeing up, and this is termed as the most common recurrent herpes lesion. The most common recurrent herpes lesion is herpes labialis, and obviously it is done by what? Herpes simplex virus. And which herpes simplex virus, guys? HSV1. And what is the drug used for that? Acyclovir, that you already know. Okay, so this comes in this herpes family. Another important which can be asked is regarding CMV. They ask ganciclovir, which is CMV retinitis drug of choice. Okay, so CMV is which number, guys? CMV is, yes, you should tell, HHV5. Epstein-Barr virus is which number, guys? HHV4. It affects which particular cells? B cells. Which receptors are there over the B cells? CD21CR2. Okay, so all these, they are already asked question and can be asked. Paul Werner test. Paul Werner test is used for infectious mononucleosis, and it's a heterophile agglutination test. Okay, now talking about this one, a 48-year-old Indian farmer reported multiple sinuses on the right foot like this. Okay, and they are oozing pus. On histopathology, the gram-positive filamentous bacteria is observed in which particular appearance? Sun ray appearance. So that you know what is this in the sun rays? That is the organism. And we are talking about which particular filamentous bacteria? Actinomycetes. Okay, so that is actinomycetes or actinomyces. This particular one associates with actinomycetoma. But this you already know that actinomycetoma is not only done by actinomycetes, it is also being done by nocardia, certain species. So basically it's a bacterial causes of mycetoma which are there, actinomycetes and nocardia. They associates with this actinomycetoma. Is it fine? So this also needs to be remembered. Along with that, so answer obviously is what? Mycetoma. And what is this sun ray appearance? Sun ray appearance is that these organisms, they arrange themselves like rays. So that is what is termed as sun ray appearance. And it is being asked that what are these rays of the sun? These are the organisms which arrange them like the rays. Is it fine? So this is also important one. And you can grow this. Actinomycetes can be grown up on a culture media, and it produces a molar tooth-like appearance of the colonies. Okay. And whereas the nocardia, you know that that is being cultured by a special method that is termed as paraffin bait technique, Noca per bat. Okay. And what is the drug of choice for nocardia? That is cotrimoxazole. What is the drug of choice for actino? That is penicillin. Is it fine, guys? Now talking about this, identify the bacteria in the correct order on the basis of the electron microscopic picture. And as you can see up that there is a single polar flagella. A single polar flagella is found in Vibrio, So A or D. Then you have these, a tuft of flagella at one end, that is Lophotrichus. And Lophotrichus example is spirillum. Spirillum, okay. And it is peritrichus all around. So that is seen in the Proteus. Because Shigella, if we think, it is non-motile. Is it fine? So answer is A. So first one is monotrichus, second one is Lophotrichus, a tuft of flagella, and all around is what, guys? All around is peritrichus flagella. It is seen in the Proteus, it is seen in the E. coli, and it is seen in some other bacteria of the Enterovectraceae family. Is it fine? Now, talking about this, a 42-year-old man presents with complaints of unusual white lesion. It was asked. Okay, this question was there in your exam only. So, need to know this. On the lateral borders of the tongue. Lateral borders of the tongue. On examination, a white hyperkeratotic lesion is seen resembling hairy leukoplakia. Already given up in the question itself that what they are talking about. So, that is the leukoplakia, oral hairy leukoplakia. Which of the following is the most likely responsible virus for the same? So, this everybody knows. Answer is Epstein-Barr virus. That is which number? HHV4. Affects of which particular B cells? Why does it affect the B cells? Because they have the receptors, which one? CD21, CR2 with them. Okay. And this is oral hairy leukoplakia is common in whom? HIV positive. Okay. It is common in whom? HIV positive. And if you remember up, the Epstein-Barr virus does which all other things? The other things are what? Other things are nasopharyngeal carcinoma. Okay. Other than that, what else, guys? Other than that, Hodgkin's, non-Hodgkin's lymphoma, Burkitt's lymphoma, that is starry sky appearance, which you have. And the most important one is infectious mononucleosis, that is kissing disease. Presents with sore throat, having a pseudomembrane. Okay. Now coming to this, a 28-year-old sexually active woman presents to her gynae with complaints of small, painless growth in the genital area. On examination, the physician observed the lesion shown in the picture. Which combination of the HPV types does this? So obviously, guys, if it is a sexually active one, so obviously genitals are being shown, and the warts on the genitals, that is clearly visible in this particular one, and it is being done by what? HPV 6 and 11. Okay, HPV 6 and 11 along with the genital warts. And what is the other name of genital warts? Condyloma acuminata, and condylomata lata you see where? In the secondary syphilis. So these are the genital warts, and along with that they are the laryngeal warts. Okay, along with that there is done by 6 and 11 what? Laryngeal warts also. And regarding these fellows like 16, 18, 31, 33, they associate with carcinoma cervix. Why carcinoma cervix? Because it have certain early regions with it, E6 and E7. E6 causes loss of P53 gene, E7 causes loss of RB gene. And what are P53 and RB? They are tumor suppressor genes. And that's why what will happen? Cancer. Okay. Another important question. And what about the vaccine of it? It is prepared from the L1, which is a capsid protein of it. I think you already know it. Now, a 58-year-old male patient, known case of HIV, presents with a complaint of persistent diarrhea. Diarrhea. Okay, non-case of HIV, diarrhea. So you know what we are talking about. 4 to 6 micron, sufficient hint. Answer is Cryptosporidium parvum. Cryptosporidium parvum needs to be treated in this individual, otherwise the patient might die of the dehydration. And you have to give IV fluids along with the antibiotic. Which antibiotic? Nitazoxanide. You have to give which antibiotic? Nitazoxanide to the patient if you want to save. Okay. And how to remember? The Nita Ambani have invested in what? Crypto. Okay. Nita Ambani have invested where? In the crypto. For the cryptosporidium, nitazoxanide, and for the cyclospora and isospora, you use up cotrimoxazole. Okay. You use up cotrimoxazole. And what about the size of that? Cyclospora is 8 to 10 or 8 to 12 micron oocyst. And for the isospora, it is 23 to 36 micron oocyst. Is it fine? And the most common cause of watery diarrhea in the HIV is Cryptosporidium parvum only. A 42-year-old veterinary surgeon, so animal handler, presents with a black eschar. Okay. So from this only you should get the hint that they are talking about some animal handling and the black eschar. On the left hand, the area on the ulcer was severely swollen. Okay, that is swollen. It was painless, only a few vascular lesions encircled the ulcer. He presented a history of injury to the hand while handling the animals. And what would be the most probable diagnosis based on the history and the lesion? So obviously, guys, these are an animal handler. Black eschar comes in the DD of cutaneous anthrax. Okay, it comes as an answer is cutaneous anthrax. And but if somebody asks you, the black eschar is seen elsewhere, where? So black eschar is also observed where, guys? The black eschar is also observed in the case of mucor, that is mucormycosis. Okay, and along with this mucormycosis, this black eschar is also observed in which disease? Scrub typhus. And you know scrub typhus is done by Orantia susugamusi, and the mucormycosis obviously by the mucor and rhizopus. And does they have a septate hyphae or aseptate? They have a aseptate hyphae and obtuse angled or right angled. Is it fine, guys? So answer is C here in this particular one. What does a vaccine against the Neisseria meningitidis contains? So you know that this comes in the list of capsulated bacteria, and this is what is being used mainly in the vaccines of it. And the main vaccine which is there is MCV4. What is the main vaccine? MCV4. And what is MCV? Meningococcal conjugate vaccine. Meningococcal conjugate vaccine 4. Okay, so that is what is there, meningococcal conjugate vaccine 4, and it is mainly for ACYW, and the missing one is which one? B, against which we don't have a good vaccine because the capsule of that is poorly immunogenic, that you know. Okay, so MCV4 is a famous vaccine for meningo, and it's a conjugate vaccine which covers up ACYW. Is it fine? Now, coming to this, a 55-year-old laborer come to the OPD with the chief complaints of persistent fever, hematuria, weight loss, and night sweating. Okay, a routine urine culture was done. It was negative for the pathogenic bacteria. That is, sterile pyuria happened. Okay, sterile pyuria happened. So, as you can see, that there is a fever, hematuria, the blood is coming, weight loss, night sweating, a laborer. Okay, which of the following is the correct regarding the patient conditions? So, this way you have to study up the questions in your exam very fast and come to a conclusion. You have to find out that hint which you want to focus upon. So, is it whole 24 hours urine sample you will take for this, or you will take the 12-hour urine sample for this, or this is better to take the first morning void urine for the lab diagnosis of this particular ones, or early portion of the urine sample should be taken for the lab diagnosis. So, one thing is for sure that in this, the first morning void urine sample will be preferred of. The answer is C in this particular one, and we are talking about what? That is renal TB. So, in the renal TB, this is the first morning void urine, which is the best of the samples to be taken for the diagnosis. Is it fine? And how we come to that conclusion that it is TB and all? So, the laborer, okay, weight loss, night sweatings, hematuria, that might be accidental finding also, fever, sterile pyuria goes in favor of renal TB. Okay, so that is one of the DDs of sterile pyuria is TB only. So, the renal TB, so answer is C. The first morning void urine sample should be taken for this lab diagnosis. And if we talk about more about TB, you know that what is the culture media? The culture media is LJ. Okay, rough, tough, and buff type of colonies are there. And which type of a growth? Eugonic or dysgonic? It's a growth which is termed as eugonic, luxuriant growth. And along with that, we have the rapid methods now, the gene expert or CBoT. Along with that, the latest one is line probe assays, and gene expert RIF is there. Na? What is RIF? RIF is rifampicin resistance. That is the which particular gene? RPOB gene. Okay, aurum and rhodamin staining is done for the fluorescent one, and other than that, we have a number of other stuff like for the latent TB, we have IGRA and the tuberculin testing. And what is IGRA? IGRA is interferon gamma release assay, and in this interferon gamma release assay, what you have in this particular one, the sample of the choice is blood, and in that you try to find out the sensitized T lymphocytes which secrete up this particular lymphokines. Okay, so basically you want to know the interferon gamma release in that particular case. Okay, is it like advanced up, enhanced up, or it is a normal levels? That is what you observe in the this particular what you say IGRA, that is interferon gamma release assay. Now coming to this one, a 24-year-old patient presents with meningoencephalitis due to the free-living amoebae. The neuroimaging revealed the cerebral edema as shown. The CSF sample shows amoeboid trophozoites. Okay, what does it show? Amoeboid trophozoites. So obviously we are talking about a particular amoeba which does meningoencephalitis, and the one which goes in favor of it is Naegleria fowleri. Okay, Naegleria fowleri. So all the following statements are correct except it is a waterborne infection. Yes, it's a waterborne infection. Respiratory transmission can happen. Might be sometimes, yes. Caused by Entamoeba histolytica? Not sure. In fact, this is what is like the answer is. Obviously, I have told up that this is a free-living amoeba which does this, and this particular free-living amoeba is Naegleria fowleri rather than the Entamoeba histolytica. Okay, and high mortality is there because it is termed as brain-eating amoeba, and the thing which it does, okay, the thing which it does is PAM. And what is PAM? Primary amoebic meningoencephalitis. Okay. Other than that, Naegleria fowleri, which other is a free-living amoeba? You have this particular Naegleria fowleri, along with that Acanthamoeba is there, and you have Balamuthia. And all of them, they are capable of doing what? Encephalitis. So that you already know. Okay. So the odd man out obviously is what here? That is the Entamoeba histolytica. It is not caused by Entamoeba histolytica, the things which are given off. This is done by Naegleria fowleri, which is brain-eating amoeba. And respiratory transmission is like controversial. Okay, this particular statement is controversial, respiratory transmission, but yes, it is observed sometimes with the trophozoites of this particular one. Mostly they are the history of swimming in a clean water pond. Now, coming to this particular question, a 7-year-old child brought to the clinic by the parents with a history of behavioral changes, the cognitive decline, and recurrent seizures over the past several months. The parents report that the child had a history of viral infection when he was around 2 years old. Okay, fever with rash. Which of the following is the most likely thing to be linked with this particular situation? So guys, 7-year-old, behavioral changes, cognitive decline, recurrent seizures, and this particular line, the child had a history of viral infection around 2 years of age. So they are talking about what, guys? Measles. And the disease, what is there in this one is SSPE, which is a chronic late complication of measles. Okay, which is a chronic late complication of measles. That is the SSPE. That is the SSPE. Now, this one presents with this myoclonic seizures. So there are myoclonic seizures in this. And when you go for like EEG, in that EEG, what you find in the EEG? In the EEG, you got to find out the burst wave pattern. Okay, which particular pattern is observed? The burst wave pattern. And when you go for the CSF examination of this particular child, what you observe? You observe the increased titers of IgG antibodies against measles. Okay, against measles, you got to see what? Increased IgG antibodies, fine, in the CSF examination. So most likely it goes in the favor of what? Measles, because in all others, like in mumps, if at all it happens the orchitis and oophoritis, which are as a complication which can happen in the young age also and in the pediatric age group also. So mumps which presents with bilateral or unilateral parotitis, that you also know. Along with it, rubella mostly does not present in this particular fashion. It have those 4 tumor spots. And if it is talked about the congenital rubella syndrome, that you have the CHD, that is the cataract, heart disease, and deafness. And which deafness? Sensory neural deafness. Okay, and rabies obviously does not align with this, and because they are talking about a viral infection and all that stuff in the question, no? So obviously rabies doesn't go in the favor of all that. Okay, the culture media shown in the image is an example of. So this is an example of, guys, a selective media. Okay, and the picture shows up the TCBS media, that is the thiosulfate citrate bile salt sucrose, and this is a selective media for what? Vibrio cholerae. And you know that TCBS, which is a selective media for Vibrio cholerae, is an important one. And how to remember that? The TC who have given up? VC. Okay, the TC was being given to you by the VC. So TCBS is a culture media for what? In fact, this is the best selective culture media for Vibrio cholerae. This is the best selective culture media for Vibrio cholerae. Is it fine? And how does we know that? Because it is a green color media and it is changing into yellow. Why it is changing into yellow? Because of the indicator color change. And why does the indicator is changing the color? Because this S, sucrose, is fermented. And when the sucrose is fermented, the acid is produced and the acid is changing up the color from green to yellow. Is it fine? So the answer is selective media. Okay, the basal media is nutrient agar, nutrient broth. Enrichment media examples are selenite F broth and alkaline peptone water. Salinide broth is used for Salmonella, Shigella, alkaline peptone water for Vibrio. Enriched media is all sorts of solid one, blood agar, chocolate agar, like what you can say, LSS also, Loeffler serum slope, that is also enriched media. Selective media, you know this. One of the TCBS, other than that, mannitol salt agar, and number of others like potassium tellurite agar for the conjugated diphtheria, mannitol salt agar is for staph aureus. So these are what? These are selective medias, which you should know. Now coming to this, in the Oakley-Fulthoff procedure, which specific dimensional diffusion process happens following the initial electrophoretic separations of the serum proteins? So Oakley-Fulthoff, you should know, that is like suppose you have a test tube, in that in between you have the agar, over it you have put up the antigen, and down in this particular agar, down this slab, what you have? You have the antibodies, and here it is the antigens over it. So basically these antigen and antibodies, they have affinity towards each other and they are moving up in one dimension only. So, okay, so that is what is termed as Oakley-Fulthoff. Okay, so basically it's a double diffusion in one dimension, means antigen is also moving, antibody is also moving, but the direction is what? This one. Okay, so that is one dimension. So this is double diffusion in one dimension. What is single diffusion in one dimension? That is termed as Auden. That is termed as Auden procedure, in which antigen is moving towards the antibody because antibody is there in the agar. Single diffusion in two dimensions means only one thing is moving. Single diffusing in two dimensions, in different directions. So that happens to be in the radial one. Radial diffusion is having this particular stuff. Okay, and the double diffusion in two dimension, that is termed as Auchterlonie. That is termed as Auchterlonie. That is double diffusion in two dimension. Okay, means both are moving, antigen antibody, but different directions. Okay, and the classical example of that is, which can be asked in your exam, Ehrlich gel precipitation test. Ehrlich gel precipitation test, which is done for the Corynebacterium diphtheria toxin. Okay, demonstration, which can be done for what? Corynebacterium diphtheria toxin demonstration. Now coming to this, which of the following organisms show the phenomena shown below? Candida glabrata, Paracelsus tropicalis, albicans. So guys, as you can see very much, this is the germ tube formation. Okay, what it is? It is the germ tube formation, and this germ tube formation is observed in Candida albicans. It is being observed in what? Candida albicans. And what is this actually? You take up the colonies of Candida albicans and you mix it in human plasma, and after after 5 minutes or after minutes also, like 1 or 2 minutes, when you observe that under microscope, you observe the formation of these projections. Okay, so after minutes also it can happen, or in a half an hour you can observe up under the microscope that you will able to see up these types of tubes, that is termed as germ tube formations, and this is what is known as Reynolds-Broad phenomena. This is what is termed as what, guys? Reynolds-Broad phenomena. And the same Candida albicans also shows up which one? The chrome agar. Chrome agar method. Okay, is like, I just want to tell them the chrome agar method is there, which tells you about what? Speciation. Which tells you about what? Speciation of the Candida. Means which Candida you are dealing up with. Is it albicans? Is it tropicalis? Is it Paracelsus? Is it glabrata? That is best known by what? The chrome agar method. And specifically, if we go for Candida albicans itself, the another name, that is chlamydospore formation, which is an asexual spore on the cornmeal. That also you need to remember. The chlamydospore formation on cornmeal agar, that also needs to be remembered. Okay, and why does it produce chlamydospores in cornmeal? Because it's a nutrient deficient media. Is it fine? Now talking about this, which of the following exists as hyphal form at 25 and yeast form at 37? So obviously, if this is the way to go, we are talking about which particular fungus? We are talking about the dimorphic fungus, and you already know the dimorphic fungus out of this list is B. Histoplasma. Histoplasma capsulatum, which does histoplasmosis, and the chronic histoplasmosis mimics TB, that you know. And which particular microconidia is seen, guys? Macroconidia, in fact, tuberculate macroconidia, which looks like a sunflower. Along with that, if there is a history of the traveling in the question, along with that, they say that we have gone for the bone marrow biopsy, and in the bone marrow biopsy, what you observe? You observe the cells. Okay, in the bone marrow biopsy, what you observe? In that, you observe the cells which are having narrow-based budding. Which are having what? Narrow-based budding of the E cells. Narrow-based budding of the E cells is observed in the bone marrow. This is a finding which you might find in your exam. Okay, so narrow base budding E cells in the bone marrow. This might be seen in the question along with a history of traveling. So that is regarding the histoplasma. So, and you already know that which all are dimorphic fungus, HSBC P square. And what is there in the HSBC P square? In the H is histoplasmosis, S is sporotrichosis, B is blastomycosis, C is coccidioidomycosis, P is paracoccidioidomycosis, and another P is penicilliosis. And this particular penicilliosis is also known as what, guys? Telaromycosis. Telaromycosis. And this was asked again and again recently. Okay, so telaromycosis done by Telaromyces marnifi produces a brick red color pigment, and this brick red color pigment is being produced up. Along with that, you need to know that this is common in HIV positive, and we have a brush border conidal arrangement regarding the same. Okay, brush border conidal arrangement, common in HIV positive. Now, this particular one, the oxidase test helps in the identification of all the following except. And first of all, you should know what is oxidase test. Oxidase test is a white color strip. In that white color strip, when you touch the organism, it changes color from white to blue. It changes color from white to blue within 10 seconds. This is what is termed as oxidase test positivity. If does not change the color within 10 seconds, that is oxidase negative. And this you already know that if you don't know the answer also properly out of them, one simple trick can give you the answer, because if you know that Enterobacteriaceae family, which is a big family of gram-negative bacteria, Enterobacteriaceae family, okay, so Enterobacteriaceae family, so this particular one is having a thing that is catalase positive they are and oxidase negative they are, and this particular thing correctly marks up the E. coli. So that you already know. So Vibrio, Neisseria and Brucella, all of them they are oxidase positive, and E. coli comes in Enterobacteriaceae family. So obviously it will be catalase positive and oxidase negative. Fine. So answer is C. So this much is there in the discussion, guys, and obviously a sort of a rapid fire type it is to save up your time, because you have a number of other things to revise, and these are the ones, okay, which you should focus upon, because they can be in the form of some integration, like oxidase test they can give you, and they can give the organism in the form of a clinical scenario, and they might try to ask up regarding Pseudomonas, they might ask up regarding E. coli, that it is oxidase negative, and also this particular entity should be remembered, okay, and if you work upon in this way, you will definitely get the success, okay. So very best of luck from my side. Thank you so much.